let's start with endocrine. All right, the first thing we have in endocrine is the thyroid development. In the thyroid, it's very high yield, okay, very, very high yield. So thyroid diverticulum arises from the floor of the primitive pharynx. This word here is really important itself. Primitive pharynx is a pharyngeal epithelium. Okay, it's a pharyngeal epithelium. They might ask you, okay, what is, because they might not say primitive pharynx. They would say, well, where does this thyroid arise from? And that's the pharyngeal epithelium. And it descends into the neck. Okay, so taking a look here, so it starts, let's say here, and then it goes down to this point. And any point that it is traveling down there, it could stop. Either it could stop right here in the mid, and we will talk about all of that. I'm just giving you an overview right now. And if it stops anywhere, and that's going to be pathology. Okay, so right now we said thyroid diverticulum arises from the primitive pharynx, which is a pharyngeal epithelium, and descends into the neck, which is the interior of the neck. It is connected to the tongue. So let me erase a little bit of these things. It is connected to the tongue by thyroglossal duct, which normally disappears but may persist as a cyst. So this thyroglossal duct would normally disappear, but if it persists, it's going to be as a cyst, or it could make a pyramidal lobe of the thyroid. Two things. Again, if it persists, it's going to make a cyst, or second thing, pyramidal lobe of thyroid. Okay. Foramen cecum is normal remnant of the thyroglossal duct. And what is foramen cecum? It is the here is the groove in the tongue. So it's the normal remnant of this thyroid duct, thyroglossal duct. Okay. So most common ectopic thyroid tissue is the site is in the tongue. Lingual is known as lingual thyroid because, again, in the tongue, lingual thyroid. Now, some questions do come on this as well. So what is a lingual thyroid? So if you have a thyroid follicle, let me just draw it here. If you have a thyroid gland here, let's say, guess what's going to happen? Now you will have, and again, they will ask you, where is it? Most likely it's going to be at the base of the tongue. Base of the tongue is the most common site. And it's going to present as mass, large red lingual mass under the tongue, at the base of the tongue. Okay. And enlargement of this mass is going to cause what? Is going to, again, if you're trying to have a mass here, guess what you can have? You can have obstruction. So obstructive signs, symptoms will be there. For example, dysphagia, dysphonia, dyspnea. 3Ds. Dysphagia, dysphonia, and dyspnea. Okay, and that's all about the lingual thyroid. And I'm going to read, okay, the way we do it, we read a page and then we go over this again. So, you could just listen, and then when we go over it, it's just going to review those details again, okay? So removal, if you were to remove this guy, which is a lingual thyroid, okay, it might result in hypothyroidism. Why? Because it might be the only thyroid tissue present. Okay, so that's there. And the next thing is thyroglossal duct cyst. So let's go back to the thyroglossal duct. This here, if it persists, we said it's going to be either cyst or the pyramidal lobe. So we're talking about cyst now. So thyroglossal duct cyst presents as an anterior midline neck mass. Okay, that moves with swallowing, high yield, that would move with swallowing. You ask the patient to swallow, or maybe take a sip of water, and you will see that proper mass moving while they swallow, versus, or protrusion of the tongue would do the same, versus persistent cervical sinus, which is again an anterior midline mass, but it will not move with swallowing. Okay, so two differentials are here, and it's leading to the pharyngeal cleft cyst in the lateral neck. So it's a lateral neck mass. Okay, and it will not important thing is this: it will not move with swallowing, and that is going to be your persistent cervical sinus. Okay, and with this, just the pyroglossal duct cyst, it's an anterior midline neck mass which would move with swallowing. Okay. Now the next thing is all about where they're derived from. The thyroid follicular cells, they're derived from the endoderm, while the parafollicular cells are derived from the fourth pharyngeal pouch. Okay. Now some more important things are going to be, let's talk about those here, which is the blood supply and the nerve supply. So blood supply, fortunately, it's here, a nice red picture here. So all we have is, all you got to know is, okay, you have a superior thyroid artery and an inferior thyroid artery. These two arteries are going to supply the blood to the thyroid and the parathyroid gland, right? Right here. Now, where these arteries come from is totally different, because the superior thyroid artery is a branch of external carotid artery, right? And the inferior thyroid artery is a branch of, first of all, left subclavian gives out branch, thyrocervical trunk, then goes into inferior thyroid artery. Okay, so just know there is a different blood supply, okay, for superior and inferior. Now, more important to that is that near the superior thyroid artery, we have something known as external laryngeal nerve. And near the inferior thyroid artery, we have the recurrent laryngeal nerve. So when we, let me zoom in here. Okay. So when we go and do the thyroidectomy, doing a surgery, okay, you might cut down this nerve, which is the external laryngeal nerve, right? Or if you you could also cut down this recurrent laryngeal nerve. Now the problem is you got to know which structures are supplied by what. So recurrent laryngeal nerve supplies all the muscles, everything of the every muscles. Like for example, posterior crico. Let me just actually write them. All muscles, for example, posterior cricothyroid. What else do we have? A lateral cricothyroid. Oblique arytenoid transfer. I mean, there's so many. That's all you got to remember is all muscle. I can just write them here. I'll just say them. Okay, you have a transverse arytenoids, oblique arytenoids, and thyro arytenoids, and posterior crico arytenoids, and lateral cricoarytenoid as well. So you have all these muscles. Now, what you got to know is only one muscle, which is total different. That's going to be your cricothyroid. What is it? Cricothyroid, right? Cricothyroid muscle. Yes, right here. Let me write this one down. Cricothyroid. So this one is important. Why? Because there's only one nerve. What this whole nerve, external laryngeal nerve, is supplies this one muscle. Okay, and that's it. And the rest of all the muscles are supplied by your recurrent laryngeal nerve. So if you knock this out, guess what's going to happen is that's very high yield actually. If you knock this out, you're going to have loss of voice, and or obstruction to the breathing. Okay, but if you were to knock this external laryngeal nerve, all you are going to have is a low hoarse voice. Let's just get this here. Low hoarse voice with a limited pitch. Okay. So you can see the difference. Two nerves, total different things. So recurrent laryngeal nerve can get injured as they run near the inferior thyroid artery. Okay, as I mentioned here, inferior thyroid artery. External laryngeal nerve can get damaged as it courses with the near the superior thyroid artery and the vein. Okay, so this is there, and this is very high yield point. Okay. one more thing that I would like to mention here, since we are talking about these two nerves, recurrent allergic nerve not only supplies these muscles, but also it supplies these sensory sensations below vocal cords. Sensory sensations below vocal cords. Vocal cords. Okay, and if this recurrent is supplying below vocal cord, so you can right away think, okay, who's going to supply above a vocal cord? It's called supraglottic sensation. That's the external laryngeal nerve, which also supplies the supraglottic sensations. Okay, and that's going to be what we have. So let's just review this now. All right, in thyroid development, what we talked about, okay, we said, let's change color here. We said the thyroid diverticulum arises from the floor of the primitive pharynx, which is the pharyngeal epithelium, and descends into the neck. While coming in, traveling down, while it is traveling down to the neck, in this migration, it might just stuck somewhere. So it might stuck in the mouth, which is the base of the tongue, or it could stuck in somewhere. And all that is going to be wherever it gets stuck, it's going to have that thyroid tissue there. So you will see a mass. So some of the mass are sublingual mass, prelaryngeal mass. If it gets stuck here, it's called prelaryngeal mass. And normal location is here, so normal is here. Normal location. Okay. So it's simple, right? But now we said, okay, it's connected to the tongue. It's connected to the tongue by this thyroglossal duct is connected to the tongue. Okay, and that connection where it starts is called foramen cecum, which is there is a depression on the tongue, and that's called the foramen cecum. Okay, which normally disappears. This whole duct would disappear. This whole duct would normally disappear. But if the remnant is there, it can be as cyst or pyramidal lobe of the thyroid. Foramen cecum is normal remnant. This is total normal. Second thing is most common ectopic tissue is going to be at the base of tongue, which is called lingual thyroid. But if you were to remove this, you can go into hypothyroidism. The cyst of the thyroglossal duct cyst will present as anterior midline neck mass, which would move with swallowing, versus persistent cervical sinus, which is going to be on the lateral side, and it will not move with swallowing. Okay. Thyroid follicular cells are derived from endoderm, while the parafollicular cells are derived from fourth pharyngeal pouch. Now, most important is this: in the thyroidectomy, if you were to cut on your superior thyroid artery, you could nick on the external laryngeal nerve, or inferior thyroid artery, the recurrent laryngeal nerve. And the recurrent supplies all muscles and below vocal cord sensations. If you were to knock this out, you're gonna have loss of voice with obstruction to breathing. And if you were to knock out the external laryngeal nerve, all you're losing is a limited pitch and a low voice. A low hoarse voice will be there. And it also supplies the supraglottic sensation. Okay, now let's talk about pituitary gland. Pituitary gland has two things. It has an anterior pituitary. There are two things: anterior and a posterior pituitary. Right? Anterior A is called adenohypophysis, or hypophysis. Posterior is called neurohypophysis. Okay, so the pituitary sits on the sella turcica. So let me just actually do that so it's easier to understand what I'm saying. So pituitary sits on a bone known as sella turcica. Sella turcica. Okay. And above pituitary, right on top of pituitary, all we have is called optic chiasm. Okay, let me just do this. Optic chiasm. Okay. and hypothalamus sits up top, hypothalamus, and you have fibers coming down from the hypothalamus to the pituitary. And this thing is called, these fibers, or this circulation or portal system is called hypothalamic hypophyseal portal system. So let's just write it, hypothalamic hypophyseal portal system. Okay, so now with that, let's just talk about anterior pituitary. Anterior pituitary secretes FSH, LH, ACTH, TSH, prolactin, growth hormone, GH, beta endorphins. MSH, which is a melanotropin, secreted from the intermediate lobe of the pituitary, derived from the oral ectoderm, Redke's pouch. High yield. So anterior pituitary is derived from oral ectoderm, Redke's pouch. Okay. And alpha subunits, we have alpha and beta subunits. The alpha subunits, they have the hormone subunits common to TSH, LH, FSH, and HCG, while the beta subunits are, they determine the hormone specificity. Okay. That means that if you have a beta subunit, they specifically would tell, okay, that's the hormone. But now something you will see that even in the beta, there are some common beta subunits. For example, HCG and TSH, thyroid stimulating hormone, they have homologous beta subunits. Okay, that's one thing. So this allows, what's going to happen, this allows the HCG to bind and activate the TSH receptors. And that's going to cause, for example, if you have a lot of HCG, it's going to cause paraneoplastic hyperthyroidism. Okay, so that's the important thing. Other than that, you have, you should know that, okay, the alpha subunits are also common to TSH. Look at that. So you have a TSH and a beta HCG, right? So they're already there with the alpha subunit and also in the beta subunit. The only two that are left that you have to know is LH and FSH, nothing else, which is not that hard to remember. And that's going to be all we have here. On the right side, it says very important is the pro-opiomelanocortin, POMC derivatives. So POMC derivatives are beta endorphin, ACTH, MSH. Go pro with the MAM. That's a mnemonic if you want to go with it. But if you don't want to go with it, just remember with ACTH, and we will talk about in pathology as well, that we have hyperpigmentations and all that. And why is that? Because of MSH being there. Okay, so with ACTH, you're going to think about there are two more things that ACTH just has. So you have a beta endorphins, and you also have MSH. Okay. Now there's another mnemonic known as flat peg, which is the FSH, LH, ACTH, TSH, P, RL, and GH. Beta flat or B flat is the basophils, which are the FSH, LH, ACTH, and TSH. An acid peg, which are acetophils, prolactin, and growth hormone. So just remember the prolactin and growth hormones. They are acetophils. Okay, and the other ones are just going to be the basophils, because there are only two here. So I guess it's easier to, memorize two than to memorize the whole thing. Okay. Now let's talk about the important thing. This was just a reading purpose, but let's talk about some important thing. So here's the Redke's pouch, right? So this guy, this adenohypophysis, is derived from the oral ectoderm, right? Which is known as the Redke's pouch. Redke's pouch. Now, in children, what's going to happen is something you will see if any remnant of the Redke's pouch remains within this oral ectoderm, it can lead to formation of craniopharyngiomas. Craniopharyngioma. Okay. Uh, and this craniopharyngioma is going to be, it's going to give you hypopituitarism and diabetes insipidus and hydrocephalus in a patient. So decrease in pituitary. Second thing is going to be DI. Third thing is your hydrocephalus, craniopharyngiomas. So what is craniopharyngioma? Is the remnant of this Redke's pouch that stays within the oral ectoderm. Okay, so that's pretty much what we have here. One last thing here is MSH. Sometimes they don't say MSH, they might say the full name, and the full name is melanocyte stimulating hormone. Let me just write it here. Melanocyte stimulating hormone. So melanocyte stimulating hormone. Okay, and that, as the name suggests, that's just going to stimulate melanocytes. And guess what? When you stimulate melanocytes, you're going to go and increase melanin. So let me erase this. Increase melanin. Increased melanin is just like hyperpigmentation, and that is why when we have ACTH high, there will be hyperpigmentation seen. Okay. And what else we can think of? So all these hormones are regulated by hypothalamic releasing inhibiting hormones as they're secreted on the median eminence. So here, this thing. Okay. So these, again, these are all these hormones are going to be regulated by hormones secreted by the hypothalamus. Okay. Which work on the median eminence of the hypothalamus and act on the anterior pituitary via hypophyseal hypothalamic hypophyseal portal system. And one important high yield point about this portal system is this does not have blood-brain barrier. So it does not have BBB. Okay, no BBB here. Okay. Now let's talk about some hypothalamic hormones which are coming from top and causing the release of these hormones. So you have GnRH. So let's just write here. Actually, it might come up. Yeah, it's going to come up later on. So we'll just talk about that at that time, and then I might come back and take a look at this figure here. Okay, so it's going to come up. So just let's read the next one here. It's called the posterior pituitary, which is the neurohypophysis. Now, important point with the neurohypophysis is this guy is in neuro, right? So it's going to be, drive from neural ectoderm. Neural ectoderm. So what is common? The common is ectoderm. Let me write this here. Ectoderm. Neural ectoderm. With the neuro being there or posterior pituitary being there, all you're going to think about, okay, neural ectoderm and oral ectoderm. Oral because it's coming from the oral cavity, evagination. So you have the oral cavity. There's a full-on evagination of the oral cavity, which is known as the Redke's pouch, which would go from here all the way towards the posterior pituitary and just join up there. And that's the normal anterior pituitary. While the posterior pituitary is straight up coming from the hypothalamus, as a part of hypothalamus, which is the neuroectoderm. Okay, so ectoderm. Remember ectoderm, and both are ectoderm, but one is oral ectoderm and the other is neural ectoderm. And that's important. So posterior pituitary, now here it stores and releases vasopressin, which is antidiuretic hormone, or ADH, and oxytocin. Only two things. Okay, vasopressin and oxytocin. Both are made in hypothalamus. Okay, they're not made in posterior pituitary. They're all made in hypothalamus, supraoptic and paraventricular nuclei, and they're transported to the posterior pituitary via neurophyssins. Now, guess what? If you knock out these neurophyssins, you're going to have a problem, right? Because they're made up high in this hypothalamus. All they do is travel down through these neurophyssins. If you knock them out, you're going to have a problem. We'll talk about that. So here, let's just when neurohypophysins are carrier proteins, so the whole posterior pituitary is derived from the neuroectoderm. We talked about it. Okay, so here is the problem with the neurohypophysins. So let's talk about that now. So neurohypophysins, they are carrier proteins for both the oxytocin and the ADH. Okay, and they are produced by the hypothalamic nuclei. They bind to the oxytocin and ADH and shuttle them where to the nerve terminals in the posterior pituitary. Now, now the problem is if you have because they bind to specifically each one of them. So if you have there's a problem known as autosomal dominant hereditary hypothalamic diabetes insipidus. All it is that you have a DI, diabetes insipidus, but that's because it's hereditary. So let's just write it. It's an autosomal dominant hereditary hypothalamic DI, diabetes insipidus. And why is that? Because when you have a congenital problem or when you have a genetic problem in the neurohypophysins, you are going to get, it's an autosomal disease, a hereditary, which will cause hypothalamic problem that will cause DI, diabetes insipidus. Why? Because you have a neurophysin 2, which specifically binds to ADH, okay, and it's involved in transport and packaging of this ADH through the ER and the Golgi apparatus into these granules. And if you have a point mutation, now important point is this called point mutation. There's a point mutation of neurophysin 2, and that is going to leading to this AD, autosomal dominant hereditary hypothalamic diabetes insipidus. And that is pretty much what we have as a pathology here. Okay, so let's take a look at the next thing. What do we have? All right, so now we have adrenal, cortex, and medulla, high yield. Again, just the names, the layers, how they are primary regulated, high yield. Okay, so let's take a look. So adrenal medulla and cortex. Okay, so adrenal cortex, it is derived from mesoderm, and the medulla is derived from neurocrest. Again, high yield. Okay, and here are the layers. So you have a mnemonic known as GFR. Normally GFR is for the kidneys, right? But here it's a mnemonic. GFR corresponds with salt, which is the first layer. Mineralocorticoids, sugar, glucocorticoids, and sex, which are the androgens. We're just talking about the cortex, not the medulla. Medulla is a whole different scenario. It's a whole different thing, right? We're just talking about the cortex. And this is the adrenal gland. And here's the cortex. And in the mid, you have this medulla, right? So let's look into this thing. So taking a look at this picture, this is also very high yield. So what do you see? You have a layer. You have a lot of cells. All you got to remember, okay, there are a lot of cells in the first layer, and you have less sort of you can see through them. So less cells, and then again there are more and more cells, and the last ones are just total out, the blue cells, right? So now you already know that the first one is going to be G, and the mid one is going to be F, and the last one is going to be R, and the very end is going to be medulla, which might they not ask, but these three, GFR, as for histology, important. Okay, so primary regulated. So that's very high yield actually. So GFR, the primary regulation is by angiotensin 2 for the G zone, or the zona glomerulosa is the angiotensin 2. Now, when you stimulate this zona glomerulosa, the hormone they secrete is called mineralocorticoid. Okay, and the primary hormone produced by them are aldosterone. Now, what is the function of aldosterone? Just talking about here, simple thing, it increases blood volume. Just one thing right now. And we'll go into details later on. Just remember, it's just going to increase the blood volume by retaining sodium in water, and we will talk about that. But just keep in head, aldosterone is just going to increase the blood volume. Okay. For the next layer, we have this zona fasciculata. Fasciculata, there are two primary regulations. One is ACTH, the other is CRH. Now, if you recall something we will talk about again, is the hypothalamus sends off the CRH, which then leads to release of ACTH. Okay, so either the ACTH is directly going to stimulate this zone, or CRH is also going to do the same thing. And the hormones they're going to produce is called glucocorticoids, and the primary hormone produced is the cortisol. Okay, and I'm just going through them right now, and we will talk about each one of them in a bit. Okay, so cortisol, just on top of that, you should know that, okay, it's going to do a couple things. It's going to increase the vascular tone, and it's going to increase blood sugars or blood glucose. With the name glucocorticoid, it's easy to just think, okay, sugar, glucose high. And again, the other thing is increasing the vascular tone. The last zone here, we have the zona reticularis. Here, again, it's the same thing, ACTH and CRH. And they are the primary hormone they produce is called androgen. Hormone class is androgens, and the primary hormone is DHEA. Okay, with the DHEA, the normal function you can think of is going to be your libido and hairs, pubic hairs in women you can think of. Okay, just basic functions here. Okay, and let's talk about now the medulla. Medulla is blue, like chromaffin cells. Chromaffin cells are deeply basophilic. Okay, two things, okay? When we think about basophil, let me just write here. Basophil, eosinophils, baso for blue. Just remember B for baso, B for blue. Eosinophils are pink. Okay. B for baso, B for blue, and others are pink. So here the chromaffin cells are basophilic. Deeply, and why is that important? Why am I telling you all this, right? This is important because they're not going to say it's the chromaffin cells, it's the medulla. They say, okay, there's a problem. There are a lot of basophilic cells or deeply basophilic cells. They are there. What are those cells? Or so you should know the last medulla is just going to be total basophilic, nothing else. Okay, so that's why this is important. It's a deeply basophilic cytoplasm. And these guys are going to be regulated by preganglionic sympathetic high yield, preganglionic sympathetic fibers. So let's just talk about this one here. Now here, what am I saying? I'm saying preganglionic sympathetic fibers, but important point is these sympathetic fibers are going to release acetylcholine. Acetylcholine. So sympathetic fibers releasing acetylcholine, okay, which would stimulate these catecholamines. Now, catecholamines they release are going to be epinephrine, norepinephrine, but high yield point is epinephrine is about 80%, and about 20% is only norepinephrine. Okay, and these guys are just going to directly go into the bloodstream, and so directly is the important point because they're not going to go into the nerves, right? They're just going into the bloodstream, and directly they will stimulate the receptors on the blood vessels. Okay, so now important point, last point that I'm going to mention here, then I'll go through the whole thing, is that GFR, so all these three layers, G and F and R, they are all derived from cholesterol. So GFR, all these layers are derived from cholesterol. Okay. And that's going to be what we have. So let's talk about this and then I'll talk about one pathology here. Okay, now let's read it and make it the way we can think and say, okay, we know it now. Okay, what do we have? Simple thing, okay. Adrenal cortex, medulla. All you gotta know is GFR, G and F and R. One thing for the first one is going to be angiotensin 2. The rest is the same. So G is the angiotensin 2, which stimulates it. And for the F and R is the same thing, CRH and ACTH in both, same, right? With the angiotensin 2, all you're releasing, if you just recall your RAS activating system, RAS, guess what? With the angiotensin 2, who are you activating? You're always activating aldosterone, right? So again, same thing. Angiotensin 2, or you could just go it this way, okay? A for angiotensin and A for aldosterone. The first layer is just going to release aldosterone. Second layer is just going to release cortisol, which is a glucocorticoid. Maybe you don't even remember the names. If you want to remember, that's great. I mean, actually, by the time we get the end of this endocrine, you would know the names yourselves. Don't worry about that. But glucocorticoid is cortisol. And the last layer is DHEA, which are the androgens, sex hormones, right? Okay. And the medulla is just the catecholamines, which are epinephrine and norepinephrine. Now, high yield with the medulla is going to be sympathetic fiber stimulating it, which is going to be these sympathetic fibers. They are not going to release norepinephrine or anything else, but they will release acetylcholine on this medulla. Okay. Now, one point that is a high yield is called, if you have a low ACTH, so let's just do it here. If you have a low ACTH, now guess what's going to happen? So if you have a low ACTH, you're not going to stimulate your fasciculata. You're not going to stimulate your reticularis. So let's just do it at GFR. These two cortex layers will not be stimulated. So you will go into atrophy. If you have a low ACTH, atrophy of fasciculata and reticularis. Why? Because the growth of the granulosa is not based on ACTH, it's based on angiotensin 2 stimulation. Because the growth of, again, granulosa, the first G is stimulated by what? Angiotensin 2. So that's total normal. The only thing which is going to go into atrophy is these two layers. And that's an important thing. And that's going to be all for this adrenal cortex and medulla. Moving on with this endocrine pancreas. Let's change color. So pancreas cell types, right? So islets of Langerhans are collections of alpha, beta, and I guess delta endocrine cells. Islets arise from the pancreatic buds. Okay, so alpha is glucagon, which is in the periphery. The easy way to go for it is just remember, you have alphas here. Okay. In the center, you can just say beta cells, right? And last thing is interspersed within them are just your delta. So let's just change color and call this these guys, which are your somatostatin delta cells. So again, alpha glucagon, which is in the periphery. Okay, beta insulin, which are central, as you can see here, and somatostatin, which is interspersed delta cells. Okay. And that's pretty much what we have here. Let's move on to the next. Okay, now we're talking about the hypothalamic hormones. Okay, hypothalamic pituitary, actually everything. Hypothalamic pituitary hormones ADH, antidiuretic hormone. Antidiuretic hormone, the function is to increase the water permeability of distal convoluted tubules and collecting ducts cells in the kidney to increase water resorption. Maybe just right now remember that they would increase water resorption. Where are they working? DCT, distal convoluted tubule. plus CT and collecting ducts in the kidney, and all they're causing is antidiuresis, right? Uh, Simple thing, antidiuresis, meaning no diuresis, meaning trying to have the conserve the water, so increase water resorption, right? Clinical note here is the alcohol consumption would decrease ADH secretion. When you decrease ADH secretion, guess what? You're not trying to conserve that water, so you're going into polyuria. When you're doing polyuria, a lot of urine is going out, causing dehydration. So alcohol leading to dehydration. The next is CRH. CRH, the function is going to increase ACTH. And again, when you, it's the whole POMC, remember? So when you increase this CRH, it's going to increase, it's going to stimulate the POMC. And POMC has all these three things. It has ACTH, it has MSH, and beta endorphins. So CRH is going to stimulate the POMC, and this POMC will stimulate all these three things. Okay, now what is CRH? CRH is corticotropin releasing hormone. So corticotropin releasing hormone. Okay, and this is decreased if you give a patient chronic glucocorticoid. If the patient is on a chronic glucocorticoid therapy, the whole axis is down, so the whole CRH is going to be down. Okay. And the next is P, a prolactin inhibiting factor, which is PIF. Again, prolactin inhibiting factor, right? So it's going to, as the name suggests, it's going to decrease prolactin. But not only that, but also it decreases TSH. Okay, so commonly referred as dopamine. So this thing that is the same thing as dopamine. Dopamine antagonists are going to be antipsychotics. They can cause galactorrhea due to hyperprolactinemia. Again, if you're knocking out your dopamine, if you're trying to inhibit this dopamine, so normal thing is dopamine normally is inhibiting prolactin release. That's normal. You knock this dopamine out, or you inhibit its, you give an antagonist of dopamine, you will not be able to stop prolactin. So prolactin is going to be high. When the prolactin goes high, you are causing galactorrhea due to hyperprolactinemia. And we will talk about that, and prolactin is going to come up in a bit. The next is GHRH. GHRH with a bigger H, right? This is going to be growth hormone. Growth hormone releasing growth hormone releasing hormone, RH. This is just going to cause increase, as the name suggests, is going to cause increase in growth hormone. With the growth hormone analog is tesamorelin, however you call it. It is used to treat HIV-associated lipodystrophy, high yield. Okay. So instead of calling it tesamorelin, you just think, okay, HIV-associated lipodystrophy is going to be treated by Tesla Morlin. You want more Teslas, okay? Tesla Morlin. Or if you just remember Tesla More, I mean, the lin is just going to be there. If you have a Tessa More or Tesla More, it is for HIV-associated lipodystrophy. I mean, if you have a better mnemonic, great. Feel free to, share it with us. And the next thing we have is called GnRH. GnRH is simple. It's a it's gonadotrophin regulating hormone. Now, high yield point with this guy is going to be that it has to be pulsatile secretion. Pulsatile secretion. And that the pulsatile secretion from the hypothalamus is going to cause increase in FSH and increase in LH, only the pulsatile secretion of it. Okay, so it's going to stimulate the anterior pituitary, cause increase in FSH and LH. And just to recall something, so what is FSH going to do when you have an increase in FSH? Well, that's going to work on your Sertoli cells. And Sertoli cells are going to produce something known as androgen binding protein locally. Okay, that's important. So androgen binding proteins, but the important point is locally. And why locally is important? Because locally, they're responsible for high local testosterone concentration, because these guys will bind to the testosterone and keep it there, not let it go into the blood and cause all its effects. So locally increasing androgen binding protein will cause more and more binding of testosterone, and local increase in testosterone concentration and FSH are both necessary for spermatogenesis. Okay, that's important. The other thing that these guys do, Sertoli cells, they also release, and this is going to come up in reproduction, but here's just a overview of how things are going to work. So again, if you're giving GnRH, it's going to stimulate this. It's going to make all of this, and it's going to have more and more testosterone locally, right? But now the problem is we don't want a lot of testosterone there. We have to have some inhibiting factors. So this is so these Sertoli cells not only produce this, but they also produce called inhibin B. They also release inhibin B, as the name suggests. Inhibin, just remember, this is going to inhibit. Inhibin will go back and provide a negative feedback to the anterior pituitary to say, hey, we have a lot of FSH already. We don't want more. So inhibit the anterior pituitary release of FSH. Okay. And that's what the FSH. Now, quickly, let's talk about LH. Well, the LH is going to, with the L, remember, L for Leydig cell. Leydig cells. These guys are going to actually release the testosterone now. Okay. And that testosterone, okay, itself is going to produce a negative feedback towards two things now. Not only is going to inhibit the anterior pituitary, but also is going to say, hey, I'm going to go to your master hypothalamus. I want no testosterone in the body. Okay, I have enough. I want to give a negative feedback. I don't want anything. Okay. And it's going to give two negative feedbacks. Okay, that's all about this FSH and LH. Again, recalling the whole thing, FSH is all about what? Here we go. So FSH is all about, what is that? Give me 1 second. I have to erase this part. All right, so FSH is going to be all about going to the Sertoli cell, release of androgen binding proteins, which will locally keep that testosterone in a higher concentration. And why is that important? For the spermatogenesis. Sertoli cell will also release inhibin B, which would inhibit the release of FSH. And the other thing we have for the LH is going to stimulate the Leydig cell, and that will lead to release of testosterone. That testosterone will go and inhibit not only the anterior pituitary, but also its master, which is hypothalamus. Two negative feedbacks. Okay. So moving on to the next thing, what do we have? It's called, okay, let's do one thing here. So it is suppressed by hyperprolactinemia. Okay. Tonic GnRH analog, which is leuprolide, suppresses the hypothalamic pituitary gonadal axis. So tonic analog, which is leuprolide, would suppress this whole axis, which is hypothalamic. From the hypothalamus, you have the pituitary, and then you have the gonads. The whole axis will be suppressed. Okay. Now, if you were to give a pulsatile RH would lead to puberty and fertility. Okay. So that's what we have. Again, as we said, pulsatile is the one which would stimulate these. And if you give a tonic or long-acting, leuprolide is actually a long-acting GnRH, and that shows the body, okay, this is like continuous GnRH being there. So that is going to suppress the whole axis. Well, if you were to give us pulsatile, a drug that is, or pulsatile GnRH would lead to actually increase in FSH and LH that would lead to puberty and fertility. Okay. The next here we have the MSH. MSH is again melanocyte stimulating hormone, melanocyte stimulating hormone. This increases the melanogenesis by melanocytes, increasing causing hyperpigmentation, right? Causes hyperpigmentation in Cushing disease, where you have increase in ACTH, right? As MSH and ACTH share the same precursor molecule, which is POMC. POMC-BAM is a good morning, actually. Let's just do it here. POMC-BAM. Let me write here, okay? So we said POMC-BAM. So B for beta endorphins, A for ACTH, M for MSH. But on top of it, I mean, if you know a little bit what we should talk about in Cushing disease, you will right away tell, okay, the ACTH is always increasing, MSH causing hyperpigmentation. Okay. Now the next thing here we have this oxytocin. Oxytocin causes uterine contraction during labor, responsible for milk let down reflux in response to suckling. Okay. But also it modulates fear, anxiety, social bonding. Okay. Mood and depression. And that is what we have. When you increase secretion by, so oxytocin, increased secretion occurs when there is a stretch to the cervix. Okay. And also with the suckling, it increases. So suckling at the lactating breast would increase oxytocin. And when you increase the stretch of the cervix, when there's a stretch to the cervix, let's say in labor, it's going to cause increase in oxytocin. Okay, that's there. So modulates all that we talked about it. Great. Now, one thing which isn't mentioned here, you can also think about the analogs that are used. So analogs of oxytocins are used for induction of labor, or to introduce labor. Okay, induction of labor, or to introduce labor. Okay, and in response to suckling, what they are doing is these oxytocin will work on myoepithelial cells in the breast. That's important. Myoepithelial cells. These are contractile muscles. These will contract, leading to milk let down. So myoepithelial cells in the breast. Now looking at prolactin, which is again known as PRL, it would decrease GnRH and also would lead to stimulates the lactogenesis, which is basically saying milk production, right? So again, if you think about it, milk is produced by prolactin, but it will not let down, meaning you will not go into lactation unless there's oxytocin there. Although milk is produced, not going down because no oxytocin. Okay, two important concepts. So pituitary prolactinoma now, when you have a lot of prolactin, with this adenoma being there, is going to cause amenorrhea, osteoporosis, hypogonadism. Why? Because it's decreasing GnRH. And galactorrhea. Why galactorrhea? Because this it's not in a normal physiologically high prolactin. It's just it's a pituitary adenoma, prolactinoma, right? So it's going to cause galactorrhea here. But breastfeeding will lead to increase in prolactin, Breastfeeding, normal physiological breastfeeding will cause increase in prolactin, and it will lead to decrease in GnRH, which will delay the postpartum ovulation, which is natural contraception. So sometimes you will think, you will see that this prolactin is a natural contraception. Why? Because when you have increase in prolactin, okay, in the breastfeeding woman, that's going to cause decrease in GnRH. When you decrease GnRH, you're decreasing FSH and decreasing LH. When you decrease FSH, LH, you don't have ovulation. So that is the natural contraception. Okay, the next one here, we have the somatostatin. Somatostatin there are a couple names to it right here. GHIH, which is growth hormone inhibiting hormone, right? So remember, GHIH is also known as somatostatin. Okay, this guy, as the name suggests, this is growth hormone inhibiting hormone. So it's going to inhibit that growth hormone, causing decrease in growth hormone, and also going to cause decrease in TSH. Okay, and I'll talk about the odds, which are the odd things here. Decrease in TSH is done by here and also here, and we'll talk about that in a bit. So somatostatin GHIH, there is an analog known as octreotide, which is also a somatostatin, which is also a GHI, but this is a analog, right? You could give it from outside as a drug. Okay, the next thing we have is TRH. TRH is thyrotropin releasing hormone. Okay, and that is going to increase TSH, and that will cause increase in prolactin. Increase in TRH, which is thyrotropin releasing hormone, example in primary or secondary hypopituitarism, may increase prolactin secretion. Why? Because when you increase this guy, it's going to, when you have this TRH, it's going to stimulate the prolactin release, and for sure you're going to go into prolactin secretion, causing galactorrhea. Here's a schematic diagram here. You can see a basophil, again, basal blue. Blues are going to be your CRH, GnRH, and TRH. Well, for the eosinophils, which are eosinophils, which are pink. Here we have GHRH, dopamine inhibiting the prolactin and all that. Okay. So now let's revise this quickly and move on to the next. Here it's a simple thing, not but very high yield. You got to know the normal physiology, right? So here the ADH is all about increase in water resorption, right? And alcohol, what's going to happen? You're decreasing ADH, causing polyuria, leading to dehydration. CRH is corticotropin releasing hormone, which will stimulate the POMC, which will lead to increase in not beta ICG, but ACTH, MSH, and increase in endorphin. Glucocorticoid use is decreasing CRH. Prolactin inhibiting factor will for sure inhibit prolactin. Just remember this: whenever you have a prolactin now, if the something is stimulating prolactin, TSH will also be stimulated. For example, here, if something is inhibiting prolactin, the TSH will also go down. We will see that in prolactin how that is working. But here, just remember on top of your head, okay, TSH is correlated with the prolactin. So prolactin inhibiting factor, PIF, is inhibiting prolactin, so it will also decrease TSH. TRH is stimulating TSH, right? So it's also increasing prolactin. Okay. Now GHRH, GH again is growth hormone, the bigger H, right? Growth hormone, releasing hormone, increasing GNRH. Within N, it's the gonadotrophin, so increase in FSH, LH, MSH, melanocytes, increase in melanocyte oxytocin, contraction, uterine contraction, and milk letdown reflux by suckling. Prolactin, milk production, which is lactogenesis, and decreases GnRH. somatostatin, which is octreotide or GHIH, and that is just going to decrease the growth hormone and also decreasing the TSH. So this is a TSH being low with the growth hormone, but not high with the GHRH. So a little different thing here. Other than that, that's pretty much it. Now let's move on to the actual details of each hormone. All right, let's talk about now the growth hormone. Now the growth hormone is the other name for growth hormone is going to be somatotropin. So let's just write that down here. Somatotropin. So a lot of somato, right? And we will differentiate how the names are different. For example, somatotropin is a growth hormone, while somatostatin is the octreotide, which is inhibition of the growth hormone releasing hormone. So somatostatin versus somatotropin, important thing. Or the other name for growth hormone is going to be pituitary somatotrophs. Pituitary somatotrophs. Okay. So that's important. Next thing is, as I mentioned, also called somatotropin, secreted by anterior pituitary. You already know that. It stimulates linear growth, high yield, and muscle mass through the IGF-1, which is insulin-like growth factor 1. Insulin-like growth factor 1, which is known as somatomidin or somatomedin. I don't know how you want to call it, but somatomidin C. So let's just write that down here. Where is it? Somatomidin C. Okay. It is secreted by liver. So this guy is secreted by liver, IGF-1. Now it is released so growth hormone is released in pulses in response to GHRH. Secretion is increased in deep sleep, hypoglycemia, stress, puberty, and exercise. So all these conditions, I mean, think about it, hypoglycemia. So think about a child. Think about a child who's not going into hypoglycemia. I mean, this is one of the factors. For example, he's eating all the time. So growth hormones not released. I mean, it is released where in the sleep, in the stress, in the puberty, and exercise. So a child who has obesity, eating all the time, is not going into hypoglycemia, is not exercising. So the only factor which is going to release that growth hormone in a child is either the deep sleep or the stress, which a child might not get into stress, or it might go into stress, who knows. But deep sleep is the only thing. So with obesity, the linear growth of a child, muscle mass of a child. What about the linear growth, bone growth, the height of a child? So sometimes we think the food, the more we eat, the more we're going to grow. Well, that's not the case physiologically. I mean, as far as right now we can think of course, there's going to be a lot of papers on it. So we're just trying to, think more and more, dive into some discussions here, right? So hypoglycemia, wow, I mean, this amazes me all the time. Okay, hypoglycemia causing growth hormone, causing increase in linear growth of a child, having a more heighted child. Wow, amazing. But next we have the secretion that is decreased. Well, secretion decreased by aging for sure. I mean, with aging, decrease. Obesity, see, here you go, obesity. We were talking about this hyperglycemia. We were talking about it right now. Obesity, hyperglycemia, and for sure somatostatin, which is octreotide, and the somatomidin, which is the regulatory molecule secreted by the liver in response to growth hormone acting on the target tissues. So this guy, IGF-1, which is insulin-like growth factor 1, is going to give a negative feedback to two things: anterior pituitary and to his boss, which is the hypothalamus. They're like, it's the same thing as what? As testosterone, because it's giving two negative feedbacks. Growth hormone itself is giving two negative feedbacks, same thing as testosterone. So why am I keeping these previous discussions here? So we know, okay, three things doing the same, almost this similar way of negative feedback. Okay. Then we have this thing called excessive secretion of growth hormone, which is also a problem. For example, in pituitary adenoma, may cause acromegaly in adults and gigantism in children. In children, it's going to be gigantism. In adults, it's going to be acromegaly. Can't fit the hat size. The ring is getting shorter. The hands are getting bigger. The voice tone there's deep voice tone. Joints problem. Adults. In children, they're just big, humongous. Okay, because there is no fusion of this epiphyseal bone plates. We'll talk about that when we see growth hormone pathologies. But treatment-wise, we have, again, what we want to give is we want to give growth hormone inhibitor, so somatostatin analog, like octreotide or surgery, that could be as for the treatment. So let's take a look at this now. Here we have sleep, hypoglycemia, stress, puberty, and exercise would stimulate growth. This is hypothalamus. It would stimulate the release of GHRH, growth hormone releasing hormone, which is going to stimulate the anterior pituitary. And anterior pituitary is going to secrete growth hormone. Simple. Right? Now, that growth hormone does a lot of things. Now, there is a question now. What does it do directly and indirectly? So directly is going to the adipose tissues and to the liver. Okay, that growth hormone directly is stimulating the liver to produce IGF-1, nothing else. And in the adipose sites or adipose tissue, it's increasing lipolysis and decreasing glucose uptake. Okay. So when you say it's decreasing glucose uptake, that means that you will have increased glucose in blood, right? And that is known as diabetogenic. So this hormone is also known as diabetogenic hormone, okay? Because it's increasing blood sugars, increasing glucose in the blood. It is also known as it is anti-insulin. Why anti-insulin? Because it's keeping the sugars in the blood, while the insulin, the main function of insulin is, the only function for the insulin is to put that sugar back from the blood into the tissues, in the peripheral tissues. That's insulin. But when you're anti-insulin, you're trying to keep that sugars within the blood. So it's a diabetogenic, it's anti-insulin. Okay. Okay, so that's what we have. Okay. And then this is the main function, right? Not the main function, but this is the direct function, I should say, right? A direct function of growth hormone is on adipocytes, causing increase in lipolysis and decreasing glucose uptake, anti-insulin effect, and IGF-1 secretion. Now let's talk about IGF-1, which is the major thing here. So majorly is going to work on bone and on the muscles. On the bone is going to cause every single thing increase amino acid uptake, increase protein synthesis, increase DNA, RNA synthesis, increase carnitine sulfate, increase collagen, increase cell size and number. Now, the major thing is you need to know is increase in linear growth. That's it. Increase in linear growth. And whenever you see anything increase, decrease, everything is increased by the IGF-1, right? And that's when you increase the linear growth, that's called a pubertal growth spur. Pubertal growth spur. Okay. And stimulate the chondrocytes in physis, epiphyseal growth plate. Okay. It also stimulates, which is mentioned here, carnitine sulfate, and also stimulates this chondrocytes. Chondrocytes in the physis. which leads to epiphyseal growth, increase in epiphyseal growth plate, which gives you the increase in linear growth, which is the growth of the bone. Okay, so that's for the linear growth through the bone. Now let's look at the when you're increasing the bone, you also want to increase the muscle mass, right? So it's going to cause increase in muscle mass. One word, increase in muscle mass. How? By increasing protein, for example, increasing protein synthesis and increase in amino acid uptake. You take up amino acid, you cause them to increase protein synthesis. So that is going to increase a lean body mass. Lean body mass. Also increases organ size. Organ size. Okay. So in the muscle, you're increasing lean body mass. In the organs, you're increasing the organ size. So that is what we have. And that is pretty much it. Now, some other things are one thing that you have to know, which is not here. That is going to be, so you have, and let's just draw it like this. So you have insulin on one side, which wants to, take out that glucose from the blood and put it in the periphery. While there are other hormones, counter-regulatory hormones. These counter-regulatory hormones, they are just going to increase. They want to have the glucose within the blood. And what are those hormones? Those hormones are your growth hormone, your glucagon. You also have your epinephrine, and you have cortisol. So all these hormones, look at the level of insulin. I mean, insulin is only one versus like 4, 5. Amazing. Wow. And these guys, if they come into the bloodstream, they want the blood to have that glucose. And that's why they're called diabetogenic anti-insulin hormones, as they will increase the glucose within the blood. So the question is how they do it. Let's talk about that as well. So they increase blood glucose by increasing gluconeogenesis. So let's just put it here. Increasing in gluconeogenesis, meaning formation of more and more glucose. Neogenesis, right? By increasing in glycolysis or glycogenolysis, to break down that glycogen and to have that glycogen back into the bloodstream, causing more glucose in the blood. Glycogenolysis. Two things, right? Other things are increasing lipolysis. They're like, hey, fat, we need to cut you down. We want to have everything within the blood. There's a party going on, right? Everything in the bloodstream, lipolysis, lipolysis, right? The next thing is ketogenesis. With a lot of that fat in there, you also have ketogenesis going on. Formation of ketone bodies. So look, you have more and more glucose. On top of that, you have ketogenesis there, thanks to these counter-regulatory hormones, growth hormone, glucagon, epinephrine, cortisol. Okay, and that's pretty much what we have. Now let's talk about last point. Let's just erase this point. And that is about growth hormone. So we talked about access, right? We said growth hormone access, adults, acromegaly, gigantism in children. What about deficiency? If you have a growth hormone deficiency in a child, it's called dwarfism. Dwarfism, which is failure to growth, right? Short stature and delayed puberty. Short stature and delayed puberty. That's within a child. Now in adults, what you're going to have is this growth hormone that you will have increase in fat. And why do you have increase in fat? Because remember, growth hormone was doing lipolysis, breakdown of fats. So when you don't have a growth hormone, which was breaking down the fat, now you have a lot of fat, increase in fat, right? And that increase in fat, with low muscle mass, so decrease in lean body mass, known as, now you will have called it central obesity. Central obesity is there, right? Uh, so for the adults, for the treatment wise, for the whole growth hormone deficiency, treatment is going to be your synthetic growth hormone. You just want to get from outside synthetic growth hormone, and that should treat the problem. And that is all for growth hormone. Let's just quickly go over this and move on to the next. Okay, so growth hormone, simple. Growth hormone is going to be, first of all, got to know the names, right? Growth hormone, also known as somatotropin. Remember, you have a tropin and you have a statin. Statin is inhibition, while tropin is the same name. And midin is IGF, which is here. Okay. It is released by anterior pituitary. It stimulates the linear growth and muscle mass through IGF. IGF, look, linear growth, muscle mass. Increases insulin resistance, diabetogenic. We talked about it like in depth, how it is insulin resistant, diabetogenic. Release in pulses, anything pulsatile will stimulate the growth hormone, but if you give a continuous, it will not stimulate growth hormone. So pulsatile response of this GHRH coming down will stimulate and release of growth hormone. Secretion is increased in sleep, hypoglycemia, stress, puberty, exercise, and secretion would decrease with aging, obesity, hyperglycemia. Now, somatomidin, which is going to be a regulatory hormone, is going to inhibit the secretion, and growth hormone itself inhibits its secretion. And IGF-1, which is insulin-like growth factor, comes from liver. So guess what? If you have a liver problem, let's say there's cirrhosis or something, you will not be able to make IGF. And there's going to be a lot of fat deposition. Fat, why? Because you don't have lean mass. So only fat is there. Central obesity. Okay. Excess secretion of GH, for example, in adenoma, pituitary adenoma, will give you acromegaly if in adults, and gigantism in children. Treat by inhibition of that GH or by surgery, remove that adenoma. While in deficiency in a child, you will have dwarfism, and in adult, you will just have central obesity with increased fat content. Increase in fat is going to be increase in LDL and increase in cholesterol. Okay, and that is pretty much it for growth hormone. Okay, one more thing, my bad. Last thing, actually, very high yield. How does it stimulate in the liver? That's through the JAK-STAT pathway. Through the JAK-STAT pathway. So growth hormone works through the JAK-STAT to release IGF-1, which is somatomidin, which is in the middle. Midin, just think about it that way. C, okay, and nothing else. Let's move on with the ADH. ADH, also known as vasopressin. The source of this ADH is synthesized in the hypothalamus, in the supraoptic and paraventricular nuclei, stored and secreted by the posterior pituitary. So it is made where? Again, important thing is hypothalamus, but it is stored where and secreted from the posterior pituitary, not made in posterior pituitary, while the other hormones are made in the anterior pituitary. Okay, the stimulation comes from hypothalamus, but they are made here in the anterior pituitary. This guy and the oxytocin are not made here. They're made in hypothalamus. Okay, function-wise, it regulates the blood pressure. Why the V1? So there are two receptors, V1, V2. For the V1 as the one for the blood pressure, and V2, there are two L's, so osmolality, right? Primary function is serum osmolality regulation. ADH decreases serum osmolality, increases urine osmolality. Again, simple thing. We will talk about that. Okay, let's read first. While regulation of aquaporin channels, insertion in the principal cells of the renal collecting ducts. Okay, so is there a picture here? No picture. Great. All we have is a V1. Remember, 1 for 1L for blood vessels. V2, 2Ls for osmolality, right? Why? Because it's going to insert that aquaporin channels in the principal cell, causing to draw more and more water, reabsorbs more water, and that is going to decrease. That when you increase the water content in the blood, that is going to decrease the serum osmolality. When the water content in the urine is low, this urine osmolality is going to be high. That's what it's mentioned there. So decrease serum osmolality, increase in urine osmolality. Simple, right? ADH level is decreased in central diabetes insipidus. Again, ADH level is decreased in central. Central means coming from top. There's low ADH because you have a problem in the either hypothalamus or in the those neurophysians anywhere along the line of the brain. So you have a central problem, and that central means you have low ADH. Normal or increased level in nephrogenic. Nephrogenic means you have a problem in the kidney. Either they're resistant, either something is wrong, it's not working. So you have increase in ADH, but they're not working, meaning you have a kidney problem. So that's going to have an increase in ADH. But both are going to have this diabetes insipidus because in central you're not making enough, or you have a problem in the formation, in the making, in the production of ADH, while in nephrogenic you have the problem in the kidney, so there is no working of ADH on its receptors. So in both cases, both are causing DI, which is diabetes insipidus, but the only difference is in one you have in central you have you have decreased ADH because you can't produce it, while in nephrogenic you have more or normal ADH. So that's ADH is a different thing that you have to think of. Now desmopressin ADH analog is a treatment for central DI and nocturnal enuresis. Okay, again, desmopressin ADH. When you give ADH to a patient, guess what's going to happen? You're reabsorbing water. When you're reabsorbing water, they're not going to go into diuresis. So a nocturnal enuresis is bedwetting, so you will not go into bedwetting. Okay, because more and more water is reabsorbed. Simple as that. But you got to know the drug, which is called desmopressin, ADH analog. Vasopressin is a potent vasopressor that can be used to increase organ perfusion in septic shock. Okay, septic shock, vasopressin, you want to have a vasoconstriction, so you have more and more organ perfusion. You can use it in septic shock. Okay. So with this, let's talk about one thing, which is when it acts on these blood pressure V1 receptor, that's going to cause. Okay, one thing. Wait. Before we talk about that, let's talk about desmopressin here. Desmopressin is specific to V2 receptor only. So it has no function on V1 receptor. When it has no function on V1 receptor, guess what's not going to happen? You will not see a vasoconstrictive effect of V1 receptor stimulation. So there is going to be no vasoconstriction. So when you have no vasoconstriction, there is going to be no effect on blood pressure, on BP. So again, desmopressin, V2 receptor, selective V2 receptor agonist. It's also known as desmopressin, also known as DD. Let me write it down. Desmopressin, DDAVP. Okay, it is selective V2 receptor, and it is selectively going to work on these V2 receptors, which are in the principal cells of the renal collecting ducts, increases in the aquaporin channels, and that when you increase those aquaporin channels, you are going to reabsorb more water. And when you reabsorb more water, you will have a low water in the urine. That's going to cause increase in osmolality of the urine. And when you're reabsorbing water, you will also that water is going to into the serum, causing low serum osmolality because that water is diluting the serum. So here's those two things. What else we can think of here? Let me see if there's anything important. Yeah, one more thing is going to be how they're working, which is again a high yield. So V1 and V2, right? So V1 would activate. So when the ADH stimulates these V1 receptors, it has to activate IP3 calcium, IP3 and calcium messenger system. So IP3 calcium messenger system, which leads to, again, when you increase the whole thing, the endpoint is going to have increase in calcium, and that is going to cause smooth muscle contraction. So arteriolar, let me write it down, arteriolar smooth muscle contraction. When you stimulate that smooth muscle contraction, you're going to cause increase in blood pressure. Okay. And that's with the V1. Let's write about the V2 now. V2, on the other hand, activates adenylate cyclase. So activates AC, which is going to increase cyclic AMP. And that increase in cyclic AMP causes the insertion of those aquaporin channels in the principal channel in the renal collecting ducts. And that causes water reabsorption, which leads to, again, decrease serum osmolality and increase urine osmolality. Simple. Let's talk about now the regulation. Regulation of ADH is done through plasma osmolality and hypovolemia. So plasma, as you increase the plasma osmolality, it stimulates. So actually, let's read this here from this picture. When you increase the serum osmolality or decrease the volume in the serum, so hypovolemia, but the primary is again the osmolality, okay? So when you do that, that's going to stimulate hypothalamus. That is going to cause the release of ADH. ADH through the storage point, which is the posterior pituitary, gets released into the bloodstream, causes medullary collecting duct aquaporin channels. Again, we calling it medullary because they're in medulla, and they're the principal cells of the collecting ducts. And that is going to cause more and more water reabsorption, and that is going to cause decrease in urine volume, and with that you will also have increase in urine osmolality. Because you're absorbing water, again, it's going to increase the serum volume and it's going to decrease serum osmolality, and this guy would also inhibit the release of ADH. So high yield points are going to be your plasma osmolality and hypovolemia, but primary again is the osmolality. And that is going to be all for ADH. Let's quickly review this. In ADH, we talked about it's known as vasopressin. The analog is going to be desmopressin or DDAVP. It is selective for V2 receptor. So there are V1, V2. V1 is blood vessels causing arteriolar contraction, causing increase in blood pressure, while the V2 is for the osmolality. Because the primary regulation, the question is, why is ADH secreted? Well, the ADH gets secreted when it gets stimulated when there is increase in osmolality. So the whole job of ADH is to decrease that osmolality, serum osmolality. And it does that by coming and going into the kidney, causing aquaporins, causing the insertion of those aquaporins, which lead to increase in water reabsorption, and that causes decrease in serum osmolality, and that would eventually inhibit that ADH secretion. And that is all for ADH. All right, now let's talk about prolactin. Prolactin, other names are going to be again going to be pituitary lactotrophs. Okay, let's look at the source. Source is mainly bind to pituitary, right? Structurally homologous to growth hormone. So again, it is structurally homologous to a growth hormone. Function of the prolactin is to stimulate milk production in breast, inhibit ovulation in females, and spermatogenesis. And in males, spermatogenesis in males by inhibiting GnRH synthesis and release. So two things. One, it's causing milk production. Second thing, it is decreasing GnRH, which leads to inhibits ovulation and inhibits spermatogenesis. Ovulation in females and spermatogenesis in males. Two things, right? So, but when you have an excess amount of prolactin, which is associated with when you have an excess prolactin causing galactorrhea, amenorrhea, infertility, osteoporosis in females, gynecomastia, again, infertility, decreased libido and input. Okay. So infertility, decreased libido and impotence in males. Well, in females, we are looking for galactorrhea, amenorrhea, infertility, and osteoporosis. So two different things, two different genders. Okay. What are the regulations of prolactin? Prolactin secretion from the anterior pituitary is tonically inhibited by dopamine. Okay. What does tonically inhibited mean? Meaning continuously. Continuously is inhibited by dopamine. From where? From tuberoinfundibular pathway of the hypothalamus. Prolactin in turn inhibits its own secretion by increasing dopamine synthesis and secretion from hypothalamus, which we will see here. TRH increases release of prolactin secretion, example, primary, secondary hypothyroidism. Again, we did talk about how TRH leads to release of TSH, which is a thyroid hormone stimulation, right? Thyroid stimulating hormone. But we also said TSH is also going to be closely associated with prolactin. So if you increase TSH somehow, you're going to increase the release of prolactin. If you decrease TSH, you're going to decrease prolactin. So here's the same thing. TRH, which is essentially going to stimulate your TSH, will also stimulate the release of prolactin, known as prolactin secretion. And why would you have TRH being there? In hypothyroidism, increase in TRH, primary or secondary, doesn't matter, but you have hypothyroidism that's going to cause increase in TRH. Dopamine has a stronger, but the problem now here is dopamine has a stronger effect on prolactin regulation than TRH does. So dopamine is like a proper holding down prolactin release, which we'll see in this picture. Let's look at the picture first. Okay, look, so we have a hypothalamus. Hypothalamus, we have a dopamine. Dopamine is always, let's say dopamine is there. And dopamine is always, whenever it's there, is going to inhibit the release of prolactin from anterior pituitary because it's there. So it's always, as we said, it's tonically, all the time, it's tonically inhibited by dopamine. Simple. Where is dopamine coming from? It's coming from tuberoinfundibular pathway. And if you want to know that, go back to CNS. There's a proper nice picture of tuberoinfundibular pathway of hypothalamus. Okay, that releases dopamine here. And so one thing we learned, dopamine is there and that inhibits this prolactin secretion. Well, the TRH, again, coming from hypothalamus, if it's there, it's going to stimulate. But we learned that dopamine has a a more effect than TRH. So even if you have a TRH, but if you have dopamine there, it still is going to be inhibited unless you have more and a lot of TRH there. So let's talk about how, first of all, TRH is stimulating prolactin. So let's take a look at this. So in hypothyroidism, what's going to happen is you have increase in hypothyroidism. Again, you have a low T3, T4, low T3, T4. The body's like, hey, we need to make some thyroid hormones. Okay, so we need to secrete TSH. But in order to stimulate TSH, you need TRH coming from hypothalamus. So you have an increase in TRH that stimulates TSH, and that leads to stimulation of T3 and T4. So let's go back a point here. Hypothalamus causing release of TRH. That TRH is going to stimulate, again, TSH, and that is going to cause, first of all, TSH is coming from anterior pituitary, as the TRH is coming from hypothalamus. And then it's going to go on to the thyroid itself and stimulate the thyroid T3 and T4 secretion. And other than that, this is normal physiology of TRH. But now the thing with this TRH, let me change color, is that TRH is going to stimulate not only the TSH in the anterior pituitary, but also it's going to stimulate receptors of the lactotrophs, which leads to prolactin, increase in prolactin. Okay, so that is there. But again, coming back to this point, that dopamine has a stronger effect on prolactin regulation than the TRH does. So TRH does not have a strong regulation on it. So dopamine is the main guy. Okay, so now looking at this picture, some other things that we have is when the baby is hungry, the baby cries. When the baby cries, the higher cortical center is going to inhibit hypothalamus, which inhibits the dopamine, releasing. When you inhibit dopamine, there is increase in prolactin. That increase in prolactin causes milk production. Okay, but there are so many other things that are going to be associated with prolactin. So let's talk about those. Medications. Whatever is going to inhibit dopamine will lead to increase in prolactin. Medication. Let's talk about some medications here. Dopamine antagonists. Most antipsychotics are dopamine antagonists, like metoclopramide. For example, metoclopramide, and estrogens. Example, OCPs have estrogen. Pregnancy also have estrogen. They all lead to prolactin secretion. So medications, chest wall injury via ANS will also inhibit the release of dopamine, causing increase in prolactin. Nipple stimulation. Again, what is this? It's called breastfeeding. Breastfeeding, nipple stimulation, suckling response of a child will also inhibit the release of dopamine. Okay. So for the medication, just remember, we talked about antipsychotics and antidepressants also. So antipsychotics and antidepressants, they both have anti-dopamine. So whatever medication you think of, which are these two, antipsychotic and antidepressants, which are dopamine antagonists, will cause increase in prolactin. Okay. What else we can think of? Again, we are trying to see who's increasing prolactin, right? Just keep that in head. Who's increasing prolactin? Medications, we talked about. These three things we did talk about. Other things are verapamil. Verapamil is a selective cardiovascular calcium channel blocker. So it's only one. It's a calcium channel blocker. Let's just put it here first. It's a calcium channel blocker, verapamil, that will also increase in prolactin. And this metoclopramide, which is antiemetic, also would increase the prolactin. What else would increase prolactin? We talked about primary, secondary hypothyroid. That would eventually lead to increase in TRH, and that would stimulate the release of prolactin. OCPs, pregnancy, which is basically estrogen, which also leads to release of increase in prolactin. So again, estrogen, main thing here, increases prolactin release. Now, one thing which isn't mentioned here is the GN. They said up top that the growth hormone with GH is structurally homologous, right? So GH co-secretes PRL, which is prolactin. Okay, now one thing which is abnormality, which is renal failure. When you have a renal failure, so again, prolactin gets eliminated by the renal failure. So when you have a renal failure, you have more and more prolactin. So you have more prolactin when you have renal failure. Okay, so now we did talk about how we have increase in prolactin. Now here, if you have increase in prolactin, it's going to cause two things. It's going to inhibit GnRH. Now, this is the normal function of GnRH. What was GnRH doing? Stimulating FSH, stimulating LH, causing ovulation, causing spermatogenesis, right? And when you knock this out, because now you're inhibiting GnRH, you are going to have the things we talked about, for example, amenorrhea, infertility, decreased libido, and decrease in estrogen. Okay, now we all know this now. But now the next thing is it also stimulates. So it inhibits one thing, it stimulates one thing. The other thing it stimulates is going to be milk production. Now, there's going to be an important point here that the milk production, let's talk about it actually. So milk production, so this prolactin is going to stimulate lactation in pregnancy, right? Or lactogenesis, or milk production in pregnancy, right? Now let's talk about what's happening in pregnancy. That's very high yield actually, and very simple. So in pregnancy, what's going on here is in pregnancy you have placenta. Now that placenta releases progesterone. That progesterone, pregnancy, again, placental progesterone inhibits the lactation. So let me just do this here. Inhibits lactation. So the milk doesn't let down in pregnancy. So milk does not let down in pregnancy. In pregnancy, okay? So this guy, okay, look at it. Prolactin, change color here. Prolactin is stimulating milk production. Okay, a lot of milk has been produced, but now we need some physiological factor which would not let it let down, meaning it will not let it milk. There will be no milk let down while it is greatly being produced. How do we do that? Well, nature. You have a normal homeostasis, you have pregnancy, you have placenta, which releases progesterone. High yield, that progesterone inhibits the milk letdown. So guess what? When you don't have placenta, when the baby gets delivered, the placenta also gets delivered, you don't have any more placental progesterone, and you have suckling, and that causes oxytocin. So the milk will come down. So after pregnancy, let me write it here. So after pregnancy, what's going to happen is you have decrease, or you will not have anything here, because when you don't have placenta, you will not have progesterone. So when you have a decrease in the progesterone, after pregnancy, that is going to cause uh, that is going to not inhibit that letdown of the milk. So after pregnancy, oxytocin can easily cause the milk letdown. Okay, that's all for this one. But now important point was only one thing, that was a placental progesterone inhibiting the lactation while in pregnancy. And that was the important point. Other than that, you have what else you might have? Okay, some other things. Let me just talk about them here as well. That is that it causes gynecomastia, right? Gynecomastia in males. So what's really happening is that you have, when you increase the estrogen. So let's take a step back. I should tell you the whole story here. So increase in estrogen to testosterone ratio will lead to gynecomastia. Okay. If you have a normal, let's say if you have a normal testosterone, that should inhibit the gynecomastia. So again, what is the pathophysiology of gynecomastia? When you have increase in estrogen in males, then the testosterone ratio, that's going to cause gynecomastia. Okay. And that's pretty much it. Let's quickly review this so we can move on to the next part. Okay. Prolactin. Well, prolactin, it is from anterior pituitary, two things. One, milk production. Second, decreases in GnRH, which causes ovulation, and inhibits the ovulation in females and inhibits spermatogenesis in males. But when you have an excess amount of prolactin, which is seen in, when would you have excess amount? The most common pituitary adenoma is prolactinoma. That's also high yield. Most common pituitary adenoma is your prolactinoma. Prolactinoma is going to secrete a lot of prolactin, and these patients are going to present with so let me just put it here. So you are going to present with, in females, you have galactorrhea, amenorrhea, infertility, osteoporosis. But in males, you're looking at gynecomastia, infertility, decreased libido, and impotence. But on top of that, also you will see loss of peripheral vision, and a mass effect. So because you have prolactinoma, which is a mass, so you will have a mass effect. Mass effects are going to cause headache, and that's loss of peripheral vision, which is the bitemporal heminopsia. Because that mass, when it compresses the optic chiasm, let me draw optic chiasm quickly so you know what I'm talking about. So you have an optic chiasm here. This is the optic chiasm, roughly. So when you are going to have a mass which is going to sit on this optic chiasm, is going to compress that. When you compress the optic chiasm, you are going to get bitemporal hymenopsia, which is you will not be able to see the temporal sides. So the sides will not be seen. So bitemporal, again, temporal meaning periphery. So loss of peripheral vision will be there. And on top of that, you will also have signs and symptoms of increasing prolactin, which are all right here. Okay. As for regulation, we have prolactin secretion from anterior pituitary, tonically inhibited by dopamine. Prolactin in turn inhibits its own secretion, which is a negative feedback, by increasing the synthesis of dopamine and secretion from the hypothalamus. TRH would also increase prolactin secretion, but dopamine has a higher, stronger effect on the prolactin. Now, important point is going to be something called as damage to the pituitary stalk. So let's talk about that as well. A clinical tie-in that if you were to damage this stalk, which is known as pituitary stalk, right? Pituitary stalk. This right here. This can lead to, if you have damage here, now what's going to happen is it will lead to inhibition of all anterior pituitary hormones except for prolactin. Except prolactin. Why? Because remember that from this pituitary stalk, dopamine was coming and inhibiting the release of prolactin. So when you lose the stalk, now the dopamine can't come down. So there's going to be increase in prolactin. So there's going to be increase in PRL, prolactin. That's one thing. And the second thing is going to be one more thing here. Clinical tie-in is during pregnancy, you have increase in prolactin throughout the pregnancy due to estrogen stimulating. So you have increase in pregnancy that causes increase in estrogen, which is mentioned here in the book. So you have pregnancy that causes you have increase in estrogen during pregnancy that stimulates the prolactin release, but doesn't cause lactation. Again, it's going to cause milk production, but there is no lactation because lactation is inhibited by PP, which is placental progesterone. Again, look at how amazing this is physiologically. Estrogen doing one thing, beneficial. Progesterone doing again same thing, beneficial, but total opposite way. Amazing. Okay, and finally, when you don't have placental progesterone, you will not be inhibiting the lactation, and after the birth, you can have the lactation. Okay, and that's going to be all. One last thing, actually, for the treatment of prolactinoma. What is the treatment for prolactinoma, which is the most common pituitary adenoma? Well, the treatment is going to be either you can give a dopamine agonist, which is cabergoline, or because it's a prolactinoma, it might not function, right? So you have to do something called as transsphenoidal surgery. And that is going to be all for prolactin. Moving on with the thyroid hormone. So thyroid hormone, it produces T3 and T4. T3 is iodothyronine, and thyroxine. These are all iodine-containing hormones that control body metabolism rate. Body metabolism, right? What is the source of these hormones? Well, they are coming from the follicles of the thyroid. Okay, let's see the follicles here. Okay, no follicle, but here, if I just roughly tried, there are follicles through which these hormones are produced, and I think we will see that in the pathology section. But follicles of thyroid. So you have an hormone which is known as 5'-deiodinase, which converts T4, the major thyroid product, to T3. Let's take a look at that. So you have, here's the T4, and here's the T3. So 5'-deiodinase in the periphery converts the T4 into T3, T4. Okay. And also uh, gives rise to reverse T3, which is known as RT3. Now, RT3, let's mention about this guy. RT3 is inactive metabolite. It is just an inactive metabolite of T4. Okay, inactive metabolite of T4. Okay, so this is one hormone. Moving on with the next thing, what do we have? So the mnemonic that they have, 5, 4, and 3. 5 is all the way in the periphery. Then let's talk about the 4. 5 converts into the 4 and 3. This is pretty easy. I don't know why they have mnemonic, but 5, 4, 3. Okay, that makes sense. Peripheral conversion is inhibited by, now important thing is this, you could inhibit that conversion by glucocorticoids, beta blocker, and PTU, which is propylthiouracil. Okay, let's look at that now. So this enzyme can be inhibited by glucocorticoids, propyl PTU, glucocorticoids, and beta blockers. Okay, keep that in head, and we will read the next one now. Now, reverse T3 is a metabolically inactive byproduct of peripheral conversion of T4, and its production is increased by growth hormone and glucocorticoids. Okay, great. Functionally, we did talk about this one. So functions of thyroid peroxidase include a couple things here. First, we have oxidation, organification of iodine, and coupling of MIT and DIT. So again, oxidation, organification, coupling. It is inhibited by PTU, which is again propylthiouracil, and methimazole, which would also inhibit this. So DIT would lead to T4. When you add these two DITs, you will cause T4, leading to formation of T4. And what is DIT? Well, DIT is simple. It's a diiodotyrosine. Diiodotyrosine. Okay. And DIT plus MIT, what is that again? If it's D is di, the M is going to be the mono, right? Simple. So monoiodotyrosine. So when you add 2 and 1, that's going to be T3. Now, there's an important thing called Wolff-Chaikoff effect. Well, that is protective autoregulation. Why is it protective autoregulation? When you have a sudden exposure to excess iodine, which would temporarily turns off thyroid peroxidase. Now, the question arises that, okay, when you have, let's say you're saying, okay, let me just go back here, look in the picture. From blood, you have this iodine, iodine going into this thyroid follicular cells, right? From blood, it's just taking up all of this. So the question arises, when you have a lot of iodine, right? A lot of iodine, does it take everything? And if it takes everything in, then it's going to cause a lot of formation of T3, T4. So just because you have a lot of iodine in your, let's say, diet or something, or that's actually with the iodine being exposed in radiation. But here the question arises that, okay, if you have a lot of iodine, would everything be taken up? No, it's not, because of Wolff-Chaikoff effect. So Wolff-Chaikoff effect is a protective autoregulation, because when you have a sudden exposure to excess iodine, it temporarily turns off the enzyme, thyroid peroxidase. When you turn this enzyme off, you have a decreased T3, T4 production. And here's the thyroid peroxidase. Okay, so iodine, let's look at this now. So iodine gets in. Again, this is getting in here is again stimulated by TSH. TSH stimulates the receptor here, which causes the iodine to be taken up by the thyroid follicular cell, epithelial cells. And this is called sodium iodine symporter. Sodium, because sodium is coming in. Iodine, because iodine also coming in. Symporter, because both are going in. right? And that when the iodine is here inside the thyroid follicular epithelial cell, now that iodine goes out into the lumen of the follicular cell, and when it goes out, it forms I2, which is the oxidation. So you have oxidation here, organification and coupling. So with the oxidation, now you have formation of I2, which is known as now iodine. Iodine. Here, I minus here, I negative, is the iodide. Is the iodide. And formation of iodine occur when there's an oxidation. Okay. And the whole thing is just, there is one enzyme responsible for all of this oxidation, organification, coupling. Whole thing is done by one enzyme known as thyroid peroxidase. TPO, thyroid peroxidase. Okay. So TPO is there. Now there is another thing that is the tyrosine. You can see it right there. TG, tyrosine. This tyrosine, my bad, this is thyroglobulin, which, my bad, 1 second. This TG is thyroglobulin, okay, which has tyrosine residues attached to it. And you can see it by in this picture. Let me erase this. So this is thyroglobulin, and these guys have tyrosine attached to it. And why am I mentioning that? Just so that if you think about, if they say anything with the thyroglobulin and the tyrosine, you will just think about thyroid development of the thyroid hormones. Tyrosine, thyroglobulin are all there associated with the thyroid hormone production. Okay, so you have tyrosine. With the tyrosine, when the tyrosine adds to I2, which is the iodide, so it leads to MIT formation, which is the monoiodotyrosine, right? And with the D is the 2, so diiodotyrosine. Simple. Again, let me just write this simple thing to make it easy. So when the tyrosine plus I2 equals MIT, tyrosine plus iodine plus iodine leads to formation of DIT, which is diiodotyrosine. Simple, but not that important. Just know a little bit of that, and tyrosine and thyroglobulin, you should be good to go. Okay, so here now we're at this point, we talked about how the oxidation caused I2. Now what's going to happen is that you have organification and coupling. So organification is that to this thyroglobulin, what's going to happen is you have addition of that. Now we formed the MIT and DIT, that's called organification. MIT, DITs are now attached with those tyrosine molecules, right? Call it MIT, DIT. And then what's going to happen is called coupling. Now these guys will join together and they will form either T3, T4, and that's called coupling. So with the coupling, now you have T3, green is T4. Okay, and that then goes back. Endocytosis occurs. Now, if you look here, the entrance of the iodide was also stimulated by TSH. As same thing here, the endocytosis is also stimulated by TSH. So TSH has a major role in production of your thyroid hormones, right? And that's with this TSH being here stimulates the endocytosis of these hormones. And with that, you have proteases which will cleave down these hormones, T3, T4, send them in the blood, and will also put this back into this in these follicular cells, so it can go back into the follicular lumen, and there's a cycle full on that would just rotate again and again, and the product that we are getting out of it is T3, T4. Okay, with the T3, T4, we did talk about how you have now. Important question is that you have a lot of production of T4, okay, and lesser amount of T3, because when they go eventually, when the T4 goes into the effector organ, there's an enzyme known as 5' deiodinase, which will convert that T4 into more active metabolite, which is T3, and also reverse T3, which is inactive metabolite. So that T3 would lead to major function of the thyroid, major thyroid functions. Okay. So let's now, with that, let's read, and then we will understand it better. Give me 1 second. Okay, now let's just read the sources here. All right. So again, we talked about how the T3 till this point. Let's move on with this. Reverse T3 is metabolically inactive, right? And its production is increased by growth hormone, glucocorticoids. Again, whatever is going to inhibit this will increase inactive metabolite of it. Simple. The second thing was about thyroid peroxidase. 3 things are done: oxidation, organification, and coupling. Coupling is simple. You know, coupling means adding together. Organification is just think about when you're adding that iodine with the tyrosine molecule. Oxidation is when you are trying to have that iodide, converting that into oxidize it and make it iodine. Iodide to iodine, but not important. Remember 3 things: oxidation, organification, coupling. That's important, nothing else. Inhibited by the whole thing. The important thing is this thing. TPO is inhibited by PTU and methimazole. DIT, T4, DIT, MIT, T3, high yield Wolff-Chaikoff effect, which is protective, which would temporarily inhibit this TPO, which lead to a decrease in T3, T4. Let's talk about the functions. Now, the functions are that it's only free hormone is active, high yield, only free hormone is active, meaning whatever is bound to, it's not going to be active. So whatever is free is going to be active. T3 binds a nuclear receptor, again, high yield. Nuclear receptors. There are only few things which bind directly going to the nucleus and have their receptor over there. So that's one of the, that's just T3 is one of them. Binds directly to the nuclear receptor with great affinity. Then the T4 and T3 functions are going to be 7 B's, important: brain maturation, bone growth, which is synergism with the growth hormone and IGF-1. So bone growth is not only dependent on GH and IGF-1, but also your T3. Then you also have beta-adrenergic effect. Beta-adrenergic effect is because this increases beta-1 receptors in the heart. So when you have increase in beta receptors of the heart, more and more stimulation would cause, for example, if you have increase in catecholamines. So basically, let me write this down. So when you increase the beta-1 receptors on the heart, essentially you're causing increase in sensitivity of catecholamines, right? Because when you have the catecholamines come down, you have a lot of beta-1 receptors. When they get stimulated, it's going to cause increase in cardiac output, increase in heart rate, increase in stroke volume, increase in contractility. So if you were to block it by beta blocker, so you're alleviating all these adrenergic symptoms in thyrotoxicosis. Again, in thyrotoxicosis, you have a lot of TSH, T3, T4. That's going to cause more and more beta-1 receptor, causing all these problems. So you could just give beta blocker, block this receptor, and alleviate all these adrenergic symptoms. Okay. Basal metabolic rate, high yield. Basal metabolic rate is increased by the T3. How? Because it increases the sodium potassium ATPase pump. That when you increase sodium potassium ATPase, for example, you had, let's say, 5, now you're increasing to 10. The more you have, the more O2 is consumed. The more O2 is consumed, meaning more O2 is needed. When the more O2 is needed, your mitochondria is just going to take up all those ATP and make causing those ATP to run this channel. And ATP, again, you're breaking down all that glucose that you have, everything. So increasing basal metabolic rate. You're not running, you're not doing anything. It's a basal metabolic rate. Increase in ATP production because sodium potassium is ATPase channels. It is an ATPase channel, needs ATP, causing increase in O2 consumption, increase in respiratory rate, increase in body temperature. Okay, blood sugars, increase in blood sugars by increasing glycogenolysis, breakdown of glycogen, and gluconeogenesis, formation of more glucose. Break down lipids. When you break down lipids, that's lipolysis. Again, more lipids, more breakdown of fats. Stimulates surfactant synthesis in babies, important. It also stimulates the surfactant. So one thing important point is, see, it's increasing almost everything. But here, when you're increasing lipolysis, which is the breakdown of lipids, when you're breaking down lipids, you would have decrease in concentration of cholesterol and triglycerides. Decreased concentration of cholesterol plus triglycerides. And that is done through increasing LDL receptors in the liver. When you have increased LDL receptors in the liver, let's say this is LDL receptor, more and more LDL from blood is going to taken up by the liver. So low LDL is going to be in the blood, which is a good thing, right? And increase in cholesterol secretion in bile. So when the cholesterol goes into the bile, again, you're decreasing the total cholesterol. Okay. What else would be there? Surfactant, for sure, very high yield. In babies, that it increases surfactant, very high yield. Okay, let's talk about the basal metabolic rate again one more time. So basal metabolic rate increase by increase in sodium potassium ATPase, right? So what the T3 does is increases the synthesis of all these pumps, meaning increases the more and more pumps, right? So when you increase these pumps, more and more ATP is consumed because it's an ATPase channel. It's going to require ATP, and when you increase when you consume more ATPs, you need more oxygen. Consumption is going to be there, and the body temperature is going to go high. And respiratory rate would also go high because you have consumed more. So to provide enough O2, you have to go into increase in respiratory rate. That is going to be there. And I guess that's pretty much what we have. One more thing here for the brain maturation. It is in the perinatal period. So perinatal period. We will see how in pathology that how in the perinatal period, if we don't have any thyroid hormone, how in the perinatal period we will not have a brain maturation. So perinatal period requires T3 because mother's thyroid hormone T4 does the job during pregnancy. Why? Because you have mother T4, which would during pregnancy, which would not show any deficiency, but after that, it's going to be a problem if there is a problem, right? Okay, and that's going to be all here. Now, going on to the regulation part. Well, the regulation is TRH. Excuse me. TRH stimulates the TSH release, simple, that causes stimulation of follicular cells. These are the thyroid follicular cells. Thyroid stimulating immunoglobulin TSI may stimulate the follicular cells in grave disease, high yield. So TSI does the job of TSH in Graves' disease. Again, what was the job of TSH? Stimulate follicular cells. What's the job of TSI? Stimulate follicular cells. So in Graves' disease, you have TSI, which is immunoglobulin, which would also stimulate the follicular cells. We will talk about that in details later on, but just brushing up some superficial knowledge here. So negative feedback is primarily by free, again, because what we said, the free is the active. So when we have the active hormone, that is going to give a negative feedback. Either T3 or T4, both can do that. Anterior pituitary decrease sensitivity to TRH. Hypothalamus decreases TRH secretion. Again, let's take a look at this picture to see the negative feedback. So we have hypothalamus. Hypothalamus releases TRH, which goes on the anterior pituitary, stimulates the release of TSH. That TSH goes and stimulates the thyroid follicular cells, leading to release of T3, T4 to the effector organ. Now, T3, T4 are going to inhibit anterior pituitary as well as hypothalamus. With the anterior pituitary, what they're doing is they're like, hey, you don't need to be sensitive to this guy. We are already trying to stop this guy, but if it still is coming, we want you to be non-sensitive. Don't be sensitive to it, meaning do not get stimulated when the TRH is there. That's what is written there. Decrease sensitivity to TRH. In the hypothalamus, they're just saying, hey, man, decrease the TRH release, please. Simple. Okay. Other than that, you have this thyroxine binding globulin, TBG. Thyroxine binding globulin. This is the one which binds to most of the T3, T4 in blood. Thyroxine binding globulin, important. It is bound is inactive again, and what is free is going to be active. Simple. But when you increase, the important thing is when you increase the TBG, which is thyroxine binding globulin in pregnancy, OCPs, for example, estrogen would cause increase in TBG, would lead to increase in total T3, T4, right? So in anywhere you are increasing the thyroxine binding globulin, that is going to increase T3, T4, but only bound. And we said bounds are inactive, but they're still there, right? The second thing is if you decrease the TBG, which in case you're decreasing steroid use, nephrotic syndrome, in nephrotic, you're losing it, it's going in urine, okay? So this guy would cause decrease in total T3, T4, but again, they're all inactive. Now, important point is T3, T4 are only lipophilic hormones with charged amino acids and require specific transporters to diffuse into the cell, facilitated diffusion. Again, simple but high yield, that they are lipophilic, charged, and they require something. They require specific transporters to when they want to go into the cell. They can't just go like steroids. I guess they also have a receptor. But here, what we're talking about is they can't just diffuse in. They need the facilitated diffusion, require specific transporter. Okay, and that's pretty much all. Let's go through this. Okay, we're talking about thyroid hormone. Simple. Thyroid hormone is the T3 with the triiodothyronine and thyroxine T4. They're all iodine-containing hormone that control the body's metabolic rate. And the body's metabolic rate is controlled by increasing the synthesis of sodium, potassium, ATPase, which leads to increase in O2 consumption. Respiratory rate is increased, and body temperature is also increased. The source of this is simple from the follicles of thyroid. You have this 5' deiodinase, which converts T4 to T3, mnemonic 543. peripheral conversion could be inhibited by glucocorticoid beta blocker PTU, but not methimazole. Reverse T3 is just inactive metabolite of T4, and it could also be increased by growth hormone, glucocorticoid. Now, there is another hormone known as thyroid peroxidase, the major hormone for synthesis, does three things: oxidation, organification, coupling. It is inhibited by two drugs, PTU and methimazole. Important thing, Wolff-Chaikoff effect. It is a protective mechanism. It turns on when you have sudden access of the iodine, and it temporarily turns off the same hormone, which is the thyroid peroxidase, leading to a decrease in T3, T4. 7 Fs are going to be brain, bone, beta-adrenergic, basal metabolic rate, blood sugar, blood lipids, and surfactant in babies. Regulation is super easy. TRH stimulates TSH, which stimulates the follicular cells, leading to release of T3 and T4. Negative feedback by T3, T4 inhibit both hypothalamus and pituitary. Important thing is thyroxine binding globulin, which is increased in pregnancy and OCP use because estrogens are going to, the high yield estrogen causes increase in TBG, which leads to increase in total T3, T4. Steroid would decrease it, and nephrotic syndrome would also decrease it. T3, T4, they require a transporter to go into the cell. Okay. What else we can have? One more thing, important point is going to be your radioactive iodine. Radioactive iodine. It is in small, for example, if you were to give it in small dosage, which was actually used for imaging purposes, right? But the large, if you give in the large doses, it destroys the gland. And it is when it destroys the gland. So guess what? It is used in hyperthyroidism. Now, these large doses can also be released if there's a nuclear accident that is going to cause, first of all, it's going to cause radiation-induced hypothyroidism. One thing. Second thing is going to be a thyroid carcinoma. So when you have a thyroid carcinoma in people who are exposed to some nuclear accidents, just think about thyroid carcinoma again in young patients. Okay, that's one thing. Other things are going to be something known as potassium iodide. Potassium iodide. Ki. This competitively inhibits the thyroid uptake of iodide. So competitively inhibits the thyroid uptake of iodine or radioactive iodine, any iodine. So the treatment of nuclear accident is you give patients potassium iodide. So when you give potassium iodide, it's going to inhibit the take-up of that radioactive iodine, so it does not cause the destruction of the thyroid gland. Okay, that's also important. Okay, some important drug here when where you see Wolff-Chaikoff effect is, for example, amiodarone. Let's just write it here. Okay, amiodarone. So amiodarone, it contains iodine, right? When it contains iodine, it can lead to, with the Wolff-Chaikoff effect, it can lead to hypothyroidism. it can lead to hypothyroidism. But this amiodarone also, with wall check of it inhibits, it leads to hypothyroidism, but also it inhibits the 5' deiodinase, which leads to decrease in T3 and T4, which leads to actually T3, right? Because T4 converts into T3 by this enzyme. So when you inhibit this enzyme, you cannot have T3. So when you don't have T3, you are going to cause increase in TSH. Okay, that's an important thing for the amiodarone. Okay, one last point here is going to be that we did talk about how the beta HCG has the same subunit as the SIADH, right? So when you have increase in beta HCG, it's going to stimulate again the thyroid. That is going to release again increase in free T4 and eventually causing decrease in TSH. Remember that beta HCG has a connection here. All right, let's talk about the next thing we have is the parathyroid hormone. Parathyroid. Where the parathyroid is the source of the chief cells of the parathyroid. The function is going to be you're increasing free calcium in the blood, which is the primary function, right? Increasing calcium and phosphate absorption in the GI, increasing calcium phosphate from bone resorption, increased calcium reabsorption from DCT, decrease in potassium, not potassium, phosphate reabsorption in the PCT. I'm reading right now, but I'll make things very simple in a bit. Also increases 125 OH2 D3, which is the active form of vitamin D, which is calcitriol production by activating enzyme known as 1-alpha hydroxylase. In the PCT, the mnemonic is try to make D3 in the PCT. Okay, so these are all the functions of PTH. Again, we said the PTH, his job is to increase calcium and dump phosphate. So let's just write it here. Increase calcium, dump phosphate. With a P, you can just say PTH is a phosphate dumping hormone. Phosphate, P for phosphate is a phosphate dumping hormone. Okay. That's the whole function here for the PTH. Now, important point, let's talk about one important high yield point that you have third and fourth pharyngeal pouch, third, fourth pharyngeal pouch, which leads to formation of the parathyroid glands. Okay, and the parathyroid gland would lead to release of the parathyroid hormone, right? Now, if you have an absence of these pharyngeal pouch, for example, in DiGeorge syndrome, you have absence of these third and fourth pharyngeal pouch, so you will not be making PTH. You will not have parathyroid gland. Okay, and one step, this is all about your embryology associated tie-in. Now, one more important thing is that there are two hormones. Let's just write it here. There are two hormones which are closely regulating calcium and phosphate. First thing, as we're talking about, is the PTH. Okay, and the second thing we have is vitamin D. Vitamin D, active vitamin D, which is 125 OH2 D3. These guys are the primary two hormones which regulate the calcium and phosphate homeostasis. So in which PTH is just doing minute to minute homeostasis concentration, meaning it regulates change variability minute to minute. While this vitamin D, it regulates levels in the longer term, over the longer term. So longer term, you're looking at release of vitamin D, but in a minute to minute regulation, you're looking at PTH being the main guy. Okay. So now, what is the net effect? Increases the serum calcium because it's a phosphate. PTH is a dumping phosphate dumping hormone. P for PTH, P for phosphate dumping hormone. So it's going to decrease the overall phosphate, increases urinary phosphate, increases high yield, increases urine cyclic AMP. Okay, so that's there. And one important point for the bone is that it does not directly cause the increase of calcium and does not directly stimulate the release of calcium, but how the way it does it, that it increases. So let's just write it here. So in the bone, you have two cells. You have osteoblasts and osteoclasts. Now the PTH, let's change color. PTH is going to stimulate these osteoblasts, which are the bone forming cells. It's going to stimulate these osteoblasts. When these get activated, they secrete the MCSF, colony stimulating factors, that then release to stimulation of, in turn, they release the stimulating factors which stimulate osteoclasts. Now, osteoclasts, that's only one of the pathways. Second pathways, they have to have the expression. So osteoblasts have something known as rank L, meaning rank ligand. Let me write it down, rank L, which is the rank ligand. And the osteoclasts have their receptor for it. So they have the rank, which is the receptor for rank ligand. So the second thing is going to be that you have PTH is causing the expression of this rank L, which then binds to this rank receptor and activates this osteoclast. And when the osteoclast gets activated, now you will have bone resorption, right? And with the bone resorption, you're going to get increase in calcium and phosphate also. So phosphate and calcium are in the bone. When you resorb the bone, the phosphate and calcium will go from the bone outside in the serum. So you will cause increase in calcium and phosphate. Increase in phosphate levels in serum. Okay, this is very important that the PTH, again, I'm just going to go through this quickly. PTH does not directly stimulate the osteoclast. It indirectly causes increase in calcium and phosphate from the bone by causing stimulation of osteoblast, which lead to release of MCSF, which stimulates the osteoclast. But on top of that, you need a second signal. That's the rank ligand binds to the rank, activates the osteoclast. Then there is a bone resorption, which causes increase in calcium and phosphate. But here you see you have calcium and phosphate, both are increased, right? So you want to dump this out in the kidneys. So that's exactly what ADH is going to cause. So it's going to decrease phosphate reabsorption. When it goes into the kidney, it does not even reabsorb the phosphate. So all that phosphate dumps into the urine, okay? And that is denoted right here. You have increase in urine phosphate, simple, right? So that is with that. What else? Let's just take a look. We talked about bone. We talked about kidneys. So let's just write here. So in bone, we are causing increase in calcium, increase in PO4-3, which is phosphate. But in the in the bone, well, in the blood and in the GI system, it's just again trying to absorb calcium and phosphate. Bone also doing the same, uh, but only in the kidneys it's only causing increase in calcium and dumping phosphate. Uh, then vitamin D, active vitamin D, which is calcitriol. Uh, this calcitriol production is increased by PTH, stimulating 1-alpha hydroxylase. And when the 1-alpha hydroxylase gets stimulated, it converts. Let's just take a look at this picture so it makes sense. So if you look here, you have 1-alpha hydroxylase, you have inactive vitamin D to active vitamin D. This 1-alpha hydroxylase, it's stimulated by PTH. So it converts inactive vitamin D to active vitamin D. Okay. And there are some other factors which would inhibit this, again, same enzyme, 1-alpha hydroxylase. And where are we looking at? For example, we are saying this, the 1-alpha hydroxylase is also in it. First, let's talk about what else inhibits this. So it is inhibited by calcium itself. Calcium inhibits 1-alpha hydroxylase. There's another thing called as FGF23, which is fibroblast growth factor 23. High yield fibroblast growth factor 23. This also inhibits the 1-alpha hydroxylase. Now, where do we get this from? So fibroblast growth factor 23, it is released by osteocytes. In response to when you have increase in active vitamin D, these active vitamin D work on these. In response to active vitamin D, the osteocytes release FGF, which inhibits the release of more active vitamin D. So it's a negative feedback. Okay, but important. FGF 23. Fibroblast, and the full name is fibroblast growth factor 23. Okay. Now, one more high yield point is there are some other things where we get the 1-alpha hydroxylase, that is in the granulomas, in any granulomatous disease. So we have, let's just talk about it here. We have activated macrophages, right? Those activated macrophages, for example, in granulomatous disease, for example, sarcoidosis, for example, tuberculosis, for example, is non-Hodgkin lymphoma, or Hodgkin lymphoma, or any granuloma formation of diseases. You have these granulomas, these activated macrophages, they have 1-alpha hydroxylase activity. So when they have 1-alpha hydroxylase activity, they are going to cause increase in active vitamin D, right? And that increase in vitamin D will give you, as a result, increase in calcium levels. So with the granulomatous diseases, often you also increase in calcium levels. Okay, that is going to be there. So looking at this vitamin D, since we are talking about vitamin D here, so active vitamin D is going to work on the bone, causes increase in bone resorption. Okay, and that resorption is going to give us increase in calcium and increase in phosphate from the bone. Okay. With this, one more thing you will think of is with active vitamin D, you will have increase in mineralization of bone, an increase in remodeling of the bone. Okay, two things there. With the intestines, there is an increase in absorption of calcium and phosphate. Overall, in serum, if you look at the difference with vitamin D is that you have both the calcium and the phosphate, both are increased. With the PTH, parathyroid hormone, that's going to overall increase in calcium, but not the phosphate, because PTH, as I said, phosphate dumping hormone. It's going to dump that phosphate. Okay, let's take a look at PTH now. You have ionized calcium, decreased ionized calcium, increase in phosphate, or decrease in D3. So either you have decreased ionized calcium, or you have a lot of phosphate, or you have decreased vitamin D3. They're all activators for PTH. They all regulate PTH. They stimulate PTH. PTH comes from 4 glands. There are 4 parathyroid glands. They all secrete PTH. They go into circulation, stimulates 1-alpha hydroxylase, activates vitamin D. Vitamin D doesn't work. PTH goes into the renal tubular cells. And again, from here, you're causing that increased vitamin D will just go and have a negative feedback. And you will have increased D3 synthesis with the you will have reabsorption calcium, phosphate dumping. Urine will have low calcium but high phosphate. Overall, that's the effect. Let's talk about regulation, which is also important. Regulation of this PTH is, first of all, you have the low calcium, which causes increase in PTH. High phosphate causes PTH, high PTH. Again, look at this new thing now. Now, magnesium is also there. Low magnesium causes increase in PTH. Very low magnesium causes decrease in PTH. So low and very low. So mild, low, mild decrease in serum magnesium, increase in PTH. Severely low magnesium will just decrease PTH. Why? Because magnesium acts as calcium. So let me write it down. Magnesium acts as calcium on the CSER. CSER, let's talk about, first of all, you might ask what CSER. CSER is the regulate the secretion. This is a receptor on the PTH which regulate parathyroid hormone in response to changing serum calcium levels. So CSER, it's a regulation of PTH, which is normally sensing the calcium levels, and in response to that, it either stimulates or inhibits the PTH release. So let's talk about what would stimulate this receptor and what would inhibit that receptor. So first thing is that if you have the binding of the calcium, let's say binding of calcium to the CSRs, that is going to cause inhibition of PTH, because the CSRs are like, hey man, we already have calcium, we don't need you, right? And they would inhibit the PTH release. But if they sense, hey, there's a low serum calcium, meaning not a lot of calcium, not calcium binds to CSRs, they sense that, hey, the calcium is not there since we are like empty, so they release PTH. Leads to release PTH. PTH is like, hey, now the big guy is here. It's going to cause more calcium within the bloodstream. So now magnesium, on the other hand, which we were talking about, now the magnesium, let me just go a little down here. Magnesium binds to the same CSRs like calcium. So when it is just little low, mild low, okay, what it does, it acts as same calcium because it acts on, again, the same receptor, CSRs. Okay, now, but when it is very low, meaning very severely low, it leads to dysfunction of these receptors. There's a dysfunction of CSRs. And that is why when they're very low, they have no action on the PTH. That's why you have a low PTH with a very low serum magnesium. And I keep saying CSR. So what is CSR now, you might ask? CSR is your calcium sensing receptor. Simple. Calcium sensing receptors on parathyroid or a parathyroid gland. Okay, that is all we have. let's take a look at some extra things here. Pathology. So PTH, we did talk about the first thing. Okay, increase in rank L, which is the receptor activator of NF-kappa B ligand, secreted by osteoblasts and osteocytes. Okay, again, you have increase in ligand, which is a receptor activator of NF-kappa B. It is secreted by osteoblasts and osteocytes. They bind the rank, which is a receptor on osteoclast, and they're precursors to stimulate the osteoclasts. An increase in calcium. This causes bone resorption. Intermittent PTH release can also stimulate bone formation. Now, this is high yield. We said the PTH, its job is to cause bone resorption so we can have more and more calcium in the blood, right? Trying to get that calcium from bone, right? Now, if you were to give intermittent PTH, it is doing the opposite. It is actually stimulating bone formation. It is stimulating the bone formation. That's also very high yield. Now, intermittent PTH, it's the, now there is a, for example, in let me just write it down. For example, there is an osteoporosis. Osteoporosis treatment could be, one of the treatment could be that you want to give an intermittent PTH, which is your teriparatide. Let me write it down. Teriparatide. Now, this teriparatide, it is an analog of the PTH, which again causes what? Leads to bone formation. And that hence we are giving an osteoporosis. PTH, as they have mentioned, is the phosphate trashing hormone. P for phosphate. Okay, and that's very good actually. P, T, and H. Phosphate trashing hormone. All right, the next thing here is high yield is going to be PTH-RP, which is PTH-related peptide. And this, as the name says, is a related peptide. It functions like PTH, and it is common increase in malignancies, for example, squamous cell carcinoma of the lung, renal cell carcinoma, RCC. So when you have increase in the PTH-RP, it's going to act like PTH. Guess what's going to have? You will have osteoporosis. You can have increase in serum calcium. An increase in serum calcium with a person who has a squamous cell carcinoma of the lung or RCC. You'll think about, okay, there's a lot of PTH-RP being released, and it is released from the malignancy itself. Okay. Now, something for the phosphate. When we have increase in free calcium, now, okay, we did talk about how we have increase in free calcium and low phosphate in the PTH versus different thing in the vitamin D, in which case we will have both of them increased. Okay. One point also I have to mention here. This is the intermittent PTH. For example, if you were to give a continuous PTH, continuous administration of PTH is going to cause, again, the same thing: bone resorption, increase it will increase the osteoporosis. So let me draw the bone here. So let's draw a bone here. I'm pretty bad in drawing, but okay, let me just try one more time. Something like this, I guess. Well, this is actually bad. Let's do this. Easy. Okay. Now we have, for example, now we know this is cortex. And just below the cortex, which is the hard bone, just below the cortex, we have the trabecular, which is a spongy bone here. So trabecular bone. Uh, and with this, with this, what is it? Teriparatide, you're basically causing the trabecular bone to increase in osteoporosis. You're trying to rebuild this trabecular bone. Okay, that is important. With the continuous PTH administration, you have bone resorption, which occurs at the cortex. So when you give a continuous PTH administration or normal PTH when it is there, it's taking the bone out from the cortex. Okay, I hope that makes sense, but that is there. Okay, now important thing, let's talk about something here for the kidneys. That how that PTH is causing two things in the kidney. So in the kidney, we have, let's mention kidney here. We have the PCT, right? And the DCT. So what's happening in the kidney that you have parathyroid is going to cause, in the PCT, it's causing inhibition of a channel, inhibiting a channel. This is urine, and this is your blood, let's say. So it's going to, why did I put PT in the urine? Okay, it's coming from the blood. Okay, PTH is going to inhibit this channel, which is trying to reabsorb the phosphate. Okay, and the PCT. Now remember, we're talking about PCT phosphate inhibition, phosphate reabsorption inhibition. Okay, and also in the PCT, PTH is stimulating 1-alpha-hydroxylase, two things in the PCT. Now the DCT, on the other hand, is causing, let's mention here, it's causing what? It's causing reabsorption of calcium from urine into the blood. So why did I draw all of this? Because you have to know the PCT and the DCT. It's not that it goes to the kidney, does one thing only in the PCT. It's also working at the DCT. In the PCT, trying to block this phosphate and also stimulating 1-alpha-hydroxylase. But in the DCT, it's causing the calcium reabsorption. And that is what we have within the kidneys. Let's erase this part now. Okay, now lastly, we have on bone. On bone, we have PTH action is by stimulating the bone formation cells, for example, the osteoblasts, which in turn then stimulate osteoclasts, high yield, leading to increase in bone resorption. That's on the bone. While on the PTH stimulates, it has no direct function on the GIT. So PTH stimulates active vitamin D, which then in turn acts on the GIT tract, causing absorption of your calcium and phosphate. Okay, and that is going to be all for that. Okay. Okay, now one extra thing that we have is that, for example, if you give someone vitamin D supplementation, right? What's going to happen is vitamin D supplementation in a moderate dose is recommended. Because if you were to give some excess dosage, so excess vitamin D will cause what? Let's talk about that. So excess vitamin D will cause symptomatic hypercalcemia, which will lead to, we'll talk about what it's going to cause, but it's going to cause impaired depolarization of NMJ, neuromuscular junctions. leading to muscle weakness, constipation, confusion, impaired concentration of urine in distal tubules, leading to polyuria, polydipsia, and this we will talk about how symptomatic increased calcium will cause. But chronically vitamin D intoxication will cause renal stone formation, one thing, and bone demineralization, which then leads to bone pains. And that will also come up. And where do we see chronic vitamin D intoxication? For example, if you have chronic granulomatous disease, that is going to increase 1-alpha hydroxylase, that is going to activate vitamin D, and it will lead to intoxication of that. For example, in sarcoidosis, right? That's just one of the things, but other things like tuberculosis, anything could be there. But this is all access. What about if we have a low vitamin D? Let's just change color here. Low vitamin D. Where do I write that now? Let's erase this and write it here. If we have low vitamin D in children, it's going to cause rickets. And in adults, it's going to cause osteomalacia. Okay, and that is all. Now let's talk about CKD. CKD, chronic kidney disease, what's going to happen is there is going to be impaired conversion of inactive to active vitamin D, right? Inactive to active vitamin D is going to be impaired, right? With that being impaired, now you don't have active vitamin D, right? As a summary of this. So there is going to be increase in FGF 23 in early CKD. Now you got to remember this. In earlier CKD, you have increase in early. Let me write it down. Early CKD. Okay. Which will lead to inhibition of that 1-alpha hydroxylase in early CKD. But that's first thing. Second thing you will have is decrease in GFR. GFR is, because it's a CKD, for sure you have a decrease in GFR. That is going to limit the delivery of that active vitamin D to the PCT cells. Okay. And third thing is going to be your decrease in functional renal mass. Limits the production of 1-alpha hydroxylase. So what did I mention all of this? So here again, in CKD, all you have is in earlier CKD, meaning earlier time, you will have increase in FGF, which I talked about, that is going to inhibit that 1-alpha hydroxylase. Later on, you will have, in CKD, you already have a lower GFR. So although you have vitamin D, but it is not going to go on to the PCT where it does its action. Okay. Third thing is that with the CKD, you have decrease in functional mass of the renal functional mass. So when you decrease the functional mass, you're already decreasing the PCT, which is the 1-alpha hydroxylase, which has the 1-alpha hydroxylase cells. So that's also going to decrease. Okay. That's going to be pretty much what we have. And that is all. So one more, let's just talk about how vitamin D comes in. Although it's a biochem type thing, but since we are going in details here, so let's just go in. a little bit deep dive into how vitamin D comes in. So you have a normal vitamin D metabolism. That's if you want to open your biochem, that's going to be there. But here, what happened? You have a UV again B rays. UVB rays are going to get on the skin, right, when you're in the sun. So there's a conversion of 7D hydrocholesterol. Let me write it down. 7D hydrocholesterol to vitamin D3. Vitamin D3, which is cholecalciferol. Cholecalciferol. That cholecalciferol, again, there are two ways that you can get this cholecalciferol. One, by the UVB rays. Second, by the dietary intake. Dietary intake will give you not only D3, but mostly D3, but also D2, vitamin D2, which is your ergocalciferol. Okay, so either D2, D3, no matter what you're getting, is vitamin D, right? That is going to cause, that is actually, first of all, is going to go to liver. When it goes to the liver, it is the primary, liver is going to be the primary storage for the vitamin D3, which is called the calciferol. So primary stores D3. Let's just mention that. From there, the liver, there's an enzyme that is 25 hydroxylase. This enzyme here, 25 hydroxylase will convert, will actually, because we said it's a storage, right? So it's going to send that 25-OH-D3 to the kidneys when the 25 hydroxylase works on it. So 25 hydroxylase, when it is there, is going to send that stored vitamin D to the kidneys. While in the kidneys, that 25-OH-D3 will convert into the active metabolite of vitamin D, which is 125-OH-D2-D3, which is 125-dihydroxy vitamin D3. Other name is calcitriol, D3-triol. And the enzyme we need is 1-alpha hydroxylase, which is present in where? It is present in the PCT, proximal convoluted tubular. We would talk about that. I think it will come up where, or maybe in the kidneys, that there are specific cells, I think fibroblast cells, that produces this 1-alpha hydroxylase. Okay, and we did talk about everything else that is going to go on the bone and the kidney. I mean, in the bone, in the intestines, and cause the function. Okay, so let's review this part and move on to the next. So we UVB rays work on the skin, convert that 7-dehydroxycholesterol into vitamin D3, which is cholecalciferol. You also get that from diet, D3, and also D2. You also get that from diet. Now, an important point is, no matter you get it from the UVB rays or the diet, it has to go to liver to get stored there. When it is stored, now if you when the 25 hydroxylase, again, look at the name, 25 hydroxylase, 1-alpha hydroxylase, same enzyme. Whenever you see hydroxylase, this enzyme, hydroxylase, you think about vitamin D. 25 is the one which converts, which sends that stored into the kidney, while the 1-alpha is the one which activates it from inactive to active calcitriol. Okay, and that is just going to work on its organs and eventually cause increase in calcium and phosphate. And that's pretty much it for PTH. Let's review it quickly and move on. PTH, important thing is, again, it's overall, it's going to cause increase in calcium. Overall, it's going to cause decrease in serum potassium, not potassium, phosphate, okay, phosphate. But high yield increases urine phosphate. High yield increases urine cyclic AMP. And why is this increasing cyclic AMP? Because when it is working on the kidneys, it works through G protein adenylate cyclase. It works through G coupled proteins, adenylate cyclase. So when the PTH works on a receptor, it works through this adenylate cyclase, causes increase in cyclic AMP that goes in urine. So you will see increase in urine, cyclic AMP. That just means that you have a lot of PTH. Okay. Second thing, you have increase in rank ligand, which binds to the rank and then stimulates the osteoclast. So it does not, PTH does not have a direct response on the osteoclast in turn. It stimulates osteoblast, which then in turn activates osteoclast. PTH is a phosphate trashing hormone, simple. PTH-RP, seen in malignancy squamous cells, RCC. Magnesium acts like, for example, low calcium. And low calcium, low magnesium stimulate PTH. High phosphate or very low magnesium decrease. Very low magnesium would decrease. Well, I think I said it opposite way. Let me say it one more time. Low calcium, low magnesium, both will stimulate PTH. Now, when you have a high phosphate, I mean, this is not for memorization. It should be a concept in the head, right? It should be a concept in the head. Low calcium, phosphate, high. Simple. Common causes of low magnesium, that's important. What are the low, for example, if you have low magnesium, the common causes are diarrhea, aminoglycosides, diuretics, alcohol use, all that can cause low magnesium, in turn causing increase in PTH, in turn causing high level of calcium in the blood and low phosphate. Calcium is a major regulator of PTH release, simple. And we did talk about all of this and that. Okay, that's pretty much it for PTH. Okay, now let's talk about calcium homeostasis. Well, the calcium homeostasis, we have the plasma calcium. It exists in three forms, important, okay? The first is your ionized or free, which is 45%, wow, which is the actual active form, right? Which is the free, ionized free, right? The other one is bound to the albumin. Now, whatever is bound is not active, so you have 40% of that, wow. Then you have some calcium which are bound to anions, which is about 15%. So the only regulation here is this. So this ionized free calcium, it regulates the PTH, right? Okay, now let's look to, so PTH, ionized free calcium is the primary regulator, simple. Now, important thing is changes in the pH alters the changes in the pH would alter the PTH secretion, whereas changes in albumin concentration do not. Again, what did we say? We say when we have a change in a pH, it will alter PTH. Whereas when you change the albumin, it does not. Whereas changes in albumin concentration do not change the PTH secretion, which I guess is mentioned here, but we will see that. Okay, now let's read first here, the left side or right side. That's the calcium competes with hydrogen to bind to albumin. Important. So calcium is competing with what? Hydrogen, right? So when you have low hydrogens, that means you're freeing up more albumin. So albumin binds more calcium, simple. And that's going to cause decrease in ionization of the calcium. Decrease in ionized calcium, meaning decreased free calcium. And that's going to cause decreased calcium sign and symptoms, which are cramps, pain, paresthesias, carpal tunnel, spasms. Simple, right? But when you increase, that also decreases, that also increases the PTH. Again, let me recall the whole thing. Makes sense. It's a simple thing. That calcium and hydrogen, both of them are going to compete against what? one thing, albumin. So when you have low hydrogens, more albumin will bind to calcium. Simple. When the more albumin binds, you are essentially decreasing the free calcium. When you're decreasing free calcium, we said it is the primary regulator for PTH, so it's going to cause increase in PTH. Simple. Now, in other way, if we were to increase the hydrogens, now albumin will bind less calcium and more hydrogen, causing increased free calcium, causing decreased PTH. Simple. As seen in the picture, here you have a normal, you have, let's just write it down here. You have alkalemia, meaning you have increase in pH, meaning you have decrease in hydrogens. When you have decreased hydrogen, what is going to happen is you will cause the albumin to bind more calcium, and that is going to cause decrease in free calcium. So here you have more bound calcium, simple. And here you have more free calcium because in acidemia, and you can just read the above and it's the same as I explained. But if you, let's just actually go through it if somebody missed it. Okay, we have acidemia, for example. Acidemia is what? Low pH. Even if you don't remember, forget the low pH, just acidemia, meaning more hydrogens. More hydrogens are going to bound to what? Albumin. When they're bound to albumin, right? So there's going to be less calcium bound, meaning free calcium. Right there, free calcium. Simple. Okay, that's what we have. Okay, one other thing. Let's just mention it here. And that is that calcium and magnesium. Let me write it down here. So calcium and magnesium, they both interfere with QT intervals. Okay. So QT interval is increased with both. Increase meaning prolonged, just remember that. And QT interval will be decreased with both. Simple way, let me just erase this and make it simple. Simple way, when you have, just remember, when you have increase in calcium or magnesium, what's going to happen is going to increase the QT prolongation. And when you have decreased, and this is going to decrease QT prolongation. Simple. Okay. And that is going to be all. One important high yield point again is going to be this point, that free ionized is only 45%. And this is the primary regulator. And remember, the hydrogen and calcium, they try to compete for albumin. The more it's bound, the more the calcium is bound to the albumin, the more, the less we will have the free calcium, right? The more is bound. So the less we have. So the less we have, the more PTH is going to be there. Okay, simple. And that is all for calcium homeostasis. Let's talk about calcitonin. Calcitonin, it's coming from the parafollicular C cells of the thyroid. So it's coming from the thyroid. Again, it's coming from thyroid, but which cells? Parafollicular. What about the follicular cells? Well, the T3, T4 thyroid comes from the follicular cells. So para, on the side of follicles, you have the parafollicular cells that releases the calcitonin. Now, we talked about how we need the calcium. Now, this is total different. It causes decreased bone resorption. So basically decreases serum calcium. So wait, let's talk about regulation first. When you have increase in serum calcium, it causes increase in calcitonin secretion. That increase in calcitonin causes decrease bone resorption. Okay. So calcitonin opposes the actions of PTH. Not important in normal high yield. It is not even important in normal calcium homeostasis, because we said normal calcium homeostasis is done by two things: PTH and vitamin D. Normal homeostasis. Calcitonin does what? It just tones down the serum calcium levels and keeps it in the bone. And what we do is we could use this for pharmacologic therapies for hyperglycemia. Otherwise, as you know, it has a very minimal role. So let's just take a look at its normal function again. Normal function is going to decrease. Let me write them down here. Decreases serum calcium, right? By inhibiting bone resorption. An increase in if there is an increase in calcium in serum, it leads to increased calcium in urine. Okay, so that's only one thing. Second thing it can do is, if there is increase in calcium in serum, it causes increased calcium release in urine. Okay, by inhibiting renal reabsorption of calcium and phosphate. So it inhibits the renal reabsorption. So more calcium goes out in the urine as a function of it. So let's take a look at this picture. So we have the calcium as green. In the peripheral blood, we have let's say we have increase in serum calcium. That leads to release of calcitonin from the parafollicular or C cells of the thyroid. Okay, because calcium binds to the receptors and causes increase in calcitonin. Increased calcitonin also inhibits the osteoclasts. While osteoclasts were doing the bone resorption, right? So it decreases the bone resorption. And when you decrease bone resorption, you're decreasing the calcium coming from the bone. Calcitonin lowers the serum calcium by inhibiting osteoclastic bone resorption. Okay, and that is there. So the thing that you can just remember is, with the C's, you can say, okay, increased calcium leads to increased calcitonin. C for calcium, C for calcitonin. And calcitonin would just inhibit the osteoclasts directly, leading to decrease in calcium. All right, now let's talk about glucagon. Glucagon is coming from the alpha cell of the pancreas. If you recall, we had the peripheral alpha cells, and in the middle, we had the beta cells. So it's coming from the periphery. It promotes, it has a job opposite to insulin. It promotes glycogenolysis, which is so all it does is it's trying to keep glucose in blood. So the way it does it is by increasing glycogenolysis, breakdown of glycogen, gluconeogenesis, formation of glucose, lipolysis or lipolysis, breakdown of lipids, ketogenesis, formation of ketone bodies, which essentially all of that is elevates the blood sugar levels to maintain homeostasis when the bloodstream glucose level falls too low, for example, in fasting state. So normally this guy comes in the fasting state, keeps the blood sugar level in homeostasis, meaning in normal levels. Regulation, it is secreted in response to hypoglycemia, and it is inhibited by insulin, amylin, somatostatin. Again, statin is the one which is somatostatin, right? Which inhibits the growth hormone, right? Hyperglycemia. Okay, again, it is secreted in response to hypoglycemia. Again, it is secreted when there is a hypoglycemia. It is inhibited when there is hyperglycemia. You eat a food, you're not in fasting state, you have glucose in the blood, you're going into hyperglycemia. You're going to inhibit glucagon. And who's going to come up? Second thing, insulin, to put that glucose back into the peripheral tissues. So, okay, we're going to talk about here the insulin. Let's start with insulin. Insulin, simple thing, okay. What we have is, if you recall, the pancreatic beta cells, these pancreatic beta cells are going, the nucleus of these pancreatic beta cells are going to form insulin mRNA. That insulin mRNA will travel to the RER in the form of pre-pro and forms into pre-pro-insulin. This pre-pro-insulin then gets the cleavage of pre-signal. So this pre is going to be, there's going to be cleavage of this pre-signal, and it's just going to form into a pro-insulin. Okay. And once the pro-insulin is formed, what's going to happen is this pro-insulin will go into the Golgi apparatus and stored it. So wait, let's read it here first. So pro-insulin stored in the secretory granules. Then there's a cleavage of pro-insulin leading to exocytosis of insulin and C-peptide. Although, okay, let's just, since they haven't mentioned, so let's just talk about each one of those things. Let's put it one more time here. Simple. So in the RER, we said it's a very high yield. Look, in the RER, we're talking about pre-pro insulin, right? And there was a cleavage of this pre-signal within the RER. And when it goes out of the RER, it's going to be just a pro-insulin. And this pro-insulin is it goes into the Golgi apparatus. Let's just put Golgi apparatus. And within the Golgi apparatus is going to pack this pro-insulin, okay, into secretory granules within the Golgi apparatus, okay. Then from when, let's say this is the package of pro-insulin, okay. From here, what's gonna happen is, from Golgi apparatus, these secretory granules are then going to go into the cytoplasm. Now, there's something that's going to happen within these secretory granules. What's going to happen is, we have specific enzymes known as endopeptidases. So that's important enzyme. So let me just write it here. Endopeptidases. Within these secretory granules, what they are going to do is they are going to cleave, these endopeptidases are going to cleave pro-insulin into two things, all right? So pro-insulin into two things. And that will be, first you have insulin, which we need, right? And second thing is going to be, you're going to get C-peptide. So if you read from here, in the first aid, what we have is both insulin and C-peptide are increased in endogenous insulin secretion. Example, type 2 diabetes and insulin secretagogues or insulinoma, whereas exogenous insulin lacks C-peptide. And I'll talk about that, what they were trying to say here. But let's go a step back again and let's recall the whole thing we talked about. So we said the very high yield that beta pancreatic cells, nucleus, they are going, it's not a neutrophil, it's a nucleus, it's a short form, okay? Within the nucleus, what's going to happen is we are releasing what? Insulin mRNA. So now with that, we have a full story. So let's talk about it. So insulin synthesis, pancreatic beta cell, we form insulin mRNA. That insulin mRNA is going to the RER. When it goes into the RER, there's a pre-pro insulin formation, and that pre-signal, there's going to be a cleavage. RER, which is rough endoplasmic reticulum, will cleave the signal peptide, which is the pre, and leading to formation of just the pro-insulin. That pro-insulin will go into the Golgi apparatus, and in the Golgi apparatus, all the Golgi is doing is packing that pro-insulin. It's going to pack that up and send it to the cytoplasm. So Golgi is going to pack up in these secretory granules and send it to cytoplasm. Now, within the secretory granules, these small granules, we have an enzyme. The enzyme is known as high-yield endopeptidases. Endopeptidases. What this endopeptidase is going to do is going to cleave this proinsulin further more into two more things. The first thing is the insulin, and the second thing is C-peptide. So whenever we have the release of insulin endogenously, meaning within the body, we always have a C-peptide coming with it. Simple as that. So this first aid here is trying to say, okay, when you have endogenous secretion of insulin, of course, you're going to have a C-peptide. So this is one of the things we can check clinically. If the insulin is high, either the C-peptide is high or not. If it is high, then say, okay, man, this is coming straight from pancreas. But if there is just insulin without C-peptide, this helps differentiate factitious hypoglycemia, that someone is taking insulin from outside. It's not due to insulinoma. It's not a secretagogue or insuloma. It's something else. Okay, I hope that makes sense. Now, the second thing is insulin is synthesized in pancreas and cleared by both the liver and the kidneys. Okay, great. Now, let's also look at the structure, which is also high yield. So in here, the structure, we have insulin. Look at the insulin. So this is just the insulin part, which is connected by two disulfide bonds. So disulfide bonds. Okay, that's the insulin. And look at the C-peptide. This whole thing is just C-peptide. And the whole thing is called proinsulin, and eventually is going to form just insulin C-peptide. Right. Now, one other thing is that when we are trying to check the levels of insulin, we actually look for C-peptide. Why is that? So we do check for the, let me do one thing here. Okay. We do check the level of C-peptide because it has a higher, or a longer, I should say, half-life. So it has a longer half-life than insulin. Okay, that's one thing. And we measure this as an indicator for insulin secretion. Simple, right? So if we have a C-peptide high, that means for sure we're going to have a lot of insulin. No question about it, right? And because insulin, as insulin C-peptide, because the C-peptide does not undergo significant first pass metabolism. That is why we have a longer half-life. So it circulates, the C levels are going to be higher because it doesn't have, again, the first pass metabolism. And that is pretty much it for this synthesis. Yep. Okay, so let's go on with function now. Now the function, let's change color. Now the function is insulin. It's pretty easy. Okay, it binds insulin receptor, high yield. What receptor it binds? Tyrosine kinase activity. It binds to the tyrosine kinase, causes inducing glucose uptake, which is a carrier-mediated transport, which we will talk about in the other right side. So it induces glucose uptake into insulin-dependent tissue. So what is it doing? It's binding to insulin receptor, causing the glucose uptake into specifically insulin-dependent tissues, and we'll talk about those, and causing gene transcription. Okay, insulin is an anabolic hormone, causes anabolic effects. So that is, you have increased glucose transport in skeletal muscles and adipose tissues. Right, the main thing is you're trying to have that all glucose from the blood, sending that into tissues. The insulin doesn't want glucose to be there. Okay, so look, causing increased glucose into skeletal muscles, adipose tissue, causing increase in glycogen synthesis and its storage, causes increase in triglyceride synthesis. So you're taking a sugar, a carbohydrate, but it causes, as sugar goes in there, but you're causing increase in triglycerides, right? The other thing is increase that this is also important, that it causes sodium retention within the kidneys, increase in protein synthesis in the muscles for sure, causes increase in cellular uptake of potassium, high yield. So look at this. It causes cellular uptake of potassium and amino acids, but potassium is high yield. Also causes sodium retention. But most important is this, that it causes cellular uptake of that potassium. One thing it is decreasing is it's the other hormone, which is the counter-regulatory hormone, glucagon. For sure, it's going to decrease the glucagon and also decrease the lipolysis in adipose tissues because all the other counter-regulatory hormones were doing what? Lipolysis, ketogenesis, everything coming to the bloodstream, right? So this guy's like, hey, I'm trying to clean this up and you're trying to mess up with me. So these are two opposite functions than the counter-regulatory hormones, which we did talk about. Okay, so unlike glucose, insulin does not cross placenta. In mothers with diabetes, excess glucose can cross placenta, causes fetal itself will have increase in insulin from their own pancreatic beta cells, high yield. Okay, and in the diabetic mothers, what's going to happen is these patients, these child will go under hyperplasia of those beta cells. So as soon as they're born, they will go into hypoglycemia because they have a lot of insulin and they're not getting glucose. So they will go into hypoglycemia. And this is one of the complications of diabetes, gestational diabetes, okay, which I guess we will talk about in repro. Okay, let's talk about this right side now. Very important. So here we have insulin-dependent glucose transporters, which is just going to be GLUT4. I mean, you think about insulin, you say, hey, insulin is doing a lot of stuff, right? But here you just have insulin-dependent glucose transporter, only one, which is 4. Insulin independent, meaning these guys, they don't even think about insulin. They're like, hey, insulin, no matter you're here, not there, it doesn't matter. We're still going to take glucose. We don't need you. Okay. But importantly, what you really want to think about is that the GLUT4 is present where? Adipose tissues, striated muscles. But again, in the striated muscles, very high yield point is that in exercise with these skeletal muscles, they don't even need insulin. So an exercising muscle can increase GLUT4 expression, causing glucose to go into these muscles. They don't even need insulin. So one thing that really needs insulin is the adipose tissues, right? Isn't that amazing? That's actually very amazing. Okay, let's take a step back one more time. Very high yield, insulin-dependent GLUT4. Adipose tissue, skeletal muscle, but skeletal muscles and exercising skeletal muscle. Meaning if you're sitting, resting down, doing nothing, these skeletal muscles are not going to put that GLUT4 on the expression on the cell, so you can take up that glucose from the blood into those skeletal muscles. But then at the resting point, you need insulin. But if you are in exercising, if you are moving, then these skeletal muscle, they don't need insulin. They can just put up these GLUT4s, get all that glucose into skeletal muscles, and burn that, right? So let's talk about independent transporters. Independent transporters are going to be GLUT1, 2, 3, except the 4, everything, right? 5, NSGLT1 and 2. So GLUT1, seen in the RBCs, brain, cornea, placenta. GLUT2 is bidirectional, high yield. 2, bidirectional. Okay, beta islet cells, liver, kidney, GI tract. Think two-way street, right? Two-way street. GLUT3 is brain, placenta. 5, fructose. 5 is for fructose. Fructose is needed for spermatogenesis and GI tract. SGLT1 and 2. We have these. These are sodium, glucose, S for sodium, G for glucose, co-transporter. Okay. We have transporter 1 and transporter 2. They are in the kidneys and in the small intestine. So brain prefers glucose all the time, but can use ketone bodies during starvation. Okay. But the RBCs, there's a problem. They can only utilize glucose. They cannot utilize ketone bodies as they lack the mitochondria for aerobic metabolism. They cannot utilize ketone bodies because they lack mitochondria for aerobic metabolism. Well, as for the brain, although it prefers glucose but does work on ketone as well, so no problem there. And the RBCs just use glucose. Okay, what else we can talk about, which might, okay, yeah, let's talk about one graph. Okay, here. So we have a graph, and this graph is going to be about insulin concentration and your GLUT expression. Okay, so as the insulin concentration goes higher and higher, your GLUT4 concentration goes higher and higher. GLUT4 specifically, GLUT4. But what is going to be constant? You guessed it right. That's going to be insulin independent GLUT transporters, which is going to be all of the rest of GLUTs. For example, GLUT 1, 2, 3, 5. Not the 4, the rest of them, right? So this is sort of a graph that you will see with insulin concentration. So let me just do the highlighting part. So as the insulin concentration is growing, all you will have the expression of is GLUT4. But the constant are going to be all the other GLUT transporters, which are not dependent on insulin concentration, as you can see in this nice pretty graph, right? Okay, and that was important. Other than that, let's talk about a little bit of this glucose itself. Okay, so glucose, where are we here? Okay, this GLUT4, it is stored in cytoplasmic vesicles, and under the influence of these guys, they're just stored in the cytoplasmic vesicles, and they don't show up on the surface of cell membrane. But when there is an insulin, when you have insulin, or when you have exercising skeletal muscles, they are going to cause these vesicles to go up into the cell membrane and cause the expression of these GLUT4s, so they can catch up the glucose and take them up within the cell. Okay, that's the GLUT4. Let's talk about one thing about insulin. But glucose. Glucose goes from a higher concentration to lower concentration. Okay, with the help. So glucose need a transporter, which is your GLUT. All the GLUTs, right? GLUT family acts as what for glucose now? Facilitated diffusion. So glucose needs GLUTs, which are the transporters. So glucose needs a facilitated diffusion. It's not it doesn't just go right away into the cell without these GLUTs. It's a facilitated diffusion. They go through facilitated diffusion, but no energy is required, but needs a carrier protein, which is the GLUT. So glucose does not need energy, no energy, meaning no ATP required, but they do require, glucose requires GLUT transporters. Okay. And these GLUT transporters, they have a preference for D-glucose. That's just a L'Oreal thing, but forget that point. Then what else we have? Okay, I guess that's pretty much for the glucose. So here we have brick lips. Insulin independent glucose uptake is taken up in the brain, RBCs, intestines, cornea, kidney, liver, islets, beta cells. So pancreatic islets of beta cells, right? Placenta and spermatocytes. Maybe an easier way would be that you just remember insulin dependent ones, which are just adipose tissue and skeletal muscles. And the rest is just insulin independent. But who knows? If you want to memorize this, that's great too. Okay, let's talk about the regulation. Okay, now regulation of insulin is glucose is the major regulator for insulin release. Okay, again, glucose is a major regulator for insulin release. Increase in insulin response with oral versus IV glucose due to incretins, example, glucagon-like peptide 1, GLP-1. So they're saying simply that you have increased insulin response with oral glucose. Although if you think about it, you say, hey, I am going to have some glucose orally, it will take a longer time to go into the bloodstream and cause the pancreatic beta cell to release insulin, but that's not the case. Versus, I'm just giving you an example, which is written there, that you say, hey, if I give you glucose in IV, it's just going to go straight to the bloodstream, cause insulin release, which makes sense. But here, it's a little different. Hormones work a little differently. Why? Because we have something known as, if you did your GI, you had something known as GLP-1, glucagon-like peptide 1, your incretins, and also your glucose-dependent insulinotropic polypeptides, GIPs. So GLP-1s and GIPs, which are released after meals, and these guys, they go to the pancreatic beta cell and cause increased beta cell sensitivity to glucose, causing release of insulin faster orally than if you give IV. Again, what we talk about, I yield point, that if you were to give an oral glucose, okay, what's going to happen is this oral glucose is going to go to GI and going to stimulate these hormones known as incretins, which are GLP-1 and GIP. These guys are going to go straight to the pancreatic beta cells and cause increase in beta cell sensitivity to glucose. So if only one molecule of glucose hits the beta cells, it's going to secrete 100 insulin molecules. I'm just giving an example here. That's sensitivity being increased, right? Versus that if you were to give someone IV glucose, now whatever glucose reached the beta cell is going to secrete insulin based on the levels it reached. Based on the levels they have reached to the pancreatic beta cells, they will release insulin. So for example, if let's say 10 molecules insulin release, maybe you have 10 insulin. I'm just giving an example, okay? This is not how it works, but giving an example that the IV will not lead to release of insulin. IV glucose will not cause a lot of insulin to be released as comparison with your oral glucose, because oral glucose go to stomach, stimulate incretin, GLP-1, GIP, which increase the sensitivity of the beta cells to the glucose. So even if one molecule of glucose can secrete a lot of insulin. Okay, so here, increase in insulin response. So summary, increase in insulin response with oral versus IV glucose, period. Okay, so let's talk about now the release. The release is decreased by, so insulin release is decreased by alpha-2 stimulation, and it is increased by beta-2 stimulation. So 2 equals regulates insulin. So all the 2's are regulating insulin. Alpha causing the insulin to go down, and beta stimulation is causing the insulin to go up. Okay. But now the question arises, if we have alpha and beta receptor, right, to cause insulin release, But what's happening normally and which one is dominant? I mean, if you get the epinephrine to work on both, so what's really going on? Are we getting any insulin, or the functions just cancel out? Well, the thing is, insulin, the dominant effect of the epinephrine is to stimulate alpha 2. So this is the dominant by epinephrine. So the alpha 2 stimulation, which causes decreased insulin release, is the dominant effect of epinephrine. Okay. But if you block, now the question arises, if you were to block this dominant by giving alpha 2 blocker, then what's going to happen? Now you are causing epinephrine to work on the beta 2 and causing increase in insulin. Right? Amazing. Okay. And that is what we have for the regulation. Now, the next thing is glucose enters the beta cells, and it leads to increase in ADP generated from the glucose metabolism. So when we are reading this, let's also take a look in this picture. Okay. So picture 3, point 3 here. So here is the GLUT2. We said 2 is bidirectional. Okay. So glucose is taken up by GLUT2. Where? Look at the insulin pancreatic beta cells. Right? So that glucose goes in, and then when the glucose goes in, again, this is facilitated diffusion by GLUT2. And this glucose goes in. Once it is inside the pancreatic beta cell. Now, the whole thing we're trying to talk about here is how glucose is going to cause stimulation of insulin release. Okay, that's the main idea here. So, and now the small steps, how it really happens is as follows. So we have glucose that goes in. That glucose goes in and goes into glycolysis within the pancreatic beta cells. Glycolysis causes increase in ATP production, right? There's an increase in ATP. That increased ATP, which are these molecules there, those are going to cause ATP sensitive. They're going to go on these channels, potassium channels. When the ATP gets bound to these channels, they will close. So potassium gets closed. When the potassium gets closed, the cell goes into depolarization. Let's actually read before I mess up with something. But here, you have these beta cells, leads to increase in ATP production. We get that from this point. And this closes, yeah, I was right. Okay, this closes the potassium channel. Right here, as soon as these ATPs get bound to these channels, they will close this channel, which also, as a drug, sulfonylureas do the same thing. They close these channels. And once these channels are closed, there is going to be a depolarization. That depolarization of the beta cell membrane is going to happen, and that is going to cause voltage-gated calcium channels to open. These guys will open, which is voltage-gated calcium channels. Now, the calcium is going to come inside the pancreatic beta cells, and once we have calcium influx, there is going to be stimulation of insulin exocytosis. That increase intracellular calcium is going to cause what? Exocytosis of insulin granules. And you can see how they are just going out of these pancreatic beta cells. They go into bloodstream and cause their action. Okay, now let's go back let's talk about one thing here, which we need to address, which is ATP sensitive potassium channels. These ATP sensitive potassium channels, normally at a normal level, these are open at rest. So when they are open at rest, you are not causing depolarization. So no calcium is coming in, no insulin being released because they're open. They're open, meaning more and more potassium is going out. So you're not going into depolarization. Okay. which when they're open at rest, it allows again the outward potassium current, which maintains the membrane polarization. But when the ATP gets bound to these channels, from this channel, what's going to happen is you will have a decreased efflux of that potassium, and that is going to cause membrane depolarization. Okay. Why is that happening? Because when you have increase in potassium inside the cell now, because they're not going out, it leads to increase in resting membrane potential in the cell. And that causes membrane depolarization. Okay. And this membrane depolarization will cause these calcium channels to open, so that the calcium can go in. And then when the calcium, there's influx of calcium, an important point here is going to be about that calcium is going to cause exocytosis. Now, one important point is going to be about something, again, GLP-1 and GIPs. Actually, just GLP-1s. So let me write this down here. GLP-1 receptor. So there's a receptor on the pancreatic beta cell that is for GLP-1, which is right here, glucagon-like peptide 1. Okay, so glucagon-like peptide works on this channel, which works through adenylate cyclase, causes increase. This is high yield, causes increase in cyclic AMP. And that increased cyclic AMP leads to exocytosis of these insulin granules, which is just normal function of calcium. So you see how GLP-1s are again irrespective of glucose levels, of anything. They're just going on the pancreatic beta cell, causing more and more insulin release. Okay. No wonder there's a weight loss with these drugs. I mean, and these are right now the top drugs for obesity, diabetes, given subcutaneously. And you can look up online. And the function is simple, that they're just going to cause more and more insulin release, directly working on the pancreatic beta cells. Okay. So yeah, that's pretty much what we have for this one. Now, we said one more thing here for sulfonylureas, high yield, that okay, let's just, make a simple thing here. We talked about here the GLPs, and we're going to talk about, GLP-1s receptor, and we are talked about sulfonylurea. Sulfonylurea, what's going to happen is if you give someone sulfonylurea, which we'll talk about in pharmacology, that they don't even look at ATP. What they're going to do, they're going to come and just close this channel. When they close the channel, the whole thing will just go on its own and cause insulin release. So that's the function of sulfonylureas essentially. Now there's a problem. Now the problem is going to be if there is a mutation in this channel. It's called the potassium channel mutation, for example. It's called potassium ATP mutations. So what's going to happen with this mutation? You will have these channel being mutated. You need what's going to happen with this mutation, that you would need increased affinity. There's going to be increased affinity for ATP. So the closure of channels will cause depolarization and insulin release at a low concentration of blood glucose. Okay, again, let's step back and understand what did I just talk about. Well, there are two mutations in the ATP, potassium channel ATP mutation. One mutation is that it's going to increase the sensitivity for ATP, meaning there is a more these channels are more sensitive to ATP, meaning one ATP gets bound to this and they will close. When they close, again, what's going to happen? You have more insulin release. When the more insulin release, guess what's going to happen? Now you have a lot of insulin and not glucose in there, so you are going to cause hypoglycemia. And because this is a congenital problem, congenitally, you will see it's called congenital hypoglycemia or neonatal hypoglycemia. Okay, it is the familial form of neonatal diabetes. So let me write it down. Familial form of neonatal diabetes. Okay, that's one thing. Now, the second thing what can happen is you have a decreased affinity. As a mutation, you might go into decrease affinity for ATP. So it's total opposite. No matter how much ATP you give here, no matter how much glucose you have here, no matter how much ATP you can produce within the pancreatic beta cells, they will not be able to close this channel. When they do not close this channel, they do not go into depolarization. They don't release insulin. When the insulin is not out, you have a lot of glucose within the blood, right? High blood glucose levels. So for the treatment of this second problem, you can give sulfonylureas, close these channels, and that insulin can take care of that glucose molecules. Okay, so now with that, let's talk about insulin. So now the insulin is out. The big guy is out. What does it do? All right, so insulin works through tyrosine phosphorylation, okay, and it causes a couple things. It causes vesicles containing GLUT4 to go on the surface, and if you can see they're going on surface, that's one thing. Second thing it's going to cause glycogen lipid protein synthesis, which is also that glucose is coming down with the help of insulin. It's leading to glycogen lipid and protein synthesis, which we talked about how normal mechanism is here. And third thing is going to cause is eventually going to cause cell growth DNA synthesis. Now the important point is how are these, or the actual important point is going to be how the insulin, or through which receptors the insulin is causing all these effects. So it is causing glycogen synthesis, glycogen and protein synthesis, and vesicles containing GLUT4s to go out on the cell membrane by one pathway, which is called phosphoinositide 3 kinase pathway. So let me just write in a simple word. PI3s. Important, okay? So through PI3, which is phosphoinositide 3 pathway, or phosphoinositide kinase 3 pathway, it's going to cause vesicles to go up on the surface, and it's going to cause protein synthesis, glycogen synthesis, okay? And one other high yield point is going to be how the way it causes glycogen synthesis is going to be through, so it stimulates an enzyme known as protein phosphatase. And that protein phosphatase will cause glycogen synthesis. Okay. And the other cell growth DNA synthesis is due to RAS MAP kinase pathway. So let's just write that down. RAS MAP kinase pathway. And that is going to cause cell growth DNA synthesis. So the important thing here, why I mention all this, is because see, insulin has different actions through different, working through different receptors, not receptors, but to different cyclic channels, not cyclic channel, what are these? These are through different intracellular pathways, like PI3s, like RAS MAP kinase. So very high yield is that you just have to know that insulin, first of all, stimulates tyrosine kinase. High yield. Through tyrosine kinase, it has more function through other signaling pathways. First of all, we have the PI3. PI3 is going to cause vesicle containing GLUT4 to go on the cell surface. Second thing is going to cause is protein stimulates the protein phosphatase enzyme, which causes glycogen synthesis, and the rest is just lipid protein synthesis. But this is important. Names PI3 causing all of this. Okay, and RAS-MAP kinase causing cell growth and DNA synthesis. Okay, yeah, that's what we have. Now, which one thing we talked about here, let me just put that here, that we have skeletal muscles. That skeletal muscle, when it is exercising, meaning there's a activity within the skeletal muscles, muscle contraction basically, right? So muscle contractions or active skeletal muscle is going to release calcium. And that calcium is, again, putting these vesicles on the cell surface. So they don't need the insulin, which is the point right here. Okay. Okay, lastly, let's talk about one last thing for insulin. Clinical tie-in point, one more. That is going to be that glucokinase. And all of these, the enzyme, everything is also in biochem. But it's a really important point. That glucokinase function as the glucose sensor in controlling glucose entry, right? And insulin release. So glucokinase, as the name suggests, so it is a glucose sensor. Just remember that. Glucose sensor in controlling glucose entry and insulin release. Now, if there is a mutation of this glucokinase, it is known as heterogeneous mutation of glucokinase, And now with that, what's going to happen is, because it was a glucose sensor, and all it was doing was, it was a glucose sensor in controlling glucose entry and insulin release. So glucose entry and insulin release, two things, right? So now when you have a mutation here, guess what's going to happen? You will cause higher glucose levels within the bloodstream. And through higher levels, then you will stimulate the insulin release. Okay, that's one thing. Second thing is going to be with the mutation of glucokinase, you have decreased ATP formation that leads to a decrease in insulin secretion. Okay, hope this makes sense. And the last pathology that we are going to mention here is going to be that you have something known as maturity onset diabetes of young, MODY. Okay, this MODY, which is basically maturity onset diabetes of young, right? Here, all you have, again, it's an autosomal dominant. You have, because it's diabetes, you will have a mild hyperglycemia, increasing glucose level, which worsens with pregnancy-induced insulin resistance. Because it's of young, so it will worsen with pregnancy-induced insulin resistance. So typically, what you will see in this patient is this patient is young and non-obese, although has diabetes. So let me write it here: young patient, non-obese, no obesity, but it has the patient would have the diabetes, and it is this MODY is non-progressive, meaning it's not a progressive disease. Okay, so it's just two tie-ins. Hopefully, you will see that in other resources. But here, simple. We talked about, again, glucokinase being an important thing, which is a glucose sensor. G for glucokinase, glucose sensor. All it does, it controls the glucose entry into the cell, causing insulin release. So when you have a problem in the glucokinase, guess what's going to happen? You need more and more glucose within the blood to cause insulin release. Simple, right? And that more and more glucose is basically hyperglycemia. That's one thing. And that is known as heterogeneous mutation of glucokinase. That's one. Second thing about MODY MADI is your maturity onset diabetes of young non-obese patient, but has a diabetes mellitus. So you will think about it's an autosomal dominant hyperglycemic patient who is non-obese, and that's about MADI. Okay, and that's going to be all. So let's just quickly review this and move on to the next part. So we did review insulin synthesis, pretty good. Functions, just remember, try to put glucose out of the blood into these tissues. Only two things are decreased glucagon for sure, because it's a counter-regulatory hormone, and decrease in lipolysis. Okay. And then you have what else? A regulation. Remember the GLP-1s and GIPs. These are incretins. And remember your alpha-2 being dominant. You block this out, the epinephrine is going to work on beta-2, causing insulin increase in release of insulin. Insulin works through tyrosine kinase, stimulates PI3, and causes these two functions, which is here is going to be your protein phosphatase, PP, and tyrosine kinase also stimulates your RAS, MAP kinase, and that is going to cause cell growth and all that. Glucose comes in, causes increase in ATP, blocks this channel out, which is ATP sensitive potassium channel. Sulfonylurea is doing the same thing, causes depolarization. Calcium comes in, releases the insulin out. GLP-1s are directly causing increased exocytosis of insulin by increasing cyclic AMPs. And that is all for insulin. What did we talk about? We said 17, there is a deficiency of 17-hydroxylase. When it is deficient, why do we have a decrease in aldosterone here? Okay, let's just skip this part. I'll come back to this, but let's look at what's going to happen as the functions of it. So if you recall, what is the function of aldosterone? Well, the aldosterone, let's just write the function of aldosterone, and then we will understand what the potassium blood pressure is, what's happening with these guys, right? So aldosterone increases, aldo, let's just say, aldo increases renal sodium reabsorption, which increases sodium reabsorption, which leads to increase in blood pressure, right? Because wherever sodium goes, water follows. So when you reabsorb your sodium, the water is going to follow, and it is going to cause increase in blood pressure, which is essentially known as hypertension. That's one thing. But also aldosterone dumps out or secretes potassium and hydrogen ions secretion into the renals, causing low potassium levels. That's just normal physiology of aldosterone, okay? And because it's also dumping your hydrogens, it's going to cause metabolic alkalosis. Metabolic because it's the kidneys, alkalosis because you're losing acid. So it's going to cause metabolic alkalosis. Okay. That is just the normal physiology of aldosterone. So with this, let's take a look at 17-hydroxylase. So 17-hydroxylase deficiency, they have mentioned that you have decrease in aldosterone. Why is that? I have no clue. But okay, maybe, well, I mean, I will take a look at that. But maybe because aldosterone, we need angiotensin 2 to work and form aldosterone. So when you have a lot of aldosterone, because essentially if you look at The rest of things is just it's just the high level of aldosterone, which is low potassium, increase in blood pressure, right? Let's actually take a look at another book. I'm going to open another first aid, see if there's a problem here. Give me 1 second. Androgens. What is it? Congenital adrenal hyperplasia. Congenital. Adrenal. Okay, yeah. Okay, I was right. Here we go. Let me just open this up. Okay, here. This is another version of this. Okay, actually, previous version of first aid. So here, absolutely, you have increased because that doesn't make sense. So this doesn't make sense that you have decrease in aldosterone because, I mean, it's a simple thing that when you have, I mean, wow, when you don't have 17-alpha hydroxylase, meaning you can go there. So the only thing that all of that is going to cause is everything will shuttle down to the formation of aldosterone. This is as simple as it gets, right? Simple. That is why. So this is the new one, right? 2025 version. And I guess there's a problem here, which is they were saying it has decreased aldosterone, which is not the case. Now, this is the old version. You have mineralocorticoid. Mineralocorticoid is an aldosterone. Mineralocorticoid is aldosterone, okay? And glucocorticoid is cortisol or cortisone. So you have increase in mineralocorticoid, meaning you have increase in aldosterone. And that increase in aldosterone will cause low potassium because it's going to dump out that potassium, high blood pressure because it's going to reabsorb that sodium, and decrease in cortisol because, again, we are not going on this side. When we're not going this side, we will not form all of this, and we will not form anything here. All we are going to form is this side, which is going to be you have low cortisol, low sex hormones, labs, you have decrease in androstenedione. Right here, you have a decrease in androstenedione because nothing is made over there. So let's go back to our book. Here we have the new version. Okay, so this, forget this part. So just remember that you have increase in mineralocorticoid, which is increase in aldosterone, increase in aldo, increase aldo. Again, simple thing. Aldo, normal function, sodium reabsorption in the kidney. So you have increase in blood pressure because as the sodium follows, you have, whenever the sodium goes, the water follows, right? So you have increase in blood pressure, causes hypertension, which is blood pressure rise. Potassium, you're losing potassium with the high aldosterone. So low potassium, you're also losing hydrogen ions. That's going to cause metabolic alkalosis because it is acid. Okay, thank you, Dr. Judith. NFA 2022 is also aldo increase. Great. Because this is total mess up. I mean, I was reading this right now. This does not make sense, okay? Doesn't make sense. So we need a errata for 2025. And here's the problem in this book. Okay. Okay, so here, simple, guys, very simple thing. All you have to know is where the hormone is. Because you can't go this side, you cannot form cortisol. You can't go this side because this the same hormone. You can't form this. So guess what's going to happen in labs? You have decreased androstenedione, which is right here. You don't have that. So in the presentation, if it's a male, it's going to present as atypical genitalia because you don't have sex hormones. Atypical genitalia, undescended testes, no sex hormones. How come? You can't have that, right? In a female, you're going to lack secondary sexual development because everybody's normally the dominant is female unless you have the sex hormones which convert everything into those into the genitalia being formed and formation of testes. And here with the female, you just can't make the secondary sexual development. With the 21, so let's change color. 21 here. So when you can't, let's erase all this. When you can't have 21, now all of this will funnel down into the side, right? Because you cannot convert these guys here. So everything will go where? On the right side. So you have decrease in mineralocorticoids. When you have decrease in mineralocorticoid, which essentially means aldosterone, normal job of aldosterone was to throw out that potassium. You can't throw that out. It's going to be increased. Normal job of aldosterone was to have a high blood pressure, if it is a high level of aldosterone for sure. But here you have a low blood pressure and you have low cortisol because you're not making aldosterone now. You're not making cortisol. So both of these are low. Only one thing is high. That's going to be your steroids. With that, because you're not forming aldosterone, your renin will keep poking angiotensin 2 to make aldosterone. So your renin activity will go high. Your 17-alpha hydroxyprogesterone is going to go high because if you look up top, because you're not making anything at here, this guy will go high. There's going to be high level of 17-hydroxyprogesterone. So here, which is mentioned here, increased level of hydroxyprogesterone. What's going to happen with presentation with 21 hydroxylase is most common. Okay, this is most common enzyme deficiency. It presents in infancy, which is salt wasting. The patient is going to present with in infancy with salt wasting because if you recall, Aldo was doing what? Sodium retention. When you can't have sodium retention, you have all that sodium going into the urine, causing salt wasting, okay, or childhood precocious puberty, which is because of all of that high level of sex hormones are going to cause childhood precocious puberty. In females, it's just virilization. In females, it's just going to be virilization. Now you ask, what is virilization? Virilization is basically women develop male pattern hair growth and men masculine features. So let me just write it down. Virilization in women is going to be that woman will develop hair pattern, male pattern hair growth. One thing. Second thing, they will undergo a masculine looks. That's the virilization in females. Okay. What else we have? Okay, let's add one more thing that is going to be about ACTH, which I've seen. So we need to put an ACTH here. Let's say ACTH. Like what's happening to the levels of ACTH. So here, because you have, let's just say here, ACTH is going to be high. Why? Because what you are trying to do is that your normal cortisol, if you have a cortisol, normal job of cortisol is to inhibit ACTH as a negative feedback, right? So when there is no cortisol, the ACTH will be like, hey, we need cortisol. Go to the adrenal cortex, stimulate the whole thing so that we can get that cortisol, right? But this guy doesn't know that, hey, there's a problem in the whole adrenals that you don't even have the enzyme. So the ACTH level is just going to go high, trying to get increased level of cortisol, which it won't get, but the levels are going to be high whenever you have decreased cortisol because, again, ACTH will come down to increase cortisol. We don't have the enzyme for that, so you always have a low cortisol, but the ACTH level is going to be high. Okay. And the last one here is going to be your 11 beta hydroxylase. With the 11 beta hydroxylase, what we have is, let's just first take a look at image again. So you don't have this enzyme, 11 beta hydroxylase. When you don't have this enzyme, although you have something here, and everything will also go back up into the formation of more and more androgens. So let's take a look. Here we have decrease in aldosterone. For sure, we don't have aldosterone. Increased level of 11-deoxycorticosterone. And if you look, you have increased level of deoxycorticosterone because you have blocked this enzyme here. And because you don't have aldosterone, same thing. But now if you look, this is very important. If you look at blood pressure and your potassium, they look like, hey, they are getting aldosterone. But that is due to the fact that you have a weak, like I talked about when I was saying all these points, that you have a weak mineralocorticoid activity within this enzyme. Within this byproduct, which is 11-deoxycorticosterone, has a weak aldo activity. Because you have a weak aldo activity and you have so much increased level of this 11-deoxycorticosterone, which has a weak aldo activity, although you have low aldosterone, but because you have this weak aldo activity and this enzyme is you have a lot of levels of this, it's going to cause as if you have increased aldosterone, which is throwing out that potassium, reabsorbing that sodium, causing increase in blood pressure. But the cortisone, which if you recall, this was the weak cortisone, as the name suggests, corticosterone, weak cortisone, or weak cortisol. You don't have that, so your cortisol level is going to be low. And that is going to cause what? That is again going to cause increased level of ACTH, because ACTH wants to secrete cortisol, but it's not getting it, so it's going to be increased. Sex hormones, because everything is just going either formation of this, or it's going all the way formation of androgens, because you can't really go down. You can come here. So it's going to cause increase in sex hormones. But since you are getting aldosterone activity, so you have a decreased renin activity. Again, decreased renin activity as comparison to the increase in renin activity when you had no aldosterone. Okay, the presentation is going to be, in infants, you will see severe hypertension. Again, why? Because you have this aldosterone, which will cause increase in blood pressure right here. So hypertension. Or childhood precocious puberty. Again, because you have sex hormones, it's going to cause precocious puberty. Again, in females, it's going to cause virilization, which is deepening. You have masculine looks. You have male pattern hair growth. And that is what you see with this. Okay. Now, let's take a look at mnemonic and finish this topic. So, if you look at all the congenital adrenal enzyme deficiencies or autosomal recessive. So all of these are AR, autosomal recessive, one thing. Second thing is, and most are characterized by skin hyperpigmentation. And if you recall, why do we have that? We said when you stimulate that POMC, that is going to cause increase in MSH, which is co-secreted or co-produced and secreted with ACTH. So all of these are causing, since we talked about here, ACTH, we said everywhere it's high. In the first one high, second one high, last one high, everywhere we have ACTH high. Why? Because everywhere we have low cortisol. No matter what enzyme we're talking about, we have low cortisol. Okay. So that means indirectly we have increase in ACTH. Whenever we have increase in ACTH, that is the ACTH is co-secreted by MSH and also beta endorphins, but MSH is going to cause hyperpigmentation, and that's what we see. So all of these AR, autosomal recessive disease enzyme deficiencies, will have hyperpigmentation. Okay. And not only that, but also bilateral adrenal enlargement. So you have bilateral adrenals on top of kidneys. These are going to be enlarged, okay, because of increase in ACTH stimulation. Okay. Now the second point is that what is B? B results in increase in blood pressure. Okay, yeah, here, which is the 11-deoxycorticosterone, which is a weak aldosterone. It is just going to cause increase in blood pressure. Okay. The last is if, that's the mnemonic now, if the enzyme deficiency starts with 1, it's going to cause hypertension. So 1 HTN 1, right? So if deficient enzyme ends with 1, it's going to cause virilization in female. So let's look at that. So we said if it starts with 1, so 1 is 17 and 1 is here. If it starts with 1, it's going to cause hypertension. Here is the hypertension. Here is the hypertension. If it ends with 1, which is only 1, which is actually 2 of these actually, it causes virilization in females. So 21, 11, virilization. Okay, that's one of the mnemonics. The second mnemonic, another mnemonic which you can think of is all of these are going to, which I talked about just now, all of them are going to cause decrease in cortisol. Decrease in cortisol meaning you have increase in ACTH, meaning you will have hyperpigmentation. That's one important point for all of them, right? Now, other thing that you're going to think of is the ones which are causing hypertension. And you can just think, hey, hypertension is caused when you are retaining sodium, right? So the potassium, there has to be something going on with potassium as well. Whenever you think of sodium as something, you got to think about potassium as well. So all of them which are starting with 1 will cause hypertension and loss of potassium. That's going back here. Let me highlight this part. Look here. Increase in BP, low in potassium. Increase in BP, low in potassium. This is only if you don't understand this. I mean, if you understand the whole point, I mean, the whole thing, if you understand it, I mean, you don't even have to memorize this. You would just know on top of your head that, okay, if you block this, if you block 17 out, all you're getting is aldosterone. What is the normal function of aldosterone? Hypertension, low potassium. You're not making any cortisone. You are going to cause increase in ACTH and increase in cortisone. You're not making any aldosterone. I mean, androgens, my bad. When you're not making any androgens, you're going to lack the secondary sexual characteristics in females, and you're going to lack genitalia and undescendencies in males. Okay, it's just the way when you think about it. Okay, if you think about the other way now, if you think, okay, your 21 hydroxylase is out. When the 21 hydroxylase is out, everything is funneling down into, first of all, your androgens. So you don't have any aldosterone, you don't have any cortisol. All you have is androgen. So what's going to happen is that you will have, first of all, increase in renin activity because you need aldosterone. So renin is going to poke this angiotensin 2 to cause increased aldosterone, which it will not be able to because there is an enzyme deficiency. So you have increased level of renins, but also you have increased 17-hydroxyprogesterone, which is right there, right? And lastly, what you are going to get because of a lot of those sex hormones being there, it's going to present with precocious puberty. Whenever you have a lot of sex hormones, it's going to cause precocious puberty in child and virilization in females. With the second point that I wanted to mention here, with the 1, whatever ends with 1 will cause virilization in females, and it is going to cause precocious puberty in a child. Okay, hope it makes sense. Okay, there's also something called as newborn. Newborn undergo screening for 17-hydroxyprogesterone. So let's just write that down. Newborn. They do screen the newborns for 17-hydroxyprogesterone here. This guy. 17-hydroxyprogesterone levels. Okay. And just a normal thing about the testes and ovaries. If you recall, the testes, they have 2 cells, right? Which we did talk about when we talked about FSH and LH. But here again, Sertoli cells and Leydig cells. Sertoli cells secrete MIF, which is going to cause inhibition of internal female genitalia. And what is internal female genitalia? All the ways start from the proximal vaginal canal, then the cervix. Okay, and that's the job of MIF, Mullerian inhibitory factor. Leydig cell, on the other hand, it releases testosterone. That testosterone is going to stimulate internal male genitalia, and this testosterone, when converted into DHT, will form external male genitalia. Okay, and this is all about testes. Now let's talk about ovaries. Ovaries, when you have the ovary, you don't get MIF, because MIF was just getting from the Sertoli cells, so no MIF, which is Mullerian inhibitory factor. When no MIF, meaning no inhibition, you're not inhibiting any internal female genitalia. So you will form on proximal vaginal cervix and top little uterus. And estradiol now here with the ovaries. So testes are forming, they're leading to release of testosterone, while the ovaries are releasing estrogen or estradiol. This estradiol is going to form external female genitalia, which is distal vaginal canal. Okay, this again we will talk about in the reproduction. With this, I guess that's pretty much it. Maybe I could add a little bit of. So since we did talk about all of the internal and external genitalia, let's talk about a little bit of the sex hormones. Sex hormones, for example, testosterone or anything, estradiol, all of them, right? Androgens. So these guys, if they're low, for example, in the first disease, 17 alpha, there are low sex hormones. So what's going to happen is you have male. If the patient is male, they're going to go into ambiguous genitalia, and the female will have no secondary sexual characteristics when they're low. When they're high, they are going to cause precocious puberty in the infants. And what is precocious puberty? Basically, acceleration of linear growth in child and pubic and axillary hair development in a child. Okay, before the puberty hits, you already have the puberty features, basically, right? And virilization in females. Again, as we said, this is important to just sex hormones when they are low, ambiguous genitalia in male. And in the females, no secondary sexual characteristics. Simple. When they're high, precocious puberty in child, and in females, virilization. Hope it makes sense. And that's going to be all for this page. Let's move on to the next one. All right, now let's talk about the cortisol. Cortisol, the source is zona fasciculata. So you had a G, and F, and R. So F is the one. So G gives you aldosterone. F is for cortisol. R is for androgens. So the cortisol coming from the middle layer, fasciculata, it causes a couple things. The very important thing is just remember this mnemonic and you should be good to go. A big fib. So the way you need to know is increased in a big, but a fib is decreased. Okay, so let's talk about it. Increase in appetite, increase in blood pressure by upregulating alpha-1 receptors on the arterioles, which then causes increased sensitivity to that norepinephrine and epinephrine permissive action. Okay, at higher concentration, can bind to even mineralocorticoid aldosterone receptors. Wow, amazing, right? Second thing, increase insulin resistance, diabetogenic, which if you recall, we talked about cortisol growth hormone, and there was one more. These were all anti-glucagon, all anti-regulatory hormones. My bad. All counter-regulatory hormones, which are diabetogenic, insulin resistance. And the other hand, all you had is just one insulin, which was trying to not get that glucose, out of the bloodstream, right? So this cortisol, that's why the name goes glucocorticoid. It causes glucose to go into the blood vessels, so causing insulin resistance, diabetogenic. The way it causes insulin is to go into the blood. It's the same way, which increase in gluconeogenesis, increase in lipolysis, increase in pyrolysis, and decrease glucose utilization. Now the Fib is all decreased, high yield, decreased fibroblast activity, which causes poor wound healing, decrease in collagen synthesis, which leads to formation of stria, increase in stria formation. So when you don't have collagen, the vessels break, leading to formation of stria. Okay, decreases inflammatory and immune response. A high yield that the cortisol decreases inflammation and immune response, inhibits the production of leukotrienes and prostaglandins, inhibits WBC adhesion, leading to neutrophilia. Right, neutrophilia, not neutropenia. Neutrophilia means increased level of neutrophils. And why is that? Because if you recall, neutrophils, they're like bats. They go into the not kidneys, but lungs, and they are just there upside down, right? And as the inflammation goes, they go there into the inflammatory side. But when you don't have the adhesion, because you give cortisol, you can't have the adhesion molecules through which the neutrophil adheres or are joined to the structure. Now they can't have that adhesion, causing all those neutrophils to go in the bloodstream, causing increased level of neutrophils. Blocks the histamine release from the mast cells. Eosinopenia, meaning low eosinophils. Lymphopenia, low lymphocytes. Block IL-2 production. Now recall, what is IL-2 doing? IL-2 leads to inhibition. Let me just write it here. IL-2 causes inhibition of T lymphocyte proliferation. T lymph proliferation. That is why glucocorticoids are used to prevent the rejection of transplant. So again, rejection of transplant is done by T lymphocytes. You try to inhibit IL-2 production. You try to block that IL-2 production to prevent rejection of transplant by giving glucocorticoids. Okay. And then you have decrease in bone formation, because causing decrease in osteoblast activity. Osteoblasts were the one which were formation of the bone, which form the bone. When you decrease their activity, you're just going to cause decrease in bone formation, leading to osteoporosis. Okay. One more thing which is not mentioned here is something known as lipocortin. Let's just write it here. So it inhibits production of leukotrienes and prostaglandins by synthesis of lipocortin. All the lipocortin does is it inhibits that enzyme that is known as phospholipase A2. Phospholipase A2. And what is phospholipase A2 doing? All it was doing was converting arachidonic acid into your prostaglandins and leukotrienes, which are here. Leukotrienes and prostaglandins by the phospholipase A2 enzyme, right? And this is a very simple thing. But now this is a new thing which is known as lipocortin or lipocortin. So these guys, cortisol causes lipocortin increases or causes increased level of lipocortin, which inhibits this enzyme so you don't make prostaglandins and leukotrienes. Okay. So again, but high yield point, which is again not mentioned here, that is going to be that you need cortisol. It is essential for in response to stress. So essential hormone in response to stress. Essential. Okay. Going back at this, cortisol, it is bound to corticosteroid binding globulin. Corticosteroid binding globulin. Okay. Cortisol is a big fib, but it is increased and that fib is decreased, and you have seen that here. Exogenous glucocorticoid can cause, if you give someone from outside exogenous glucocorticoid, it will cause reactivation of tuberculosis. Reactivation of tuberculosis and candidiasis, because exogenous glucocorticoid is also going to block that IL-2 production, and that IL-2 production and also TNF-alpha inhibition. So all of that will cause interleukin-2 production, and also the TNF-alpha inhibitors, or like, for example, Intercept are going to do the same. So let's just write that. TNF-alpha inhibitors. Okay, so now looking at how we have the regulation is simple. So you have stress, as we talked about, it is essential in stress, and circadian rhythm, which causes the stimulation of hypothalamus. That hypothalamus then secretes CRH, corticotropin releasing hormone, and that causes stimulation of anterior pituitary, which converts again POMC. Here's the POMC, pro-opiomelanocortin, POMC, to get converted into formation of ACTH, but not only ACTH, but also MSH and endorphins. MSH is going to cause hyperpigmentation. ACTH will go into the core and into the cortex, adrenal cortex, into the lead to formation of cortisol, and that leads to cortisol. When it is out, it causes inhibition of hypothalamus, which leads to no release of ACTH. That is why previously we discussed that cortisol, when you don't have cortisol, there is going to be more and more production of ACTH, because all they're trying to do is have that cortisol to give a negative feedback, which they're not getting. So they will make more and more ACTH to go and make cortisol. Okay, and then cortisol is just going to do its downstream cortisol functions, which are a big fib or a big fib. Okay. So let's look at the same regulation here. And that is that CRH in the hypothalamus, corticotropin releasing hormone from hypothalamus, stimulates ACTH release from pituitary, causes cortisol production in adrenal zona fasciculata. Excess cortisol decreases CRH, ACTH, and cortisol secretion. So a simple thing, when you have a lot of cortisol, you're giving negative feedback, low CRH, low ACTH, and eventually causing low cortisol secretion. Simple. Chronic stress may induce prolonged cortisol secretion. Cortisol resistance can occur. Impaired immunocompetency can occur. Dysregulation of HPA axis. And that is also important. One thing that they haven't mentioned is that the cortisol, when it is down here in the bloodstream, it also causes a couple things. First of all, the cortisol also converts norepinephrine to convert that norepinephrine into epinephrine by stimulating enzyme PNMT, stimulated by cortisol. So more and more epinephrine due to the fact that you just have cortisol. Cortisol stimulates the conversion of norepinephrine to epinephrine. That's important. Second thing is going to be when you have low cortisol, it is the function with the ADH. So let's just put normal cortisol first. Normal cortisol is going to have two things. Normal cortisol, okay. It's going to, first of all, I just talked about, it's going to have increased level of epinephrine. And second thing is going to have, it going to inhibit ADH as a regulation, as a negative feedback. When the cortisol is there, it tries to give a negative feedback for the ADH production. But again, this is normal cortisol. So guess what's going to happen when you have deficiency of cortisol? When you have deficiency of cortisol, you are going to have ADH because there's no negative feedback. And you also have increase in ACTH to cause more and more release of cortisol. Okay, let me see if there is anything. So one thing we mentioned here that was that in circadian rhythm, normal circadian rhythm will stimulate hypothalamus, causing release of cortisol, right? So night sleepers, just before waking up they will have the highest cortisol concentration. And what is it lowest? So just before they wake up in the morning, and I'm talking about night sleepers, okay? Just before they get up in the morning, because they have a proper circadian rhythm going on. So just before they wake up in the morning, they're going to have higher level of cortisol. And the lowest level they're going to have is at the midnight. And why am I talking about that? Because it's going to come up later in pathology. Midnight, they're going to have a low cortisol, lowest cortisol. And I guess that is going to be all for cortisol. So let's just go over this. We said cortisol coming from fasciculata binds the corticosteroid binding globulin. A mnemonic is a big fib, or however you want to call it. First of all, you got to know that a big is high and fib is low. So you have increased appetite, increased blood pressure by increasing, upregulating alpha-1 receptors, increased insulin resistance, increased gluconeogenesis, lipolysis, proteolysis. Now, everything else is just going to be decreased. Decreased fibroblast activity, poor wound healing, collagen is low. When the collagen is low, you have the breakage of the vessels causing stria formation, decreased inflammatory response, decreasing inflammatory immune response, but causing increase in neutrophils and decrease in bone formation because decreasing in the osteoblastic activity, which is osteoporosis. In inflammatory response, decreased leukotrienes and prostaglandins by synthesis of lipocortin or lipocortin. So cortisol, lipocortin, which inhibits the phospholipase A2, and that doesn't lead to formation of from arachidonic acid into prostaglandins and leukotrienes. You will not be able to make that. Other than that, you will have eosinopenia, lymphopenia, IL-2 blockade, and yeah, that's pretty much what we have. And yeah, that's pretty much, and you already know regulation. All right, the next thing we have is called appetite regulation. In the appetite regulation, we have a couple things. We have ghrelin, leptin, and endocannabinoids. So ghrelin, the first thing we have, it stimulates hunger. Right, simple. The mnemonic is very good. Ghrelin makes you grow hungry. Okay, so it stimulates hunger, simple as that. Orexigenic effect and GH release, growth hormone release via GH secretagogue receptor. Okay, so two things, hunger and growth hormone release. It is produced by where? By stomach. So stomach produces ghrelin. Sleep deprivation, fasting, or Prader-Willi syndrome increases the ghrelin production. So again, if you think about sleep deprivation, it's going to cause release of ghrelin, which is going to make you grow hungry, which you eat, and cause GH release as well. Important. Okay. We talked about mnemonic here. Ghrelin makes you grow hungry. Acts on the lateral area of hypothalamus, which is the hunger center, to increase appetite. Lateral area. So lateral area of the hypothalamus. Okay, important. The second thing is, okay, one more thing here is what else is going to increase ghrelin production? Well, it is starvation. So they mentioned fasting here, right? So starvation will increase ghrelin levels, and decrease in caloric intake will cause increase in ghrelin production, which essentially stimulates the hunger center, causing making you hungry, and also cause growth hormone release while acting on this lateral area of the hypothalamus. Okay, the second thing is leptin. Well, this leptin is the satiety hormone. Okay, it is produced by adipose tissue. So adipose tissue produce leptin, which produces satiety. Mutation in the leptin gene causes severe obesity. So satiety is like feeling full. Okay, I'm not hungry. But if you have a mutation here now you never feel full. You keep eating, you're going to cause severe obesity. Obese people will have increase in leptin due to increased adipose tissue. First of all, two things. Obese, they have increase in adipose tissue. And that increase in adipose tissue makes it increase leptin, but or tolerant. When you have a lot of level of something, the body gets tolerant to it. There are no more receptors for it. So body becomes tolerant or resistant to leptin, anoxygenic effect, which is basically satiety. Okay. Sleep deprivation or starvation causes decreased leptin production. In other way, this is opposite. Sleep deprivation and starvation was causing increase in ghrelin production, which is makes you grow hungry, right? Here, sleep deprivation or starvation is causing decrease leptin production. Okay, leptin keeps you thin. Leptin makes you thin. Acts on the VM, ventromedial area of the hypothalamus, which is the satiety center, to decrease appetite. Okay, so VM and lateral. So VM. So the mnemonic is going to be something like this. Ghrelin makes you grow laterally. So when you grow, for example, this is a normal person. When you grow, you're going to go laterally. You're going to get big, right? So ghrelin makes you grow laterally. So you can remember ghrelin works on the lateral nucleus of the hypothalamus. Okay. And leptin, the mnemonic for leptin is going to be that leptin is going to decrease the appetite. So it regresses medially. So leptin decreases appetite, so regress medially, which is VM. So if you know first one, the other one, you just know that it is ventromedial. The last one here is the endocannabinoids. Well, the endocannabinoids are they act as cannabinoid receptors in the hypothalamus and the nucleus accumbens, which are two key areas of homeostatic and hedonic control of food intake, which causes increase in appetite. Exogenous cannabinoid causes the munchkins. Okay, it causes the munchkins. So let's talk about a little bit of these endocannabinoids. Endocannabinoids, for example, endocannabinoids are marijuana. Okay, all they are going to cause is, again, increase in appetite. That's why they're called the munchkins. So the way they act is they act on the cannabinoid receptors. Again, where? In the same way hypothalamus. So all of these appetite regulations are in hypothalamus. So lateral, ventromedial, and cannabinoid receptors. And also nucleus accumbens here, a new thing here, nucleus accumbens. Two brain features, which are homeostasis. They do the normal job of homeostasis and hedonic control of food intake. Okay, and leading to causing increase in appetite. Exogenous, like for example, marijuana cannabinoids can cause the munchkin. Is basically you're eating all the time. You're eating, and that is what we have. Okay, lastly, one extra thing that we are going to talk about is called the caloric restriction. So a lot of people go into caloric restriction diet, right? So caloric restriction will lead to weight loss. Let's just mention that. It does lead to weight loss. That weight loss will indirectly cause increase in ghrelin and decrease in leptin. Because weight loss essentially losing adipose tissues, you're decreasing leptin, but that weight loss, because you're going into starvation, you're increasing ghrelin, right? Normal physiology. That also, not only leptin, but also it will decrease insulin. Two things are decreased, one is increased, okay? And that will essentially cause increase appetite. So they will go into increased appetite. They will think about eating more. They want to eat more. And which makes it very difficult for a patient trying to lose weight, trying to go into caloric deficit, but the body is like, hey, what you are doing is not going to work. I'm going to send that ghrelin, which is going to make you grow. So their appetite is increased, which essentially is going to make difficult to maintain that weight loss. So essentially they did the weight loss in the first place, but later on in life, the weight loss is not there, or they regain the weight that they have lost due to the fact that normal physiology is what increase in ghrelin now, although because you have increase in ghrelin and you have decrease in leptin, and that increased ghrelin causes increase in appetite, which is right here, increases appetite. So one last thing, let's talk about here. One more thing is called leptin, right? Leptin decreases appetite, right? That's the normal function of leptin, but obesity will blunt this action. So let's just write it here. Obesity will blunt this action. So obese patient, now you ask, hey, let's just go back a step and say adipose tissues, because in obese patient, we have a lot of adipose tissues, they're producing leptin. Why don't we have low appetite? Because obesity is going to blunt that action. And why? Because you have a lot of leptin in the blood the body is going to get tolerant to it. The body is not even responding to that leptin just due to the fact that you have a lot of adipose tissues, which is seen in obesity. So obesity is going to blunt the appetite function. Let's go over all of these and call it a day. Okay, again, very easy, but very important, okay? All we have is ghrelin makes you important, mnemonic. Ghrelin makes you grow hungry, simple. Okay, it's going to stimulate hunger and also growth hormone release. Sleep deprivation, starvation is going to cause increased ghrelin production. It acts on the lateral area of the hypothalamus, causing increased appetite. Leptin, on the other hand, comes from the adipose tissues, causes, if there is a mutation in leptin gene, causes severe obesity. But the obese patient, although they have increased leptin due to the fact they have increase in adipose tissues, but they become tolerant and resistant to leptin. So that leptin does not work and does not decrease the appetite. Lastly, endocannabinoids, which act on the cannabinoid receptor in the hypothalamus and the nucleus accumbens, causes increase in appetite. And these guys, whoever is taking marijuana or any exogenous cannabinoids, they are known as the munchkins. They are eating. They are hungry all the time. They're trying to eat. One last point is about the caloric restriction, which causes weight loss. It does cause weight loss in the first place. but eventually the patient will go back to that. Why? Because you have a lot of ghrelin being produced, as seen here, with the starvation and hunger. You're going to cause increase in ghrelin, and it will be harder for the patient to stop that that increase in appetite. So they eventually will go back unless they're very determined, and that weight will come back. And it is very difficult to maintain that weight loss. And that is it. All right, we're going to start with signaling pathway of the endocrine hormones. Although this looks low yield, but it is not. It's very high yield because it's simple yet important. Okay, so let's just get started. The first one we have is cyclic AMP. And if you just recall, how do we get, first of all, we got to go back, right? How do we get cyclic AMP in the first place? So if you recall, you have a GS and GIs, right? GIs, GS would stimulate adenylate cyclase, right? And that will stimulate the conversion of ATP into cyclic AMP, right? So GS stimulation is going to get you cyclic AMP, adenylate cyclase stimulation, cyclic AMP. Now, cyclic AMP, which they haven't mentioned here, but they most likely would ask, will further go ahead and do the stimulation of protein kinase A, so PKA. And that PKA will lead to further actions. Now, if you just think about it, all you are seeing here is all the A's. So A, cyclic AMP, PKA. Okay, that's just the signaling pathway here. Now let's see which hormones work through the cyclic AMP. So the hormones are a lot of hormones. Look, FSH, LH, ACTH, MSH, TSH. Wait, actually, let's put CRH as well here. TRH, ACG, ADH, all of that. So the mnemonic they have is called flat, champs, chug. You want to remember that, that's great. But if you just want to know, okay, some hormones, about almost all hormones we're looking at, look, FSH, LH, ACTH, MSH, and CRH, beta ACG, TSH, and ADH. Don't you see almost everything is coming from anterior pituitary, posterior pituitary, except some like oxytocin, except some like ADH V1 receptor. So you can just think about it that way, or you could memorize this, whichever way you like. But most important, let's talk about not which ones are high yield to look into this. So PTH is high yield here, works through cyclic AMP. Calcitonin works through cyclic AMP, high yield. Glucagon here, high yield, works through cyclic AMP. These three are high yield. Others are also high yield, but remember, all are coming from your one is coming from hypothalamus, and this also is coming from hypothalamus, and the rest is just anterior pituitary. Posterior pituitary, all you have is the ADH V2, because oxytocin and the ADH that is working on V1 will work through IP3. Okay, let's look at the next one. That's the cyclic GMP now. Cyclic GMP is going to, the hormones that are going to work through it are also very simple if you think about it. You have the BNPs, ANPs coming from heart, from the ANP from the atria, BNP from ventricles, and you also have nitric oxide, NO, that is all going to work through cyclic GMP. And the mnemonic here is bad grandpa. Okay, bad grandpa works through that's so BAD and grandpa GMP. So all are they doing? They're just doing vasodilation. If you want to remember this mnemonic, you could, but just if you know that, okay, whatever is doing vasodilation, especially your NO, ANP, BNPs, that's cyclic GMP. Okay, the other one now is the IP3. IP3 is, so if this was GS, right? So IP3 is going to work through GQ couple receptor. So GQ would stimulate the phospholipase C if you recall, right? Phospholipase C, and that would eventually stimulate your IP3 and one more thing called DAG, and those are going to stimulate your protein kinase C. So here, what is important is all the C's. For example, let me take a just take a look here. You have a C, you have a phospholipase C, and on cyclic AMP was all about A's. Adenylate cyclase protein kinase A. When they talk about protein kinase C, right away you're going to think IP3 pathway, GQ coupled receptors. When they talk about protein kinase A, you will think about GS coupled receptors. Now let's talk about the actual hormones that are going to work through these. So you have a GnRH, this is exception from the anterior pituitary hormones, right? Oxytocin, ADH, TRH coming from hypothalamus, histamine, and angiotensin 2, gastrin. So these are the ones that go through IP3. The mnemonic that you have here is called GO-TAG. If you're into mnemonics, you could do this. The other one is going to be intracellular receptors. One thing they will ask you, these intracellular, what are they? Well, that's the zinc finger receptors. Zinc finger receptors intracellularly. Okay. So the hormones that work through these are progesterone, estrogen, testosterone, cortisol. So what is common in all of this? So these are all steroid hormones. So all steroids have intracellular receptor. Okay. Aldosterone as well. Now, if you look at this one now, aldosterone, T3, T4, vitamin D, these are also steroid receptors. They also have intracellular receptors. They work like steroid. One thing they haven't mentioned is also vitamin A. Vitamin A also works as steroid. Or something they can mention as retinoic acid. Okay. So these all are going to work through steroids. When you think about intracellular receptors, like intracellular, a receptor within the cell, you're going to think about steroid, progesterone, estrogen, testosterone, cortisol. That makes sense, right? These all are steroids. But when you think about aldosterone, I mean, might be the mind doesn't go there. So aldosterone, you think about aldosterone, T3, T4, vitamin D, vitamin A, they're all like steroid. They work through steroids, work like steroid receptors. And the good point about these, let's just take a look that how they, these steroid receptors, they diffuse from the cell membrane and they go into the cell. And in the cell, they have their own they have these zinc finger receptors or their own receptor known as sometimes, let's say for cortisol, you have something known as heat shock protein receptor, HSP receptor. So when you have these receptors, let's say this is cortisol, it binds to this receptor. When it binds to the receptor, and that leads to dimerization of cortisol, and that then it goes into the nucleus, and in the nucleus it directly binds the DNA. Okay, and then from DNA it's going to start making their reactions. So there'll be formation of mRNAs, and then transcription and everything will go forward from there. But the important point is they diffuse through the cell membrane without anything. Okay, so that is important for steroids. The next is receptor tyrosine kinase, high yield. We did talk about a lot. Receptor tyrosine kinase for insulin. So receptor tyrosine kinase, it has insulin. So insulin works through tyrosine kinase. So here IGF-1, insulin-like growth factor, right? So as the name suggests, so I guess, with the name, you can say, okay, it's insulin-like growth factor. So why not it should work just like insulin? Yes, it's going to work like insulin. This is high yield, this and this. And the rest is just, you have the FGFs, PDGFs, and EGFs. Okay. Other than that, the mnemonic here is called what is this? MAP kinase pathway get found in the MAP. Okay. Then you have this non-receptor tyrosine kinase. So you had a receptor tyrosine kinase. Now you have a non-receptor tyrosine kinase. These are going to be your prolactin, high yield, your immunomodulators, for example, cytokines, IL-2, IL-6, IFN, and growth hormone. Okay. And you're also CSF, CSFs, erythropoietin, thrombopoietin, and all of them. What is important in this? Well, high yield is your erythropoietin, okay, that it works through non-receptor, high yield non-receptor tyrosine kinase, because this receptor tyrosine kinase has an activity called intrinsic tyrosine kinase activity, intrinsic tyrosine kinase activity, okay. So these are non-receptor tyrosine kinase, which are erythropoietin, prolactin, and your growth hormone. Okay, they work through which pathway? JAK-STAT pathway, and the tyrosine is working through MAP kinase pathway, right? And the mnemonic is get a jacked pig. If you are into mnemonics, for sure, you could go with that. But yeah, that's pretty much what we have. Same thing, similar. We talked about the steroid hormone, how the signaling pathway works for steroid hormones. So there is a hormone which binds to the receptor located in the nucleus, or could be in the cytoplasm, not on the cell surface. So it just goes in, binds to the receptor either within the cytoplasm or within the nucleus itself. Okay, the transformation of receptor to exposed DNA binding protein. When this steroid binds to the receptor, takes it in, there's an exposure to the DNA binding protein, and then that receptor binds to that DNA and leads to formation of pre-mRNA, mRNA, and then synthesis of proteins or whatever the further action they're going for. Okay, one thing similar to this is called epinephrine. Let's talk about that. Epinephrine has a surface receptor, so surface receptor epinephrine. Let's just mention it here. Okay, so epinephrine comes and binds to this receptor on the cell surface. Now the difference here is this transmembrane surface receptor then activates the second messenger, which is total normal in everything we see, which activates the second messenger, and then it goes into transcription factors and it goes through activation of the gene within the DNA itself. Okay, that's also a little bit to think of. Steroid hormones, you have to know this. Okay, which are steroid hormones? So with these, you can just think of these are all steroid hormones. Yes, but with the aldosterone, T3, T4, vitamin D, the mind not always go there, but remember, thyroid hormone is a steroid hormone. Aldosterone, vitamin D, vitamin A, all work like aldosterone, work like steroid. Okay, now important point on the right side is that steroid hormones are lipophilic, therefore they must circulate bound to specific protein, specific binding globulin, which increase their solubility. In males, increase in sex hormone binding globulin, SHBG, lowers the free testosterone, leads to gynecomastia. We did talk about it in prolactin, that whenever you have more testosterone bound to its sex hormone binding globulin, there is less free testosterone. That means that it's going to cause increase in estrogen to testosterone ratio, which leads to gynecomastia in males. Okay, that's in males. Now in females, if you were to decrease that sex hormone binding globulin, that is going to raise that free testosterone, and in females, it's going to give you hirsutism, right? So again, same thing. Here, all we had is increased sex hormone binding globulin, right? That would bind the testosterons. Now, when we have decreased sex hormone binding globulins, more free testosterone will be available. And that is going to cause hirsutism in females, right? And the last thing is with estrogen. When you increase the estrogen, for example, in OCPs, for example, in pregnancy, it's going to cause increase in sex hormone binding globulin in high yield. That when you give someone an OCP or they're pregnant, their sex hormone binding globulin increases. Okay, uh, that's also important, and I think this is also going to come in thyroid somewhere. Okay, then what else we might have? Okay, let's talk about simple one more thing here since we were talking about all the receptors. Is about the diffusion. So let's just do it here like this. So we have something known as you know that there was a simple diffusion, facilitated diffusion, and active transport, right? So let's just say required energy, like ATP, for example. Here is no, here is yes. They require and they don't require. Do they require the transport? Protein? Yes and no. So which, and this is the transport across the membrane. So which ones? So for example, if you talk about simple diffusion, they don't need any energy. They don't need any transport because they're simple diffusion. They will diffuse simply. They don't need anything. Now with the facilitated diffusion, what these guys need, they need the transport protein. If you look, this is yes. So they need the transport protein, but they do not need energy. Now, when you think about active transport requires energy. On top of that, requires the transport protein. Okay, that's just there. So yeah, that's pretty much what we have. Let's just quickly go through this page and move on to next. Okay, cyclic AMP, almost all anterior pituitary, posterior pituitary hormone. What you really have to know: PTH, calcitonin, glucagon. Okay, cyclic GMP is all about vasodilation, BNP and PNO. IP3 is all about the rest of anterior pituitary. You can think about GnRH, oxytocin, ADH. On top of that, you can think about angiotensin 2, histamine, intracellular high yield, all steroids with T3, T4, DNA, vitamin DNA, and aldosterone. Receptor tyrosine kinase, you should know insulin, IGF-1. Okay, they have intrinsic tyrosine kinase activity. Okay, with the non-receptor tyrosine kinase, all you got to know about erythropoietin, your prolactin, and growth hormone. And that's going to be all. One high yield again here. If in males, if you have low, let me use the pen here. If you have low free testosterone, then you are going to go into meganogamastia. In females, if you have high free testosterone, you are going to go into hirsutism. And why would you have low or high testosterone? It all depends upon sex hormone binding globulin. If you have normally testosterone binds to sex hormone binding globulins. So if you have a higher SHBGs, more testosterone going to bound, less free testosterone. If you have lower, vice versa. Okay. And that's pretty much all we have. Let's move on to the next. Here, very important is called, now we are going into the pathology section. The first thing we are going to talk about is syndrome of inappropriate ADH secretion. Okay. With this, it is characterized by excessive free water retention, euvolemic hyponatremia with continued urinary sodium excretion, urinary osmolality greater than serum osmolality. Okay, so one thing that you have to know that when we think about, as first of all, you got to know the definitions, right? So when you think about SIADH, what do you think of? Well, you think how simple. The names are complicated, but things are very simple. But you got to know what they are, right? So just think about it as there's increase in ADH. There's increase in ADH. So let's take a look again. Syndrome of inappropriately high ADH levels. Okay, and that is going to cause. Let's take a look at this picture first. So you have ADH, which is stored in the posterior pituitary, goes into the blood. SIADH, which is now known as SIADH, a lot of ADH is going there. So syndrome of inappropriate ADH secretion, a lot of ADH has been secreted. Okay, that excessive ADH is going to cause its normal physiological actions, but now because it's in axis, that's going to look in pathology, right? Um, so what you are going to get is so it's going to go to the medullary collecting ducts, put on those aquaporin channels, and will cause water retention. Water retention. That water retention is going to do what? Okay, when you have that water retention, the body will have an increased amount of water, right? Let me just write this down here. Increased total body water, right? And that increased total body water is going to do a couple things. So the first thing, well, let's just zoom in and write this down here. Because if you understand this chart that I'm going to draw, you understand everything. So SIADH, water retention. Water retention leading to increase in total body water, right? That increased total body water going to do a couple things. First of all, it's going to cause ECF expansion, extracellular fluid expansion, right? And on the other hand, it's going to cause, because you have a lot of water, it's going to cause hyponatremia, right? Natremia meaning sodium level is going to go down, but if you think about it, it's not going down. It's just that you're having a lot of free water that you think the sodium is low. So it's called dilutional hyponatremia. Dilutional, that you have diluted the serum so much that it looks like that you're hyponatremia, but you're not in hyponatremia, because why would you have hyponatremia when you didn't lose any sodium, right? So it's called dilutional hyponatremia. Hyponatremia. Okay, so this dilutional hyponatremia, and you have extracellular fluid expansion. First of all, let's talk about the fluid expansion. ECF expansion, volume expansion, is going to decrease your aldosterone levels, and it's going, because that high fluid overload is going to go into the heart. The whole volume is going to be high, so heart is going to release ANPs and BNPs. So increase in ANP plus increase in BNP. And that increase in BNP will eventually, what they are going to cause, they will say, hey, we think we got so much fluid, let's just throw it out. So the way that they throw out fluid is by increasing urinary sodium excretion. As you remember, the sodium wherever sodium goes, water follows, right? So what they will try to do is they will throw out, so let me just write it here, increased urinary sodium excretion. Okay, and that is going to cause a couple things now since you are now throwing out sodium, that is going to get you into the sodium loss, one thing. But on a positive note, what they are going to cause is normalization of your ECF, extracellular fluid volume, will be normalized. Okay, and so with the sodium loss and normalization of your extracellular fluid volume, you are going to cause euvolumic hyponatremia. Hyponatremia. Okay. Okay, now with this, let's read and we'll come back here to or this chart whenever there is something that we need to understand, okay? So it is, again, it is characterized by excessive free water retention. Here's the first point we talk about is excessive free water retention. That is going to cause euvolumic hyponatremia, euvolumic hyponatremia with continued urinary sodium excretion, continued urinary sodium excretion. Urine osmolality will increase greater than the serum osmolality, right? When you ask why. So when you increase the urinary sodium excretion, okay, that means, let's say this is urine. Here you're causing more and more sodium to go into excretion. It's going to raise its osmolality, simple as that. And because where is the sodium coming from? It's coming from serum, right? So because the sodium is going from serum into the urine, you're essentially decreasing serum osmolality and increasing urinary osmolality, right? So you're causing an increase urinary sodium excretion, which leads to increase in urinary sodium excretion because you're losing sodium in urine. So of course, you're going to cause increased osmolality in urine, right? So that's exactly what I mentioned there. Next point is body is going to respond, which we did talk about. Body responds to free water retention with decreased aldosterone, and increase in ANP-BNP, increase in ANP-BNP, causing increase in sodium secretion. Again, increase urinary sodium secretion, which is again this point. Normalization of extracellular fluid volume. You are normalizing the ECF volume, causing euvolumic hyponatremia, right? Now let's talk about the treatment now. So this is all the pathology. Okay. Now the treatment, let's change in color. Treatment is going to be, you want to go for fluid restriction, first line, salt tablets, IV hypertonic saline, diuretics, ADH antagonists. Example, what is it? Conivaptan, right? Let me make sure. Yeah, conivaptan or tolvaptan, or demiclocycline. So these are all the drugs that you can give to these patients uh, as a treatment. Now, here is some mnemonic for easy recalling. SIADH causes include healed up water. So why, the question is, why would you have SIADH in the first place? Why would you have increase in SIADH, basically increase in ADH levels? Why? And the reason why could be any of this, right? You could have a head trauma, CNS disorder, ectopic ADH secretion from the small cell lung cancer, exogenous hormone, for example, vasopressin you get from outside, desmopressin or oxytocin, lung disease, drugs like SSRIs, carbamazepine, cyclophosphamide. All of them can essentially cause increased level of ADH. And for sure, they got to tell you this when they talk about ADH, right? History is going to be important. History about head trauma, ectopic ADH small cell carcinoma, exogenously taking some hormone, lung disease, some other medication like SSRI, carbamazepine, cyclophosphamide. All of them are high yield, and then this is the pathology that you are going into. Okay, and that's going to be all for SIADH. Some important other points could be, as a summary, we have all you have to think about as a summary point that water retention has happened because of ADH, and that water retention is going to cause hypervolemia in the first place, increased total body water. But your hemostasis is going to start working. For example, that increase in body water will go to the heart. That volume expansion will release ANP, BNP. They will throw out the sodium and trying to have euvolemia. That's the main thing, euvolemia. So if you in a question stem, for example, you will for sure see euvolemia, meaning the volume is going to be normal by the time you see it in the question stem, but high yield is going to be low sodium, and it's going to be low plasma osmolality, and they can also mention increased urine osmolality. So if you have some picture like this, you're going to think about SIADH or increase in ADH another way. Okay, so this was high ADH. So that's pretty much it. Now let's talk about something which is low ADH. Low ADH or ADH deficiency, right? So when you have a low ADH, what's going to happen is it's that because you don't have ADH, you cannot reabsorb the free water. So you will cause hypoosmotic volume contraction. Hypoosmotic volume contraction. Okay. And why is that? It is due to loss of sodium chloride with ECF depletion. So due to loss of sodium chloride with your extracellular fluid depletion. Because you cannot reabsorb water, that extracellular fluid will deplete, and that is going to cause the loss of your sodium and chloride, and that's what is going to give you hypoosmotic. Again, the word is hypoosmotic volume contraction. Okay, so in the labs, what you are going to see is going to be your, first of all, water depletion, so hypovolemia, increase in sodium, and increase in plasma osmolality, and decrease in urine osmolality. The opposite of whatever you have in increase in ADH is going to be with the ADH deficiency. Okay, and that is pretty much what we have. Okay, one last tie-in actually is very high yield is lithium. Okay, lithium, I don't know if they're talking about it here or not. But let's just mention it here, and then they did great. So lithium is going to inhibit, for example, ADH in kidney. So if lithium is going to inhibit in kidney, something known as nephrogenic DI, you will see. So let's take a look at the whole scenario now. So here we have the primary polydipsia and diabetes insipidus, high yield. Okay, so primary polydipsia and DI, which is diabetes insipidus, it is characterized by production of large amounts of dilute urine. Again, what is DI? Diabetes insipidus, you have a low ADH. What is SIADH? You have high ADH. Okay, remember these terminologies, okay? So when you have a low ADH or PP, which is the primary polydipsia, they're both characterized by production of large amount of dilute urine plus minus thirst. Okay, so basically, calling it polydipsia, a lot of urine, or polyuria. Intense thirst, polydipsia, a lot of urination, polyuria. And it's going to cause what? Volume depletion, right? Volume depletion. And when you deplete the volume, you are basically when you deplete your extracellular fluid volume, the more sodium you will see. So it will be hypernatremia because you're losing free water, right? So let's read more now. Urine specific gravity will be less than 1.006. Urine osmolality usually less than 300. Why is it less? Because you're just putting so much water in the urine that you don't have increased osmolality of the urine, right? Central DI may be transient if the damage is below hypothalamic median eminence or in the posterior pituitary. ADH in hypothalamus can still be secreted systematically via portal capillaries in the median eminence. So this is a very high yield thing. All they're saying is, since ADH is formed where? In the hypothalamus, right? ADH is formed in hypothalamus. And if you recall, it is stored in the posterior pituitary for further secretion. So they're saying if you have a damage below the hypothalamus, so let's say you have a damage here, here, anywhere, or in the median eminence, which is right here, or in the posterior pituitary right here, ADH in the hypothalamus can still be secreted. That ADH, because it is produced in the hypothalamus, it could still be secreted in via the portal capillaries in the median eminence, so you will not see deficiency. Okay, because it's not made anywhere here; it's made in there. But if you have a problem in the hypothalamus, guess what? You will not be able to make ADH, right? So let's read now. Central DI, also known as arginine vasopressin deficiency, is the name for it. Okay. The next one is nephrogenic DI, also known as arginine vasopressin resistance. Okay. This is also important. Why is it important? Because first, it does not write anything extra. If they have mentioned arginine vasopressin deficiency, that means it is important that you have to know, okay, when we think about ADH, a new name we have to think about is arginine. Arginine. You already know vasopressin. Vasopressin is ADH. Deficiency is deficiency. No question about it. So arginine is a new name. Let's just say that. So when you have arginine deficiency, you will think about central DI because there is deficiency. But here in nephrogenic DI, it's called resistance because it is a resistance, and we will see how. So let's take a look at each one of the details. All right, the first thing we have is primary polydipsia. With the primary polydipsia, the definition here is that there is an excess water intake, as the name suggests. Polydipsia, intense thirst, that they will drink a lot of water, excess water intake. Causes are your psychiatric illness, hypothalamic lesion affecting the thirst center. So either they have some problem, psychiatric illness, or their thirst center, there's a problem there, which is not letting them stop, or they don't have any regulation. So thirst center or psychiatric illness. Okay. Serum osmolality, because you are putting so much water in the extracellular fluid, that serum osmolality for sure is going to go down. ADH levels, for sure, either is going to be going down or normal, but think about it as low because you have more water inside. You don't need ADH to bring more water in because you already have a lot of water. Okay, if you were to restrict the water restriction test. So let's take a look at A first. What is water restriction? No water intake for about 2 to 3 hours, followed by the measurement of urine volume and osmolality, as well as plasma sodium concentration and osmolality. Okay, you don't take water in for 2 to 3 hours, and then you measure the levels. So if you were to have water restrictions, you will see there is a significant increase in urine osmolality. There's a significant increase in urine osmolality, greater than 700. Okay. Desmopressin administration. What is again desmopressin? Is for the ADH, so we're not going to read in primary polydipsia, but anyways, this is ADH analog, as we talked about. It is administered if serum osmolality is greater than 295 to 300, and the plasma sodium is greater or equal to 145, or urine osmolality does not increase despite increase in plasma osmolality. We'll talk about ADH desmopressin when we talk about central DIs. But treatment is going to be water restriction, simple as that, because you're drinking more water from outside. All you got to do is restrict the water. You will be fine. Everything will be good. But you got to treat the disease, either psychiatric illness or either you look in the third center. Is everything okay with that? Okay. So now the second thing is all about your central DIs and nephrogenic DI. So you have a low ADH. Central means coming from the top, brain and everywhere else, posterity, right? And nephrogenic means working in the kidneys. So when you by definition, the central is decrease ADH release. And by definition, nephrogenic is you have ADH in the bloodstream, but it is resistant, meaning it's not working on the kidneys itself. Okay. What are the causes for decreased ADH release from the top? You have idiopathic, we don't know the cause. Brain injury could lead to that. For example, trauma, hypoxia, tumor, surgery, infiltrative diseases. Okay, any disease of this sort can cause decreased release of ADH. And the nephrogenic resistance, why would you have resistance, right? It is resistance due to hereditary cause. For example, V2 receptor mutation. So ADH works on V2 receptors in the kidneys. There's a V1 receptor it works on, but that's only on the blood vessels. So here, when we talk about nephrogenic, we're talking about V2 receptor. Hereditary mutation in the V2 receptor is going to cause resistance because there is a mutation in that receptor where normally ADH works on. Now, because there's a mutation in that receptor, the ADH will not work on it. So no matter how much ADH you have, nothing will work. And that's going to come in handy when we talk about this treatment, because no matter how much from outside you give desmopressin, nothing is going to work. So we will give something else. We'll do something else for that. But here, hereditary V2 receptor mutation, drugs, for example, which can cause it, again, lithium, demiclocycline, they are all going to cause this ADH resistance by inhibiting the ADH receptors. Hypercalcemia and hyponatremia. Okay, so let's just write this down. Low sodium, potassium, and high calcium, and lithium, and this demiclocycline or hereditary mutation. All of them can cause nephrogenic DI. So what's going to happen is, with these, both of them, you are going to have increase in serum osmolality. Increase in serum osmolality because you can't get, again, what was the normal? You got to know the normal, right? Always go back, what is the normal physiology of ADH? Normal physiology of ADH is to bring that water back into the blood by putting on those aquaporin channels, right? But since you don't have ADH, when you don't have ADH, you cannot bring back that water. When you cannot bring the water back into the bloodstream, you are going to cause increase in serum osmolality. Simple as that, right? Okay, now ADH levels, for sure, we said it is decreased here. Here, it has to be high, or it could be normal, but high is the more appropriate way, because there are a lot of ADH here, but they're resistant, meaning it's not working on its receptors. Now, water restriction test. With 2-3 hours, you try to take no water for 2-3 hours, followed by testing. What do you see change? There is no change or slight increase in urine osmolality. And why there's no change? Because no matter what you do, you don't have the ADH. Simple as that. You don't have the, let's say, nucleus that produces ADH. So there's going to be no change. With the ADH resistance, again, there's going to be no change because no matter how much ADH you're going to put in, the receptor is not working, so you will have no change. Now, with the administration of desmopressin, this is the important thing and very differentiating point in both of these, that if you were to give desmopressin, now what's going to happen with a central DI, which had a low ADH, you give ADH from outside, the patient is going to feel better. Everything will just go in. He's going to be better, right? Because you're giving ADH, you don't have any receptor problem. ADH is going to work, and all good. But with the resistance, no matter how much ADH you give from outside, it's not going to work. So you have to manage the underlying cause. What is the underlying cause? Lithium. Stop lithium. Demiclocycline. Treat hypercalcemia. Treat hypokalemia. Okay. Put the patient on low solute diet. Hydrochlorothiazides, amiloride, or endomethacin. All of them are the treatment for nephrogenic. Okay, let's review this part. primary polydipsia, endocrine, and ADH, which is diabetes insipidus, all you will see is going to be your polyuria and polydipsia. Okay, and that so with the primary polydipsia, you're taking a lot of water, either psychiatric illness or third center illness. Because you're taking a lot of water, serum osmolality is going to be down. And if you were to do the restriction on water, you will increase your urine osmolality, and the treatment is going to be your water restriction. With a central DR, nephrogenic DI, with the central meaning from top, for example, hypothalamus or the ADA, anterior posterior pituitary, something is wrong. But the question arises if you, again, very high yield, that if you have a damage anything below hypothalamus, you are going to cause transient DI, transient central DI. Why? Because ADH is produced from hypothalamus, so you will not be going into permanent DI. But if you knock out your hypothalamus, you are going into permanent DI, not transient, permanent DI. That's also a very high yield point. Okay. Other name for ADH, low ADH central or nephrogenic is going to be arginine, either arginine deficiency or arginine resistance. Okay, so with that, let's quickly look at both of these, central and nephrogenic. Central, again, low ADH resistance with the nephrogenic causes are high yield. Okay, with the ADH resistance, high yield, again, with the hereditary mutation of V2 receptors or drugs, lithium, demyclocycline, hypercalcemia, hypokalemia. They will both lead to increased level of serum osmolality. ADH is, again, a differentiating feature. With central, you have a low ADH. With nephrogenic, you have high ADH. That is why in central, you can treat it by giving ADH. And in nephrogenic, you don't give ADH from outside because there is resistance. So you treat the underlying cause and the other things. With the water restriction, there's no change. And desmopressin administration will significantly increase urine osmolality. That's high yield for central, but minimal change in urine osmolality with nephrogenic DI. Okay, and this is a pretty nice graph, although, if you take a look at it, I mean, if you understand it, the normal is this. When you give, this is normal urine osmolality 500. When you give outside, from outside, you give DDAVP, which is desmopressin, is going to increase urine osmolality, and also this is normal. So if this is normal, straight up here, if you give someone DDAVP, nothing changes. Is permanent nephrogenic DI, or not permanent, is called complete nephrogenic DI because nothing is changing. But if you were to give DDAVP, which is desmopressin, and it does change a little bit, that's just a partial nephrogenic. With primary polydipsia, it again has nothing to do with DDAVP, so it will just continue to move higher and higher. And just the one thing that will have the most effect when you administer DDAVP is going to be your central. So it's going pretty low, but as soon as you give DDAVP, it's going to increase urine osmolality, which is also denoted right here. And in a graph, you will see it like this. Okay, and that is pretty much it for that primary polydipsia and diabetes insipidus. Moving on to the next one. Okay, now let's talk about hypopituitarism. As the name suggests, hypopituitarism. There's the under secretion of pituitary hormones. What are the factors? Why did this happen? Well, it could be a problem in hypothalamic diseases, for example, a mass lesion, radiation, infiltrative disease, pituitary surgery, pituitary disorder, for example, mass effect due to non-secreting pituitary adenoma, or craniopharyngiomas, or empty sella. If you recall, the anterior pituitary was sitting on the sella turcica, that's the bone, right? If you have an empty cell, I mean, this whole thing is empty, there is no anterior pituitary, of course you are going to go into undersecretion of pituitary hormones. Okay. High yield point is going to be Sheehan syndrome. Sheehan syndrome is an ischemic infarct of the pituitary following severe postpartum hemorrhage. Okay. So question is, why does this happen? Well, when you go into pregnancy, there is a pregnancy-induced pituitary growth, right? Because you need more and more hormones. The pituitary grows in pregnancy. When you grow in pregnancy, you need more blood. So while you're pregnant, you're giving more blood supply and everything. But when you are going into postpartum bleeding and hemorrhage, you are going into hypovolemia. You are going into hypoperfusion of this area, leading to ischemic infarct. Okay, let's read back this here. Pregnancy-induced pituitary growth occurred, which leads to increased susceptibility. They're susceptible to hypoperfusion. Usually presents with failure to lactate, amenorrhea, cold intolerance. Anterior pituitary hormones mainly affected. Why? Because posterior pituitary were coming from hypothalamus, right? Treatment is hormone replacement therapy. For example, you give glucocorticoids, you give thyroxine, sex steroids, human growth hormone. All of them can be given. Okay, with this, also let's talk about something. When we think about undersecretion, right? Hyposecretion of hormones specifically. So we say, let's say ACTH is undersecreted, let's say ACTH deficiency. It will lead to hypotension, weight loss, and hypoglycemia. Weight loss, hypoglycemia. And due to the fact that, can you recall which, where does the ACTH go and stimulate? Well, if you recall, if you're saying from the GFR, you're saying F and R, then you're right. They stimulate F and R. F making the cortisol, and R making the androgens. So with the cortisol, because you cannot maintain the vessel, you cannot have the cortisol work on the vessels, you're going into hypotension because they're going to vasodilation, hypoglycemia because cortisol is also a glucocorticoid, remember? So, and weight loss is going to be there with ACTH deficiency. With gonadotrophins, let's say gonadotrophins, low gonadotrophins in women is going to cause amenorrhea, infertility, and in men it's going to cause loss of libido and again infertility, right? One high yield point is that you don't cause any of undersecretion. So let me put it this way: symptoms of hypopituitarism arise when you have greater than 75% of pituitary parenchyma being lost. So you need to have about more than 75% of destruction of the pituitary in order for you to have symptoms, which are all of these and the ones that I mentioned. Okay. And yes, that's going to be pretty much all we have. Simple yet important. Let's take a look at now acromegaly. Well, acromegaly is all about excess growth hormone in adults, right? So if this is in adults, what about in children? If you have increased growth hormone in children, it's called gigantism, right? So in adults, we are talking about acromegaly, typically caused by pituitary adenoma. Okay, so pituitary adenoma, meaning this adenoma is, wait, one more thing here, very high yield. When you think about pituitary adenoma, the most common hormone they will secrete is the prolactin, most common hormone. But second to that, most common is going to be your growth hormone. Okay, so here, if you think about pituitary adenoma, we can say this adenoma is secreting growth hormone. And this growth hormone is just causing in adults acromegaly. And if it was a children, it would cause gigantism. Okay. With that, let's look at the findings. The findings are that you have large tongue with deep furrows, frontal bossing, high yield. Look at the frontal bossing. Look at the normal baseline picture. And look at with acromegaly, with growth increase in growth hormone. The whole everything is almost changed here. Frontal bossing, coarsening of facial features, with aging, deep voice, diaphoresis, excess sweating, hypertrophic arthropathy, high yield. This hypertrophic arthropathy is basically your hypertrophy of articular cartilages, articular cartilage, and that is going to cause in these patients arthralgias, high yield arthralgias, because the cartilage has gotten so bigger. You have hypertrophy of those articular cartilages that it causes now pain when they move, and also causing this arthralgias with osteoarthritis, right? So these two things with the hypertrophic arthropathy. Impaired glucose tolerance, because if you recall, growth hormone was counter-regulatory hormone to the insulin, right? All they wanted, these counter-regulatory hormones, they wanted to increase glucose within the bloodstream. So that is why they will have a lot of glucose, causing insulin resistance, hypertension, left ventricular hypertrophy, and you have heart failure with preserved ejection fraction, and this is the most common cause of death. So these patients go into heart failure, but with preserved ejection fraction, and this is going to be the most common cause of death in these patients. Now, if you think about how this happened, it's that when you're growing everything with this growth hormone, you're also growing your cardiac muscle, right? When your cardiac muscle is growing, it's going to cause left ventricular hypertrophy, which is mentioned right there, right? And after left ventricular hypertrophy, eventually they will go into heart failure, right? Cardiomegaly, important thing they will mention in the findings. The patient went into cardiomegaly. With the cardiomegaly, the PMI, the maximum impulse is going to be into the axilla. The maximum impulse is going to be deranged from the fifth intercostal all the way going to the axilla. Okay, and that's the cardiomegaly. Okay, what else we might see with this? So high yield point, which I don't know why they haven't mentioned, but it's going to be that these patients, they will classically say, hey doc, my ring size does not fit me anymore. My shoe size does not fit me anymore. Okay, so increase in hat size, increase in ring size, increase in shoe size. Okay, or in females, they can come with carpal tunnel syndrome, okay, or OSA, obstructive sleep apnea, as well, OSA, because you have growth of the tissue so much that it is going into OSA and it's going to carpal tunnel syndrome. Okay. So with that, let's just look at one last thing here. When you think about growth hormone axis in adults, you're going to think of growth of everything. So growth of visceral organs, so all the organs growth, enlargement of all soft tissue. What are the soft tissues? For example, bone, cartilage, everything is going to be increased in size. Okay. So let's look at here now. The second point is increase in growth hormone in children is called gigantism. Now in gigantism, you see increase in linear bone growth due to unfused epiphysis, or epiphyseal plates are not fused. So their growth, gigantism people, they will have height they will be very tall, large hand, big guys, right? Big people. That's the gigantism. Because why? Because their linear growth has been increased, because they did not fuse their epiphyseal plate with the adults. Because the epiphyseal plates are fused, all they are going to grow is their organs, visceral organs, and soft tissues. Well, in gigantism, you're growing the linear bones. Okay, that's very important. Now, acromegaly in adults and gigantism in juniors, that's mnemonic. Okay, and then let's talk about diagnosis. How do you diagnose this? Oh, well, diagnosis is simple. If you recall, we said the growth hormone to diagnose growth hormone has a direct function of only one thing, and that was on adipocytes, right? And secondly, it was just going on liver, causing release of IGF. So that is why we check for the level of IGF, which is insulin-like growth factor, because this is the main guy who does all the job. Okay, so here, increase in IGF-1, its growth hormone levels, unreliable as they fluctuate throughout the day. Okay, that is why you check for IGF-1. Okay, failure to suppress growth hormone following oral glucose tolerance tests like OGTT, pituitary mass seen on brain MRI. Okay, so again, how do we diagnose? We diagnose it by looking at increased level of IGFs. Okay, and we diagnose by failure to suppress by giving oral glucose tolerance test. Okay, or we actually, when we looked in the brain MRI, we saw the proper pituitary mass, so we can then say, okay, we have diagnosed the problem. One important thing, which again, I don't know why I didn't mention, is called prolactin. So if you recall, whenever you have the growth hormone is going to increase prolactin secretion. You increase growth hormone, you increase prolactin, simple as that, right? So when you have increase in growth hormone, that should give you increase in prolactin. So you should also see increase in prolactin levels. Okay. And let's look at, now with that, let's look at treatment. In treatment, we have pituitary adenoma resection. If we see there is a problem in the MRI, there is a pituitary adenoma, we just go with the resection of that. Simple. If not cured, okay, treat with octreotide, which is somatostatin. Anything with the statin, you can say it's the inhibition. Okay, what is inhibiting here? Somatostatin. So it's inhibiting somato, which is again, if you recall, somatomidin, somatostatin, all of them are growth hormones, and somatomidin being IGF-1. And you can go back to physiology, see that one. But somatostatin, which is octreotide analog, can be given as a treatment. Pegvisomant, which is growth hormone receptor antagonists, can be given, or dopamine agonist, for example, cabergoline. Again, what are you trying to do with dopamine agonist? Well, you're trying to inhibit the release of prolactin and in turn release of growth hormone. So let me just do it here. I'll write this down here. So octreotide, your octreotide and dopamine agonists, both are going to inhibit the growth hormone release from anterior pituitary, okay? Essentially leading to decreased GH and decreasing in IGF-1, which is insulin-like growth factor 1. But also on top of that, because you're inhibiting the release from anterior pituitary, if there is a mass, you're decreasing the adenoma mass, adenoma size, right? Because you're decreasing secretion of whatever it's producing, so for sure it's going to decrease the size. Well, on the other hand, this pegvisomant is going to inhibit IGF release from liver. Why? Because pegvisomant is growth hormone receptor antagonist, and again, recall, growth hormone works on liver. So there's a receptor that it works on. So you try to block this receptor, you are going to have growth hormone, but what you're not going to have is IGF-1. That's exactly with pegvisomant, that it's going to inhibit IGF-1 release from liver. Simple. Okay. But if again, first of all, if nothing goes out, then you can go for it's called transphenoidal resection of pituitary gland. So transphenoidal resection of pituitary. That's one thing. Or second, these are all the meds you can give. The third thing is that you can give radiotherapy, which is radiation basically. Okay. Okay. One last point is you have to screen these patients for colonic neoplasm. So screen these patients for colonic neoplasms with colonoscopy. So with these patients, you got to do colonoscopy. This is acromegaly is associated with men1. Okay, and we will see what men1 is later on. Okay, and that's going to be all for acromegaly. Let's just quickly review this and move on to the next part. Acromegaly, first of all, is hypopituitarism. Hypopituitarism, everything is low. Under secretion, could be disease of hypothalamus, could be surgery to pituitary or any pituitary disorders. For example, there's an adenoma or craniopharyngioma, or there's just empty sella, or high yield Sheehan syndrome. Sheehan syndrome is that it did grow in pregnancy, but now because we lost so much blood that it needs more blood, and now we don't have the blood, so it's susceptible to hyperperfusion, leading to ischemic infarct of the pituitary. Okay, and then it's going to cause failure to lactate, amenorrhea, cold intolerance. So postpartum woman with impaired to lactate, with amenorrhea, with cold intolerance, all the anterior pituitary mostly affected. Treatment is you got to give hormone replacement of whatever is damaged. Then you have acromegaly, which is excess growth hormone in adults. Findings are large tongue, coarsening of facial features, deep white diaphoresis, with arthropathy leading to osteoporosis and leading to arthralgias, increase in head size, increase in ring size, increase in shoe size, all are findings. And then you have this, there is an impaired glucose tolerance leading to insulin resistance, leading to secondary diabetes mellitus, right? Hypertension, high yield is because you're growing the cardiac tissue, leading to left ventricular hypertrophy, causing heart failure, cardiomegaly, basically, all of that, right? Diagnosed by increase in IGF because growth hormone fluctuates. So you can look at increased level of IGFs. Okay, with normally glucose should suppress the growth hormone, but if the glucose does not suppress the growth hormone, then you can also think about acromegaly or increase in growth hormone, or you could actually see the pituitary mass on the MRI. If you do the MRI, you see the pituitary mass. Treatment is, if you have the pituitary mass, do a transphenoidal resection of that tumor, okay, or give octreotide somatostatin analog or dopamine agonist, both are going to inhibit the growth hormone from the anterior pituitary. Well, pegvisomant, which is a growth hormone receptor antagonist, it will lead to decreased level of IGF-1. And that is going to be all for acromegaly. So let's take a look at one thing for, this was all about high level of ADH, right? And in children, you were thinking, I mean, there is a increase in linear bone growth, but what about we have a low growth hormone? Well, again, it's different in children and different in adults. In children, if we have a low growth hormone or growth hormone deficiency, again, simple thing, decrease in linear growth. With decrease in linear growth, we are going into short stature and dwarfism. Short stature, dwarfism. Okay, in children and adults, we have we will have a decrease in lean muscle mass, central obesity, increase in cholesterol, LDL cholesterol levels, and they will have, essentially they will have fewer signs symptoms because other counter-regulatory hormones like glucagon, cortisol, catecholamines, and all these are going to take over and do the job. Okay, so but what you will see is decreased muscle mass, central obesity, and increase in LDL cholesterol levels. And that is all for growth hormone. Okay, now let's talk about hypothyroid and hyperthyroidism. Very important, okay? Hypo and hyper. So as a mnemonic, you can just think of everything with hypothyroidism. Let's just put it here. With hypo, everything is going to be low. There are some exceptions, but just mostly with hypo, everything is low. Everything low. And with hyper, everything high. But there are some exceptions, okay? And we will take a look at that as well. So let's just take a look at now each one of the details. Now, metabolically, with hypo, these patients are going into cold intolerance, okay? And the way you think about cold is if you go low in temperature, you are going into cold. So I said everything low, low temperature, cold intolerance, okay? Decrease in sweating. Weight gain is an exception. So weight is an exception, which is high, okay? And decreasing in basal metabolic. Weight gain is due to the fact that you have a decrease in basal metabolic rate, so BMR. That decreases the caloriogenesis, okay? And then hyponatremia, low in sodium, leads to decrease free water clearance. Okay, with the metabolic on the hyper, we have heat intolerance, we have increased sweating, we have weight loss. So exception here is weight loss because of the fact that you're increasing the synthesis of sodium, potassium, ATPase. That increases the basal metabolic rate. Again, the BMR is increasing caloriogenesis. Okay. That's with the metabolic. Now with the skin and hair, we have a dry, cool skin due to decrease in blood flow. Coarse brittle hairs, high yield, coarse brittle hairs, diffuse alopecia, brittle nails, puffy faces, high yield generalized non-pitting edema, mixed edema due to increase in GAGs, glycosaminoglycans in intestinal, interstitial spaces, increase in GAGs in interstitial spaces, increased level of osmotic pressure, water retention. That's the whole point we're trying to figure out. Water retention. Okay. On the other hand, hyper is going to give you warm, moist skin due to vasodilation, fine hairs, onycholysis, which is picture A. Where's picture A now? Okay, here. Okay, this is and then you have the pre-tibial myxedema and the Graves' disease. Okay, what else might be there? Okay, something that they haven't mentioned, which is also very high yield. It's about when you talk about increase in metabolic rate, you also have to think about there's increased metabolic rate and direct vasodilation. So let's just say increase in vasodilation. It might come up, but I'm just going to write it here. Increased vasodilation that will lead to decrease in SVR, which is systemic vascular resistance, which is also known as TPR, right? Or peripheral resistance. So when you increase vasodilation, you're decreasing the TPR, and that is going to cause decrease in diastolic blood pressure. Important. And we will talk about that in a bit. Um, but then you have this ocular findings. Well, the ocular, you have again high yield preorbital edema. Let's take a look at picture C, preorbital edema. Okay. Uh, and in hyper, you will see ophthalmopathy and Graves' disease, including you will have periorbital, my bad, not pre, but periorbital edema, and high yield is exophthalmos for the Graves' disease. Graves' disease, exophthalmos. Lead lag retractions will be seen because of increase in sympathetic stimulation of the superior tarsal muscles. Okay. Uh, and since we are talking about here the Graves' disease, one of the things that we can do to treat this problem, which is the exophthalmos, and that is going to be your treatment of the Graves' disease by giving glucocorticoids, which essentially decreases inflammation, which would decrease the exophthalmos or the Graves' disease ophthalmopathy. Okay. The next one here we have is the GI, which is for constipation, decrease in GI motility, decrease in appetite. So everything is low if you think, right? Decrease in GI motility leading to constipation, decrease in appetite. With everything being high, hyperdefecation leading to diarrhea, increased GI motility leading to diarrhea, increase in appetite. Then you have MSK, musculoskeletal. Musculoskeletal, you have hypothyroid myopathy, which is proximal weakness. That proximal weakness causing increase in CK levels. Okay, high yield. You don't think about proximal muscle weakness with hypothyroid, but this is important because if you think about the other way, let's look at this hyper one. This is thyrotoxic myopathy. Again, you have proximal weakness, but a normal CK. So both are giving you proximal weakness, so proximal muscle weakness, but one is giving you the normal CK, another one is giving you a high CK. Okay. But there are also a couple more differentials that go with high CK, proximal muscle weakness. What are those? Well, those are going to be something, if you can recall, polymyositis, dermatomyositis if there's skin involved, right? But also statins, if you think about it, statins giving you proximal muscle weakness, right? Which would also increase cyclic, not cyclic, but CK, creatine kinase. Okay. With the normal CK, there are also differential diagnoses. What are the differential diagnoses with the normal CK but proximal weakness? You have glucocorticoid muscle myopathy. So due to the fact that someone is taking glucocorticoid, it leads to myopathy. The second thing is your polymyalgia rheumatica. Then again, you also have thyrotoxic myopathy as well. And these are the things for differentials when you think about proximal weakness within high yield. Okay, because only with one thing you can right away tell where's the problem. So if you have proximal weakness with increased CK, what do you want to do? You want to check for TSH testing. So next best step would be, if you see hypothyroidism, you want to check for TSH testing to confirm the diagnosis. But another way, you can also see all of this in polymyositis, dermatomyositis, or statin therapy. So high yield. And with this polymyositis, polymyalgia rheumatica, and glucocorticoid induced myopathy can lead to normal CK levels. Okay, moving on with the carpal tunnel syndrome, myoedema. High yield myoedema is again very high yield. Okay, it's a small bump arising on the surface of the muscle when struck with a hammer. You struck a small muscle with a hammer, there's a myoedema, bump comes on it. High yield for hypothyroidism, okay? And for the hyperthyroidism, we have osteoporosis, uh, increased fracture rate, because T3 stimulates the osteoclastic activity, differentiation, uh, and causes increased bone resorption that leads to osteoporosis, and release of calcium may affect the osteoblasts. Again, what did we talk about? We said this is again very high yield, so I'm just gonna talk about a little bit of this. So we said with increase in thyroid, we are going to cause osteoporosis, increase in fracture rate, okay, increase in fracture rate. All is everything due to the fact that the T3 is stimulating the osteoclast differentiation, and that is going to essentially cause increase in bone resorption. When you increase the bone resorption, you are going to release calcium, hypercalcemia. That's one thing. And it's going, because when you are reabsorbing the bone, and it's going to cause osteoporosis, which leads to increase in fracture rate, all due to the fact that you have increase in T3, which is directly stimulating osteoclast differentiation. Okay. Reproductive high yield. Here we will have AUB, abnormal uterine bleeding, decreased libido, infertility. Okay. Again, you will also see AUB in the hyperthyroid. You will see infertility. You will see decreased libido. The only extra thing that you will see in hyperthyroid is gynecomastia. Other than that, the whole reproduction is all same, no matter you're in hypo or hyper. Okay. And then one thing which is different, which I don't know why they haven't mentioned, is with the hyper, you will see oligomenorrhea. Okay, and with hyper, you will see oligo. With hyper, you will see increase in menstrual flow. Okay, that's reproductive. And the next one you have is neuropsychiatric. Neuropsychiatric, you have hypoactivity, lethargy, fatigue, weakness, depressed mood, decrease in reflexes, delayed slow reflexes. So important. What is important here? Low reflexes is high yield. Why is this high yield? Because the other one is going to give you, increased reflexes, which are brisk reflexes. Here you have low or decreased, delayed or slow reflexing. Again, with this, you have hypoactivity. These patients will have hyperactivity, restlessness. They're not getting tired no matter what they're doing. These hypo are going into lethargy. They're always tired. There's fatigue in hypo. There's weakness in hypo. In the hyper, restlessness, anxiety, insomnia. They're not sleeping, but still they're like, hey, we're not tired. Restlessness is there. Okay. But importantly, fine tremors because of increase in beta-energetic activity. You have fine tremors. Okay. In the cardiovascular, we will see bradycardia, dyspnea on exertion. Why? Because you are decreasing cardiac output. That is why you will have dyspnea, shortness of breath on exertion. You're trying to exert, but you don't have a cardiac output. You are going into shortness of breath, SOB, dyspnea, bradycardia. While on the other hand, not techie, but hyperthyroid is going to give you tachycardia, high yield, palpitation, with tachy leading to palpitation, dyspnea, shortness of breath, arrhythmias. Okay, arrhythmias, for example, AFib. Okay, AFib. What else? Chest pain, systolic hypertension due to increased number and sensitivity of beta-adrenergic receptors. Okay. And you will have increased expression of the cardiac sarcolemmal ATPase, decreased expression of phospholamban. Okay, one important point that they have mentioned, which you need to know, is increased in systolic hypertension, right? Why specifically systolic hypertension, we should say, right? Why? Because if you recall, we talked about how in hyperthyroidism, you're causing increase in the vasodilation, which will decrease the systemic vascular resistance, which will decrease the diastolic blood pressure. When you're decreasing the diastolic blood pressure, so let's just say when you're decreasing diastolic blood pressure and you are essentially causing increase in systolic hypertension. So if you, let's just write it here, decrease systolic, increase in systolic, decrease in diastolic, the pulse pressure will also go high. So increase in pulse pressure. Okay. And what is the pulse pressure? Pulse pressure is difference between your systolic minus the diastolic. So here the difference is a lot because you're decreasing one thing, the other thing you're increasing. It's causing increase in pulse pressure. Okay. Other than that, tachycardia. So you will see a patient with, so let's just put it this way, thyroid heart. Let me erase this part and right here, the cardiovascular things. So thyroid hormone directly affects on the heart and blood vessels. So heart plus vessels. So the things they do is increase in vasodilation, which leads to decreased SVR, which leads to decreased diastolic blood pressure. We talked about it. Second thing it would do is increase contractility. When you increase contractility, now you're going to cause a couple things. You're causing increase in ejection fraction, increase in cardiac output, and this is going to cause high output heart failure. So with thyrotoxicosis is one of the cause of high output cardiac failure. Okay, with increased contractility, you're causing increase in myocardial oxygen demand. Okay, you're also causing increase in pulmonary artery pressure and high yield. Because of one thing about increase in myocardial oxygen demand, that you're causing increase in demand for oxygen from the cardiac muscle, there is a propensity that you can go into angina, okay, with thyrotoxicosis. And lastly, important factor is increase stroke cause. Increase in, not stroke cause, but increase in stroke volume. We're talking about contractility on the heart. So increase in stroke volume, which will lead to increase in systolic blood pressure again, which we talked about here. Where is it? Systolic hypertension. And that was due to the fact that you're increasing cardiac output, increasing ejection fraction, increasing stroke volume, increasing in systolic blood pressure, while not maintaining, but decreasing diastolic, eventually increasing your pulse pressure. Okay, I hope this makes sense. If it does not make sense, you need to go back to cardiology. Okay, what else that could be an important point here? Okay, hypertension. Okay, HDN. HDN is due to the fact that you have increase in PVR. So HDN is caused, although if you look here, you have bradycardia, right? High yield, bradycardia, low pulse, but you will see hypertension even in your hypothyroidism, but you also see hypertension in hyperthyroidism, but the factors are totally different. Okay. What else we can think of? Okay, yeah, that's pretty much it for the cardiovascular. Now let's take a look at labs. In the labs, what we will see is labs, you have increase in TSH. So first of all, you know that you have, this is hypothyroidism, right? With hypothyroid, you will have increase in TSH because they want to stimulate the thyroid hormones. So they all send in TSH. But you still have decrease in T4. Why aren't we talking about T3? Because T3 levels fluctuate. If you look here, we are not talking about an hypothyroidism T3, but here we do see T3 there. But we don't look at T3 much. We look at T4, TSH more. Why? Because T3, let me write it down, T3 high yield, T3 levels fluctuate. Okay. because it is mainly produced when you convert T4 into T3. So you don't know how much T3 you're going to produce because it all depends upon what T4. So we say, hey, why not we just skip that and let's look at T4. So that is why we only look at T4 because T3 levels again fluctuate. So it could be normal or decrease. So high yield is they will try to mess you up by giving you T3 normal level. T3 normal, and you be like, hey, T3 is the main guy, right? If you recall, T3 was the main thing for thyroid for its own actions, right? The more active molecule, T3. And now when in the labs, they say, hey, T3 is normal. And then you say, oops, it can be hypothyroid because T3 is normal, but now they're trying to mess you up. T3, don't even look at it because these levels fluctuate. So this does not tell us if the patient is in hypothyroid or hyperthyroid. All you want to look for is TSH and T4. Hope it makes sense. And thank me later for it. But what else? Okay. One also important point is going to be your hypercholesterolemia. Well, hypercholesterolemia, you have, again, simple thing that you have increased level of cholesterol. Why? Because decrease LDL receptor expression. So again, this is liver. Here is your LDL receptors that go on the liver. So when you decrease the expression of these receptors, normally what's happening is you have these LDL receptors, more and more LDL come from the bloodstream, go into the liver, taken up by the liver. Now, when you don't have this, when you knock these receptors out, when you don't have the receptors on the cell surface, the LDL is not going to go. When the LDL doesn't go, it stays in the blood, leading to increase in LDL or increase in cholesterol levels within the blood, leading to hypercholesterolemia. Okay. Other than that, what else we might see with it? That is going to be your not only hypercholesterolemia, but increase in total cholesterol levels, increase in LDL levels, increase in triglyceride levels, and these all things are essentially the cause of what? The increase. So hypothyroidism will increase the risk of cardiovascular disease or coronary artery disease. Okay, because of all that hypercholesterolemia. And lastly, one important thing is hyponatremia. With this, you will see hypo. Remember, we're talking about labs here. Hyponatremia. You will see with this low thyroid. With that, also labs, you will see something, my bad, not decrease, but increase in CK. We did talk about it. Increase in CK. But on top of that, we will see one more thing called anemia. And I think they have mentioned up top, but here, anemia, which side of anemia? It could be normocytic or macrocytic. Normo or macrocytic anemia. Okay. We did talk about how we would have increase in LDL, but why would we have increase in triglycerides? It is due to the fact that there is, with hypothyroid, there is a decreased expression. Hypo means low, like everything is low, right? So there's a decreased expression of what? LPL, lipoprotein lipases. When you decrease the LPL levels, you are going to cause increase in triglyceride levels. Okay. Let's compare this with hyperthyroid. You have a low TSH, simple, high T4, simple, and you also have opposite of that cholesterol. So you have a low LDL, low HDL, low total cholesterol, known as, all of this is hypocholesterolemia, right? But there's going to be one thing more, which is going to be hyperglycemia. Okay. And that is going to be pretty much what we have for this. Okay. let's just mention one thing here. T4 for neuropsychiatric, meaning for the brain development. Okay, T4 is essential. T4 is essential for brain development and myelination during earlier life. So essential for brain plus myelin development. Okay, T4. So if you have a deficiency in T4 in a child, you will be going into irreversible intellectual disability, and we will see that in pathology. Okay, and let's just talk about the whole thing and move on to the next. All right, so let's revise this part. Okay, hypo and hyper, right? Hypo, everything is low except the weight, gaining, except the menstrual flow, and except the water retention. Everything is low. Cold intolerance, decreased sweating, decrease in basal metabolic rate. And why do we have basal very high yield? Is when we put on these sodium potassium ATPase, and normally you might ask, where does these work? So if you recall any action potential, and let's say in the skeletal muscle, you have an action potential. That action potential, at the end of that action potential, what do you need? You need a sodium potassium ATPase to throw back the levels. So for example, if you have to get the sodium out of the cell and put the potassium back in, that is the sodium potassium ATPase, and it requires ADP. When you require ADP, you are using energy, and that energy is your caloriogenesis. You have to form energy in order to use it, right? So when you increase your sodium potassium ATPase channels, you're increasing high yield, you're increasing basal metabolic rate, which is at the resting point. Whatever energy or whatever calorie that you are utilizing, that is going to be your due to the fact that you have whatever sodium potassium ATPase you have, because they're requiring active energy. Okay, so with this, just remember that you have a decrease in basal metabolic rate because in hypothyroidism, you are decreasing your sodium potassium ATPase channels, leading to decrease in basal metabolic rate. When hyperthyroidism, you're increasing sodium potassium ATPase channels, increasing basal metabolic rate. And because you're increasing, when you increase this ATP, you are going to go into there's going to be heat formation, so you're going to sweating, increase in sweating. Okay, weight loss is also there. One thing important with the weight loss is this is going to be without decrease in appetite. So you will have weight loss, but if you look at appetite, where's GI? Let's look at GI. When you look at appetite, it's high, and the patient is going to do weight loss. Okay, very high yield, and this is because, again, the same point that I'm mentioning, that you have increased your basal metabolic rate. Normally, you needed 2,000 calories. Now your body needs 5,000 calories. All you're taking in with increased appetite even is, let's say, 3,500 calories. Still, you're losing 1,500 calories. You are going into weight loss. Simple as that, right? A very high yield point. Increase appetite, but weight loss with increase in basal metabolic rate. High yield or the skin hair findings, although they look very low yield, but very high yield, because every time they define this: dry, cool skin, coarse, brittle hairs, brittle nails, puffy face, generalized non-pitting edema, and here you have warm, moist skin, fine hairs, and pre-tebal mixed edema. With a GI, high yield, use simple constipation, decreased appetite, diarrhea, increased appetite, musculoskeletals, proximal weakness with increase in CP, not CP, CK, carpal tunnel syndrome, myoedema. High yield is myoedema, which is a bump which comes up on the surface of muscle when you struck the muscle by a hammer. Okay, thyroid toxic myopathy with normal CK. High yield. High yield again is osteoporosis, fracture rate because of T3 stimulating the osteoclast. High calcium will be there. Hypocalcemia will be seen. Reproductive, AUB, both will have decreased libido, decreased infertility, decreased libido, AUB, but gynecomastia, oligomenorrhea with increase in menstrual flow with hypothyroidism. Neuropsychiatric, T4 is essential for it because T4 is more active. Not active, but T4 is essential because as a child, it needs brain development and myelination by the T4. Okay, with this, all you get is with hypoactivity, lethargy, decreased reflexes, high yield, delayed, slow relaxing of reflexes. Okay, one high yield is going to be exact wording, which is when you say decreased reflexes, you say delayed relaxation phase of DTRs. Okay, let me just write this down. Okay, decreased relaxation phase of your deep tendon reflexes. Okay, and it is delayed. Why is it delayed? Because due to decreased uptake of calcium from SR. So reflexes are delayed. Why? Because there is decreased uptake of calcium, and calcium comes from SR, sarcoplasmic reticulum. Okay. And with the other one, hyper is the guy who's going to be hyperactive, not resting, restlessness, anxiety, insomnia, can't even sleep, fine tremors, high yield. Why is that? Because hyperthyroid is going to increase on the vessels. It's going to increase beta-adrenergic receptors. So more and more epinephrine catecholamines can work on it, and that's going to give you fine tremors. Okay. And that's why you can treat this by giving beta blocker, propranolol, okay, specifically for these fine tremors, because nothing else would. And beta blockers would because you're trying to block these receptors, and it's going to work out. Increase in reflexes, which is the brisk, okay. With the cardiovascular, again, you're going into a bradycardia, but hypertension will be seen. Here you have tachycardia with systolic hypertension and diastolic blood pressure being low, and that is essentially going to cause increase in pulse pressure. Okay, you will have, again, same thing which you talk about up top right here, increased sensitivity and numbers of beta-adrenergic receptors. So hyperthyroidism is increasing the numbers and sensitivity to the receptors of the beta-adrenergic. So if epinephrine, cortisol, not cortisol, but epinephrine, norepinephrine works on it, is going to have a more bigger action. Increased expression of corticotropic ATP is a decreased expression of phospholamban. Okay. Now labs, super high yield. How do you diagnose this, right? How do you diagnose this? Well, you will see increase in TSH, simple, decreased T4, simple, but hyper cholesterolemia, everything high, LDL, triglyceride, cholesterol, everything high, with hyponatremia, with the increase in CK and anemia. With the hyperthyroid, it's the opposite, low TSH. And I'm assuming that you right now you know already why would we have low TSH. If you don't, go back to the physiology and you will see the autoregulation, not autoregulation, but negative feedback. And that is why we have low TSH, because we have a lot of T4 here. We have a lot of T4, or you can say a lot of T3, but mainly look at T4. That's going to give a negative feedback, causing low TSH. Okay, hypocholesterolemia, opposite the other one. Okay, but here you're going to have hyperglycemia. Okay, and that is going to be all for thyroid. So since we're just here, let's also talk about some treatments. The treatment for hypo is going to be, you got to replace the thyroid hormone, right? Replace the thyroid hormone with what? With levothyroxine. Levothyroxine for life. Okay. But importantly, one high yield point is you got to increase the dosage in pregnancy. In pregnant patient, you got to increase the dosage, because if now you know you're looking after two individuals, not only one, right? So in pregnancy, since there is since if you that was just a mnemonic, but in metabolically, what in pregnancies was happening, if you recall back, we said in pregnancy you have increased level of the binding globulins. So here it's going to be the thyroid binding globulin increased. Okay, and when you increase the thyroid binding globulin, you will have low free thyroid hormone. So, but you need it for the brain development of the brain, and we said the myelin for the child. So that is why you increase the dosage. So no matter how much you increase this part, you will still have enough for the brain, for the fetal brain development, because the fetal brain depends on this, on the mother T3 or T4 levels. Okay, that's for the hypo. For the hyper, let's just write this hyper here. You can give PTU, propylthiouracil. You can give beta blocker, propranolol, which provides the fastest relief of hyperthyroid signs and symptoms. And also fine tremors, also treated with this, right? You could destroy the gland by giving radioiodine, I-31, I-30, which destroys the thyroid, or you can just go for thyroidectomy. Okay, and that is going to be all for thyroid. Okay, now let's get started with hypothyroidism. Very easy, okay. As the name suggests, you have low thyroid. Let's talk about the diseases now. The first disease that you see in hypothyroidism is Hashimoto thyroiditis. As the name suggests, it's a sort of inflammation, right? Thyroiditis. So you're right. It is a chronic autoimmune thyroiditis. So chronically autoimmune disease causing inflammation. Most common cause of hypothyroid. The way the first stage right things is very actually very unique. So the first thing they write is always almost most important, and then goes into not least common, I should say, but most common cause of things are going to be up top, and then the line is just gonna go on and on. Okay, so here's the most common cause of hypothyroidism, and in iodine sufficient regions, okay, associated with, because it's autoimmune, so it is associated with HLA, DR3, which differs by ethnicity, increase risk for primary thyroid lymphoma, high yield, that it would increase the risk of primary thyroid lymphoma, which is typically which one? Diffuse large B-cell lymphoma. Again, diffuse large B-cell lymphoma. Okay, and what are the findings we will see in Hashimoto's? In Hashimoto's, we will see moderately enlarged, high-yield, non-tender thyroid. So enlarged but non-tender thyroid may be preceded by transient hyperthyroid state, which is called hashitoxicosis, okay, which is basically saying, okay, toxicosis hyperthyroid, so they named it hashitoxicosis, calling Hashi means Hashimoto thyroiditis, and being an hyperthyroid state, which is only transient. Okay, and why do we have in hypothyroid? Why do we have hyper? Because of follicular ruptures. You have inflammation causing rupture of follicle that leads to release of thyroid hormone, and when the thyroid hormone goes in the bloodstream, you are going into thyrotoxicosis, but it's only transient. It's only transient hyperthyroid. Okay, that's one thing. Second thing is in serology. In serology, what do you see? You have a positive, high yield, anti-thyroid peroxidase. So if you recall, there was only one enzyme, TPO, thyroid peroxidase, which was doing everything, right? So oxidation, organification, coupling, right? So now that enzyme, now there is an anti-thyroid peroxidase antibodies. So there is an enzyme, there is an antibody against this. So when you knock this out, you will not be able to make thyroid hormones, leading to hypothyroidism, right? Simple. And this anti-thyroid peroxidase is antimicrosomal and anti-thyroglobulin antibody. So two sort of antibody you have to think about, and anti-thyroid and anti-thyroglobulin antibodies. Okay. On histology, what do we see? High yield again, Hürthle cells. Hürthle cells, let's take a look at that. Picture A is the Hürthle cell. So here is we have the Hürthle cell. What are these Hürthle cells, by the way? So these are, again, follicular epithelial cells which went into a metabolic change. And why did this change occur? Well, because of chronic inflammation, They couldn't stand that chronic inflammation. They wanted to change. Now they're called hurthle cells, but they're not just normal follicular cells. Okay. And with the specifically, what do we see here? The hurthle cell, these will have eosinophilic. Again, eosinophil means pink. Okay, so eosinophilic cell, right? Filled with granular cytoplasm. So if you look closely, you'll see granules within the cell. So eosinophil cell with, because the name, not a lot of time they have mentioned hurthle cell as a name, because that would be just right away giveaway, right? So the histology is very important. Cells with eosinophilic cells with granular pattern or granular cytoplasm is this specifically for in case of in the history with everything presentation with the thyroid, hypothyroid. So you'll think about hurthle cells. That's one thing. Second thing, on histology, you will see lymphoid aggregates, high yield. Again, here you have lymphoid. Why lymphoid? Again, because you are looking at chronic autoimmune inflammation. That's why there are the lymphoid aggregates with germinal centers. And again, if you think about germinal centers, that's why you're making this this thyroid lymphoma, which is diffuse large B cell lymphoma, because in germinal centers you get that extra layer which has the which has the propensity to go into diffuse large B cell lymphoma. Okay, what else we can think of here? So one thing, not only you will have lymphoid aggregates, just add one more thing here. You will see lymphocytes, plus you will also see plasma cells. So two sort of cells, inflammatory cells, you will see hurthle cell, lymphoid aggregate, germinal centers, plasma cells. Okay, now let's talk about something postpartum thyroiditis. This postpartum thyroiditis, let's erase this part. It is mild. Okay, it is self-limiting variant of the main disease we're talking about, Hashimoto thyroiditis, which arises less than 1 year after delivery. So as the name suggests, postpartum, but time frame less than 1 year. So any female less than 1 year develops into hypothyroidism, but only self-limited, meaning it's going to go back to normal. You can think of postpartum thyroiditis. Okay, here again, you will have a natural history of hyperthyroidism first within the 3 months of birth. So this lady postpartumly will present with hyperthyroidism for the first 3 months, and then will go into hypothyroidism, and then eventually the lady is going to go into recovery or euthyroid, meaning the thyroid is going to be normal state. So hyper, then hypo, and then eventually normal state. And that is also very important. Okay, so yeah, I guess that's pretty much it for Hashimoto. So let's just review this quickly. In Hashimoto, very simple, as an autoimmune, got to know the antibodies. Okay, antibodies out of a high yield here. So what do we have? Antibody, we have anti-thyroid peroxidase antibody and anti-thyroglobulin antibody. So not only the enzyme itself, but also that thyroglobulin, two types of antibodies which are associated with Hashimoto's. Histologically, hurthle cell, lymphoid, plasma cells with germinal centers. Those germinal centers can go and form diffuse large B-cell lymphoma. This is autoimmune disease, so it is associated with the HLA, DR3, but this is, again, differs by ethnicity. Okay, and this is seen where? In the iodine sufficient region. So not the developing world, the developed world, you will see iodine sufficient regions, right? Okay, and predominantly, again, high yield, you will have predominantly this patient is going to be in hypothyroid, but initial stages are transient hyperthyroid because of follicular rupture leading to release of that hormone. Okay, and that's going to give you hyperthyroid first, and then it's going to go predominantly it's going to be hypothyroid. By the time we see in a question stem, it's going to be hypothyroid. But again, they might confuse you with hyperthyroid. but got to look at these antibodies, okay, and the histology. One of the variants is postpartum. Again, postpartum less than 1 year after delivery. Again, same natural history, which was hyperthyroid, then hypothyroid. But here's the difference is that there's a recovery because it's self-limited. It is self-limited, so there is a recovery. Okay, and what else we can think of? So if we were to look at the labs, which they did not mention, so labs are going to be, you will have low T4 because it's low, it's a hypothyroid, so low T4, um, and that's going to cause increase in TSH, right? Now T3, again, T3 is going to look normal. This is very essential. I did talk about this in physiology, so do take a look at T3. T3 is going to be normal. Why is it going to be normal? Because T3 fluctuates. The level of T3 fluctuates. So do not look at the level of T3, because if you remember, T4 converts into T3, right? So the level is always either up, either down, either not normal. So we cannot think about that. The way we look at hypothyroid or hyperthyroid, the most important things are T4 and TSH. And T3 is just a metabolite of T4. So we don't, it fluctuates, the level fluctuates. And also it has a shorter half-life. One more thing, fluctuation and shorter half-life. That is why we don't look at T3. Okay, and that is going to be all for Hashimoto. Let's look at the next one. We have subacute granulomatous thyroiditis, again, inflammation. It's also called dequarine thyroiditis, usually self-limited. Natural history, again, you have a transient hyperthyroid, which and then causes euthyroid normal, and then hypo, and then it again goes into euthyroid. It is often preceded by a viral infection, high yield, that there is going to be viral infection, and then there is going to be something known as subacute granulomatous thyroiditis. Findings, high yield, again, because you have inflammation, all of that is inflammation, granulomatous inflammation, right? You have increase in ESR, jaw pain is there, and highest yield is very tender thyroid. Very tender thyroid is your dequarine thyroiditis. So the mnemonic here is dequarine is associated with pain. Pain is painful thyroid or tender thyroid. On histology, you will see granulomatous inflammation. Okay, so granuloma will be there. So the pathology, let's just take a look at one more time the pathology here. So we said it is preceded by viral infections, right? So after you have infection is after you have an infection, which is going to be your post-viral. So you will cause something called post-viral syndrome, okay, in which there is going to be destruction of thyroid follicles. When you destroy these thyroid follicles, again, they are going to release the preformed thyroid hormone, causing hyperthyroidism first. Okay, and then when this level goes down, then you are going into euthyroid, because levels are getting normal. But instead of staying here, because it's self-limited, instead of staying here, it goes into hypothyroid. That means that we are not making any thyroid hormone. That is why we are going into hypothyroidism. And from hypothyroid, eventually we will go back to the euthyroid state, which is total normal formation of thyroid hormones. Okay, the time frame is also very important here. So let's just talk about the time frame. So the time frame is that you have hypothyroidism, and this hypothyroidism, within less than 6 weeks, it has to go back to euthyroid state. It will go back. Let's just say that it will go back within 6 weeks, because it's self-limited. Self-limit how much time? Time frame 6 weeks. Okay, this inflammation is going to get you back on the normal state of thyroid within 6 weeks. Okay, that's important. Other than that, where is it? Okay. Yeah, that's going to be all. So let's just review this part. Subacute granulomatous with the granulomatous, you should know, okay, with the name, as the name suggests, okay, first our granulomatous, so you are going to see granulomatous inflammation. Let's take a look at picture C. In the picture C, we see granulomatous inflammation. Not in C, it is in C, granulomatous inflammation, okay. Oh yeah, here. The quality isn't that good, but so you can see within the follicles, you have granulomatous inflammation, okay. Now, one more thing that you have to know with the granulomatous inflammation, which cells are involved. Well, the cells that are going to be there are going to be your macrophages and your giant cells. Okay, and that's basic simple thing, but you got to know this, okay. So let's just talk about more, just review this one. So we have self-limited disease, which goes from hyper to euthyroid, then hypo, then again euthyroid. Important, okay? This is the cycle that it goes through. But more importantly, high yield, it's a very tender thyroid, because it's again, inflammation and granulomatous inflammation. It is self-limited after post-viral infection, okay? With that, you will have ESR high, okay, which is an acute phase reactant inflammation. You will see that. So this is not specific, but just there. What is specific is going to be jaw pain and tender thyroid, specifically here, okay. Granulomatous inflammation specifically here, with macrophages and giant cell specifically here, okay. And that is all for subacute. Let's move on with Riedel thyroiditis. Riedel thyroiditis, it is called invasive fibrous thyroiditis, may occur as a part of IgG4 related disease spectrum. Example, autoimmune pancreatitis, retroperitoneal fibrosis, non-infectious orotitis. Okay, so these are all IgG4 related diseases. Hypothyroidism occurs in 1/3 of the patients. Fibrosis may extend to the local structures. Example, trachea, esophagus, mimicking anaplastic carcinoma. And this is high yield, that it mimics anaplastic carcinoma. Okay, because if you recall, you have a dense fibrous tissue, which if this here, let me put it this way. If you have, because this is a fibrosis, right? So this dense fibrous tissue extended beyond that, because it's going to extend beyond the thyroid capsule. So let's say this is thyroid capsule, it's going to extend beyond the thyroid capsule. And when you extend it beyond thyroid capsule, it looks like, because when we will see anaplastic carcinoma, that one does the same thing. It does not care, because it's a carcinoma, it does not care about a capsule. It just invades the capsule, right? So how do we differentiate now? Because they both are invading the capsule. Well, so differentiated. So the way we differentiate it, the first thing we do is, first of all, we want to see the age of the patient, and we will do the biopsy. So as a young patient less than 40, and second thing is going to be the biopsy. Biopsy will show thyroid cells and follicles, right? So if they are in anaplastic, you will not see the normal cells or follicles, but here you will see normal cells and follicles. Okay, let's take a look at findings. Slowly enlarging, that also gives a clue. Okay, it could be anaplastic carcinoma. That is why you have to differentiate. Okay, again, hard, rock-like, fixed, non-tender. Only one thing that is going to be tender is going to be this subacute granulomatous thyroiditis. Other than that, I think most of them are non-tender, but let's read and we'll figure out more. But on top of my head, if you think about tender, you're going to think about decoy rain. Simple as that, okay? Histology, you have thyroid replaced by fibrous tissue and inflammatory infiltrates. Let's look at picture D here. So you can see that the thyroid follicles, the whole thyroid is replaced by fibrous tissue, and a lot of inflammatory cells. Okay, and that is in the riddles or riddle thyroiditis. Okay, so let's talk about extra things here. So you will see hypothyroid in these patients, but on top of this, you will see something else as well. For example, these patients are going to because this fibrosis is going out of this thyroid. It is invading this capsule and going. It invades the capsule and goes to the local structures and obstructs them. Okay, so if it obstructs the trachea, uh, if it obstructs the trachea, you're gonna the patient is gonna present with dyspnea, and if which is shortness of breath, uh, and esophagus, if it goes and obstructs the esophagus, which are if you think about thyroid is you have thyroid, you have the trachea, right, and then you have the esophagus. So you could obstruct each one of those structures which are nearby, and obstructing will cause their symptoms. For example, with esophagus, is going to cause dysphagia, okay, difficulty swallowing. So you will see hypothyroid plus sign symptoms of this right here, and that's how you will think, okay, it's riddles thyroiditis, and on top of that, you have to think about, okay, it's the one which is going above and beyond the structure, which is invading. Where is it? Which is mimicking the anaplastic tissue because it is invading the fibrous capsule of the thyroid. Okay, because that's why it's called the invasive fibrous thyroiditis. So let's quickly go over with this. Riddle thyroiditis, it is invasive fibrous thyroiditis. It is occurs as a part of IG4 related diseases. For example, they are the autoimmune pancreatitis, retroperitoneal fibrosis, non-infectious otitis. Hypothyroidism occurs in 1/3 of all these patients. Okay, fibrosis will extend to the local structure and also mimics the anaplastic carcinoma because it's going to extend beyond the thyroid capsule. That is why it's going to go, when it goes above and beyond the thyroid capsule, it's going to go into the local structures. Findings, again, slow enlarging, hard, fixed, non-tender thyroid. And if you look at histology, thyroid is replaced by what? Fibrous tissue. Okay, fibrous tissue and inflammatory infiltrates. And that is going to be all for riddle thyroiditis. Now let's take a look at congenital hypothyroidism, very high yield. Congenital hypothyroidism, formerly called cretinism, most commonly occurs by thyroid dysgenesis. What is the most common cause? Thyroid dysgenesis, which is abnormal thyroid gland development. Example, if there is an agenesis, the thyroid didn't even develop. Hypoplasia, thyroid developed, but it is very low. The organ size is not that normal. Hypoplasia of the thyroid gland. Ectopy, it formed in somewhere else. It did not form at the place it should have been there. For example, in the interior of the neck. Maybe it's ectopically present somewhere. Okay, all of these are your thyroid dysgenesis, that the thyroid has not been formed properly or in normal fashion, right? Or the second cause is going to be your dysharmonogenesis, saying abnormal thyroid hormone synthesis. You have the normal gland, but the hormone synthesis is not normal. Okay, example is mutation in the thyroid peroxidase. There's only one enzyme within there, so and guess what? That enzyme is going to be involved. So mutation in TPO, thyroid peroxidase, in iodine sufficient regions. Now findings are very high yield. Okay, with a child, with a congenitally an infant, will have 6 P's: pot-bellied, pale, puffy-faced child with protruding umbilicus and protruding tongue. Poor brain. High yield is poor brain development. If you take a look at child here, they have puffy face, protruding belly, and with protruding umbilicus and all of that, and tongue being enlarged as well. But with treatment, they probably look like a normal child. Okay, that is with the congenital hypothyroidism. One more thing, high yield, is going to be that initially with the congenital hypothyroidism, these patients are going to be normal at birth. So normal at birth. And why is that? Because the mother, maternal T4 is giving all the thyroid, so they don't need it because the mothers from the mother circulation, you're getting all the T4s. So initially, mothers initially normal at birth, and these signs and symptoms will appear after the maternal T4 wanes, right? That is going to be there. So the treatment is going to be, again, the treatment is simple, levothyroxine, but you got to give earlier, okay, because they need it for brain development, right? So by 2 weeks, they need levothyroxine, okay? So newborn, then you ask, hey, if maternal T4 was covering, how do we know if the patient is a congenital hypothyroid cretinism or not? So the way we check it is called newborn screening. We do newborn screening on the patient, and that basically shows increase in TSH and decrease in free T4. We have a little bit from mother, which is eventually going to wane off. So by 2 weeks, start the patient on levothyroxine. Okay, that's with the congenital hypothyroidism. Okay, the next thing we have is going to be other causes. What are the other causes? Well, iodine deficiency, most common cause worldwide for sure. Iodine deficient states, right? Typically presents with goiter. So if the iodine is deficient, it's going to present with goiter, which is G. So let's take a look at G picture here. You can see goiter, enlargement of the thyroid gland. Okay, iodine excess will give you Wolff-Chaikoff effect, and that is also going to go into transient hypothyroid, right? Drugs, for example, amiodarone, lithium. Amiodarone causes, again, Wolff-Chaikoff effect because amiodarone contains iodine in it, and it goes into Wolff-Chaikoff effect. Lithium, non-thyroidal illness syndrome, also known as euthyroid 6 syndrome. Okay, euthyroid 6 syndrome, what you have here is you have low T3 with normal or low T4 in critically ill patients. Again, what is it? We will see hypothyroidism in critically ill patient because that's called euthyroid 6 syndrome. Okay, so in critically ill patient, just take a look at in the scenario of in the question stem, you have a critically ill patient and going into hypothyroidism. With the hypothyroidism, you look at T4, look at TSH. Now, the problem here is going to be that not only you have T4 low, which you will see in hypothyroid, right? But here you will also have TSH being low. So that is how you will say, okay, this patient did not go into post-viral or anything else, but this patient has a euthyroid 6 syndrome because you have even as a negative feedback, this should have been up, right? So if you have a low T4, TSH should have been up, should have been high in hypothyroidism. But here it's different. What is different here, you have low T4 and a TSH is also low in critically ill patients. And that's how you diagnose euthyroid 6 syndrome. Okay, with that, yeah, that's pretty much all. Let's just quickly review the whole page and move on to the next one. Simple Hashimoto thyroiditis. It is an autoimmune thyroiditis, okay, which will cause everything is non-tender if you look at all of them, non-tender thyroids. But one thing which is going to be tender is the name suggests, which is, you got to know the mnemonic, okay? Decurrent pain. Decurrent is associated with the pain, okay? Decurrent pain, okay? Which is going to be tender thyroid. With the Hashimoto, 2 antibodies, anti-thyroid peroxidase, antithyroglobulin antibodies, Hurther cells, lymphoid aggregates, germinal centers, and plasma cells. Okay, it can go so one of the variants is postpartum thyroiditis, which is again is a variant of Hashimoto, which is self-limited. Here again, whenever you have a natural history, first of all, you will see hyperthyroidism. Why? Because there's a destruction of cells leading to release of pre-made hormone that causes hyperthyroid first, leading to hypothyroid, and then euthyroid. With the subacute granulomatous thyroiditis, all you have here is again self-limited disease, hyperthyroid here because you have, if you think about this versus the top one, in the top one is a postpartum woman, right? But with the subacute granulomatous thyroiditis, which is decoraine, is going to be after post-viral infection. It's going to cause hyperthyroid, then euthyroid, then hypo, within 6 weeks going back to euthyroid state. Okay, it because the name suggests granuloma, so granuloma is going to be the Riddle. Riddle is just fibrosis of the thyroid, and that would invade the local structures. Trachea, esophagus. It's a slowly enlarging, hard, fixed thyroid. Here, simple. It's going to be again fibrous tissue being replacing the normal thyroid gland. Congenital, everything you have low, but again, it's the 6 P's, which are high yield. Pot belly here. Let's just draw it here. You have a pot belly with protruding umbilicus, protruding tongue, or puffy face, and poor brain development. Other causes, iodine deficiency is going to present with goiter, iodine excess, which is Wolff-Chaikoff effect, drugs, high yield, imidrone, lithium, and non-thyroid illness syndrome is going to be your euthyroid sick syndrome. And that is going to be all for hypothyroidism. Okay, now let's talk about hyperthyroid. Hyperthyroid, and the first thing we have is the high yield disease called Graves' disease. Okay, in the Graves' disease is the most common cause of hyperthyroid. Okay, again, as I said before, the first thing is always going to be the most common. That's how the first is right things. Okay, hyperthyroid. The second thing is going to be a thyroid stimulating immunoglobulin, which is your antibody. As the name suggests, if you think about it, thyroid stimulating immunoglobulin. So you have an immunoglobulin, which is IgG, which will stimulate the thyroid. Okay, can cause transient neonatal hyperthyroidism. High yield is a type 2 hypersensitivity reaction. It will stimulate the TSH receptors wherever you have the TSH receptors. So where you have TSH receptors, so you have the TSH receptor on thyroid, causing hyperthyroidism. Makes sense. Simple. Causing diffuse goiter. Makes sense. But now think about the other ways. You have TSH receptors on the dermal fibroblasts. Location, pretibial. Pretibially, we have the TSH receptor is going to cause myxedema. So pretibial, in other words, shin edema, which if you press on it, you will be able to press because we will see that part. But just remember where the TSH first is thyroid, second is dermal fibroblast on the pretibial state, third thing is orbital fibroblast. Orbitals, again, as the name suggests, orbitals, eyes, right? So Graves' orbitopathy. Okay, and then you could treat this by glucocorticoids, high yield. Graves' exophthalmos or Graves' orbitopathy can be treated by glucocorticoids. Now there's an activation of T cells. Okay, activation of T cells causes lymphocytic infiltration of the retroorbital space, right? And that is going to cause increase in cytokines, example TNF alpha, NIF gamma, and that is going to cause increase in fibroblast secretion of hydrophilic glycosaminoglycans, right? And that is going to causing increase in osmotic muscle swelling, muscle inflammation, and adipocytes count to increase. And that is eventually going to cause exothelmos, which is picture A, exothelmos. Often presents during stress or pregnancy. So whenever you have stress, for example, pregnancy or any other stress, it can present with exothelmos, associated with, again, HLA-DR3, because it's an it's an autoimmune. So that is going to give you an HLA-DR3 and HLA-B8. Okay, let's talk about more important things here. Histology, high yield. You will see tall, crowded follicles. Okay, so here are the follicles. They are tall and they are crowded. Okay, and what else? Epithelial cells, crowded follicular epithelial cells. Scalloped, high yield is a scalloped colloid. Let me zoom into the scalloping here. If you see the follicle, this is not up against the epithelium, right? It is, you can see the white surface. This is scalloping. So it is the scalloping, so it's called scalloped colloid. Colloid is not up against the epithelium, and that is called the scalloping or scalloped colloid. Okay, let's talk about some extra things. You got to know this is type 2 hypersensitivity reaction. First thing, it is an autoimmune disease, which is, so let's just write this down here. It is an autoimmune grave disease. It's an autoimmune disease, which is triggered by antibodies, right? So triggered by, let's just put the names here. So thyroid stimulating immunoglobulin, in other ways they can say TSI, again, thyroid stimulating immunoglobulin, or they might say thyrotropin receptor antibody. So let's just write that one out. Thyroid receptor antibody. So TRAB is let me write thyrotropin receptor antibody. And what is thyrotropin receptor? That's your TSH. Okay, so you have the antibody against your TSH. So antibodies that are stimulating the TSH receptor. Okay, and this is going to cause, simply as I just said, all of these, they're the same thing. They will stimulate your TSH receptor. And when you stimulate your TSH receptor, as you know that you have that TSH receptor on the thyroid itself, on top of that you have on the dermal fibroblasts and on the orbital fibroblast, thyroid tissue. Okay, and all of that will cause their own things, which are going to be on the orbital is going to cause exothelmos, on the dermal is going to cause peritibial myxedema, and on the thyroid is going to cause hyperthyroidism. Simple. Okay, that is very important. Second thing you can think of is, again, pathology of how things are really working out. So you have activation of the T cells. Okay, that activation of T cells would cause, lymphocytic infiltration of the retroorbital space. So just remember, there's a lymphocytic infiltration, and that's going to increase cytokines. That is going to increase fibroblast secretion. When the fibroblast secretion of GAGs, which are glycosaminoglycans, when the GAGs are high, it's going to draw the water inside. So it's going to cause increase in osmotic muscle swelling. And because increase in cytokines, you are causing more and more inflammation, right? And you will have increase in adipocyte count. So all of that is going to give you mixed edema. Okay, mixed edema. In the mixed edema in the peritibial in the shin, and mixed edema in the orbital area, so leading to exothelmos. Okay, That is important. Other than that, not only you will see exothelmos, but these patients are going to present with diplopia. So with the exothelmos plus, you will see diplopia, double vision. So exothelmos, diplopia. Okay. With that, why do you have diplopia? Because you due to restriction of your extraocular movements. So extraocular muscles, they can't move here or there. It's going to give you diplopia. Okay. Uh, so this again, it is treated by high yield is glucocorticoids. Where is it? Glucocorticoids. Uh, and if you know just here, why are we giving glucocorticoid here? Because it's going to decrease all of this inflammation. It's going to decrease this inflammation, decrease the lymphocytic infiltration and inflammation, leading to decrease in extracellular volume and eventually helping out with the exothelmos. Okay, now let's just talk about labs here. What labs are we going to see here? Because it's an hyperthyroid, so you will see decrease in TSH, increase in T4, right? Increase in total T4, and also very high yield are always the antibodies. You will see thyroglobulin, thyrotropin receptor antibody, which is called TRAB, or TSI, which is your thyroid stimulating immunoglobulin IgG. Okay, with the antibodies there, you will just think of Graves' disease. And now, importantly, where do we see? Most commonly, you will see Graves' disease in women of childbearing age. Women of childbearing age. And that is also here. It is going to be present in stress where in pregnancy. Who can be pregnant is a woman of childbearing age. Okay, and that is all for Graves' disease. What do you have to remember in the Graves? Got to know that it is their antibodies, thyroid stimulating immunoglobulin antibody, which is IgG in state. Okay, it is type 2 hypersensitivity. It is an autoimmune disease in which it is triggered by either TSI, which is here, or your TR antibodies, which are your thyrotropin receptor antibody, which all of them are causing essentially what? Stimulating your TSH receptor, which is present in 3 tissues. It is present here. It stimulates the TSH receptor on the thyroid itself, on the dermal fibroblast, or on the orbital fibroblast. And on the dermal, it's going to cause mixed edema. Orbital is going to cause exothelmos, treated by glucocorticoids. Present with during stress in pregnancy, so it is associated with women with childbearing age, and the autoimmune disease also associated with HLA-DR3 and HLA-B8. Okay, we did talk. Let's see which HLA was the other one. Hashimoto was also HLA-DR3. So B8 is only the new one. And here you also have HLA-DR3. Okay. With that, let's move on to the next thing. We have toxic multinodular goiter. Toxic multinodular, again, toxic multinodular meaning multinodules, goiter, right? Diffuse enlargement. Focal patches of hyperfunctioning of the follicular cells distended with the colloid, working independently of TSH. Okay, again, so we have the follicles. We have the hyperfunctioning of the follicular cells with colloid. Colloid, they are working. So these guys are working independent of the TSH. Normally, what happens is you have the TSH, which goes down and binds to TSH receptor on the thyroid, leading to activation of the follicular cells and the colloid to make more T4, T3, right? That's normal. But here they're independently working. They don't care if you have the TSH or not. They will produce more and more T3, T4. Okay. So with that, what's going to happen is, why do we have that in the first place? Because due to TSH receptor mutations, the question is always why. Why are they working abnormally? Because there is a mutation of the TSH receptor. So they think that they got the TSH, but in fact they don't. So, but still, because of mutation, they're working continuously, right? In about 60% of the cases, this causes increased release of T3, T4 simple hot nodules, which are hyperfunctioning nodules visualized on the radioactive iodine scan, are rarely malignant. Right? Normally, you think about hot nodules, which are functioning independently. You think about malignancy here, but here we don't, because they're first of all, there's a mutation which is causing it, and you have these hot nodules, uh, uh, which are rarely malignant. Very important. Okay. So here, let's again mention a couple points here. Multiple nodular. Uh, so some are working, some are hot and cold, meaning hot meaning working, and some are just cold, but they're nodules. Okay, hot are working, functional, and cold are non-functional. Okay, also known as non-toxic. That's the other word. Okay. Other than that, um, yeah, I guess that would cover the whole thing. Okay, yeah, let's just quickly read this one more time and move on. Toxic, multinodular goiter. Toxic are the ones which are working. Okay, we call them toxic because they are producing the hormone. Non-toxic, which are also known as cold, non-working, and you'll see that in the next page possibly. Here we have the focal, some right, focal patches of hyperfunctioning, those toxic follicular cells and colloid, independent work of TSH. Without, they don't need TSH. They're just working with the good guys, right? Not good guys here, but normally, when you don't have supervision, you're working. That's sort of a good thing. They don't have supervision; they are working. Okay, so due to TSH receptor mutation, okay, increased T3, T4, hot nodules are rarely malignant, and you can visualize them by radioactive iodine scan. All right. The next here is uh, thyroid storm. Thyroid storm, it is uncommon but serious complication. A serious complication that occurs when hyperthyroid is incompletely treated or untreated, and then significantly worsen in the setting of acute stress, such as infection, trauma, surgery, presents with agitation, delirium, fever, diarrhea, coma, tachyarrhythmias, which is the cause of death. May see increase in LFTs. Uh, Treat with 4Ps. First of all, give beta blocker, example, propranolol, propyl tyrosine, PTU, and glucocorticoid, which is example, prednisolone, and potassium iodide, which is Lugol iodide. Iodide load would lead to, through Walsh-Chaikov effect, it's going to decrease the T4 synthesis, which is the Walsh-Chaikov effect. So again, we talked about thyroid storm. All you have to know, as the name suggests, thyroid storm, right? So we want to think about that you have a lot of thyroid hormone, and on top of that, you will have a lot of catecholamines. Um, why catecholamines? Because it is in the settings of acute stress. You have a lot of thyroid hormone being produced and a lot of catecholamines being produced in response to stress. What sort of stress are we looking for? Infection, trauma. Infection is a stress. Trauma is a stress. Surgery is a stress. Okay. With that, uh, you have it is. Let's read one more time. It is uncommon but serious complication that occurs when hyperthyroid is either have incompletely treated the hyperthyroid, or you didn't even treat it, that led to all of the problem, which is going to show up. So you have hyperthyroid already, hyperthyroid, okay, and that would worsen setting of you have acute stress. That's going to push more thyroid and catecholamines to go high in the stress, and that is going to cause the patient to go into agitation, delirium, fever, diarrhea, coma, tachyarrhythmia. All of these things you do see as a sign symptoms of hyperthyroid. But look, agitation, delirium, okay, and fever, tachyarrhythmia, may see increase in LFTs and 4Ps. Give everything you got as a treatment. Give beta blocker, give PTU, give glucocorticoid, give potassium iodide, because that load is going to decrease T4 synthesis through Wolff-Chaikoff effect. Okay, so that is going to be all for thyroid storm. We have other causes of hyperthyroid. First of all, we have the exogenous thyrotoxicosis. Exogenous, look at that word, exogenous, coming from outside. Someone is taking excessive intake of thyroid hormone, okay, taking from outside. Now, you have to suspect in what patient, in patient trying to lose weight. Wow, what a common thing, right? Patient is trying to lose weight. They're going to take a lot of thyroid from outside, and they are going to present with a thyrotoxicosis. Now, you got to differentiate. Either the patient has thyrotoxicosis, which essentially means hyperthyroid, or is the patient just taking from outside and trying to say, hey, I'm not taking it, but he's taking it to lose weight. Okay, I hope that makes sense. Second thing is you got ectopic thyroid production. You don't know where normally normal gland looks normal, but there's an ectopic thyroid production, which is stroma ovari, meaning that in the ovarian tumor, you will see an ectopic thyroid production. Contrast-induced thyrotoxicosis. You gave someone contrast that caused thyroiditis, which is the Jod-Basedow phenomena. Okay, and then you have this drug-induced thyroiditis, which is again drug-induced amiodarone and lithium. They are going to cause thyroiditis. So we see these drugs here in thyroid, right? So just remember them: amiodarone, lithium. Okay, amiodarone has an iodine. It contains an iodine. That is how it gets into the thyroiditis. Okay, and that's going to be pretty much all for the other causes. Let's look at the causes of goiter. Goiter is diffuse enlargement of thyroid gland, right? So you have smooth and diffuse or nodular. So this goiter, enlargement of the thyroid gland, could be smooth or diffuse or nodular, meaning it will have nodules, right? So smooth or diffuse or Graves' disease, Hashimoto thyroiditis, iodine deficiency, TSH secreting pituitary adenoma. Okay, in nodular, you have toxic multinodular goiter, thyroid adenoma, carcinoma, cyst. Cyst, adenoma, carcinoma, and a toxic multinodular goiter will present as nodules, meaning some part of the thyroid will be hyperfunctioning and some will be non-functioning. The ones which are going to be hyperfunctioning will be present as nodules, or in other words, hot nodules or toxic nodules, and some which are not going to be functioning. They are just going to be normal, and you will not see enlargement of that. So no goiter on that side. So that's why it's nodular, meaning let's say this is a thyroid, you have some nodules, so you will see nodular goiter instead of being a smooth diffuse goiter. Okay, that is going to be all for the causes of goiter. Now let's take a look at thyroid adenoma. Thyroid adenoma, you have benign solitary. Adenoma is benign. It is solitary growth of thyroid. Most are non-functional, meaning you have cold or radioactive iodine, cold on radioactive iodine scan. Again, because it's a benign adenoma, they're not working. So when they're not working, non-functional, they are going to be cold. Okay, that's first thing. They can rarely cause hyperthyroidism via autonomous thyroid hormone production. So these guys, although they're cold, but rarely they can start making the hormone, and that will go into hyperthyroid. Simple, right? By autonomous thyroid hormone production. and that will be either called hot or toxic, simple. So cold or non-toxic is the same thing. Hot or toxic, meaning you are producing the hormone. And cold, non-toxic, you're not producing hormone. Not producing hormone. Okay, most common histology is follicular histology, arrows in A. So you have most common histology is going to be follicular, meaning you will see follicular adenoma, follicular cells being there, absence of the capsule or vascular invasion. So you will not see any capsule being invaded or being vessels being invaded by the adenoma. Okay, unlike follicular carcinoma, which will invade the capsule and the vessels, and we will talk about when we see the follicular carcinoma. Okay, that's pretty much it for this page. Let's quickly go over this and move on to the next one. Okay, here, the first one, we did talk about it in a very ample time, so I think that's pretty clear. The second thing is toxic multinodular goiter. Again, it's a hyperfunctioning nodules which independently work. They don't need TSH. Why are they independently working? Because of mutation in the TSH receptor. Okay, hot nodules will be seen on the radioactive iodine scan, and they are not malignant. Thyroid storm, it is when you already have hyperthyroid, which is either untreated or incompletely treated. With that, you have stress that increase catecholamines. It leads to agitation, delirium, fever, all of this. Tachyarrhythmia is high yield because it causes death. Okay, you treated with whatever you got. What do you got? You got beta blockers, you got PTU, you got prednisolone, you got potassium iodide, everything you just give because it is a storm and you want to inhibit that storm. Okay, other causes are going to be either you're taking something from outside and leading to hyperthyroid that is normally seen in weight loss, or there's an ectopic thyroid production, which is seen in the stroma ovari, or you give patient a contrast, which causes hyperthyroid, which is due to the fact that it went into jod-based out phenomenon. Okay. And then you have drug-induced thyroiditis. You gave a drug that causes thyroiditis, amiodarone lithium. Causes of goiter is going to be either smooth or either nodular. The ones nodular are, you can think about only one disease being here. That's going to be toxic multinodular goiter. Other than that, you think about adenoma, carcinoma, cyst. In the smooth, just think about all the diseases that we talked about. For example, Graves, Hashimoto, iodine deficiency, TSH secreting, pituitary. Okay. Thyroid adenoma is a benign growth of thyroid, which is non-functional, but could go into functional, leading to formation of hyperthyroid hormones being produced in the hyperthyroid. And when it does produce hormones, it's called hot or toxic. Simple. Histology is going to be follicles which are not going to invade the capsule or the vessel, unlike follicular carcinoma, which will invade all of this, and we will talk about that on the next page. Let's talk about thyroid cancer. Thyroid cancer. It's typically diagnosed with fine needle aspiration, FNA. It is treated by thyroidectomy. Okay, simple. Complication of surgery. If you were to go into thyroidectomy, what are the complications? They include hypocalcemia, because when you were doing thyroidectomy, you also remove the parathyroid glands, and that causes hypocalcemia. Okay, transection of the recurrent laryngeal nerve during the ligation of the inferior thyroid. We did talk about it in anatomy in the very first pages, that if you were to transect the inferior thyroid artery, essentially there's a propensity that you could transect the recurrent laryngeal nerve, and that will cause dysphagia, dysphonia, hoarseness. Okay, and with the injury to the external branch of the superior laryngeal nerve. There is during ligation of the superior thyroid vesicular pedicle. There is a loss of tenor voice, usually noticeable in professional voice user, meaning there's going to be a loss of low pitch sound. So with one, now important thing is with the recurrent laryngeal nerve, which supplied every muscle, and with the external branch of superior laryngeal nerve, this only supplied cricothyroid muscle. So if you were to knock out superior laryngeal, you're knocking out your cricothyroid. So all you're losing is the low pitch voice. If you were to knock out the other one, which is the recurrent laryngeal nerve, you're essentially knocking out all the muscles, and that is going to cause hoarseness, dysphonia, and dysphagia. Again, high yield concepts. If you want to know more on this, go back on the first page, where's the thyroid formation and everything. I believe it's the first page. But again, that's very important. The next thing is going to be the actual cancers. First cancer we have is called papillary carcinoma. It is most common. Here we will have empty appearing nuclei with central clearing, high yield, orphan and eyes. Let's take a look at picture A. What do we see here? We have orphan and eye, so empty appearing, as the name suggests there. And look here, it says empty appearing nuclei. So if you look at the nucleus, they look empty, right? And that's exactly what we have. Empty appearing nuclei with central clearing, right? Here we have central clearing and empty appearing nuclei. And those are specifically named as orphan and eyes. Okay, that's one thing with the papillary carcinoma. Second thing, you will see samoma bodies. Third thing is nuclear grooves. So the mnemonic they have is Papi and Mama adopted orphan and eye. So Mama for samoma bodies. Okay, orphan and eye is orphan and eye, and Papi is for the papillary or papillary carcinoma. Okay. There's increased risk. High yield is increased risk with RET or PTC rearrangements and BRAF mutation. Okay. Increased risk with RET, high yield, and your BRAF mutation. Childhood irradiation is also very high yield. Okay. Now, family history. Something about family history here. There's going to be a positive family history. With thyroid carcinoma. And that will lead to, and if the leading to childhood irradiation, just remember there's a positive family history. If there's a positive family history, you think about childhood, you think about BRAF mutations, and leading to childhood irradiation. Okay, that's one of the cause of it. Now, importantly, you have one more thing important is going to be it is characterized by this papillary carcinoma. It is characterized by branching papillary structures with concentric calcification. So let me write this down. Branching papillary structures, okay, with concentric hypertrophy. My bad, not concentric hypertrophy, but with concentric calcification. Concentric calcification is your samoma bodies. Okay, so because now let's go with the names. Papillary structures, right? So what are papillary structures? They are going to be having a papillae. So branching papillary structures with your samoma bodies, which is your concentric calcifications. Okay, that is important. Other than that, you will also see palpable lymph nodes with it. Palpable lymph nodes. Let me erase this part. Palpable lymph nodes. Okay. Now there's a T cell variant which is seen in elderly, which has the worst prognosis. Okay. Which is characterized by follicular hyperplasia by the tall epithelial cell, but this is of lesser yield, so don't worry about it. The most important thing here that you have to know is going to be how the nucleus are going to appear, right? So let's just think about those at a moment. So you will see large cells with nuclei containing a dispersed chromatin. This is another way of explaining the same thing of an empty pairing nuclei. Okay, so in large cells with nuclei containing dispersed chromatin, giving it a ground glass appearance. So it will give a ground glass appearance. Okay, which is again same thing as saying empty appearing nuclei with central clearing. You can see both on the histology. And intranuclear grooves. So nuclear grooves, specifically, we're looking at intranuclear. Within the nucleus, you will see grooves. Okay. So what is small body again? It is just a calcium deposition. So concentric calcium deposition leading to formation of small bodies. And that is going to be all for papillary carcinoma. The next thing we have, and I'll read all of these and then we'll go through them once we're done with this page. So next we have the follicular carcinoma. Follicular carcinoma, it has a good prognosis. It invades the capsule and the vasculature, unlike adenoma, which was not invading the capsule and not invading the vasculature. These guys are uniform follicles. Let's look at picture B. You can see follicles, but they're uniform. So uniformity is there. Follicles being uniform. Okay. Now, importantly, they are going through heterogeneous spread is common. So if you think about carcinomas, generally, the carcinomas, they like to go through lymph nodes, right? Or lymphatics. The like to go, the cars run on lymphs, right? That's the way they do it. But this is an exception here, that the carcinoma is actually going through heterogeneous spread by the blood. Okay, that is there. And then it is associated with RAS mutation, okay, and PX8 and PPAR gamma translocation. RAS mutation, high yield, and also PAX8 and PPAR also translocation, also high yield. FNA, which is fine needle aspiration cytology, may not be able to distinguish between follicular adenoma and carcinoma. And why is that? Because if this is your thyroid gland, you stuck a needle in, it's going to take up the tissue. With this, you don't know if this the carcinoma invaded the capsule or the nearby vessels or not. All you're looking at the cells, and here the cells are uniform, right? So you would not know, is it due to the fact that you have adenoma or carcinoma? Simple as that. Okay, because you're just stucking in a needle, taking out a tissue at that specific location. You would not know. Did it invade or no? Did it invade the capsule or not? Okay, so and that is also very high yield. FNA cannot distinguish between follicular adenoma and carcinoma. Okay, and with that, I guess that's pretty much all we have for follicular carcinoma. Now let's talk about medullary carcinoma. Now medullary carcinoma, again, it's a medulla, means the middle part, right? So what do we have? We have the follicular cells in the mid, right? So what we will see is we will have parafollicular C cells, which normally produce calcitonin, Now you will see, because it's a carcinoma of those cells, we will see sheets of polygonal cells in amyloid stroma. Whenever you think about amyloid, yeah, it's going to stain with Congo red. Congo red stain will be there, will be present. If you were to do a Congo stain, you will see that. And it is associated with MEN2 high yield and MEN2B, which we will talk about. And red mutations, so MEN2 Larry carcinoma, instead of calling it medullary carcinoma, medullary carcinoma. If it makes sense, then you can just think of these, but it's going to come up anyways. Okay, now what do we need to know here? So first of all, it's a this, because it's a medulla, right? So it is a neuroendocrine tumor. Neuroendocrine. It's a neuroendocrine tumor, which is going to write from the medulla, which is the malignant proliferation of the parafollicular C cell, produces calcitonin. And these parafollicular C cells, because they are going to the malignant transformation, you'll see sheets of polygonal cells. Again, sheets of polygonal cells in amyloid stroma, high yield, okay, and which would stain with Congo red. So the mnemonic they have here is CC, MEN2A2B, so medullary carcinoma. And with the C's being there, just think about Congo red and C, calcitonin. So when you have, one more thing is going to come up, as when you increase a lot of this calcitonin, right? I mean, there is going to be some actions of it. So what are the actions of so much increased calcitonin levels? Well, it is going to give you hypocalcemia, via increased renal excretion of calcium. That's one thing. Second thing is going to deposit, this calcitonin is going to deposit within the tumor as amyloid. So which we talked about as an amyloid stroma. Okay, that is there. Now, there's a couple of causes we did talk about associated with RET mutations, right? Now, RET mutations, if RET mutation is positive, then do prophylactic thyroidectomy. So if you see a RET mutation positive in MEN2, MEN2B, 2A or 2B, if they are due to the fact that you have the RET mutation, then you would just go for thyroidectomy, because it will develop MEN2A, 2B with RET mutation. It will develop medullary carcinoma too. So to do prophylactic thyroidectomy, you're trying to save the patient from going into medullary carcinoma. That's one important thing. Second important thing is going to be that this medullary carcinoma itself, it could be sporadic, which is most of the time sporadic, or also it could be due to familial cause. So let's say sporadic is about 80% and familial is about 20%. And familial is the part, now you think about MEN2A, 2B, but the familial, which is MEN2 and MEN2B, it is the part of MEN, meaning MEN2A and 2B, and an R RET mutation. So it's only 20%. The rest is just sporadic. Okay. Again, what did I talk about? Let's go back, revise the whole thing. Well, I said with MEN2A, 2B, due to RET mutations, you are going to prophylactically remove thyroid, which is known as thyroidectomy, because essentially it is going to go into medullary carcinoma. So you remove it before it develops. One thing. Second thing I talked about, that all of this is only 20% of medullary carcinoma. But if there is RET mutation, there is development of medullary carcinoma, and that's why you do thyroidectomy. I hope that makes sense. Now, if this is only 20%, what about the rest of it? That rest of the 80% is just going to be sporadically formation of medullary carcinoma. Okay. With that, let's talk about last thing here, which is the RET. What is RET gene itself? RET gene, it codes for, let's just mention it here, it codes for It codes for membrane-bound tyrosine kinase receptor, TK receptor, tyrosine kinase receptors, which are involved in tyrosine kinase receptor, which are involved in cell cycle regulation. Cell cycle regulation. That's one thing. These guys, RET encodes for this. Okay. So if you have a mutation in RET, what is going to happen is that you will have the constitutive activation, which means always active, of that tyrosine kinase receptor, and which were normally doing the cell cycle regulation. Now they're constitutively active, meaning they are going to have continuous activation of TK, which is tyrosine kinase receptor, leading to unregulated cellular proliferation. And that unregulated cellular proliferation will lead to formation of carcinoma. Okay. And that is all. And this was just, I guess, an extra detail for RET, but important to understand what is RET. It's going to come up in men 2A, 2B, so important RET mutation. You understand the normal physiology there. Now let's take a look at picture. You can see on picture C, you have a lot of amyloid here. Look at all of this amyloid deposition, right? Amyloid deposition in the stroma. Okay. What else we can have here? And these are the malignant C cells. Malignant C cells. And that is all for medullary carcinoma. And the next thing we have is called undifferentiated anaplastic carcinoma. This one is older patient, older meaning greater than 60. And it's going to present with rapid enlargement of neck mass. Okay. Now let's compare this while we're talking about it. Compare this versus Riedel, right? Riedel thyroiditis. This is old patient. In Riedel, we said it's going to be young patient. Now, what is the common feature? Enlarging neck mass. You would also see enlarging neck mass in Riedel. Okay. What is also common? They will compress. There is going to be compressive symptoms. For example, dyspnea, dysphagia, or hoarseness. You will see that also with Riedel. Okay. Very poor prognosis. Then you have typically composed of pleomorphic cells with frequent mitosis. Look at picture D. This does not even look like thyroid, does it? Question mark. Is it even thyroid? Not thyroid, right? That is why it is an undifferentiated anaplastic carcinoma. The cells there, they don't even look like thyroid. That is why you have poor prognosis. That is why you see frequent mitosis there. Okay. And it's going to arise either de novo, which means on its own, or most often arise from the de-differentiation of pre-existing follicular or papillary thyroid carcinoma. So from follicular or papillary can eventually go into undifferentiated anaplastic carcinoma. But most often it arises, most may arise de novo, but most often arises from the de-differentiation of these thyroid and follicular carcinomas. So let's add one more thing here. On cytology, what do we see? Now, how the cells are going to be present? Well, there are going to be, you have pleomorphic cells, irregular giant cells, and biphasic spindle cells. Pleomorphic cells that will have irregularity, so irregular giant cells, and biphasic spindle cells. That's one thing. Now, more than this, the important thing is that these cells do not resemble normal or some sort of normal epithelial thyroid follicles. They don't resemble nothing like thyroid. So again, these cells won't resemble anything that will normally be present in thyroid. Okay. And that is why we call it anaplastic. With that, let's just review the whole thing and move on to the next part. Okay, thyroid cancer. We can diagnose the thyroid cancer by FNA and treat it by thyroidectomy, but we have to figure out one thing. If we are doing thyroidectomy, there are a couple complications. First complication is you could remove the parathyroid gland, leading to hypocalcemia. You could remove or you could cut down the recurrent laryngeal nerve, which leads to hoarseness. Or you could cut down your superior laryngeal nerve, which will lead to loss of your tenor voice, which is going to be loss of your pitch, and it is used in professional voice. So those are some complications of your thyroidectomy. Now, couple carcinomas. First of all, we have the papillary carcinoma. Couple features of papillary carcinoma is going to be your empty appearing central, look here, empty appearing nuclei with central clearing, with samoma bodies, which are essentially your calcium depositions, and intranuclear grooves. These couple things, if you look at it, if you see in the question stem, you will think about papillary carcinoma. The mutations are going to be your RET mutation. Again, RET also shows up here at the medullary carcinoma. And also you have a BRAF mutation. Okay, papillary carcinoma, most prevalent, palpable lymph nodes, high yield, and has a good prognosis. Now, the follicle carcinoma means the follicles. There's a carcinoma. There is a tumor of those follicular cells. The important thing with follicular adenoma and carcinoma is that carcinoma would invade, and the adenoma would not invade. What are they invading? They're invading the capsule and the vasculature. Okay, and follicles are going to be uniform follicles. Important thing is going to be this is going to have an homogeneous spread, but this is not seen with the carcinomas. Normally, the carcinomas, they travel through lymphs. The car goes in lymphatics. That's the carcinoma, right? But here it's different because this carcinoma goes through lymph. So there are four, let's just actually mention it here. So there are essentially just four carcinomas that go through blood. Those are going to be your, first of all, we just talked about the first one, which is follicular carcinoma. The second is going to be your renal cell carcinoma, and that is going to go into renal vein and then eventually blood. The third thing is your HCC, which is hepatocellular carcinoma. Again, goes through the hepatic vein and goes to blood. Fourth one, the last one, is going to be your choriocarcinoma, which goes straight into the blood. Okay, so RCC, HCC, choriocarcinoma, and follicular carcinoma, they go through blood. All the rest of carcinomas, they go through lymph. So CARs go through lymphs. That's going to be important. Okay, other than that, but now how do you differentiate between adenoma versus carcinoma? Well, the differentiation point, if you do FNA, which is fine needle aspiration, all you're looking at is just one side of cells, right? You will see cells there. They are all uniform follicular cells. But so you cannot differentiate these two things based on FNA. Fine needle aspiration would not distinguish between follicular adenoma and carcinoma. Okay, for that you have to cut down the whole thyroid from the start, which is the capsule itself, to see if it invades the capsule or not. Okay, the second point is going to be for your medullary carcinoma. Medullary, with all the C's, and first of all, medullary is associated with MEN2A, 2B. MEN2A, 2B are going to MEN2A, 2B are going to have RET mutation. What is RET gene itself? Well, it encodes for tyrosine kinase receptor that then causes cell cycle regulation. So if you have a mutation, it leads to constitutively active RET, which essentially means RET is always active. That means you're always making tyrosine kinase receptor, which is always going into cell cycle. So there is unregulated cell cycle growth, and that essentially causes carcinoma. Okay, with the medullary, you are going to think of sheets of polygonal cells in amyloid stroma. Okay. Uh, Polygonal cells with amyloid stroma. This is C cells, parafollicular. Other signs and symptoms of this parafollicular C cells is going to be hypocalcemia, because you're going to lose the calcium in the renals, right? So hypocalcemia, that's one point. Second point is going to be your amyloid stroma, which is going to be stained by Congo red. Okay. That's going, and prophylactically, when you have men 2A 2B, prophylactically you do thyroidectomy. Okay, and that is all for medullary. The last one here is going to be your undifferentiated anaplastic. As the name suggests, this is undifferentiated anaplastic carcinoma. These cells do not look nothing like, they have nothing in common as the thyroid. Look at this picture, nothing in common with thyroid tissue. Okay, and that is why they have very poor prognosis. And they are going to, again, go into the local structures just like Riddle, but here it's an older patient. In Riddle, you have a younger patient. And again, it's going to be enlarging neck mass. Both have enlarging of the mass, compression systems, symptoms, for example, dyspnea, dysphagia, or hoarseness. And it is composed of high-yield pleomorphic cells, which are undergoing frequent mitosis here. And it might arise de novo, but most commonly arises from the pre-existing follicular or medullary carcinomas. And that is going to be all for thyroid cancers. Okay, now let's talk about here. We have the diagnosing parathyroid disease. Okay, there's a nice chart here, a graph here. So look at the calcium levels here. We have a normal calcium level. That is going to be your, the normal is 8.4 to about 10.2. On top of my head, that's what I think. But if you have a new ones, that's what I think right now. 8.4 to 10.2 is going to be the calcium levels, normal. Okay, so let's take a look at hypoparathyroid, in which you have lower side of calcium. So this is your calcium, and this is your PTH. Hypoparathyroid, right? So parathyroid is basically saying you have low PTH. Yeah, you can see there's a low PTH here, right? And you also have low calcium. And why would you have this? Well, either you have removed the parathyroid gland, or there's an autoimmune destruction of the parathyroid gland. Essentially, you don't have parathyroid gland. Okay, that's going to give you hypoparathyroidism. Simple. Now, looking again at the same spectrum of lower calcium, look at here. We have a low calcium, but we have high PTH. So let's just write it down. Increasing PTH, because look at the levels, 250 PTH and the low calcium, right? So here you have the secondary hyperthyroidism. And why secondary? Either you have vitamin D deficiency, or you have calcium intake low, or you have CKD, okay, chronic kidney disease. All of that, certainly you're going into, all of these are causing low calcium causing increased levels of PTH, parathyroid hormone. Okay, that's the hyperparathyroid. Secondary, due to secondary thing. What is secondary thing here? Low calcium. Okay, now we're going to change the spectrum. We're going to look at, we have a higher calcium. So here, PTH independent hypercalcemia, we have high calcium, first of all, because we can see the levels here, they're higher. So high calcium, and PTH is low PTH, right? So PTH independent hypercalcemia. Why? Because we have a low PTH, but we have high. So whatever the calcium we're getting is not due to PTH, it's independent of PTH. Okay, so excess calcium intake that you got it from outside, cancer, or increase in vitamin D, essentially opposite of all of this. Just remove the CKD to cancer, and all you have is increase in calcium and low PTH. Now, with this, look at the primary hyperthyroidism. Now, with the primary hyperthyroidism, You have you have increased in your PTH as well as increase in calcium. So in which things we can have this in the hyperplasia of the parathyroid, in the adenoma of the parathyroid, in the carcinoma of the parathyroid. Essentially, normal function of parathyroid is to get increase more calcium. So this is exactly what we are seeing here. Okay. Now, lastly, tertiary hyperthyroid. In the tertiary hyperthyroid, you have again same sort of a scenario where you have increase in PTH, but way too much high of PTH, and you have increase in calcium, and that isn't seen in CKD, your chronic kidney disease. Chronic kidney disease, and this will come up in the next pages. So with that, let's take a look at now all of these in details. So you have hypoparathyroid, so low PTH. Question, why? Why did we have this low PTH? Well, it is either due to injury to the parathyroid gland, or due to their blood supply, usually from the thyroid surgery, or there is an autoimmune destruction of the parathyroid gland, or there is going to be DiGeorge syndrome. Okay, all of these are the causes of having low PTH. Okay, the findings with the low PTH, what's going to happen when you have low PTH, you're going to have a low calcium. The findings are going to be of low calcium, tetany, hypocalcemia causing tetany, and hyperphosphatemia, because if you recall, PTH was phosphate dumping hormone, right? Phosphate trashing hormone. So when you don't have PTH, your phosphate is going to be high. Okay. So now two things we will see. We will see neuromuscular hyperexcitability, one thing, and which is essentially is going to go into muscle spasm. So let's just write that: neuromuscular hyperexcitability, excitability. Here you will have Chov-Stek sign and a Trozo sign. Okay, what is Chov-Stek sign? Well, when you tap the facial nerve, where would you tap on the facial nerve? So anterior to the ear, anterior part to the ear. When you tap on the face, on the facial nerve, for example, tap the cheek, is going to contract the facial muscles. Trozo sign is when you have an occlusion of the brachial artery when you put the BP cuff on. Now that cuff the tricep leads to carpal spasm. So again, when you occlude the brachial artery by putting on the BP cuff the triceps, leading to carpal spasm, or in other words, you can call it carpopedal spasm. So let me write carpopedal spasm. Okay, so these two things are these are the muscle spasm associated with neuromuscular hyperexcitability. Okay, that is seen with the hypocalcemia. Okay, again, with hypocalcemia, you are going to see tetany, right? That is going to cause spasms. Which spasms? Chov-Stek sign, Trozo sign. Okay, muscle is first of all is going to first you have twitching of the muscle, hyperexcitability, and also one more thing is going to be with low calcium is going to cause increase in QT interval. If you recall, we talked about how low calcium, low magnesium will cause increase in QT intervals. Okay, so that is with all of this. Now, one extra thing that you will see when there is low calcium, hypocalcemia, here you also see perioral paresthesias. Perioral paresthesias, which is basically you will have numbness, tingling periorally, and paresthesias periorally. Okay, in the labs, let's write the labs here. Where do I write? Let's just write it here. Labs. In the labs, we have what we will have low PTH, which is the first problem, right? That is going to cause low calcium. That is going to cause increase in phosphate, right? And yeah, that's going to be all with all these signs and symptoms of hypocalcemia. Okay, now let's talk about the second thing here. We have pseudo hypoparathyroidism. So we have hypoparathyroid, which is proper hypoparathyroid. Now we have pseudo false hypoparathyroid type 1 and type 2. So let's talk about, I don't know where's the type 2, but let's talk about this one right here. So hypoparathyroid type 1A is an autosomal dominant, maternally transmitted mutation, which is imprinted GNAS gene, which is GNAS S1 inactivating mutation, which is coupled to PTH receptor that encodes for the GS protein. So this GNAS, GNAS1 or GNAS gene encodes for what? Encodes for GS coupled alpha 1 subunit. Okay, so now when you have a mutation here, you cannot encode for normal GS alpha subunit. And if you recall something, and that is that the PTH, it works on its receptor, and that receptor activates your GS cyclic adenylate GS protein, which then goes and activates your adenylate cyclase, which then increases cyclic AMP, right? So now since you have a problem here, nothing else is going to work since you have a problem here. Where's the problem again? The problem is in the GNAS1 or GNAS gene, which is encoding the GS protein alpha subunit. So when you have a problem in the GS protein alpha subunit, there's an inactivation of adenylate cyclase. So when PTH binds to its receptor, it leads to end organ resistance, meaning no matter how much PTH binds to this guy, nothing is going to work because there's a mutation here, right? That's exactly what's mentioned there, right? It's going to cause resistance where in the kidney and the bone to the PTH. If you recall, the PTH was working on the bone and the kidney itself, and it was working on GI through vitamin D. I don't know why my pen is lacking here, but vitamin D, it works on GI through vitamin D. So no effect on GI, increased absorption of calcium and phosphate, but only problem in the kidney, which it directly works on. Wherever is the direct work of PTH, that's where the problem is. Now, physical findings is going to be albright hereditary osteodystrophy, which is essentially saying you have a shortened fourth and fifth digit right here. Shortened fourth and fifth digit, right? Again, with short stature, round face, subcutaneous calcification, and development delay. So think about this: so development delay, short stature, fourth and fifth digits are being short. It's called Albright hereditary osteodystrophy. Okay, with the labs, with the pseudo hypoparathyroidism. Why is it called pseudo? Because it is hypoparathyroid, but you have increase in PTH. Why is it hypoparathyroid? Because essentially PTH is not working on its target tissues because there's resistance, because you cannot make that alpha subunit normally of the GS protein. So there's a resistance. That's why you have increased PTH, but they cannot work on their organs, causing low calcium and again high phosphate. Okay, because although you have PTH, but it is not working. Okay, that is why you will see low calcium, high phosphate. Now compare this with something known as pseudo hypoparathyroid. So we have pseudo and pseudo hyperparathyroid. Here, why it's called pseudo, I'll talk about that, but let's read first. Here again, autosomal dominant. Both are autosomal dominant. The pseudo one is from maternal mutation, and pseudo is from paternal mutation. Again, impaired GRAS gene. But here, now the issue is there is no end organ resistance. Without end organ resistance to the PTH, Why? Because normal maternal allele maintains the renal responsiveness to PTH. So here we had a problem in both the kidneys and the bone. Here we don't. We don't have a problem. Specifically, they're mentioned here the kidneys. Okay, so physical findings is going to be same as Albert hereditary osteodystrophy, which is again all of these are same. Short stature, development delay, fourth, fifth digits are going to be small. Okay, the labs, you have a normal, everything is normal here in the labs. Okay, so normal PTH and calcium, and that is why it's called pseudo, meaning you have normal labs, meaning normal PTH, normal calcium. So pseudo, it's not pseudo means cancel each other out. So just think about it that way. Okay, here's it cancels out, everything is normal. Pseudo cancels out each other, everything is normal. So if you look at the labs, you have PTH normal, calcium level, but still you will see Albright hereditary dystrophy. Okay, that's one. Okay, let's add one more thing here. With this, first of all, let's compare this. Pseudo hypothyroid, pseudo hypothyroid. Both will have Albright hereditary osteodystrophy. But what they will not have is pseudo will not have end organ resistance. Pseudo, just the top one, pseudo will have end organ. Again, what is end organ resistance? Let's mention that again. End organ resistance is basically when the PTH cannot work on its targeted tissue, for example, kidney, for example, bone. Why cannot it work? Because there's a mutation in the GS alpha proteins, alpha protein subunits. That's why it cannot work. Okay. And so here you will have end organ resistance, meaning you cannot work. But here you don't have any end organ resistance because maternal genes are going to respond to your PTH. Now we have to know which one is coming from maternal side and which is coming from paternal side. So the mnemonic is going to be something like when you were talking about pseudo, right? Who can fake it more, a male or a female? Okay, paternal, a male would fake it more, pseudo. Okay, a mother, maternal, would not fake. I mean, this is just a mnemonic, guys. Okay, a mother will not fake it more, so she's just going into pseudo. Okay, pseudo, paternal side of the mutation, gene-as mutation is coming from the paternal side. From the maternal side is only gene-as mutation coming from, again, maternal side. So, I mean, if you have a better mnemonic, happy to share it here, But what else we can think of? Okay, yeah, one more high-yield tie-in is going to be these fingers, okay? These two fingers, fourth and fifth digits are going to be short, but tell me disease in which you just have the fourth finger being shortened, fourth finger or fourth digit being short. And that specifically you will see in Edwards syndrome. Edwards syndrome, and that is in biochem. We will see that. But just here, we're trying in everything that we can. Okay, you see one finger being shortened, which is just the fourth finger. That is seen in Edwards. Fourth and fifth, high yield Albert hereditary osteodystrophy. Okay. With that, I guess I made everything pretty clear. Now, one thing about DiGeorge syndrome here is going to be, again, you have a neural, let's just write it. So you have a neural crest fails to migrate. When they migrate, where are they migrating to? They are migrating normally to third and fourth pharyngeal pouch to form the parathyroid gland. So, but when they will not migrate, they will cause PTH deficiency, and they will not make the thymus itself. So in DiGeorge syndrome, you will also have T cell deficiency. Okay. With that, let's take a look at this table. And it's going to clear up most of the things. So first of all, we have the vitamin D deficiency. In vitamin D deficiency, first of all, we look at vitamin D. we look at vitamin D. Why is it high? Okay, inactive vitamin D. Look at this. It's low, right? So this is active. Okay, this is active part of vitamin D. This is inactive part of vitamin D. But when you get the vitamin D from outside, it's always inactive, and 1-alpha hydroxylase acts on it to make it active. So we are essentially looking at what we have from outside. So it is low, right? So that is vitamin D deficiency. When you have vitamin D deficiency, you will not be able to reabsorb calcium. That's going to be low. You will not be able to reabsorb your phosphate. That's going to be low. Because you have calcium low, it's going to stimulate PTH. And because PTH is going to stimulate osteo. What does PTH stimulate? Osteo. You got it right. Osteoblasts. And indirectly, those osteoblasts will activate those osteoclasts. So when you activate the osteoblast, blast is the mnemonic here is going to be basic environment. Basic environment. That basic environment is your ALP, alkaline phosphatase. So because you're activating osteoblast, the clinical markers is going to be ALP being high. And the mnemonic is, again, I mentioned B for blast, B for basic environment. Basic is given by your alkaline phosphatase. Okay, that's all with the vitamin D. Now, looking at the next one is secondary hyperthyroidism, CKD. You have hyperparathyroidism. Secondary hyperparathyroidism. Where's the problem? Well, the problem is that you have CKD, right? So where would be the problem be? That you have increase in PTH with increase in phosphate. So the problem is here in CKD. You cannot remove the phosphate. When you cannot remove the phosphate, all that phosphate is going to bind to the calcium, causing low calcium, right? When you get the low calcium, it's going to stimulate your PTH. Again, PTH stimulating osteoblast, increasing ELP, right? And your vitamin D is just low because, again, where does it activate? Where is this activation occurs? In the kidneys. You are already in CKD. You cannot activate in the PCT, proximal convoluted tubules. You cannot activate your vitamin, inactive to active vitamin D. That's why you have a low vitamin D. That's what the secondary hyperparathyroidism, which essentially means you have increase in PTH and low calcium and high phosphate. Now you have hypoparathyroidism. Hypoparathyroidism, again, same thing, but low with the name hypoparathyroid, low PTH. When you have low PTH, you will not be able to dump phosphate to increase phosphate. Low calcium, that is which is stimulating low hypoparathyroidism. Why would you have low calcium here? Let me think. Oh yeah, here, because you don't even have PTH. When you don't have PTH, you will not be able to reabsorb calcium. Simple. Look, again, it's simple. Look at the name hypoparathyroid. Hypoparathyroid, essentially you don't have parathyroid. When you don't have parathyroid, you cannot reabsorb calcium. When you cannot reabsorb calcium, you're not going to have calcium. And your phosphate is going to be high. Simple, right? And here, this could be normal or decreased vitamin D. Pseudo hypoparathyroidism. Pseudo hypoparathyroidism is you have the first one, right, with the mother. So it's a pseudo hypothyroid. Why is it pseudo? Because you have, if you look at the PTH level, it is high. It is high. You look at your phosphate level, it's also high. And why is that? This is similar. If you look at these, look at this, phosphate high and calcium low. Only difference is going to be your PTH level itself. Why? Because in the pseudo hypoparathyroidism here, you have resistance. This PTH cannot even work on its target tissues. So the body is not even getting, let's say body is not even getting that PTH because it's not working, right? It is malfunctioned. That is why although you have increased in PTH, but it functions like no PTH. I hope that makes sense. Okay. And where, which organs are we specifically are going to be resistant? It's going to be in the kidneys and the bones. Okay, kidneys and bones. Okay, and that is all. So let's just revise the top part. This is very high yield, guys. Let's revise it quickly and move on to the next. Important things, okay, just important things. Hypoparathyroidism, you have low PTH. Why don't they put the labs here? I have no clue. But in the question, they put every lab. So I don't know why. But low PTH, simple. Hypoparathyroid, low PTH. When you have low PTH, you are going to hypocalcemia. That hypocalcemia, all the signs and symptoms are due to the fact that you have hypocalcemia. Tetany, Chopstick sign, Trozo sign. Chopstick is all about tapping the cheek, leading to contraction of the facial muscle. Trozo sign is all about tricep, where the BP cuff goes, causes carpal spasms, tetany, and hyperphosphatemia. And that also hypocalcemia can lead to seizures, can lead to perioral paresthesias, and all that, right? Now, the second thing is going to be your pseudo. A mother is a pseudo, and a father is a pseudo. So from mother is transmitting a mutation in the gene S gene. In the pseudo, a father, a paternal gene is transmitted that gene S mutation. Okay. And when the paternal is being pseudo, mother is always there to help. So you have a normal mother allele, which will try to save the thing on the kidney, so you don't have much of effect. So that is why you are going to get everything normal. Okay. And that is all for these things. All right, now let's start with hyperparathyroid. The first thing we have is primary hyperparathyroidism. Okay. Now, the primary hyperparathyroidism, it's usually due to parathyroid adenoma or hyperplasia, that you have the adenoma who's making the PTH. Hyperplasia, you're also making the PTH. It essentially is going to cause hypercalcemia. And with the previous one, we talked about everything with hypoparathyroid, low PTH, low calcium, right? Which is here. And now with the hyper, we're going to think about everything with high. So increased PTH causing increased calcium. Okay, with that calcium also goes in urine, hypercalciuria. When it goes in urine, it's going to form stones, so renal stones. Also going to cause you polyuria, which are stones, and hypophosphatemia with increased PTH, as PTH is a phosphate trashing hormone. It's going to trash that phosphate, so you will have hypophosphatemia. With the labs here, increased PTH, increase ALP, increase urinary cyclic AMP. Now, this is very high yield. We did talk about ALP. Let's just mention it one more time. Again, PTH works through osteoblasts. Blast work in a basic environment that is given by ALK phos. So B for blast, you can say B for basic. Basic is ALK phos or alkaline phosphatase, and that is if you have increased ALK phos, you can just think of that your activity of osteoblast has increased. Why? Because PTH does not directly work on osteoclast, right? It stimulates osteoblast, which in turn stimulates osteoclast, which in turn causes increased calcium release from bone, right? Bone resorption. Where is my eraser? Okay, here. And now increased urinary cyclic AMP. Let's talk about this one. If you recall, again, PTH works through which receptor? Well, it works through your GS coupled protein receptor, which in turn causes what? Which in turn causes converts, is through adenine cyclase, and that leads to ATP conversion into cyclic AMP, right? And then when you have a lot of PTH, stimulating all this pathway, causing a lot of cyclic AMP. That cyclic AMP is going to be seen in urine, so increased urinary cyclic AMP. Most often it is asymptomatic, may present with bone pain. Bone pain because a lot of that osteoclast or reabsorbing bone, essentially leading to bone pains. Okay, weakness, constipation, groans, abdominal flank pain, kidney stones, acute pancreatitis, neuropsychiatric disturbances like psychiatric overtones. So mnemonic is stone, thrones, bones, groans, and psychiatric overtones. This is all due to the fact that you have high calcium. So it's not necessarily that you just see it with increase in PTH, but whenever you have high calcium, you will see all of this: stone, thrones, bones, groans, and psychiatric overtones. Okay, that is important. What else we can think of? You have increase. I mentioned about increase in cyclic AMP in the urine, which essentially means you have increase in PTH, which works on its receptors, and that just goes and get excreted into the urine. Question is, why do we have pancreatitis here? Acute pancreatitis? Question mark. Why? Because if you recall, calcium is an activator for all enzymes. So calcium activates all enzymes, right? So this high calcium is going to cause activation of the pancreatic enzymes. When you activate the pancreatic enzymes, you are going to cause pancreatitis. Okay. And that's the pancreatitis. Other than that, you also have, one more thing which they haven't mentioned here is going to be something PUD. You will also see PUD, which is peptic ulcer disease. Okay. And you also have nephrolithiasis. So you have renal stones, right? So nephrolithiasis and nephrocalcinosis. Okay, two things with these stones being there: nephrolithiasis and nephrocalcinosis. And what is nephrocalcinosis? Well, nephrocalcinosis is just the calcium being deposited in the kidney, nephrokidney. So calcium get deposited in the tissues, for example, in the kidneys. And what do we call when the calcium deposits in the normal tissue? We call it metastatic calcification, right? Which is in fact that you have high calcium that deposits in normal tissues. Here we will see nephrocalcinosis. Okay, metastatic calcification. And through this metastatic calcification, what's going to happen now is that you are going into renal failure because of this nephrocalcinosis. And that will also lead to polyuria and renal failure. Okay. Other than that, some other thing that are worth mentioning are going to be, let's talk about the bone pains. With the bones, bone pains are due to the fact that because you are inactivating the osteoclasts, right? And they are going to cause osteoporosis. Let me write it down. Osteoporosis, one thing. So unlike aging, osteoporosis are two types. Due to aging, you have osteoporosis. But here, because this is osteoporosis due to the fact that you have high PTH, right? And that will, unlike aging, with this, it affects the trabeculae. Unlike aging, which affects the trabeculae, this high PTH, again, let me repeat this. Aging in osteoporosis affects trabecular bone. Now, let's just make a bone here. And let's talk about the bone. So in the bone, you have a cortex and you have the trabecular part. So if you have the trabecular bone being affected, that is age-related. Aging. Okay, aging causing osteoporosis of the trabecular bone. But you have the cortex being affected. So that's due to that could be something else. But here we're talking about cortical bone being affected in fact due to increase in PTH. So increase in PTH will cause cortical thinning, leading to subperiosteal, I yield point, subperiosteal, periosteal or periosteal erosions. Okay. Okay, that's one thing with the osteoporosis as a bone. But as you, there's something known as osteofibrosis cystica. Okay, I think I have them mentioned in here. Let me see. If it comes up, comes up. Otherwise, I'm just mentioning it here. The bone, we said osteoporosis. Second thing, we're calling it OF, osteofibrosis cystica. And this is an advanced, as the age, advanced age patient, advanced age. As the age advances, the patient can go into osteofibrosis cystica, okay? And that is pretty much what we have here. Now let's okay, actually they have mentioned here, osteofibrosis, fibrosica cystica, osteoitis fibrosa cystica. Osteoitis fibrosa cystica is the cystic bone spaces filled with, you have cystic bone spaces now, they're filled with brown fibrous tissue. Picture A. You can see this picture A. Okay. This brown tumor consisting of osteoclast and deposited hemosiderin from the hemorrhages. Okay. Again, you have a hemorrhage taken up by the macrophages, so hemosiderin-laden macrophages, right? And that causes bone pain. Why does this happen? Well, it happened because of increase in PTH, classically associated with primary or secondary seen with hyperparathyroidism. So either primary increase in PTH or secondary, no matter what, but you have increase in PTH, and that causes bone spaces, cystic bone spaces, which are not filled by the normal calcium, they're filled by the fibrous tissue. That fibrous tissue will be seen on imaging as black spots within the bone. And you can see it here. And it is seen, it is the disease of advanced age. Okay. Okay, that's pretty much what we have for the osteoitis fibrosa cystica. Now the next part here, I think it's for the secondary. So let's just talk about secondary hyperparathyroidism. Again, we talked about primary being primary hyperthyroid. Now we're talking about secondary, that due to something we are going to go into hyperparathyroid hormone. Okay. Now, secondary hyperplasia. Well, why do we have secondary hyperplasia? Due to the fact that if you have a low calcium absorption or you have a high phosphate, that is going to cause hyperplasia of the PTA, of the parathyroid glands. Okay. Most often when in the CKDs, most often in cystic kidney, not cystic, but chronic kidney disease, you have increase in phosphate, and that increase in phosphate in low calcium will stimulate the parathyroid. But since the parathyroid is there, but it will not be able to work on the kidneys, so it will be getting higher and higher. It will get stimulated by low calcium and high phosphate. So let's read the book here. It causes hypovitaminosis D, right? And why hypovitaminosis D? Because if you recall, vitamin D was getting activated in the kidney through 1-alpha hydroxylase enzyme. When we have CKD, the kidney is not working. When the kidney is not working, we might not have those cells there, or they might be atrophied or non-functional. So your 1-alpha hydroxylase activity is low. That's why you have hypovitaminosis D and hyperphosphatemia, because you were dumping out the phosphate through the kidneys. Now the kidneys are not working. When the kidneys are not working, you will have more phosphate, and that is going to cause, when you have phosphate, again, where does the phosphate loves to bind calcium, right? When you have a lot of phosphate, it's going to bind that calcium. You will not have free ionized calcium left in the serum, so you call it low calcium, and that low calcium is going to stimulate your, again, parathyroid hormones, parathyroid gland, leading to release of parathyroid hormone, and in turn you cannot work because you don't even have the kidneys, because you have a problem in the kidney, which is the chronic kidney disease. Hypocalcemia, we talked about it. Hyperphosphatemia, we talked about it in the CKD, versus hypophosphatemia with most other causes. Okay, this is very high yield that they're saying you have, which it makes sense. Kidney will dump out that phosphate, right? When you don't even have the functional kidney, you cannot dump out that phosphate. When you cannot dump out that phosphate, you're going to have hyperphosphatemia. But if you don't have a problem in the kidney, there is no way that there's a PTH and you're not dumping out the phosphate. As the name suggests, phosphate trashing hormone, and that's their job, right? They're not doing it if the kidneys have the problem, because that's where they dump. Think about your kidneys as the main place where you dump out the phosphate. Okay, something else. Let's look at this renal osteodystrophy. Here, what we have is renal disease causes secondary or tertiary hyperparathyroidism, which causes bone lesions. Again, if you have a renal disease, which is known as renal, but it causes bone lesions, so osteodystrophy. Why bone lesion? Because it's causing increase in PTH. Again, increase in PTH is going to stimulate osteoblast. Those osteoblasts are going to stimulate your osteoclast. Those osteoclasts are going to cause bone remodeling, take up all that calcium from the bone, put it back in the serum, and that bone destruction is going to cause bone lesions, and hence the name. And why did it all happen? Due to renal disease, hence the name renal osteodystrophy. That due to renal problem, renal disease, there is a bone lesion, okay? And in between you have increase in PTH as the main guy who is doing the actual work, okay? Now, with that, let's take a look at something CKD. So again, I want you to understand the CKD. When you have a chronic kidney disease, a couple things are happening. First of all, your GFR is going to go down, right? Not enough fluid to go there because you're in the chronic kidney disease. When there's a low GFR, guess what? GFR is the plasma that goes there, which contains the phosphate too. So you cannot even have the phosphate going down in the kidney. When you don't have the phosphate going down in the kidney, you have low phosphate excretion. That's one thing, right? Low phosphate excretion. When you have low phosphate excretion, essentially you're causing increase in phosphate in the serum, right? In serum, when you have increased phosphate, that's going to bind calcium, right? And when you bind more and more calcium, you are essentially causing low calcium, right? When you have low calcium, what is this low calcium going to do? Well, it's the only thing that you have for the calcium homeostasis is going to be you are going to stimulate your parathyroid hormone. You would stimulate the parathyroid hormone, that's going to go and act on the bone and say, hey, I need calcium, okay? So bone is going to eventually give calcium out and out and out, but eventually it's going to go into renal osteodystrophy, with leading to bone lesions. And why name it renal osteodystrophy? Because where's the main problem? Main problem is the renal. There's a renal disease which started the whole spiral, right? That is a perfect way to understand this, okay? So let's look at the labs, and then we move on to the next thing. The labs, although not mentioned here, I mean, some are mentioned, so we're going to take a look from here. So you have a low calcium, increased phosphate, okay, increased PTH, increase in ALK phos, okay. So just remember one thing, which is very high yield, that you will have increase in phosphate level, okay, and low calcium, and increase in PTH levels. Okay, compare this secondary to tertiary now. Now, tertiary hyperparathyroidism, here you have refractory autonomous hyperparathyroidism resulting from end-stage renal disease. Again, you have starting point, end-stage renal disease. That end-stage renal disease causes increased level of PTH, but now the PTH is stimulated so much all the time that now it became autonomous refractory. No matter now you give a transplant to the patient, still you're going to have increase in PTH. Why? Because they went into refractory autonomous hyperthyroidism, hyperparathyroidism. Why? Because with end-stage renal disease, you were stimulating the because you had low calcium, you were stimulating your PTH so much that now they are just autonomous. So that is why in labs you have high calcium, but very, very high PTH. Okay, you have high calcium, but very, very high PTH. And let's mention one more thing here. So what's going to happen to your phosphate with end-stage renal disease? Well, again, same thing, because you cannot throw out that phosphate in the kidneys. You're going to have increase in potassium. So now wait, what's the difference between this and the secondary? The only difference is about calcium here. So here in the secondary, you had a low calcium, you had high PTH, you had high phosphate, but you had a low calcium. Here in the tertiary, again, you have high phosphate, high PTH, but again, high calcium. This is the difference with the primary tertiary. And the question is why? Because again, let's go back a step here. Why do we have all of this? Because here, all you had was that phosphate was binding to more calcium, leading to low phosphate. But here you say, hey, it's the same thing. You have more phosphate, which are bound to more calcium. But look at the phosphate levels. The phosphates are so much high that they will take up every single calcium from bone, causing increased calcium within the serum. Okay, that's the difference. That's going to be all for this. Now let's take a look at the last one here on this page. We have the familial hypocalciuric hypercalcemia. Okay, this is again very high yield. This is familial, so it's autosomal dominant. It is defective G-coupled calcium sensing receptors. So if you recall, you have a calcium sensing receptors, CASRs, calcium sensing receptors, right? These calcium sensing receptors, now here they're defective. So let's talk about normal first. And then we talk about abnormal, right? So let's just talk about normal. So normally what's really happening, you have serum calcium. If you have a low serum calcium, right? That low serum calcium, it is sensed by, think about these small nose, they're sensing, or some, these are receptors which are essentially sensing calcium levels, simple as that. So when you are low in calcium, these, what are these receptors? Let's mention that. CASRs, calcium channel sensing receptors. Again, calcium sensing receptors. They are receptors that regulate the secretion of PTH. So this is, let me just put up PTH. Let's say this is PTH. Okay. So if the calcium, so if normally what's happening is binding of the calcium is there, it binds to these receptors. When the calcium binds to these receptors, it leads to inhibition of PTH. But now when you have low calcium, no calcium is binding to these receptors, it leads to stimulation of PTH release. Okay, so when the PTH releases in the bloodstream, it causes calcium to go back up high, and that causes inhibition of PTH. Okay, this is all normal, but how are they working? That was the question, right? How are they working this calcium? How does this work? Well, this calcium, again, this calcium, when there's low calcium, which is sensed by these CASRs, let me write this down, CASRs. This CASR then causes, let's mention here, CASR, then it leads to activation of your GS cyclic protein, and that causes adenylate cyclase activation, which causes ATP conversion into cyclic AMP. Okay, and that cyclic AMP will cause stimulation of the PTH to go out in the blood. And the question is now, how does the PTH work? And the PTH is in the blood. Now it acts the same way. Well, it works through GS, couple receptor, adenylate cyclase, activates adenylate cyclase, leading to ATP conversion into cyclic AMP. So look at the commonality here. Cyclic AMP, cyclic AMP. Oops. Yes, cyclic AMP, right? So now with that in mind, let's look at the disease now. Diseases, we have defective G protein calcium sensing receptor. So we are talking about the defect of what? Of this here. Calcium sensing receptor. GQ coupled specifically for the for the calcium channel receptor. There's a problem in multiple tissues, for example, in the parathyroid and the kidneys. So it causes higher than normal calcium levels required to suppress PTH. So normally what is required is 8.4 to 10.0, 10.2. This is the normal level of serum calcium. It would, when you have normal calcium, it's going to get, it binds with CESRs and you are inhibiting PTH. But now you need higher levels of calcium so that you can inhibit the same thing, right? And that is one thing. Second thing is you have excessive renal calcium reabsorption, right? And leading to mild hypercalcemia and hypocalciuria with normal PTH, with normal to increase in PTH levels. Okay, I think let me make it a little more clear. You have defective GQ coupled calcium sensing receptors. You have a normal calcium which binds to the CSR. If you have your normal levels of this binding to it would inhibit PTH. But now in this hypocalciuric hypocalcemia, that you need increased levels of calcium to be bound to CSRs in order to inhibit PTH. So how do we get increased calcium levels? Well, when let's say only one molecule was inhibiting the PTH, now we need 3 molecules of calcium to inhibit the PTH. So now since we have normal, we're talking about normal here, we only have 1 molecule. This is not inhibiting PTH, so PTH comes out. When the PTH comes out, it causes renal to reabsorb all that calcium, right? So that's the hypocalciuric, meaning calcium is not going into the urine. And one thing is there. And second thing is, again, it works through the bone, again, causes increase in serum calcium. Okay, with that, let's look at the text here. Higher than normal calcium levels required to suppress PTH, excessive renal calcium reabsorption, right? Which causes, when you're excessively reabsorbing more calcium, you're going into hypocalciuria, which is there, and also mild hypercalcemia with normal or increased PTH levels. Simple. Okay, I hope that makes sense. With that, I guess that's pretty much it. So now let's just quickly review this part and move on. Okay, here we have hyperparathyroidism, increase in PTH, right? Primary, meaning itself, there's an adenoma there or there's a hyperplasia. It's going to cause hypercalcemia, hypercalciuria, polyuria, hypophosphatemia, because PTH is a phosphate trashing hormone. So that's why it's going to cause hypophosphatemia. Increased PTH, increase in ALK-Phos. ALK-Phos because it causes stimulation of osteoblasts. Blast is the basics are the ALK-Phos environment. That's why ALK-Phos is high, because osteoblasts are activated. That increase cyclic AMP because you have a lot of PTH that is stimulating the kidneys, reabsorption, causing increase in cyclic AMP because PTH works through what? GQ, GS, adenylate cyclase, cyclic AMP pathway. Okay. And Most often it is asymptomatic, but may present with all of this due to the fact that you have increase in calcium, stone thrones, bones grown, psychiatric overtones. In bones, you will see osteoporosis. Osteoporosis, normally with aging, you have trabecular bone loss, but here you will have the cortical bone loss. Something is wrong with my pen here. Latency is not right, but what can we do? I'll try to fix it after this session, okay? What else? Abdominal pain, flank pain, pancreatitis, because calcium, you have hypercalcemia. Calcium is activator for all enzymes. So when it activates a pancreatic enzyme, those pancreatic enzyme itself will activate more and more enzymes of the pancreas, leading to pancreatitis. Neuropsychiatric disturbances are there, psychiatric overtones, okay? It can cause osteitis fibrosa cystica, which is that it is activating osteoclast so much that is leading to formation of bone spaces, which are going to be filled by fibrous tissue seen black here on the imaging, okay? That fibrous tissue, okay? And then also you will have hemorrhages, so you will see hemosiderin-relating macrophages there, and which leads to bone pain. Increase, all due to the fact that you have increase in PTH associated with a primary problem, which is adenoma, hyperplasia, or secondary due to CKD or end-stage renal disease, okay? And that's going to be pretty much what we have here. The next one here is all about, just remember the labs. And for the secondary, you will have low calcium, high ALP, increased PTH, and high phosphate. But with the tertiary, you have differences in the calcium. You have high calcium and very high PTH, and again, high phosphate. Renal osteodystrophy is a renal disease, for example, CKD, leading to activation of PTH, which essentially reabsorbs the bone, causing bone lesions. That's the renal osteodystrophy, okay? The start point was CKD, okay? Now, looking at the last one here, familial, as the name suggests, familial, so autosomal dominant. Where's the problem? You are going into hypocalciuria. Hypocalciuria means low calcium in urine because you are trying to absorb. That's the normal job of PTH, right? PTH causes, now normal job is to reabsorb all that calcium. It's going to do that. So it's going to cause all that calcium absorption to a level that it goes into calcium hypercalcemia. So it's reabsorbing every single point of calcium, okay? And that causes hypercalcemia, but mild only, and hypocalciuria with increased PTH. Okay, with that, we are done with hyperparathyroidism. Okay, let's talk about diabetes mellitus. Okay, we have acute manifestations of diabetes mellitus, chronic complications, and then diagnosis. Okay, in acute manifestations, we are going to have 3 P's: polydipsia, polyuria. Polydipsia, increased thirst. Polyuria, increased urination. Polyphagia, increase in eating. 3 P's. But these 3 P's are seen with type 2. Polyphagia being most commonly seen with type. Let's just mention it this way. Polyphagia less commonly seen with type 1. Okay. Weight loss and DKA are going to be seen with type 1. Okay. Hope that makes sense. But if not, just remember that weight loss and DKA are going to be seen with most commonly with type 1. Young, thin patient, type 1 diabetes. Okay. Now, hyper or smaller, hyperglycemic state is type 2. Okay. And we will talk about details of these two. The next is you have, they rarely can be caused by unstopped secretion of growth hormone. So if you have glucagon growth hormone secretion, not glucagon, but growth hormone secretion unstopped. For example, if you have a problem with pituitary gland, it leads to formation of growth hormone, right? And that growth hormone over secretion or epinephrine over secretion, and or the patient who are on glucocorticoid therapies, steroid, all again, go back to again simple thing, counter regulatory hormone to the insulins are what? You have growth hormone, you have cortisol, you have epinephrine, right? All of these are counter regulatory to insulin, meaning these guys will keep will try to get all the glucose back into the bloodstream, causing diabetes, mellitus, while the insulin will try to put that glucose back into the cells. So that's the way they work, right? Simple. So here we have either we have a lot of growth hormone, epinephrine, or we're giving from outside a glucocorticoid therapy, and that will all essentially cause diabetes mellitus. Okay. Now the complications, the chronic complications is very high yield, non-enzymatic glycosylation, glycation, non-enzymatic, simple thing as the name suggests, non-enzymatic. There is no enzyme involved. Glycation, addition of sugar, right? So without any enzyme, you're adding glucose, which is your sugar, onto the small, large, everything here. You're adding sugar or adding glucose to these things, right? But without any enzyme. That's called non-enzymatic glycation. So let's talk about where do we have non-enzymatic glycation, my bad. So you have a microvessel, micro means small vessel, and you have a macrovessel, meaning large vessel. So microvessel is a small vessel disease in which it's going to cause hyaline arteriolosclerosis, small vessel, right? Causing retinopathy, causing neuropathy, nephropathy. Okay, this nephropathy is essentially going to cause renal failure. Okay, with a large vessel, macro vessel, you are going to see, with diabetes, you're going to see atherosclerosis, which is going to cause coronary artery disease, cerebrovascular disease, for example, TIA, transient ischemic attack, or stroke. Okay, peripheral vascular disease. With the peripheral vascular disease, one thing that you will see is going to be the claudication. Okay, claudication. MI is the most common cause of death in patients with diabetes mellitus as a chronic complication. Okay, after this, okay, let me just go back. We had two sorts of chronic complication. One was non-enzymatic, and the second was osmotic damage. This osmotic damage is due to the fact that you have a sorbitol accumulation in organ with aldose reductase and decrease or absence sorbitol dehydrogenase. So let's go back a step, go back to biochem. We have glucose. Glucose gets converted to sorbitol by an enzyme, known as aldose reductase. Sorbitol gets converted to its metabolite by an enzyme, sorbitol dehydrogenase. So in the tissues where we don't have either the sorbitol dehydrogenase, or we have low amount of sorbitol dehydrogenase, or we have a lot of glucose outside that just gets converted into sorbitol, we are going to have a problem. Okay, so what are those tissues? Those are, let's talk about them now. So that's the first thing is neuropathy. Okay, neuropathy, you're going to have a motor problem, sensory problem. It is known as glove and stocking distribution. Okay, and autonomic degeneration. Example, GERD, gastroparesis, diabetic diarrhea. Okay, why would we get this neuropathy? If you recall that in the PNS, peripheral nervous system, we get the myelination by Schwann cells, right? Those Schwann cells, they myelinate the peripheral nervous system. So they take glucose they take glucose without insulin. So whatever glucose is there, they just take it, right? Now, what happens here is that you have increased when you have increased amount of glucose in the blood that is taken up by these Schwann cells. So there's increased glucose in these Schwann cells, right? And that increased glucose will eventually get converted into sorbitol, right, by the aldose reductase enzyme, right? That sorbitol is, it causes osmotic damage. Okay, it draws in the water, causes osmotic damage to the tissues where you have the Schwann cells, which is in the nerves. So it's causing neuropathy. Okay, neuropathy by the Schwann cells. Okay, now and now most importantly, in the sensory part, you will see decreased sensation on the foot, specifically decreased sensation of the foot. Okay, and when you have decreased sensation on the foot, it's going to cause ulcerations there, right? You had a minor trauma, you eventually bumped into the door on a chair somewhere, right? It causes small ulceration. That ulceration you don't even notice it because you don't even have a pain there. So that ulceration can go into infection, and that can lead to osteomyelitis. Okay. That's with the decreased sensation of the foot. That is why, let's just write it here. That is why all patients with diabetes mellitus should get checked for, should get the feet checked every visit. On every visit they have to the primary physician, they should get the physician should check the feet. The foot should be checked. The feet should be checked. Okay. Not only that, but also they need diabetes patients. They need all diabetic patients, and they need pneumococcal vaccines. Pneumococcal vaccine. They let's just write it somewhere. So pneumococcal vaccine. Okay, one thing. Second thing, these patients with diabetes, they need to be on ACE inhibitors or ARBs. ACE or ARBs. Why? Because for the blood pressure, right? If the BP is greater than 140/90, which is high blood pressure, simple as that. Either high blood pressure or they have microalbuminuria, which we will talk about in a bit. Microalbuminuria. Okay, put the patient on ACE inhibitors or ARBs. Third thing, they should be on statins if the LDL is greater than 100. So if a diabetic patient has LDL greater than 100, put them on statin. Fourth thing, you have to use aspirin in these patients. Okay, why aspirin? Because they are at high risk of formation of cardiovascular disease, cerebrovascular disease, and peripheral vascular disease. You want to put that on aspirin. Okay. Fifth thing, not only foot you want to check, but also you want to go for eye checkup. So let's just put eye plus foot exam yearly at least. Exam yearly must be done. Okay, yearly for the eye. Why? Because we want to look for retinopathy, which is proliferative retinopathy. Proliferative retinopathy. High yield diabetic patient goes into a proliferative retinopathy. For the foot, they are just going to neuropathy and formation of ulcers. Neuropathy with ulcers plus ulcers. So these are all the complications and how they should be, how to treat these diabetic patients. Not only you just want to put on metformin or any other drug, but also you got to take care of all its complications, which will eventually rise due to diabetes. Okay, so with that, what else we might can think of? Okay, with that, let's also think about cataracts, lens, right? In the lens, the same way. What happens in a cataract is that lens will take up that a lot of glucose that was in the bloodstream. It's going to take that glucose up. That glucose is going to convert into sorbitol. That sorbitol is going to cause osmotic diuresis, lead to formation of cataract. Aldose reductase is an important enzyme, right? Okay, with that, now the question arises: how do we get this retinopathy in these patients? Again, retinopathy is going to be associated with, so we have pericytes. We have pericytes on the blood vessels, or pericytes of retina in the retina. We have the pericytes. I mean, pericytes is everywhere, but here specifically we're talking about pericytes of the retinal blood vessels. What they are going to do, they are again going to get damaged by these parasites that can take up that glucose that's going to convert to sorbitol. Sorbitol is osmotic diuretic, not diuretic, but osmotic. That is going to cause osmotic damage to these parasites. When these guys get damaged, it's going to cause hemorrhage, right? Hemorrhage in the retina, and hemorrhage in the retina is the proliferative retinopathy, leading to eventually causing blindness in these patients. Retinopathy causing blindness with the diabetes. Okay, so that is with that. Let's talk about gastroparesis. Now, gastroparesis is diabetes. What's really happening with the clinical features that you have a patient who's diabetic for years, and it's going to be even if when the patient eats, after the eating, you have postprandial fullness. After a small amount of eating, the patient will have postprandial, meaning after they eat, postprandial fullness is there. Fullness. This is specific for gastroparesis, in which basically the guts are not moving, food is staying there, causing fullness, and that fullness will give you not only fullness, but you will vomit that out, and you will also feel that bloating. Okay, with just small amount of food. Okay, gastroparesis, because nothing is moving forward. Again, due to neuropathy, due to damage to the nerves there. Okay, and now how do you treat this? Now, very high yield is the treatment. Now, for the treatment, you can give two things. The first thing you can give for the gastroparesis is your metoclopramide. Let me write it down. Metoclopramide, which is your D2 receptor agonist. But the problem with this drug is when you give this drug to this patient, the patient will develop extrapyramidal sign and symptoms. Extrapyramidal sign and symptoms. So you could do another thing, which is called macrolide, which is an antibiotic. For example, erythromycin. You can give erythromycin, which will stimulate. Now, important thing is, what are they going to do? They will stimulate motilin receptor. When the motilin receptors are stimulated, it causes motility of the gut, leading to movement of the gut, causing food to pass, leading to you would not feel any fullness or any bloatiness or vomiting or anything with the gastroparesis. Okay, what else we can think of? With the autonomic, one last thing is about this autonomic degeneration. We talked about GERD, gastroparesis, diabetic diarrhea, but we have one more thing: hypotension. It is an autonomic degeneration, all due to the fact that you have neuropathy, peripheral nervous system is out. You have autonomic degeneration, causes hypotension. Okay, hypotension in these patients. Okay, with this, let's look at the diagnosis. How do you diagnose diabetes? Well, to diagnose it, you have the test. The first test we have is A1C levels, HbA1c. Diagnostic cutoff is greater than or equal to 6.5%. Okay. It reflects average blood glucose over the 3 months. So average blood glucose. So the more, let's say your average was, let's say 200. So about more and more RBCs will, the glucose will bind to more and more RBCs. And that's exactly what we see in A1C. How much of glucose is bound to the RBCs, glycosylated hemoglobin, right? How much of the hemoglobin has been glycosylated? Simple as that. Over the month of 3 period. Why? Because RBC has a life of 120 days, which is essentially 3 months. After that, they die, and the new RBC come up. When the new RBC come up, then they again have to bind to the glucose in order for us to see. So 3 months. So this test is good for 3 months. After 3 months, do another HbA1c to see the diagnostic cutoff, which is 6.5. Now with that, there's again, when we think about a problem here, which is a 3 months, we also have to think about what if a patient has a rapid erythrocyte turnover, so rapid RBC turnover. What's going to happen to that patient? Well, first of all, who is that patient, or what disease you see rapid erythrocyte turnover? Let me tell you an example. What about, do you think about beta thalassemia? Do you think about sickle cell anemia? You are right then. Beta thalassemia patient, sickle cell anemic patient, they have a rapid RBC turnover. When you have a rapid RBC turnover, guess what? This is not going to work, because now you see a level is normal, I don't know, I think 5.4. So you have a normal A1C level, right? But it's not the case, and the patient is going to diabetes, and you're thinking, hey, normal level, no way diabetes. But no, yes way diabetes, because there is an RBC turnover. The RBCs, instead of these 120 days, now they're turning over every single day. You don't even have the actual data there, so you cannot use HbA1c in patients who have rapid turnover. So what can we use as a substitute to this? Well, we can use something known as fructosamine. So let me write this down. Fructosamine. This fructosamine, so in patients with a rapid erythrocyte turnover, for example, they have hemolysis, hemolytic anemias, or sickle cell, beta cell, and all of that. In these patients, the glycated serum protein fructosamine is used to see the levels. And it's not always used; it's only sometimes used. So that's only one thing that we can think of. But remember, most important is not fructosamine, but what is important is in your hemolytic diseases, you cannot trust your HbA1c. Simple as that. Now, moving on to fasting blood glucose levels. So fasting plasma glucose levels is diagnostic cutoff is 126. Okay, greater than or equal to 126. Anything from 100 to 125 is going to be your pre-diabetes. Above or equal to 126 is going to be your proper diabetes. Okay, pre-diabetes is pancreas are like, hey man, we can't match up whatever you're eating. We're trying to produce as much as we can insulin, but hey, it's not working. So pre-diabetic patients eventually will go into diabetes unless or until they fix their diet, exercise, and do something about their life, right? That's one thing. So what are the notes here? Fasting for greater than 8 hours. Again, what you mean by fasting? How long you have to fast to check the blood levels? Well, 8 hours or greater than 8 hours. Simple as that. Now the next point is 2 hours OGTT, oral glucose tolerance test, has to be greater than or equal to 200. 2 hours after consumption of 75 grams of glucose in water. Okay, so you give the patient 75 grams of glucose. After 2 hours, you check the blood sugar levels. If they are greater than 200, you say, okay, you are diabetic. That's as simple as that. Now, the random plasma glucose levels, you have greater than 200. Randomly, you check the plasma glucose levels greater than 200. So presence of hyperglycemic symptoms is required. Okay, with this, greater than 200, but you got to have symptoms of hyperglycemia. Okay, and that is going to be all for this. But one more last thing is should be here that this plasma glucose should be done at least at 2 different occasions, and then you can say, okay, we have a problem, right? And that is it for diagnosis. Let's look at this table chart, whatever you can call it. Pretty nice one. Okay, when you have decreased available insulin, basically insulin deficiency, in other words, insulin deficiency. what's going to happen? Well, we're going to have increase in lipolysis, increase in proteolysis, increase in gluconeogenesis, formation of glucose, breakdown of glycogen, decreased tissue glucose uptake. So if you go back to normal physiology, we have insulin, what normally insulin does. Here, everything is opposite. So in other way, you can think about glucagon. Glucagon does all of these things. This is normal physiology of glucagon, okay? Glucagon causes increase in lipolysis, increase in proteolysis, increase in glucogenesis, and increase in glycogenolysis. And also decrease in glucose uptake. More specifically, decrease in glucose uptake, glycogenolysis, and gluconeogenesis. And these are just extras, lipolysis and proteolysis. So when you have insulin deficiency, you're doing a there's a breakdown of fats, right? Lipolysis, breakdown of muscles, proteolysis, right? So let's talk about now the whole thing. So when you lose your fat, or not lose fat, but when you are trying to break down the fat, you are going to cause increase in free fatty acid in the plasma. Simple as that, right? That is going to cause increase in ketogenesis. Where does the fat has to go into some metabolism, right? So for the fat, the metabolism is ketogenesis, formation of ketone bodies. Simple as that. Okay. So it's not only going to go ketone bodies, but it's that ketonemia, meaning it's going to be in the serum. Ketonuria, that ketone also go into urine as well. I mean, simple as that. But the problem here is it can go into anion gap metabolic acidosis. Okay. That's important. Other than that, you have with this, when you are going into metabolic acidosis, you are going to, because it's a metabolic acidosis, you will try to lose that acid by ventilation. That acid is going to be your carbon dioxide. You want to try, you would lose that by giving hyperventilation, increase in respiratory rate, increase in hyperventilation. You're throwing out that carbon dioxide, essentially decreasing your pH levels. Okay, and you have Kussmaul breathing. Hyperventilation is known as Kussmaul breathing. Simple as that, okay? With ketogenesis, ketonuria, ketonemia also leads to vomiting. That vomiting causes loss of water, sodium, and potassium, right? Let's stay here and let's look at the rest of this verse. Proteolysis, breakdown of proteins, causing decreased muscle mass. That decreased muscle mass and also causes weight loss. Again, the fat, if you put 5 pounds of fat and 5 pounds of muscle, you won't see the difference. Only, let's say, this much of muscle is 5 pounds and this much of fat would be 5 pounds. Okay, so when you're losing the muscle, you're losing the weight, you are happy, but the problem is you're losing muscle, which you could make if you are not that old. So no problem, as long as you're going for weight loss, I say it's a green signal. But in turn in life, you got to go for weightlifting, make that muscle up. But again, weight loss, proteolysis. With that proteolysis, all that protein is going to go into formation of more glucose, gluconeogenesis, more glucose formation. Glycogenolysis, glycogen gets destroyed, not destroyed, but breakdown of glycogen, which essentially is glucose, causes hyperglycemia and glucosuria. That glucose in the blood goes into urine, causes glucosuria, and that would lead to osmotic diuresis. That glucose in the urine draws more water in the urine. That is going to cause osmotic diuresis. Basically, you're losing more water. When you're losing more water, again, you're losing water, sodium, potassium, going into hypovolemia. That hypovolemia can lead to circulatory failure and decrease in tissue perfusion. Okay, although these are just theoretical. Okay, theoretically speaking here, this is the normal functions. Okay. Here on the other side, that again, hyperglycemia and and glucosuria, glucose in urine causes increase. That hyperglycemia would cause increase in plasma osmolality, and that is going to give you increased thirst. So didn't we just look at, okay, we called polydipsia, increased thirst, polydipsia, increased urine, polyuria, right? Lastly, we have decreased glucose uptake. Now, if all of these are causing increase in glucose in the blood, but if you only had one thing to put that glucose back into the tissues, you wouldn't have any problem, right? So the problem is where? This is the main problem, that you cannot uptake that glucose because you don't have insulin. So that glucose stays in the blood, causes more and more damage, and it's just a silent damage. You don't even know about it. All you're doing is polyuria, polydipsia, polyuria, going in, urinating more than normal and drinking more than normal. And you think, hey, that tablet, 500 milligram of metformin, is doing the work. Well, it's not. Maybe increase the dosage. Who knows? But that's what we have for this one. Okay. With that, let's talk about the last point here, which is not mentioned here. That's going to be your counter-regulatory hormone. So the counter-regulatory hormone, if you have low insulin, which we just talked about here in the whole thing, if you have, this is just a summary what I'm mentioning. If you have low insulin, simple thing, you have decreased peripheral glucose utilization, glucose utilization, one thing. Second thing is going to be you have increase in hepatic gluconeogenesis, meaning formation. Neo means formation of glucose. Glycogenolysis, breakdown of that glycogen, right? And this is decreased insulin. If you have increase in glucagon, that is again going to cause increase in gluconeogenesis and increase in glycogenolysis. Same thing here, but differently. It's just going to cause the same things. But epinephrine, so forget the different part here. Epinephrine, what is going on? Okay, epinephrine, increased epinephrine, it is going to cause the same thing, which is increase in hepatic gluconeogenesis, glycogenolysis, glycogen breakdown, formation of glucose, and also is going to cause increase in mobilization of glycogenic substrates. That is even not important. Forget that part. The last one is cortisol and growth hormone, which you talk about. Cortisol and growth hormone, they are going to alter the transcription factors, right, of many genes to conserve glucose. Okay. And these are these are going to be your counter-regulatory hormones. Insulin is the only one which is not part of the counter-regulatory hormones. Everything else, glucagon, epinephrine, cortisol, growth hormone, are all counter-regulatory hormones. Okay, and that's pretty much all we have for this one. So let's just review it quickly and move on to the next. Okay, diabetes, acute manifestations, polyuria, polydipsia, polyphagia. 3 Ps, weight loss, DKA, seen with type 1, most common. Thin, lean patient, you see it, you call it type 1. Okay, HHS will be seen with type 2. With that, but again, diabetes, meaning a lot of glucose in the blood, can be also caused by growth hormone, high level of growth hormone, high level of epinephrine, high level of cortisol, glucocorticoids. Chronic complications are going to be your non-enzymatic or osmotic. Non-enzymatic is a microvascular, which is small vessel, and macrovascular, which is large vessel. Small vessel will go into hyaline arteriolosclerosis, small vessel, retinopathy, neuropathy, nephropathy. Large vessel, atherosclerosis, big guys, coronary artery disease, cerebrovascular disease, peripheral vascular disease, which lead to claudication. MI, most common cause of death. Osmotic damage, Osmotic is due to sorbitol. We mentioned this one. Sorbitol converts, what am I saying? Glucose converts into sorbitol by aldose reductase. And this sorbitol it causes the osmotic damage. Where is the damage? It's in the neuropathy, in the peripheral nervous system, PNS. In the peripheral nervous system, which cells are going to be affected? Schwann cells. Schwann cells are going to take up all that glucose, which is going to convert into sorbitol, and that sorbitol, which causes damage, osmotic damage within the Schwann cells. You knock out your Schwann cells, you knock out your peripheral nervous system, you're causing neuropathy. With neuropathy, you have a motor neuropathy sensory. You can't even feel your foot. When you can't feel it, you're going to cause ulcer. You cause ulcer, it's going to cause infection. It's going to cause osteomyelitis. Autoimmune degeneration is going to cause hypotension, GERD, gastroparesis. Your gut is not even moving with the diabetes. So when the gut is not moving, diabetes, you treat with metoclopramide or erythromycin as a macrolide, which stimulates which receptors? High yield motilin receptors. Okay, with that, you have cataracts. Lens, again, take up that glucose, convert them to sorbitol. Sorbitol goes and causes osmotic damage, causes cataract formation. Retinopathy, again, retinopathy being pericytes of the retinal blood vessels, getting all that glucose conversion into sorbitol, damaging these parasites. When you damage the parasite, it leads to hemorrhage, and that hemorrhage is going to cause proliferative retinopathy. You will see dot blot hemorrhages, flame, and all that, and you can see that back in your ophthalmology section. Lastly, diagnose A1C. That's levels are going to be more than 6.5, but in hemolytic diseases, A1C will not work because you're getting new bloods, new RBCs, and that's not going to be an effective marker. Excuse me. Okay, so for that you can use, for hemolytic diseases, you can use fructosamine. Okay, then fasting blood glucose level at least on 2 occasions greater than 126, 2 hours OGTT greater than 200, random greater than 200. Okay, with this, all you have is, if you think about it, just whenever you have low insulin, everything is high. Lipolysis, proteolysis, gluconeogenesis, glycogenolysis, everything is almost high, right? One thing is low, which is, if you know a little bit, you will know that, okay, there's a decreased glucose uptake for sure. No rocket science about it, right? And when you increase lipolysis, you're increasing ketogenesis, simple as that. When you're increasing proteolysis, you're decreasing muscle mass, but you're forming glucose. Glycogenolysis, you're causing hyperglycemia. Hyperglycemia is going 2 ways. It's going in urine, it's going in serum. In serum, you're causing increased plasma osmolality. That's going to cause increased thirst, polydipsia, right? With the glucose in the urine is going to cause hypovolemia, and in the urine, because you're urinating a lot, it's called polyuria. Simple as that. And that's all for diabetes. So now let's talk about type 1 and type 2 diabetes mellitus. Okay, so here what we have is type 1. What is the primary defect in type 1? It is an autoimmune, again, very high yield, autoimmune T cell mediated damage or destruction of the beta cells, which are the islet cell cytoplasm, plus or minus anti-glutamic acid decarboxylase, plus minus insulin autoantibodies often present. So these are high yield T cell mediated autoimmune destruction of the pancreatic beta cells, and this is going to be a progressive destruction of the beta cells, which will essentially cause absolute insulin deficiency. Absolute insulin deficiency, okay? And the question arises now, why would you have this autoimmune destruction? Like, who is going to stimulate this autoimmune destruction of the pancreas, right? So it is triggered by, what is a trigger essentially? It is triggered by environmental factors or environmental stimuli in where? In genetically susceptible individuals. So someone who is genetically susceptible, they get triggered by some environmental stimuli that triggers the autoimmune destruction of the pancreatic beta cells. Okay, so this is the whole pathophysiology behind the destruction of the pancreatic beta cells. And it's a progressive disease, meaning it does not happen right away. It occurs after some time. So with time, there's a progression of type 1 diabetes. For the type 2 diabetes, all you have is increase in resistance to the insulin, right? And that causes progressive pancreatic beta failure. Because now you have resistance, no matter how much insulin gets produced by the pancreatic beta cells, there is going to be failure of that pancreatic beta cell, because the way they're producing so much of insulin, and still that is not working, so they will go into failure. But it's going to cause relative deficiency. So relative deficiency of insulin. Here you have absolute deficiency of insulin. Okay. So this progressive beta cell failure is basically exhaustion. These beta cells of the pancreas gets exhausted, okay, and then they would just fail and not make any insulin because they went into exhaustion. Okay, that's the first thing you will see in type 2 is first you will see resistance, followed by a lot of insulin being formed, but that insulin is not working because there is resistance. So beta cells are going to go in overdrive, making insulin, not working, then leading to getting into exhaustion, which is going to be insulin secretion deficiency. But again, it's a relative deficiency, not a absolute complete deficiency. Okay. Then let's talk about the second line, that is going to be insulin necessary in treatment. Because you have it here, you have an absolute insulin deficiency. For sure, you need insulin from outside. But here, you don't have insulin deficiency. The problem is the resistance. So you might need it sometimes when the beta cell go into exhaustion or failure. At that time, you would need an insulin from outside. But that's, again, with the advanced diabetes mellitus type 2. Age is less than 3. Again, young, thin patient, greater than 40. Is for the type 2 diabetes. Associated with obesity? No, it is not associated with, because it is associated with environmental stimuli in the genetically predisposed or genetically susceptible individuals. And for this, the other one is, yes, the obesity is the main culprit. Let me just talk about the obesity action in type 2 diabetes. So factors that contribute to insulin, let's just write it here, factors that contribute to insulin resistance. What are they? First and for most important, you will have obesity. Insulin resistance is happens when you're obese. So obesity causes that, and when you're obese, you are having a sedentary half-life. Not half-life, but a lifestyle. My bad. When you're not active, right, in your lifestyle, you're essentially obese. When you're obese, because if you're active in your lifestyle, you won't get obese. When you won't get obese, you're not going to form insulin resistance. So obesity, sedentary lifestyle, that's one factor. The second thing is, with insulin resistance, you can see something known as acanthosis nigricans. Acanthosis nigricans or nigrans. This is essentially signs of insulin resistance. You can see in the neck folds, meaning on the backside of the neck, in the axilla. Uh, you will see hyperpigmentations or velvety appearance of the skin. That is known as acanthosis nigrans. This tells us is there's insulin resistance, but it's also associated with colonic malignancy. But with an obese patient, you are thinking more of insulin resistance. Okay. What else we can have? So yeah, this is it for the obesity. Now, next line is genetic predisposition. Although you think about, when you think about diabetes type 1, you think about, hey, it's the genetic type 1, but it's not the case. It's not the case. Amigos, it's a little different, because if you look here, genetic predisposition is weak for type 1. 50% concordance in identical twins. Polygenic. Polygenic is the word here. Why polygenic? Because it's due to environmental. Everything is affected here. So environmental factors plus your genetically susceptibility in genetics is there. But again, you need environmental factors as well that would initiate the problem. Well, for the genetic predisposition for type 2 is strong. 90% of the concordance in identical twins and polygenic. Okay, but which is genetic predisposition in type 2 is strong. Okay, then you have HLA system. HLA, you have HLA-DR4, DR3, 4 minus 1, 4 minus 3 is type 1, so they are saying type 1. I guess this is important, that's why they mentioned this mnemonic type of thing, 4 minus 3, type 1. So just remember DR3, DR4, that's give you type 1 diabetes. And HLA is not associated with type 2. Regulation, or no, glucose intolerance. Glucose intolerance is severe. It is severe in the 1, and mild to moderate in 2. Insulin sensitivity is high, because here is the insulin deficiency. Here you have insulin deficiency. That's why sensitivity is high, because the body is not having insulin. But for the type 2, we have insulin. Its sensitivity is low because there is a resistance to the insulin. That's why sensitivity is low. Keto acids are commonly formed in the type 1 and rarely found in type 2. Okay, beta cells number in the islets is decreased because they have been destroyed, right? But here's a variable, but what you will see high yield is amyloid depositions. Amyloid depositions, or if you see anywhere amyloid deposition with the pancreatic beta cells, you're going to think about type 2 diabetes. So why is the amyloid, and or how the amyloid gets deposited here? Islets amyloid polypeptide is beta islet amyloid polypeptide is known as amylin. Amylin gets secreted by with insulin. So it is secreted along with insulin. And more insulin gets secreted, more amylin gets secreted. When the more and more amylin gets secreted, it gets deposited. It gets deposited, and leading to formation of amyloid. Okay, and it get deposited in the type 2 diabetes, where you have a lot of insulin being secreted out, and that is going to cause a lot of amylin being secreted out, and that is just going to cause deposition, leading to amyloid formation or amyloid deposition within the pancreatic beta cells seen in type 2. Then you have this insulin level. For sure they're low, and for sure high initially, which I mentioned, but with age they're just going to decrease because of exhaustion of those pancreatic beta cells, or deficiency, not sort of a deficiency, but a failure of the pancreatic beta cell. They will get exhausted. They're like, hey man, we're trying to put that insulin out, but it's still not working. No matter how much we produce, not working. They're going to go in overdrive and eventually go into failure. And that's exactly what we have later on the disease. There's going to be low insulin. With the classic symptoms are going to be common. What are the classic symptoms? Polydipsia, polyuria, polyphagia, weight loss. All of them are common with your type 1. Okay, weight loss for sure. 100% you see that with type 1. Everything else you also see that. But with the type 2, you don't see many of these symptoms. More likely you see polyuria, polydipsia, nothing else, not all these. But sometimes they are present. Polyuria, polydipsia sometimes can be present. Histology is again high yield. You have islet leukocytic infiltration. Leukocyte get infiltration. So there's an first of all, there's an inflammation of the islets. The inflammation, let's talk about it. So in type 1, you will see inflammation of islets. Inflammation of islets, not only inflammation in T cell, but also you will see autoantibodies, which we talked about up top here. All these antibodies, they are going to be against your islet antigens and insulin, eventually causing these two things: inflammation by the T cells, destruction by the T cells, causing inflammation, and autoantibodies causing destruction. All of them will cause essentially destruction of the pancreatic beta cells, leading to type 1 diabetes. Okay, that is the leukocytic infiltration is high yield. Again, T lymphocyte being infiltrated into the pancreatic beta cell. That's important. Other than that, you also have, on the other hand, histology, you have islet amyloid polypeptide. Which amyloid polypeptide? Amylin. Amylin gets deposited. Okay. As you know, the myelin gets secreted with insulin. When the insulin gets secreted, myelin also gets secreted. Okay. And it just gets deposited within the pancreas, leading to formation of amyloid. Okay. Then we have what would be the treatment options for type 1? Well, because we have absolute insulin deficiency in type 1. We want to give insulin, simple as that, right? So we want to give lifelong insulin to these patients. For the type 2, because they are often clinically, they're silent, right? They don't know, the patient don't know, right? So they have, they first of all, if you do diagnose them, then you have, first of all, you would want to go with weight loss. Obesity is the main culprit here, right? Weight loss. Then you want to go for, if weight loss is not working, then you want to go for drugs to counter that insulin resistance, like for example metformin and all that. Or then essentially at the later stages you want to give insulin. Okay, but we will talk about drugs in the details later on in the pharmacology section. Okay, now let's talk about a couple more important points and then we move on to next. So the couple important points are that you have. So let's talk about some polygenic or what is it associated with. So it can occur in susceptible individuals who are exposed to, as I mentioned, exposed to environmental factors, right? What are some environmental factors? For example, viral infection will cause that. Somebody goes into viral infection, they cause autoimmune disease, and that leads to, that's the way it can go. Or some environmental toxins can initiate the process. Or lastly, you can have some dietary component. Somebody ate something, dietary component. Any of this can start the inflammatory process, okay, and initiate the problem. And for the other one is going to be that you have insulin resistance as the problem. Insulin resistance as the main problem, right? Why would you have insulin resistance? The most important factor for insulin resistance is obesity. Why is that? Why would obesity cause insulin resistance? Because obesity decreases the number of insulin receptors, okay? When you decrease the insulin receptors, so no matter how much insulin you have, because you don't even have the receptors, it's not going to work. So that's the way obesity causes insulin resistance. That's one thing. Second thing you have to remember, abdominal fat deposition. Abdominal fat deposition also causes insulin resistance. Okay, excessive body weight, so abdominal fat, excessive body weight, obesity. All of these cause insulin resistance. Now, when we talk about this abdominal fat deposition, you have to know one thing now. Intra-abdominal visceral fat is more important than subcutaneous fat. So intra-abdominal visceral fat, I mean organ, on top of the organ you have gut fat. That fat is more important, causing diabetes and all the other things like atherosclerosis, increase in you have all the metabolic syndrome and everything. So you have intra-abdominal visceral fat is more important than your subcutaneous fat. That's an important thing. Okay. And with that, I think I did cover majority of things. Destruction. Let me see. Okay, yeah, one last thing for the type 1. For type 1, we have beta cell function, and we have progression of type 1 diabetes mellitus. So the first thing we have, first of all, here, we don't have any beta cell dysfunction, and this is what you have is a genetically susceptible individual. Your beta cell function is at 100%. But with the environmental stimuli or environmental factor triggering the autoimmune response, your beta cell function goes down to about 50%. Okay. And with that, you have, for example, autoantibodies being present, autoantibodies causing more and more destruction. And you're going to hit about 30% with that. So here's the 30% of that. And then lastly, so if you look at it, your beta cell function is progressively going down and going to zero at a point. There will be a point that you will be absolutely, beta cell function will be zero. There is the absolute insulin deficiency. And the signs and symptoms of diabetes, and that's also about signs and symptoms of diabetes mellitus, they would occur when you have greater than 90% of your beta cells being destroyed. So again, this is important. 90% of the beta cell getting destroyed. At that time, you will see, you will get the diabetes sign symptoms. And that is all for diabetes. Okay, now let's talk about two important high yield topics. The first is diabetic ketoacidosis, and the second is hyperosmolar hyperglycemic state. Okay, so in diabetic ketoacidosis, and these are all hyperglycemic emergencies. So what do we mean by that? Both will have hyperglycemia. But in your HHS, which is hyperosmolar hyperglycemic state, as the name suggested there, hyperglycemic state, you're going to have a glycemia greater than 600. But in here, the other one, diabetic ketoacidosis, you're going to have hyperglycemia of, let's put it greater than 300, okay? But although it is hyperglycemia, but look at the levels, way too high here, right? So with that, let's look at the pathogenesis. Okay, so pathogenesis, here we got, for the pathogenesis, for the diabetic ketoacidosis, you have insulin non-compliance or increase in requirement due to increase in stress. For example, infection. So whenever you have increase in stress, you're increasing the requirement for insulin. You need more insulin. So when would you have increase in stress? So they only mention infection here. So let's just write more. For example, you're going to have increased stress When you have infection, one thing. Second thing could be when you're in pain, you're gonna have that's essentially causing increase in stress. Okay. Other than that, you have sleep deprivation, severe mental, emotional distress. All of that would increase the stress. And that with increased stress, you are going to cause increase in lipolysis and oxidation of free fatty acids. Okay. And that's going to cause increase in ketone bodies. Which ketone bodies are we looking at? High yield, and you will see that in biochem. The ketone bodies are beta hydroxybutyrate more than acetoacetate. Okay. So with this, what is the pathogenesis here? With DKA, diabetic ketoacidosis, you have insulin, which is deficient, but you have ketones, which are present. Okay. Again, let's go back to pathogenesis. What do we talk about? Simple thing. Either you don't have insulin, insulin non-compliance, okay, you're not taking your insulin, or there's an increase in requirement, but you don't have that much. And why would you have increase in requirement? Because there is an increase in stress. So all of that is essentially saying when you have absent or deficient insulin, it's going to go into lipolysis. Free fatty acids will go into the blood, causes increase in ketone bodies, which are going to be your beta oxybutyrate greater than acetoacetate. With that, let's compare this with the HHS. You will have profound hyperglycemia. Again, very high yield. When you see something profound hyperglycemia, you are going to think about HHS. Okay. With this hyperglycemia, let's say more than 600. This is going to cause excessive osmotic diuresis, right? That's because all that glucose, again, if you recall, what is the level of glucose where your normal reabsorption of glucose, all the transport mechanisms in the kidney would just go in saturation. If you go in your kidneys, it's about 295. So when you hit this level at 295, guess what's going to happen? Every particle of the glucose is going to go straight in urine, okay? Because you lose the capacity to reabsorb that glucose once you're above 295. So here we're looking at 600, okay? Way too much. And that's going to cause what? All that glucose, wherever the glucose goes, where it's going to draw that water in with it, right? So in the urine, you have a lot of glucose, it's going to draw all that water. It's going to cause osmotic diuresis, which is going to lead to dehydration. And when you dehydrate the serum, now you don't have free water in there, your osmolality of the serum is going to go high, right? And that is going to lead to your, as the name suggests, hyperosmolar. There's increase in osmolality of serum, hyperglycemic. Again, you got increased glucose level in the serum. State is the state, HHS, okay? Classically seen in wear in older patients with type 2 and limited ability to drink. So if this is with type 2, where would you see DKA? Mostly you will see it with your type 1 diabetes. So type 1 diabetes in young patient, okay? Because type 1, you will see that in young. So that's mostly, okay? Majorly, you will see it over there. So this is all the pathogenesis. With that, let's look at sign and symptoms. With sign and symptoms, DKA is deadly. That's the mnemonic. Delirium, psychosis, gustmal respiration, which is rapid, deep breathing. Gustmal respiration. We will talk about every single detail of this, like why this is happening and all. But here, just reading here, abdominal pain, nausea, vomiting, dehydration, fruity breath odor due to exhaled acetone, okay, which is a ketone body, okay. On the other hand, sign symptoms for HHS is going to be thirst, polyuria. Again, symptoms of diabetes, right? Thirst, polyuria, lethargy, focal neurological deficit, but seizures. Two extra things: focal neurological deficit and seizures. What are going to be? What will you see in the labs? Well, the labs, again, hyperglycemia, about greater than 300. That's important. On top of that, you will have increase in hydrogen ions, decrease in bicarb. We will talk about how we got to this point that we have increase in hydrogen, decrease in bicarb, which causes increase in anion gap metabolic acidosis, increase urine and blood ketone levels, leukocytosis, normal and increased serum potassium, okay, normal or increased, right? But depleted intracellular potassium due to transcellular shift from decreased insulin, high yield, and acidosis. Let's actually talk about this first because this is very high yield. So let's go with this. Okay. So when you have insulin deficiency, right? That's the whole key mark in your DKA, right? In DKA, all you have is insulin. Never forget this. DKA, no insulin. Okay, there is no insulin. There are ketones which are present. Insulin is absent. Which disease is it? Type 1 diabetes, which is essentially, absolute insulin deficiency, right? So let's talk about this in detail now. When you have insulin deficiency, what's going to happen is now the body needs glucose, right? So insulin deficiency, the other counter-regulatory hormones will come up. Which is the counter-regulatory hormone for insulin which works right against insulin? That's your glucagon. So when your insulin is deficient, you're essentially stimulating glucagon, because when your insulin is there, it's going to inhibit the glucagon secretion. So when it is not there, the glucagon just gets released. So when the glucagon comes into bloodstream, it causes a couple things. It causes these two things, lipolysis and ketogenesis. So let's just put it here. Increase in lipolysis, one thing. And the second thing is going to be your in ketogenesis. So lipolysis, as you know, is going to release those free fatty acids, which are mentioned here. Let me erase this so maybe it can be an easier way to understand. Okay. Lipolysis, so increases lipolysis, which causes increased free fatty acids, right? Right here. Those free fatty acids are going to go into ketogenesis, formation of ketone bodies, right? And that ketogenesis forms the ketone bodies, which are going to be your beta hydroxybutyrate acetoacetate, right? So that's one thing with the glucagon. Other thing with insulin deficiency is going to be that it's going to decrease potassium intracellularly and in total body, but there's going to be increased potassium in the extracellular fluid. And the question is, why would that happen? Well, let's dive deep into that question. Why would you have decrease in potassium? Okay, so for that, we have to understand the ketone bodies, these ketone bodies, they are going to cause a couple things. One thing they are going to cause is ketonemia. So let me do this way. Make things a little better so you can, ketones, right? Ketones. We got the ketone bodies here. So these ketone bodies are having a couple things. So first of all, they're utilized by the body, by the tissues, right? So tissues are getting ketone bodies, they're good to go. Now, these ketone bodies also going to go in urine, so lead to ketonuria, okay? Ketonuria, that's one important thing. Then also, they will stay within the serum, so ketonemia. Now, this ketonemia, it's going to cause acidosis. And that acidosis is going to stimulate a couple things. So first thing is going to go, this ketoacidosis will be sensed by the medulla, and that medulla will be like, hey, we got a lot of acid, we want to get rid of it, right? So it will stimulate the respiratory center, and that's going to cause your cosmal breathing, which is your hyperventilation. So let me write it here. It's going to stimulate hyperventilation. I'm just going to write RR, which is your respiratory rate. Increase in RR, which is the respiratory rate. Hyperventilation, in other words, which is cosmal breathing. Again, here we talked about in the book cosmal breathing, respiration rapid, which is increasing respiratory rate, and deep breathing, which is cosmal breathing. Why did it happen? Because acidosis that acidosis would stimulate the medullary receptors, which would then in turn cause the respiratory centers to go high, causing hyperventilation. And the question is, why are we hyperventilating? Well, we are hyperventilating so that we can get rid of carbon dioxide, which is an acid. We have acidosis. We want to get rid of acid. Simple as that, right? How do we get rid of acid? Well, we want to get rid of carbon dioxide by hyperventilating. You hyperventilate, you blow out more carbon dioxide outside. You are going to have low CO2 within the body, right? So that's going to cause normalization, right? Again, this is very important. It's going to come up in acid-based disturbances. What do we have here? Again, it's the metabolic acidosis we have. That metabolic acidosis is corrected by causing compensatory respiratory alkalosis, right? So that will make more sense when we do the other things, which is in the respiratory, which is the renal. But here, important thing: you got acid, you want to get rid of acid, push that CO2 out. And with how are you going to push it out? By doing a lot of rapid respirations, and that's called customer breathing. Okay, that's one thing. So now with the ketonemia, the whole problem was ketonemia here, right? Now the ketonemia doesn't stop here. It doesn't just stop here, but also with this ketonemia, it's going to stimulate as this acidosis, right? So it's going to cause acidosis. This acidosis is also going to stimulate other things. For example, it's going to stimulate your potassium hydrogen pump. Okay. And why is that? Because you are already in acidosis. So the body will be like, hey, we don't want, and again, H is your hydrogen, they're also acid. So they were like, hey, we don't want this acid here now. We don't want these hydrogen ions in the body. We want to push them into the cell, man. Push them into, we want to see it. We don't want to see them in the bloodstream. Push them in the cell, right? So what they are going to do, there's a pump. Every cell has this potassium hydrogen pump. This acidosis will push that, will activate the pump, and the hydrogen is going to go in the cell, and potassium is going to come out of the cell within the ECF, extracellular fluid. When the potassium comes out, now here's the problem. When the potassium comes out, we were already having this a lot of osmotic diuresis. So this extracellular potassium will just go out in urine with the osmotic diuresis. So we are going to lose all that extracellular potassium. Okay, and we have increased level of intracellular hydrogen ions. Okay, so with that, all pathophysiology, let's read the book now. Okay, we said customer breathing makes sense. Abdominal pain, nausea, vomiting. Okay, dehydration. Dehydration is also going to be there because you are causing what? Again, osmotic diuresis leading to dehydration. You have ketone bodies, so fruity breath odor is going to be there. For the labs, hyperglycemia for sure. Now you look at this: increase in hydrogen levels, right? Decrease in bicarb to increase the anion gap metabolic acidosis. Okay, when you have due to ketoacidosis, right? Due to ketoacidosis, you have increase. Why would you have increase in anion gap metabolic acidosis? Due to ketone bodies, ketoacidosis. Okay, and you have increased urine. That all that ketone is going to go in urine and in the blood, called ketone levels high, right? This is also going to cause leukocytosis, and then normal or increase serum potassium. Look at that word, serum potassium. Why? Because when you're pushing that potassium out in the ECF, extracellular fluid, it's at the time you're checking, it either could be normal or could be increased. Okay, but eventually, but you have depleted the intracellular potassium. Why? Because you're taking everything out of the intracellular. You're pushing it out here in the serum and taking it out from the cells, within the cells, due to transcellular shift from decreased insulin and acidosis. So there are a couple of things. Insulin also puts the potassium back into the cell. first of all, we don't have insulin. Second thing is the acidosis, which I explained here. Okay, and that acidosis is going to activate this pump, which will also push out this potassium, right? Then you have osmotic diuresis. Again, whatever potassium you had, you're going to lose in urine, and leading to total body potassium depletion. Total body potassium depletion, simple as that. Okay. And the last, let's talk about, since we are here, just talk about complications here. The complications are going to be your life-threatening mucormycosis, high yield, life-threatening mucormycosis infection. Okay. Important, high yield. It is usually caused by a rhizopus infection. Okay. And then you have cerebral edema, arrhythmia, high yield arrhythmia. Okay, so how do you treat it? Well, treatment is simple for all, but here for both of them, you're treating by giving fluids, because you're essentially in dehydration state. Give fluids, give IV insulin, and potassium to replete the intracellular stores. Glucose may be required to prevent hypoglycemia from the insulin therapy. So when you give insulin, there's a propensity that you could go into hypoglycemia. So you also give glucose to not go into, or to prevent hypoglycemia. Okay, with that, let's look at this HHS. HHS is going to be, again, you have thirst, polyuria, lethargy, focal neurological deficit seizures, hyperglycemia, increase in serum osmolality because you have all that glucose in there, greater than 320, normal pH. Again, very differentiating point here. You had acidosis there. Now here you have normal pH. Okay, because there are no ketones. There are no ketones body, so there is no acidosis. No ketones. So no ketones and no acidosis. pH is going to be normal. These are a couple differentiating features versus the other one where you have ketone bodies, where you have acidosis, and also where would you have? You would also have this decrease in pH. Here is normal pH. Normal increased serum potassium and decrease intracellular potassium. So there is decrease intracellular potassium here as well, but this is not the feature that we say, hey, this is the hallmark or something. But here we have proper depletion of potassium. Total body potassium depletion is DKA. Okay. Then you have the complication, can progress to coma and death if untreated. Treatment, again, same treatment. So what are the common things? Let me erase all this and go with the summary here. Okay, so what are the things that we might see just with DKA? First of all, you got to know there's insulin deficient. The insulin deficiency, ketone present. Here you have insulin present, ketones deficient. You have acidosis, increase in hydrogen, metabolic acidosis. Here you have normal pH, no ketones, no acidosis. Okay. Hyperglycemia greater than 600, hyperglycemia greater than 300. Okay. Because you have ketone bodies present, you will have fruity breath odor, right? And that's with the ketone bodies being there is also is going to lead to delirium, which is altered mental status. And what else you might have? Dehydration is in both, so no, we can't think about that one. But yeah, that's pretty much what we have for this as comparison. Okay. Okay, one thing to add here, why would we have this shock, coma, death here? So here we have dehydration, right? So where's the word dehydration? Here, dehydration. in both, essentially both cases, we have dehydration. But here, because of a lot of hyperosmolar serum and leading to a lot of that glucose going to the urine, we have a lot of dehydration. That dehydration will essentially going to cause shock in the first of all, think about this: hypotension. Hypotension will cause shock in the patient, and that shock will cause coma and death in these patients. Okay, that's going to be all for this one. So let's move on with the next topic, and that is your hypoglycemia and diabetes. Now we're looking at hypoglycemia in DM, diabetes mellitus, right? Why would we have hypoglycemia? Well, it usually occurs in patients treated with insulin. So when you treat the patient with insulin or insulin secretagogue, which is essentially secreting insulin, example sulfonylureas, meglitinides, in the setting of high dose treatment. So either you're giving high dose, important, high dose treatment, or the patient had skipped a meal, inadequate food intake, or the patient went into exercise. Okay, so again, if you think about it, you have a patient, right? The patient takes insulin. Okay, when the patient takes insulin, the insulin stays there and slowly it secretes within the body. When you go in, the patient goes into exercise, exercising muscle, again, if you go back to physiology here, exercising skeletal muscle, they are going to put on their GLUT4s on top of their cell membranes because they're exercising. They don't need insulin. So what they're going to essentially cause, they're going to put all that glucose into the skeletal muscles. So you, first of all, you are going into hypoglycemia. On top of that, you also have insulin now, which is going to put whatever remaining of glucose is there, because insulin is slowly coming down in the bloodstream, right? So that's again is going to cause more glucose to go into the cells, leading to more and more hypoglycemia, right? So that's a very problematic thing, right? So that is why we have to be careful in insulin dosage and how the patient, lifestyle patient, or how are they going to, and educate the patient basically. Very high yield when they're taking insulin. So again, high yield point, if a patient is taking insulin, so a couple things can go into hypoglycemia. Overdose of insulin. The patient took more dosage of insulin. They have skipped a meal, or they went into exercise because exercising muscle, they do not need insulin. Okay. With that, let's look at more details here. We have the neurogenic cause. Neurogenic is autonomic symptoms. For example, okay. So we are talking about hypoglycemia sign symptoms here. Neurogenically, the symptoms we are going to get are your diaphoresis, tachycardia, tremor, anxiety, hunger. Allow the perception of decreased glucose, hypoglycemia awareness. So these all symptoms, they are allowing you to say, hey, we need glucose. And what are they? Diaphragm, sweating, tachycardia, tremors, anxiety, and hunger. And that is done through autonomic neurogenic pathway. Then you have this neuroglycopenic symptoms, which are altered mental status, seizures, death due to insufficient glucose in CNS. When that glucose does not hit the CNS, when it does not go to CNS, it's going to go into the CNS, will go into altered mental status, seizures, even death may occur in the absence of preceding neurogenic symptoms in patients with attenuated autonomic receptors. Example, beta blocker use, i.e. hypoglycemia unawareness. So if you block, again, that is why beta blockers use, they cause a problem here. So look at this beta blocker. Beta blocker use would inhibit your autonomic symptoms. So even if these symptoms are inhibited, so the body doesn't even know that they're going into hypoglycemic state. Okay. By the time that hypoglycemia hits the CNS is not getting glucose, The CNS doesn't wait. He's like, dude, like, where is glucose? You're not getting glucose. Okay, I'm going into altered mental status, seizures, and then causing death. If there is insufficient glucose and who is blocking these all normal symptoms, your beta blocker. So again, what is the important thing? Beta blockers mask hypoglycemic symptoms. Beta blockers mask hypoglycemic symptoms. Here they mention hypoglycemic unawareness because you are not aware of those hypoglycemic symptoms. Okay, now treatment, simple carbohydrates, glucose tablets, fruit juice, IM, glucagon, high yield, intramuscular glucagon, IV dextrose. Okay, let's go a little further, dive in here and talk about what are the mild symptoms, mild, severe. Okay, let's just mention it here. So mild symptoms of hypoglycemia are going to be your anxiety, tremors, sweating, okay, which are fast acting. Now, to treat your mild hypoglycemia, all you need is this oral intake of carbohydrate. For example, you can give a glucose tablet. So let me just put a glucose tablet. You can give a sweetener, fruit juice, hard candy, anything, right? Fruit juice, hard candy, any carbohydrate. That's for the mild hypoglycemia. Then there's something called severe hypoglycemia. And that severe hypoglycemia is this one, in which, and the mild was here. Okay, the severe hypoglycemia would cause development of, it develops confusion. The patient will go into confusion, loss of consciousness, loss of consciousness, eventually going into seizures and then death. Okay, and these guys, the severe one is treated by, there are two things now. Either you see on the roadside, you have someone who's diabetic patient and he's going into these altered mental status seizures. You think it's glucose. Then on non-medical settings, you can give them buccal or sublingual glucose. Sublingual glucose, okay, glucose. That's one thing. Or you can, they might have glucagon kit, or you might just get glucagon kits. So there is something called glucagon kit. Okay, these kits, they are delivered either IM, intramuscular, or subcutaneous, which is mentioned here, IM glucagon. And this is only in severe cases. Okay, in the severe hypoglycemia, where you're seeing these symptoms, seizures, altered mental status, loss of consciousness, all of that. But in the medical settings, example, you're in hospital, you're in ER, you are just going to give IV glucose, which is dextrose. IV glucose and dextrose, 50% dextrose and fuel. So IV glucose or dextrose. Glucose is dextrose, okay. But yeah, that's what we have. Now, again, I talked about, very high yield, mild, severe, different treatments. Now, let's talk about something called symptomatic hypoglycemia, which you will hear in the questions. Symptomatic, or you will see the symptoms, which is going to be your simple, which is disorientation, sweating, and palpitations. And this can be relieved by giving glucose. Relieved by glucose. Symptomatic means any symptoms that can be there due to hypoglycemia. And that is all for hypoglycemia and diabetes. Importantly, you're going to think about increased dosage of insulin, or your insulin secretagogues, skipping a meal. Hey, I'm diabetic, I want to skip a meal, but taking insulin and skipping a meal, wow. So that's another story. Exercise. I wanna lose some weight. Morning dose insulin, go for a walk, do a 5-mile run, exercise, see what happens. Okay, then you have treatment. What is the treatment? You have simple, I mean, we talked about it. Don't worry about this. Okay, the next thing we have is Cushing's syndrome. Cushing syndrome. Okay, Cushing etiology. Again, Cushing increase in cortisol due to a variety of causes. Exogenous glucocorticoid. You gave someone exogenous steroids, prednisolone, anything. Exogenous glucocorticoid causes what? Decrease in ACTH, right? So exogenous cortisol, let's put it here, cortisol, is going to inhibit the production of ACTH, and that is going to cause bilateral atrophy. Again, which layers are going to be getting atrophy? Let me put it here, GFR. So your G was stimulated by your angiotensin 2, right? F and R were stimulated, which are two big layers again. They're stimulated by your ACTH. So when you don't have ACTH, your F and R are going to go down, but it's going to go into atrophy. Okay. Bilateral. Why bilateral? Because when you don't have ACTH coming from top, you are going to cause bilateral adrenal atrophy. Simple as that, which is the most common cause. Second thing is you have primary adrenal adenoma. Let's say this is the adrenal gland, the kidney and adrenals. So you have adrenal adenoma in one place, in one of the adrenals, or you might have hyperplasia of that one of that adrenal, or carcinoma of that adrenal. So you are producing, let's say you're producing all that cortisol. That cortisol is again will go up top, inhibit anterior pituitary to not secrete ACTH. Okay, and that is going when you don't have ACTH, the other normal one will go into atrophy. But you have one which already has either adenoma, hyperplasia, carcinoma. These three warnings here. It is already enlarged. So you have atrophy of uninvolved adrenal gland. So one is going to be enlarged, and the other one is the one which is not involved, small, because you're not getting ACTH from top. Okay. The next one is ACTH secreting pituitary adenoma. You have ACTH coming from the pituitary gland. So you have a lot. Let's just erase this part. You have a lot of ACTH coming from top. When you have ACTH coming from top, guess what's going to happen? It's going to stimulate the left side and the right side equally. So both are going to go into hyperplasia or enlargement, so which is known as Cushing disease here. Again, Cushing disease versus Cushing syndrome. What is Cushing disease? Important. Cushing disease is when you have ACTH secreting pituitary adenoma. ACTH coming from top is called Cushing disease. Okay. Or you could also have, for example, paraneoplastic ACTH secretion, example, in small cell cancer or bronchial carcinoids. They will be secreting the paraneoplastic ACTH, which again, both of these are going to cause increase in ACTH essentially, which is going to cause bilateral adrenal hyperplasia, simple, right? And the Cushing disease is responsible for the majority of endogenous cases of Cushing syndrome. They're saying this guy, ACTH coming from the top, is the main culprit causing Cushing syndrome. Okay. With this, just remember, again, important thing, when you're taking something from outside, exogenous taking, you're decreasing ACTH, you're causing bilateral atrophy of the adrenal glands. When you have adrenal adenoma, hyperplasia, carcinoma, whichever side has this carcinoma, adenoma, hyperplasia will be enlarged. Other side is going to be small. Okay. With the ACTH secreting pituitary adenoma, meaning you have increase in ACTH coming from the pituitary gland, okay, due to adenoma being there, which is known as Cushing disease, is going to enlarge both glands equally. Same thing goes for the paraneoplastic ACTH secretion, which is going to come from small cell lung cancer and bronchial carcinoids. Because they're secreting ACTH, they are going to cause bilateral equal enlargement of adrenal glands. Okay, so here if you see, we have a total different thing, total different. You can right away tell, but here these two are same. and we will differentiate that later on with the diagnosis. How do we differentiate between two? We will talk about that in a bit. But here are the findings. So let's look at the findings now. The findings are moon phases. An important thing. Cortisol is going to give you high cortisol cushion syndrome is going to give you moon phases. Okay, what are they? They are the metabolic syndrome, which is your hypertension, hyperglycemia, and hyperlipidemia. Again, if you recall, it increases your alpha-1 receptors, right? So cortisol increases alpha-1 receptors on arterioles. So when you increase the alpha-1 receptors on arterioles, your norepinephrine and epinephrine would have increased effect on these receptors, right? Causing vasoconstriction, leading to hypertension. What is metabolic syndrome? Hypertension, hyperglycemia. Why hyperglycemia? Cortisol, and with the rest of the other hormone, which I talked about like a million times by now, they're all counter-regulatory hormones. All they want to do is get the glucose into the bloodstream from anywhere, causing gluconeogenesis, glycogenolysis, glycolysis, everything. They want to do every single thing to have that glucose in the blood, leading to hyperglycemia, hyperlipidemias. Okay, and this whole thing is known as metabolic syndrome. Then you have obesity, truncal weight gain with wasting of extremities. Okay, round moon phases. Picture A, you can see round moon phases, and dorsal cervical fat pad on the back side. You will have dorsal cervical fat pad on the neck, which is called as buffalo hump. Okay, that is going to be there. On top of that, you will have osteoporosis. And why? The question is, why would you have osteoporosis in these patients? Because you are decreasing osteoporosis by decreasing the osteoblasts. Decreasing osteoblast. So when you decrease osteoblast due to the fact that you increase in cortisol, you are going into osteoporosis, because osteoblasts are the bone forming cells. Okay. Neuropsychiatric disturbances are going to be depression, anxiety, irritability. Facial plethora is there. Okay. With facial plethora, what else you can think of? You have androgen axis. Androgen axis is going to cause acne, hirsutism. These are your sex hormones, right? They will cause acne, hirsutism. Okay. And then you have cataracts, immunosuppression, cortisols. They suppress immune systems by, if you recall, they inhibit phospholipase A2, right? They also inhibit IL-2. They also inhibit histamine. Only thing they're going to cause increase in, I think it was neutrophils, because they stopped adhesion. So neutrophilia, everything is just penia. Okay. Immunosuppression, ecchymosis, which is easy bruising. Okay. And you have skin changes, for example, thinning, stria, hyperpigmentation. And why would you have these stria and skin thinning? Well, due to the fact that when you have decrease due to impaired, wait, let me just write this down. This is important. Stria, because when you have decreased, impaired, let's say decreased or impaired collagen synthesis, they cause decrease in collagen synthesis in the vessels, and that when you decrease collagen synthesis in vessels, the vessels will break, leading to formation of these strias, as you can see in this picture. Okay. And that would also lead to easy bruisability, so ecchymosis. Okay. And that is one thing they haven't mentioned is, with easy bruisability and decreased collagen synthesis, there's a decrease in wound healing. Okay. So let's Okay, well, last thing here, and then I'll see some details here. Now, with hyperpigmentation, because you know that you get hyperpigmentation whenever you have increased, increased level of ACTH. ACTH comes from POMC. That POMC, if you recall, is giving off your ACTH. And if you don't know what I'm talking about, then again, go back to your, I guess it's the second page. POMC gives rise to ACTH, MSH, which is your melanocyte synthesis hormone or secreting hormone. And then you have the other thing, you have the endorphin, beta endorphins. But this melanocyte secreting hormone and synthesis hormone is going to cause increase in melanin production that causes hyperpigmentation. And that is why you will see hyperpigmentation. Okay. Okay, so let's talk a little more on these symptoms. On top of all of this, you will also see increase in muscle wasting, because this is cortisol. It tries to put all that. It leads to increase in proteolysis. When you break down that protein, you are going to cause muscle wasting, right? And why is it causing muscle wasting? Because it wants the gluconeogenesis to work so that it can put all that glucose into the blood. All right. And importantly, it's going to cause proximal muscle weakness, because you're losing that muscle. You're going to cause proximal muscle weakness. That is why you have thin extremities. Where did they mention thin extremities? Obesity, truncal weight gain, here you go, wasting of extremities. Thin extremities. That is the reason why you have thin extremities, because you are losing the muscle. And not only you will have thin extremities, but on top of that, the most important thing is, in the question stem, they're not going to say thin extremities. They'll say, okay, the patient can't climb stairs, or difficulty. There's a difficulty to climb stairs. It's hard for them to stand after sitting. So it's hard for them to stand from sitting position. Okay. And all of this is due to the fact that you have proximal muscle weakness, high yield. Okay. Okay. Other than that, you are going to see, let's just write it here. Obesity is due to the fact that you have fat redistribution due to increase fat redistribution. It is due to increased insulin, due to increased glucose. Okay. And central android obesity will be seen. Increase in abdominal fat and thin extremities, which is basically saying, again here, obesity, trunk. So increase in abdominal fat and thin extremities. We talked about that one. Let me see if there is anything extra. Okay. So with that, I think, yeah, let's okay, let's talk about now the diagnosis. In the diagnosis, screening tests include increase in free cortisol on 24 hours urinalysis. So you will see increase in free cortisol on the 24 hours of urinalysis, or increase late night salivary gland cortisol, meaning in the saliva you have increased amount of cortisol, and there is no suppression with overnight low dose dexamethasone test. Okay, simple as that. So all you have is the simplest one that you look for is your increased late night salivary cortisol, and you have no suppression with overnight. You don't suppress with overnight low dose dexamethasone test. So let's read this here. So what do we have? So first of all, we have to establish, what do we have to establish? That there is increased cortisol, right? So to establish we have increased cortisol, we either do 24 hours urine free cortisol, or we check the late night salivary gland cortisol. Again, if you think about the normally the cortisol should be very high just before when you wake up. Okay. Here you have high at the late night salivary cortisol and are inadequate. That's second thing. Third thing is you have inadequate suppression on the low dose dexamethasone test. Okay, so this just essentially establishes that we have increase in cortisol, right? With that, what we have is then once we do figure out that we have increase in cortisol, then what do we check for? We look at the ACTH level, that either this cortisol is coming from outside, either it's coming from the problem in the pituitary gland, either it is coming from itself, which is the adrenal gland. So we have to see all that difference, right? To look for that, we look for ACTH. So let's look at when we measure the ACTH, measure serum ACTH, right? We are trying to establish the cause now, cause for high cortisol. So if it is suppressed, if we measure the ACTH and it is suppressed, which means it is decreased in ACTH, then we say, okay, whatever the cortisol was coming, it's coming. Look here, ACTH independent Cushing syndrome. That is not dependent on ACTH, because ACTH is suppressed. Still, we have high cortisol. So it is not from ACTH. So it is either that you're taking this cortisol from outside, or you have the problem itself of the cortisol, off the adrenals. So you have exogenously taking, or you have a problem within the tumor. Again, it's a very simple thing. Let me read one more time, okay? First of all, you have to establish that you have increase in cortisol, which is through this, okay? Once you do establish that there is cortisol, and the way you are going to establish is they will put this here, but they will also mention all these sign symptoms. So you will say, okay, hey, there is increase in cortisol, simple. When you already have increase in cortisol, then you say, okay, let's look at this ACTH level. If they are suppressed, if the ACTH is suppressed, it's not even there. Let's just say decrease ACTH on this side. When the ACTH is low and you have increase in cortisol, that means that this cortisol, let's just say increase in cortisol, that this cortisol is coming from outside or within the adrenals, which is adrenal tumor. So how can we check that? Well, first, then we have to do adrenal CT to confirm, or ask the patient, hey, did you take anything from outside? And also confirm with the adrenal CT. Now, if the ACTH is elevated and you have increase in cortisol, an increase in ACTH, that means that ACTH is causing the stimulation of the cortisol, and that's why we have the increase in cortisol. Simple, right? Then we go for high dose dexamethasone suppression test. When we give a patient high dose dexamethasone suppression test, if the ACTH is coming from top, which is anterior pituitary, that would suppress it, because that's just an adenoma. But if it is a paraneoplastic disease, which is a carcinoma, like small cell lung cancer or your carcinoid cancers, it will not suppress those because it's a carcinoma. Carcinoma doesn't get suppressed if you give something from outside, right? So high dose dexamethasone suppression test, once you give this high dose dexamethasone, if ACTH decreases, then you call it Cushing disease. And again, what was Cushing disease? You have Cushing disease is when you have a pituitary adenoma, which causes the secretion of ACTH. So you give this high dose drug, it's going to inhibit ACTH secretion. You call it Cushing disease. And then you check on the MRI of the pituitary to identify the lesion, which is the adenoma. Okay. But you give the patient high dose dexamethasone test, still there is no decrease in ACTH. Then you say, hey, this must be some carcinoma. The carcinoma is ectopic ACTH secretion, which are, we've seen up top, which are only two ectopic places, either the small cell lung cancer or the bronchial carcinoids. Okay. So ectopic ACTH secretion. And for that, then you go for, because we were talking about lung and carcinoid, you check everything, chest, abdomen, pelvis, to identify that tumor. Okay. So this is with the high dose dexamethasone test. Now there is something CRH stimulation test. What was CRH? Can you recall? If you are saying corticotropin releasing hormone, then you're absolutely right, which comes from hypothalamus. The CRH comes from hypothalamus, goes on anterior pituitary, and stimulates anterior pituitary to release ACTH, right? So CRH, we are giving CRH from outside. And that CRH, when this CRH goes on anterior pituitary, normally it will stimulate and release the ACTH. Here's the same thing. When we give CRH from outside, it's going to increase that ACTH, and then we can say, okay, this is Cushing disease, meaning it is responding. Whatever is responding. So just imagine this thing. Anterior pituitary is going to respond to everything, whatever you get from outside. It could be your high dose dexamethasone test, or it could be your CRH stimulation test. Anterior pituitary is going to respond. There is no way the anterior pituitary is not going to respond, okay? But your carcinoma, your tumor, your paraneoplastic ACTH secretion will not respond to both the things. Neither is going to respond to your dexamethasone, nor is going to respond to your CRH. Simple as that. Okay. So with that, look at this, the other one. Okay. We give CRH, Cushing disease, which is your pituitary adenoma, does respond, increases ACTH secretion. And then you do MRI to check up the brain. You give CRH, ACTH, there is no increase in ACTH level because your ectopic ACTH, which is your paraneoplastic small cell lung cancer, bronchial carcinoid, it is not going to respond. So there is no increase in ACTH. And then you check for CT of the chest, abdomen, pelvis. Again, everything, chest, abdomen, pelvis, to identify the tumor. Hope that makes sense. With that, we are done with Cushing's. Cushing's are normal high yield, okay. I guess there is no need for a revision of this part because this is very easy. Understandable, right? So yeah, let's just take a break. So one extra thing here is about the labs. Let me write it here. In the Cushing's, you will have these lab values. With all of them are here, but on top of this, you will also have low potassium. Okay, let's just keep it here. So you have increased sodium levels, decrease in potassium levels, okay? And when you decrease the potassium and you're decreasing hydrogen ions, decreasing hydrogen ions will cause metabolic alkalosis. And metabolic alkalosis, you also have, so all of these functions, these extra labs that I'm just mentioning here, they are all due to the fact that when you stimulate your adrenal cortex, you're stimulating all the hormones, right? So you're not only you're stimulating your cortisol, but you're also stimulating your aldosterone, you're stimulating your cortisol, and you're stimulating your sex hormones. So all of them are going to be there. For example, like androgens, right? So androgens, we are seeing androgenic excess causing acne, hirsutism, all that, right? With the cortisol, we're seeing all these symptoms, But with the aldosterone, we will also see increase in sodium, decrease in potassium, uh, decrease in hydrogen ions. That is going to cause metabolic alkalosis. Let me erase this part. Metabolic alkalosis, because you're losing your hydrogens, causing alkalosis. Okay, and with and also you're also going to cause increase in bicarb reabsorption. Okay, with the just because of aldosterone. Okay, and that is all for, so these are the extra labs that you will see with Cushing's. Okay, with that, let's move on to the next thing. Then we have adrenal insufficiency. As the name suggests, you have adrenal insufficiency. There is inability of the adrenal gland to generate enough glucocorticoids, plus minus. So again, glucocorticoid is your cortisol, mineralocorticoid is your aldosterone for the body's need, right? It could be acute or chronic. Symptoms include weakness, fatigue, orthostatic high yield, orthostatic hypotension. Orthostatic hypotension will be there due to the fact that, again, your cortisol was the one which was trying to have some tone for the vessel by increasing your alpha 1 receptors. When you don't have cortisol, you don't have alpha 1 receptors, you are going to cause essentially hypotension. Okay, muscle aches, weight loss, GI disturbances, sugar or salt craving, again, high yield. These patients are going into sugar or salt cravings. Okay, and again, what is this thing? It's adrenal insufficiency. The adrenals cannot make enough cortisol or aldosterone. Okay, with that, let's look at the treatment. Treatment is simple. When they cannot make it, give it from outside. Either if the glucocorticoid, which is cortisol deficient, give glucocorticoid. Aldosterone deficient, give mineralocorticoid. Replace them, right? Now let's talk about primary, secondary, and tertiary adrenal insufficiency. So the primary, as the name suggests, is going to be your primary adrenal gland being affected. You have a decrease in gland function, right? When the gland is not functioning, it's going to have low cortisol, low aldosterone, and so with the low cortisol, low aldosterone, what are you going to get? Hypotension, hyponatremic, volume contraction, hyperkalemia, metabolic acidosis, skin mucosal pressure areas, and buccal mucosa. Okay, so why are we having all these symptoms? For that, we have to go back to the normal aldosterone. What is aldosterone doing normally? So it's going to reabsorb sodium, it's going to dump potassium, and it's going to dump your hydrogen ions, right? And with that, when you dump the hydrogen ions, and it's going to cause metabolic alkalosis, and this is normal. Normally, aldosterone is doing this, right? Causing metabolic alkalosis. Now, when we don't have the normal, when we have low aldosterone, you will lose your sodium. So low sodium, meaning hyponatremia, increased potassium, meaning hyperkalemia, and you're not going to dump your hydrogen ions, which are acid, leading to metabolic alkalemia. So you're going to keep this because you are deficient in your aldosterone, so it's going to cause acidosis, so metabolic acidosis. Okay. Other than that, let's also talk about now the cortisol. So because we have low cortisol here, that's going to show up as decreased cortisol. First of all, you have hypotension. I mentioned that one. Hypotension, hypoglycemia, because you can recall yourself that it takes a glucose, puts it into the bloodstream. Now it's not there, so it's going to cause hypoglycemia. Important thing, right? Other than that, you will have importantly, with low cortisol, you are going to have eosinophilia. Eosinophilia. Okay. And you will also have anemia, and that anemia is going to be your normocytic normochromic anemia. So normocytic normochromic anemia. And with this, two extra things are going to be, because you are going into hypotension, so you can go into shock, and also you're going to have hypopigmentation because you don't even have you don't have the cortisol. Well, my bad. It's because you have low cortisol. It's going to be hyperpigmentation, and then let me tell you how. Hyperpigmentation, and why is that? Because this, when you have low cortisol, the ACTH is from the anterior pituitary, the ACTH will come down. First of all, your hypothalamus, right? Hypothalamus is going to secrete your CRH. CRH is going to stimulate your POMC. POMC will release your ACTH, your MSH, everything, leading to hyperpigmentation. So with low cortisol, you have hyperpigmentation. Okay. And these are the functions specific to each hormones. And that is mentioned also here. Hyperpigmentation, you can see in the picture, hyperpigmentation. Okay. And then you have decrease in cortisol leads to decrease in negative feedback effect on pituitary, increased production of POMC, derivatives which are beta endorphin, ACTH, and MSH, cause an increase in melanin synthesis due to increase in MSH, primary pigments, the skin and mucosa. Okay, they're saying primarily it's the primary pigments are going to be seen in the skin and the mucosa. So you can see on the mucosa, if I zoom in, you can see the blackish hyperpigmentations, and also the skin is also hyperpigmented, right? With that, let's look at now something known as Addison's disease. In the Addison's disease, it's the chronic primary. So primary adrenal insufficiency is acute and chronic. Acutely, it's going to decrease in gland function, or chronically, it's going to decrease in gland function, which is adrenal insufficiency. If it happens chronically, the question is, why would something happen chronically? Well, it is caused by, if you go into adrenal atrophy or destruction, then slowly and gradually it's going to go into insufficiency if you have atrophy or destruction. Most common question is, why do you have atrophy or destruction? Well, due to autoimmune adrenalitis. It's an autoimmune disease. Okay, high income countries have autoimmune destruction of the adrenals, or the low income have the tuberculosis, TB, causing the adrenal insufficiency, which is also very high yield. Okay, that is going to be there. What else? With the autoimmune adrenalitis, you will see that the patient with pre-existing, so the patient will have pre-existing history of autoimmune disease, okay? Pre-existing history will be there. Another thing is called metastatic carcinoma. Let's just also mention that tuberculosis is one. Then you have the metastatic carcinoma. Okay, metastatic carcinoma is the lung cancer. So remember, the lung cancer, they love to go to adrenals. So lung cancer goes into adrenals and causes Addison's disease by chronically, slowly and gradually causing destruction of the adrenal gland, leading to adrenal insufficiency. So lung cancer leading to going to adrenals, okay? That's the metastatic carcinoma. Okay, so we talked about three causes again. The first is autoimmune, which is in high income countries. Then you have tuberculosis, low income countries, and then you have the metastatic cancer. Which cancer? Lung cancer specifically goes for the adrenals. With this, yeah, we are pretty much done with the Addison's disease. Let's look at the next thing. What do we have? Is the secondary and tertiary. So we have secondary, then we have tertiary adrenal insufficiency. So let's talk about each one of them. So here we have decreased pituitary. Secondary means it's not the primary organ being involved, meaning the adrenal is not involved, something else is. which is causing the adrenals to go into insufficiency, right? So here we have decrease in pituitary ACTH secretion. The pituitary is not secreting ACTH, that is the problem. Or there is a decrease in CRH secretion from a hypothalamus, and that's the tertiary problem. Secondary, again, if you recall the axis, how things work, you have hypothalamus, which secretes your CRH on the anterior pituitary, which then secretes POMC, which is POMC. One of the derivatives of POMC is ACTH, right? And also, always think about MSH here. Okay. Now, if you have a problem here that the anterior pituitary is not secreting ACTH, you call it secondary. And if you have a problem here, you call it tertiary. So which one was primary? That's actually right, the full axis. So it makes sense. So ACTH goes on the adrenal gland. These are our adrenal glands, right? Let's just say adrenal. Okay. When ACTH goes to adrenal gland, the adrenal gland then secretes cortisol. Okay. If you have a problem within the adrenals, that's going to be your primary adrenal insufficiency. You have a problem within the anterior pituitary, it's going to be your secondary adrenal insufficiency. And if you have a problem in the hypothalamus in the CRH synthesis, that's going to be your tertiary adrenal insufficiency. Hope this makes sense. With that, let's move on. Then you have the no hyperkalemia. We will not see hyperkalemia. Why? Because aldosterone synthesis is preserved due to functioning adrenal gland. So in the secondary and tertiary, where's the problem? The problem is here, and we're not getting ACTH, right? But adrenals are all normal. And if you recall your GFR, granulosa fasciculata and reticularis, granulosa didn't even need ACTH, right, for the aldosterone to be secreted. All granulosa needed was angiotensin 2 coming from the RAS, renin-angiotensin system, right? So granulosa will be there, and granulosa will secrete aldosterone. So aldosterone is normal. When aldosterone is normal, you will not see hyperkalemia. In fact, what you will see is hypokalemia. Opposite, right? But remember, no hyperkalemia, important. And I'll tell you the differences in a bit, but let's just read it here. Aldosterone synthesis preserved due to functioning adrenal gland because of intact RAS. No hyperpigmentation. Because in the primary and secondary, you're not even making ACTH. You're not even going and stimulating ACTH, right? Why would you have hyperpigmentation? So two things differentiate primary versus secondary and tertiary. And those are these two, hyperkalemia, hyperpigmentation. They're not going to be seen there. Okay, secondary adrenal insufficiency. Now we're talking about this secondary adrenal insufficiency, just in this part here where the ACTH comes from the pituitary. So it is due to pituitary pathologies. Yeah, I mean, wow. They're telling us something very good. Wow. For sure it is pituitary, man. Come on. You have to mention this part. But okay, anyways, you know this is coming from pituitary. For sure it's a pituitary problem. Okay. The tertiary insufficiency is most commonly due to abrupt cessation. Okay, now this is important. Now the tertiary adrenal insufficiency is most commonly due to abrupt cessation of chronic glucocorticoid therapy, HPA access. Tertiary is from treatment. Wow. That's just amazing. Now let me no matter how much emphasis I put here, this is still going to be very low. Okay. Okay. I mean, this emphasis was given to me by my pathology teacher. I mean, and still I don't forget it. So Whenever you're giving a patient glucocorticoid, okay, you always have to taper them off. Always have to taper them off. Tapering means if you are giving, let's say, dosage 20, you slowly go down, down, down to a point where it's barely minimum. Okay, and why is that important? Because when you give someone glucocorticoid from outside, it suppresses their HPA axis, which is all of this that I mentioned here. This HPA, hypothalamus, pituitary, adrenal, hypothalamus, pituitary, adrenal axis, whole thing gets suppressed, and the body just relies on whatever you're giving from outside. So if you were to abruptly stop this 20 milligrams, I mean, for sure 20 milligrams is low dosage, but more than that, 100 milligrams, let's say, what's going to happen is your body will not recover it, and your adrenals will go into adrenal insufficiency, and then they're not, I mean, there's just destruction of adrenals. They will not make the hormones anymore. Okay, and then you are left with what? Low cortisol, and you know cortisol is essential for life because it keeps the vessel in a tone of the vessels, which is required for the blood pressure to be there, right? So again, glucocorticoid, chronically you're giving glucocorticoid therapy. You're giving a steroid from outside. You have to taper it off. You have to taper it off. The reason being, if you do not taper it off, the body will go into adrenal insufficiency. And here is the book. Let's read this one now. Due to abrupt cessation right away you stop glucocorticoids. No way, Jose. No way, Jose. Okay. Can't do it. Don't do it. And also, please tell the patients don't do it. Sometimes patients stop it. Okay. They can't take like 7 drugs in one day, and then next day they take 6 drugs. Next day they 5 drugs, 4 drugs, 3 drugs. They say, hey, screw it. Can't do it. But you got to tell them, hey, if you don't do it, then your adrenals are going to go into insufficiency, and it's a bigger problem than you came with. Okay. So please cooperate with us. Okay, simple. Getting back here on the topic, we have the chronic glucocorticoid therapy. We do not abruptly cessation. We do not abruptly cessate the adrenal corticoid. Not abruptly. What do? We taper them off. Simple. Okay. Why? Because we don't want to suppress this HPA axis. Okay. So again, tertiary is from treatment. So someone, let's just say example, someone would abruptly stop the glucocorticoid therapy. When you abruptly stop the glucocorticoid therapy, what's going to happen is you are going to go into tertiary adrenal insufficiency, in which case that you're not even making CRH anymore. Okay, there's insufficiency. When the CRH is not going to go down and stimulate ACTH, you're not going to make ACTH. When ACTH is not there, you're not going to make cortisol. Simple as that. Okay, so mnemonic is pretty good here. Tertiary is treatment. With that, I think we did a pretty detailed job here. So let's move on to the next part. That is going to be your acute adrenal insufficiency. What is going on with my eraser? Okay, let's take a look at acute adrenal insufficiency, also called adrenal Addisonian crisis. Adrenal crisis or Addisonian crisis. Do not mix this with Addison disease, which is chronic primary adrenal insufficiency. This is, look, Addisonian, okay? Addisonian crisis, disease, adrenal crisis. That is why it's called acute. And here, this is chronic. Okay, often precipitated by acute stressor. What is acute stressor? That increases, that there's increased glucocorticoids, increase in glucocorticoids, glucocorticoid requirements, example, infection. You have acute stressor, could be anything, infection, we talked about it, infection, surgery, trauma, anything is there that's going to increase. That's the acute stressor. So in stress, you need the stress hormone. What is your stress hormone? Cortisol. What is cortisol? Cortisol is glucocorticoid, right? You need that, right? So in patients, when you have stress, but in patients when they are going into acute stress, but they have pre-existing adrenal insufficiency, or they are on glucocorticoid therapy, meaning they're taking glucose from not glucose but cortisol, glucocorticoid from outside, or either that, or either their adrenal insufficiency already is present in them. What's going to happen to those patients? Well, they are going to cause adrenal crisis, which is acutely failure of the adrenal glands, which is adrenal insufficiency. Well, question is, why does this happen? Well, it happened because if, again, this is again very high yield and important. We said acute stressor, right? And I said acute stress could be a surgery. So again, if someone is taking glucocorticoids and they're going for surgery, you bump their cortisol up. Because normal physiologically, if you're not giving them glucocorticoid, normal physiological action of their body would be that the body will produce increase in cortisol. So when you're giving glucocorticoid and you are suppressing the HPA axis, and the body's like, hey, relieved, we are getting something from outside, and now they're going to increase in stress, they need more cortisol, which normally they would have gotten if you're not suppressing their HPA axis by giving outside glucocorticoid. Again, my bad for saying glucose, but it's a glucocorticoid. Again, simple thing. Let's make things simple, and that is that when you are going in surgery is a stressor. Trauma, surgery, infection, all these are acute stressors. Normal physiologically, your body increases glucocorticoid, which is also known as a stress hormone. Okay, normally body increases it, but if you're giving a patient a glucocorticoid therapy, let's say 40 milligrams from outside, you're giving this patient a glucocorticoid continuous therapy, and the patient is going through infection, surgery, trauma, anything, and you do not increase your dosage, they are going to go into adrenal crisis because they require more cortisol than what you are giving them. Okay, and it's going to present with acute abdominal pain, nausea, vomiting, high yield, altered mental status, high yield shock. Why shock? Because again, alpha 1 receptors are needed for the vessel's tone. When you do not have enough cortisol, what's going to happen is you are not going to have this tone. It's going to cause hypotension. And hypotension will lead to shock, right? And also altered mental status. The patient is undergone surgery, comes back, everything normal. After a couple of days, the patient is going into altered mental status. Must think about glucocorticoid. Do they have two questions? Either were they already on glucocorticoid therapy, or is there any pre-existing adrenal insufficiency? In either the cases, give cortisol. Simple. Okay. Now there is something called Waterhouse Friderichsen syndrome. This is bilateral adrenal hemorrhage. Both adrenals are going into hemorrhage in the setting of sepsis. Example, meningococci leading to acute primary adrenal insufficiency. So the question arises is how is this going on? So meningococcemia, which is meningitis, right? Meningitis. So let's talk about this. Neisseria meningitis will cause meningococcemia, which is meningococcal septicemia, which is essentially sepsis. So let's just put simply sepsis. Neisseria meningitis causes sepsis. That septicemia or sepsis is going to cause DIC, disseminated intravascular coagulation, right? And that DIC, again, the hallmark of DIC is going to be you have low platelets, you will have petechial hemorrhages, and oozing, very high yield, oozing from IV sites. Okay, DIC. Sepsis leading to DIC. That DIC is going to cause shock, right? And that shock will lead to low sodium, high potassium, decrease in glucose due to the fact that you have low cortisol from the adrenal insufficiency. Okay. And this shock will eventually lead to death. Okay. So with this, let's just review this part and move on to the next one. Okay, for Waterhouse-Friderichsen syndrome, all you're going to think about someone having a necessary meningitis infection, which causes septicemia, which causes DIC shock, death, and that would lead to adrenal hemorrhage and necrosis. Okay, so bilateral hemorrhage and necrosis in settings of sepsis, leading to primary adrenal insufficiency. So again, here we talked about primary adrenal insufficiency, three things. We said either the patient is on glucocorticoid therapy, either there is a pre-existing adrenal insufficiency, or there is an infection, meningococcemia, which is due to your necessary meningitis, causing sepsis, DIC, and shock, leading to hemorrhage in the bilateral adrenal glands. Okay, with that, let's look at the last one here, which is concern for adrenal insufficiency. If you are concerned for adrenal insufficiency, you check the AM cortisol or ACTH stimulation. If there is decreased AM cortisol and or decrease in peak cortisol on stimulation test, then you check the measure. So this basically tells us that there is decreased cortisol, right? When you have decreased cortisol, then you say, hey, is this cortisol coming that the adrenals are not making, or there's a pituitary problem or a hypothalamus problem, right? So then you check ACTH levels. If the ACTH levels are high and still you have ACTH is high, my bad, not low, but high. ACTH is high and still you have low cortisol, then you say adrenals have the problem. You call it primary adrenal insufficiency, right? But if you look at the ACTH level, they are normal or low. Again, what do we have? We have low cortisol here. This is what all tells us that we have low cortisol. And we check the ACTH either low or normal. That means that this is due to the fact that you have a problem in the ACTH. So low ACTH would be a problem in the pituitary, and a normal ACTH would be a problem in the hypothalamus or primary and secondary and tertiary insufficiency. With that, we are done with adrenal insufficiency. Okay, let's take a break and we'll look back and do the next one, which is hyperaldosteronism. Now let's talk about hyperaldosteronism, which is increase in aldosterone, right? So increased secretion of aldosterone from where? Adrenal glands. Clinical features include hypertension. Again, what are the normal functions of aldosterone? Whatever the normal is, there's going to be hyper-functioning aldosterone. So hypertension because of sodium retention, right? Decrease or normal potassium. Normally you wanted to throw out potassium, so you're going to have a low potassium. Metabolic alkalosis. Yeah, you're going to have metabolic alkalosis because you're also throwing out hydrogen ions, leading to metabolic alkalosis, right? Primary hyperaldosteronism does not directly cause edema due to the aldosterone escape mechanism. However, secondary cause of hyperaldosteronism, example, heart failure, impairs the aldosterone escape mechanism, leading to worsening of edema. Okay. So what is your aldosterone escape mechanism now? So let's just write this down here. So when you have increase in aldosterone, no matter which cause it is coming from, it is coming from itself, the adrenal hyperplasia or hyperfunctioning adrenal adenoma, essentially is causing increase in aldosterone. That aldosterone goes to the kidney, stimulates the kidney, right? To do what? To do a couple things. Increase in potassium, my bad, not increase, but it's going to decrease potassium, reabsorption, which means essentially means throwing out that potassium, which leads to, in blood, what you are going to see is called hypokalemia, low potassium. Okay, you're also going to dump out that hydrogen ion, which is going to cause metabolic alkalosis, right? And then you are reabsorbing sodium. When you reabsorb sodium, you are essentially causing increase in blood volume. That increased blood volume will cause hypertension, right? And that hypertension, now when you are in hypertension, now what's going to happen is that your renin. So a couple things. Wait, let's just have two things here. Your hypertension is going to cause decrease in renin release, and that renin will decrease your angiotensin 2 activation. So decrease in renin and decrease in angiotensin 2, right? With that hypertension. On top of that, because you have hypertension, right, you're also causing, I don't know if you can see it. I'll try, let me just do a bigger font here. Bigger. So with hypertension, you are going to cause increase in the renal blood flow, right? An increase in renal blood flow, increasing GFR, glomerular filtration rate, and that essentially all of that is going to cause increased excretion of sodium, right? Because more sodium is going to go there, and because you are already having increase in blood volume, you are going to deplete out that sodium. So increase sodium excretion in urine. And not only that, but also increase in blood volume causes what? Again, it's going to dilate the ventricles, atria and ventricles, causing increase in ANP, right? And that is going to also cause the same thing, which is sodium excretion. When you excrete that sodium, it's going to limit the edema. So again, this is the aldosterone. So this specifically, this sodium excretion, due to the fact that a lot of blood is going, because of hypertension, you have increased renal blood flow, increase in GFR, and an increase in ANP. All of this will cause aldosterone escape mechanism. Aldosterone escape mechanism, in which you're essentially limiting edema and limiting hypernatremia. Hypernatremia basically means increase in sodium levels, and this is aldosterone escape mechanism. And this mechanism is going to cause what? Because there is excreting the sodium out, is going to cause normalization, normal sodium levels, and which will not cause edema. Simple as that. So with that, let me erase all this part, and let's read the book here. Okay. So here, again, we said the primary hyperaldosteronism does not directly cause edema due to aldosterone escape. And why doesn't it cause edema? Because it's excreting sodium. And why is it excreting sodium? Due to the fact that you have increased GFR, increase in renal blood flow, and increase in ANP, all of which are causing increase in sodium excretion. Okay, so no edema with the primary aldosterone, but secondary aldosteronism, example, if you have a heart failure, impairs the aldosterone escape mechanism, leading to worsening of edema. Okay, then you have this primary, let's talk about now the primary hyperaldosterone, increase in aldosterone, and secondary hyperaldosterone. So the primary one is seen in patients with bilateral adrenal hyperplasia. You have the adrenal hyperplasias or adenoma, which is known as Kahn syndrome. Okay, this is the primary, meaning the primary organ is affected. So primary, that's going to cause increase in aldosterone, decrease renin, high yield. Okay, primary, increase aldosterone, decrease renin, leads to treatment-resistant hypertension. Treatment-resistant hypertension, because no matter what treatment you're giving, you have increased in aldosterone due to the fact that you have hyperplasia or adenoma, and they will keep secreting that aldosterone, will keep getting that sodium in, and it's going to keep that hypertension. No matter what treatment you give is a treatment-resistant hypertension, right? Now, the secondary hyperaldosteronism is due to the fact that it is seen in the renovascular hypertension or JG cells tumor, which are renin producing, and edema, cirrhosis, heart failure, nephrotic syndrome. So again, let's take a look at each one of them. With the renovascular hypertension, you have either the fibromuscular dysplasia in a young female, in which you have the aorta and you have the renal artery here. You have this fibromuscular dysplasia. That means to the kidney, that means you have a decreased blood going to the kidney, causing increase in renin secretion, right? Increase in renin secretion. Or you have a tumor that does itself, it's no matter, you have normal blood supply, but it's a tumor which is secreting renin. You are causing increased renin. That increased renin is essentially causing increase in aldosterone. So that is what's called secondary, because it is not aldosterone problem. It is the one who is activating aldosterone. Who is activating aldosterone? Your renin angiotensin aldosterone system, right? So your renin. So when you have increase in renin, it's stimulating your aldosterone, causing increase in aldosterone, and problem is here in the renin. So what is the differentiating feature in both of them? That's your renin levels. Why? Because your aldosterone is high in both, but your renin is low in the primary, but high in the secondary hyperaldosteronism. Okay. I hope that makes sense. What else we can think of? So we talked about increased aldosterone, decreased renin, which is the Conn syndrome, increased aldosterone, increased renin with secondary. And there's a third thing, which is not even mentioned here, that is going to be you have decreased aldosterone, decreased aldo, and decrease in renin. Well, that is seen in your non-aldosterone causes, meaning hyperaldosteronism causes, and those are going to be your congenital adrenal hyperplasia, congenitally adrenal hyperplasia, your Cushing syndrome, your exogenous mineralocorticoids. I think they will mention it up somewhere, and we will talk about these at that time. But right now, just remember hyperaldosteronism, primary, secondary. Primary means primary problem. Secondary means coming from the secondary cause. Okay. The causes are very important for the secondary. Think about renovascular disease. Think about malignant hypertension. Think about renin secreting tumor, JG cell tumor. Other things are going to be your diuretic use, and renovascular hypertension will cause renal artery stenosis, atherosclerosis in elderlies or in older men, young female, renovascular fibromuscular dysplasia. Okay, all of these the causes of secondary hypertension. Secondary hyperaldosteronism. Okay, for the primary one, the cause is going to be your primary tumor, adenoma, or hyperplasia. Okay, and that is all. And with the primary, you will see aldosterone escape, and with the secondary, you will not see aldosterone escape. Okay, and that's pretty much it. Moving on with the next one, we have the neuroendocrine tumors. Neuroendocrine tumors, as the name suggests, they're neuroendocrine origin. They're heterogeneous groups of neoplasms originating from simple thing, neuroendocrine cells, which have traits similar to nerve cells. Again, name suggests neuroendocrine. So they are the nerve cells and the hormone producing cells. Simple, right? So why is that simple? And it's going because then you will have specific secretory products like chromogranin A, your NSE, which is your neuron specific enolase, synaptophysin, all of them. If you see it, then you can right away think about neuroendocrine tumors here, because they're coming from the nerve cells and they produce hormones, neuroendocrine. Most neoplasms occur in the GI system. For example, the carcinoid and the gastrinoma. In the pancreas, insulinoma, glucagonoma, and in the lungs is a small cell carcinoma. look at all these neuroendocrine tumors: carcinoid, gastronoma, insulinoma, glucanoma, and small cell carcinoma. Also, the thyroid medullary carcinoma and adrenal pheochromocytoma. Wow, amazing. Neuroendocrine cells, example pancreatic beta cells, endochromaffin cells, have a common biological function through amine precursors uptake decarboxylase. Despite difference in embryonic origins, anatomic site, and secreted products, which are chromogranin A and SE, synaptophysin, serotonin, histamine, and calcitonin. Treatments are surgical resection, or you can give somatostatin analog. Somatostatin analog is octreotide, which is going to inhibit every single thing that is there. It inhibits all hormone secretions, right? And that is why that is the treatment. With that, one more thing you have to think about with pheochromocytoma and neuroblastoma, which is going to come up as well. Okay, let's talk about now the next one, which is neuroblastoma itself. Here we have, it's a solid extracranial neuroblastoma, extracranial tumor in children less than 4. Okay. It usually arises in the medulla, adrenal medulla. Again, children has adrenal medulla tumor. It's called neuroblastoma. And we will see pheochromocytoma is also the medullary tumor, but seen in adults, which we'll talk about in a bit. But here, in a child of less than 4, you would have adrenal medulla problem, and it's called neuroblastoma. May occurs anywhere along the but it can arise anywhere against the sympathetic chain. Originates from neural crest cells, high yield NCC. So neural crest cells, if you recall, the neural crest cells, they are the ones which derive adrenal medulla, meaning adrenal medulla is derived from neural crest cells. Okay, so that is why when you have a tumor here, you say, okay, that is derivative of it, originates from the neural crest cells. Okay, so most common representation is abdominal distension, firm irregular mass that can cross midline, high yield, versus Wilms tumor, which is smooth and unilateral. Okay, Wilms tumor is smooth and unilateral, and we will talk about Wilms tumor later on. And this guy is going to be, it's going to cross the midline. And Wilms tumor is also seen in kids, and this one is also seen in kids. Okay, less likely to develop hypertension than with pheochromocytoma. Neuroblastoma is normotensive. That's very good mnemonic. Neuroblastoma is normotensive, can present with opsoclonus myoclonus syndrome, which is dancing eyes, dancing feet, high yield. Dancing eye, it's called OMS. OMS is dancing eyes, dancing feet, okay, high yield. On top of the high yield point that you will see is increase in HVA and increase in VMA, which are catecholamines metabolites in urine. So HVA and VMA will be seen in urine. Again, high yield is going to be Homocyte rosettes, which are neuroblasts surrounded with central area of neutrophil. So if you look here, you have Homocyte rosettes. Homocyte rosettes with just the, so these are circular groups of dark tumor cells surrounded by pale neurofibrils. So they're surrounded by this pale neurofibrils. Okay. So dark tumor cells surrounded by pale neurofibrils. And these are the Homocyte rosettes, high yield. Okay. And then you have this characteristic of neuroblastoma and medulloblastoma. So hemorrhoid rosettes are not only seen in neuroblastoma, but also medulloblastoma as well. Bombycine high yield, NSE. NSE is from top. Bombycine is new here. So NSE and bombycine positive. Okay. Again, wait, let's look at what was medulloblastoma. It is most common, let me write here, most common brain tumor in child or in children. Brain tumor in children. That's the medulloblastoma. And it most commonly involves the cerebellum. Okay. So both of them, medullo and they have hemorrhoid rosettes, high yield, hemorrhoid rosettes. Okay. And then neuroblastoma is bombycine positive and NSE positive, associated with N-MYC oncogene. N-MYC oncogene gives us the poor prognosis. Poor prognosis. Okay. What else we can think of? Yeah, that's pretty much what we have. So let's just talk about these pathways, how we're getting HVA and VMA. Well, the way we get it is, let's just do the biochem here. So we have, if you recall, we have dopamine. Dopamine gets converted into eventually HVA. Simple. Dopamine gets converted into norepinephrine. Norepinephrine gets converted into your normetanephrines, normetanephrine by the enzyme COMT. Okay. And then normetanephrine will be converted into VMA, vinyl mandelic acid, by the enzyme MAO. There's an enzyme that works on norepinephrine that is called SAM. SAM will convert norepi into epi, and that epi, again, that COMT will work on it and make the same, but it's going to be, instead of normetanephrine, it's just going to be metanephrine. Those metanephrine will be again converted to the same metabolite, which is VMA, through the same enzyme known as MAO. Okay. Now, this is how we are getting HVA and VMA. HVA, VMAs. These are all catecholamine metabolites in urine. And why did I mention all this? Because it's going to show up in the next page or so when we talk about pheochromocytoma. Now let's see what is HVA. HVA is homovandelic acid. Let me write it down here. Homovandelic acid. And VMA is vinyl mandelic acid. Vinyl mandelic acid. Okay. With that, let's just review both of these. So the first thing we talk about is neuroendocrine tumors. Essentially, we are talking about everything that we are going to mention from this page onward, right? So we are talking about neoplasm of the GI, carcinoid gastronoma, insulinoma, glucagonoma, small cell carcinoma, medullary carcinoma, and pheochromocytoma. All of them are neuroendocrine tumors, and they have a common biological function through amine precursor through which is taken up by the APUD, which is deoxycarboxylase, despite differences in their embryonic origin and atomic site and secreted products. Well, the important thing is that in all of them you will see chromogranin A and SC synaptophysin. They will be secreting either serotonin, histamine, calcitonin, depending on which organ they're coming from. Treatment is surgically resect them, first thing, or try to give an octreotide, which is somatostatin analog, to inhibit the synthesis of all these hormones. Now we talk about neuroblastoma. It is a solid extracranial because it is in the adrenal medulla. That's why it's called extracranial. Which one is going to be intracranial? That is your medulloblastoma. Okay. It is seen in children of less than 4. it is originates from NCC. It's going to shift from the midline versus Wilms, which will not, and it's going to cause less likely to cause hypertension than pheochromocytoma. So mnemonic neuroblastoma is normotensive. Can present with dancing eyes, dancing feet, with increase in the metabolites of catecholamines, increase in HVA, VMA, homoroid rosettes will be seen, BOM be seen, and SE positive. NMIC gene is a poor prognosis. That's pretty much what we have for neuroblastoma. Moving on with the pheochromocytoma. Here for the pheochromocytoma, it is most common tumor of adrenal medulla in adults. What is the most common in children less than 4? It's going to be your neuroblastoma. So pheo adult. Okay. There's a red arrows point that shows us red arrow points to bone metastasis. So it goes and metastasizes in the bones. It is derived from chromogranin cells from the neural crest. Rare may be associated with germline mutation. So it is associated with germline mutation, for example, NF1, VHL, RET. RET is MEN2A, 2B. Rule of 10 is also very high yield. 10% of these are malignant, 10% are bilateral, 10% are extra-adrenal, meaning they are either, because you remember we talked about the previous one as well, that it can even run in the sympathetic chain. Okay, run along the sympathetic chain. So here's the same thing. They can run in the paraganglioma. Example are they can go into the bladder or the organ of Zucker gang. I thought it's a land, but it's not. Zucker candle. Okay. Then you can have 10% could calcify, and 10% can be seen in kids. Again, kids, child is less than 4, but kids is more than 4. Then you have the symptoms that you are going to see, whether it's called is the most tumor secrete epinephrine, norepinephrine, dopamine, which we mentioned here, dopa, norepi, epi, right? Which can cause high yield is episodic hypertension, recurrent episodic hypertension. Important is the word episodic, which they also might secrete EPO, erythropoietin, which can lead to polycythemia, increase in hematocrit, right? And symptoms occur in spells. Why spells? Because it is episodic. Relapse and remit, they come and go, right? That because it is episodic again. So important point is going to be some clinical tie-in. That tie-in here is going to be in patients with undiagnosed pheochromocytoma. If you induce the patient with anesthesia, they can precipitate catecholamine surge, and which will cause hypertension crisis, flash pulmonary flash pulmonary edema, and AFib, atrial fibrillation. Again, it's a very important clinical tie-in that you have an undiagnosed patient with pheochromocytoma, and you start the induction on that patient with anesthesia. That would precipitate the catecholamine surge, and that surge will cause hypertensive crisis, flash pulmonary edema and AFib, That's important, okay? That is why patients with MEN red gene mutation, which is MEN2A, MEN2B, that is why patients with MEN2 should be screened for pheochromocytoma before they even go for surgery. Okay, so that is important clinical tie-in. Other than that, with the bladder wall, if the tumor is in the bladder wall, it's going to cause there's going to be signs and symptoms are going to be with the urination. When the patient urinates, they are going to have episodic headache because of hypertension, episodic hypertension at that moment, right? Episodic headache because of hypertension, one thing. Um, and if it is in the organ of Zuckergandel, very hard to tell, Zuckergandel, then you have, it's basically at the inferior mesenteric aortic root. Where is this organ of Zuckergandel? That's the inferior uh, mesenteric aortic root. Mesenteric aortic root. Okay. Now with this, important thing is going to be you would have episodic hyperadrenergic symptoms 5P, meaning increase in blood pressure, headache, respiration, which is essentially meaning increase in sweating, right? Palpitation, and pallor. Again, if you have catecholamine, a lot of catecholamines into the bloodstream, which will cause increased BP, which will lead to headache, increased sweating, tachycardia, and pallor. Okay. On top of this, just add one more P, which I don't know why they did not, which is polycythemia. So 6 P's essentially plus polycythemia due to the fact that they also secrete EPO. Okay. Then let's talk about now the findings. The findings are going to be that you have increase in catecholamine and metanephrines. Example, HVA, homovanillic acid, VMA, vinyl mandelic acid. In urine and plasma, episodic hyperglycemia may be uncommon finding. Episodic hyperglycemia, because again, when you have episodic increase in your catecholamines are counter-regulatory hormones. They are going to cause increase in glucose in the bloodstream, causing episodic hyperglycemia. Okay. Then in the findings, because it's coming from the neural cells, where the neural crest cells, it's going to be neural crest cells. It's going to be chromogranin positive, synaptophysin positive, and NSE positive. 3 things are going to be positive. You can screen for this. Screen for this by doing a 24 hours assay for assay for urinary metanephrines and catecholamines. So again, 24 hours urine, metanephrines, and catecholamines can be checked for the screening purposes. Okay, for the treatment, we have perioperative administration for very high yield, that irreversible alpha antagonists, for example, phenoxybenzamine, high ES yield, phenoxybenzamine, followed by the beta blocker prior to tumor resection. So you want to have tumor removed, right? But you don't just remove the tumor, because that tumor has a lot of catecholamines. When you're removing it, there is a highly likely chance that the preformed catecholamines will go into the blood, will work on your alpha receptor, and cause hypertensive crisis, which can lead to death even, right? So you want to block that alpha receptors. To block the alpha receptor, you want to give alpha antagonist, and the irreversible alpha antagonist is going to be your phenoxybenzamine. So first you want to block this out, then you want to resect it so that whatever catecholamine goes out, they are not working on the alpha receptor. Followed by the beta blockade, okay, prior to tumor resection. So alpha blockade must be achieved before giving beta blockers to avoid hypertensive crisis. A before B. A is alpha and B is beta. So A before B, alpha block it first, beta block it later. Phenoxybenzamine for pheochromocytoma, and that is also important, okay? With that, we are good to go for pheochromocytoma. Let's just quickly revise it. Pheochromocytoma, it is the most common tumor of adrenal medulla. It causes bone mets high yield. Okay, it is derived from chromaffin cells from the neural crest. Because it's a neural crest, so it's going to be chromogranin positive, synaptophysin NSE positive. It is associated with a lot of things. For example, high yields is RET mutation, VHL. Actually, all of these three are high yield. Okay, it could be associated with all of them, or it could just arise sporadically. Okay. Rule of 10, 10% malignant, 10 bilateral, 10 in the paraganglion, bladder, or organ of Zucker Candle. 10% calcified, 10% in children. Symptoms are again episodic headache, increase in blood pressure, increase in pain, which is headache, increase in sweating, tachycardia, pallor, polycythemia because it increases EPO release. Symptoms occur in spell, which is relapses, and remits, which is again same thing saying as episodic. Okay. Findings again: increase in catecholamines, myelonephrine's, HVA, VMA, all are going to be increased in urine and in plasma. It's going to cause hyperglycemia because it is increase in catecholamines. Okay. Then you want to resect this tumor, but you have to block alpha A first, then beta blocker. Alpha first because you want to block those alpha receptors before you can block the beta receptors, and phenoxybenzamine for irreversible alpha blockade. And that is all for pheochromocytoma.